days of packed scientific events will help you acquire some clinical knowledge. So without wasting much time, we'll start with our agenda. And the first, I'll invite Dr. Pitambar Prushti sir, who is the co-organizing secretary and a very helpful person in this event, to kindly chair the session. I'll also invite Dr. B.K. Das sir, senior consultant medicine from Bhubaneswar, to kindly come over the dais. So over to the chairperson. Just a small announcement, since it's a live streaming event, so mementos won't be given on the stage because it will hamper the live streaming. So we have a selfie point outside, so where after each session the chairpersons and the speakers will be given in the dining area with a backdrop. Thank you.
A very good morning to all of you. I think we are starting the session in time. Part of the organizers, especially the EDU for Diabetes and Endocrine Update 2022, that in the midst of Corona, and when it's raising its head for a possible fourth wave, we are having a physical meeting. I think the attendance is less as usual in the early morning and when the session is starting very early, but definitely it will swell up. Secondary hypertension, and out of that is equally very important, can present with a hypertensive emergencies, hypertensive crisis, various cardiovascular complications, and catastrophes in emergency. So we have to know about this hypertension. It involves really a special clinical clues, a specific diagnostic procedures, and once diagnosed, conditions like adenocortical adenoma leading to Conn syndrome, basophilic adenoma of the pituitary leading to Cushing's disease, or adrenal medullary tumor like pheochromocytoma, the three constitute majority of the endocrine hypertension, then a possible cure, surgical cure is definitely there, and that will alleviate the lifelong antihypertensive therapy. So with this, I think we should go directly to the topic, and Professor Mangraj, who is from some hospital, he will be delivering the lecture. I will hand over the mic to my co-chairperson to introduce him.
Dr. Swayamsiddha Mangaraj is now Associate Professor Endocrinology, SOM and IMS Medical College, Bhubaneswar. He was previously Assistant Professor Endocrinology, SC Medical College, Cuttack, and his achievements are, he is a national runner-up in ESI, TYSA 2016. He is peer reviewer in some case reports. He is a professional member in many societies, and he has 24 national and international journals. So he will be talking to you about endocrine hypertension. Why endocrine hypertension is important? Because this accounts for about 5 to 10% of secondary hypertension, as or 30%, as my co-chairman said. Why we are interested to know about endocrine hypertension? Because this is a abnormality of endocrine organs, mainly the adrenals and subsequent. Because if you diagnose this case, there is a cure, unlike other hypertensions. There can be surgery, so the patient can be obviated from the long-term use of antihypertensives. I think Dr. Mangaraj will do justice in speaking to all of us about this endocrine hypertension, its management, and its importance. Dr. Mangaraj, please.
Thank you, sir, for that kind introduction. Warm good morning to respected faculty, seniors, and dear colleagues. So after 2 long years, we are back with the physical meet, and thanks Dr. Sambit Das Bhai for inviting me over here to start the session for the marathon CME, which are anticipating over the next 2 days. So my job is to speak regarding endocrine hypertension. I think that has been well introduced by our learned chairpersons. So in the subsequent slides, I will just share you regarding the case detection, outlining the protocol for diagnostic algorithm, what tests has to be performed, and how it should be better managed so that the outcomes are improved. So as we all know, secondary hypertension accounts to almost 10% of all hypertensive cases, majority being the essential one, and among those, around 5 to 10% of those cases would have an endocrine background. So which patients are likely to have threshold for secondary hypertension? So we have dedicated guidelines for that. Young onset hypertension less than 40 years, a more acute worsening of hypertensive state in a previously chronically controlled one, or there is end organ damage related to hypertension. So these are the specific people who definitely would have a secondary form of hypertension. So classifying secondary hypertension, we have a lot of causes starting from renovascular, endocrine, drugs, but today's talk would be based on endocrine hypertension, and among them, around 5 to 10% of all patients would have an endocrine cause of their hypertension, for which there could be hypertension as the sole manifestation of the underlying disorder. The beauty of the diagnosis lies in the fact that once you diagnose it correctly, you can cure the patient of hypertension that is not disorders, and it could be difficult for even seasoned endocrinologists to pick up the disease. So if you talk regarding adrenocortical causes, there are a lot of around 20 specific disorders which can lead to resistant hypertension. They could be low renin high aldo or low renin low aldo. So this is the broad classification based on which the disorders are divided. In the last decade, there has been a transformational gain in knowledge with regards to genesis of primary disorders, and it could be difficult for even seasoned endocrinologists to pick up the disease. So familial hypertension. So if you talk regarding the young onset hypertension, we know now certain genetic defects which leads to so-called familiar hyperaldosteronism. Primary hyperaldosteronism was diagnosed and detected in 1944 by the Kohn. So we know is that Kohn syndrome. He predicted that for 10% of all hypertensive would qualify for the diagnosis of primary aldo in 1944. It took 40 years to align with the same fact. Now we agree that 10% of all hypertensive, especially in the higher threshold, may qualify for primary aldo. Which patients would be screen positive so that you can pick up the case earlier. So resistant hypertension, stage 3, requiring 3 or more drugs, including diuretic, presence of hypokalemia or spontaneous or diuretic induced, presence of adrenal incidentoloma with hypertension, or presence of sleep apnea with hypertension, or there is a positive family history of primary aldo. I think these are the case-specific detected thresholds. If you screen these patients, the diagnostic yield would be much higher. And these are in line with the Endo Society guidelines for case detection. How do you diagnose primary aldo? We move from case detection to the adequate test. That means establishing the disease. we use the ARR or aldo-renin ratio. So this cutoff of more than 20 would be screen positive. Those patients who are ARR of more than 20, they would be subjected to confirmatory test followed by an imaging modality to detect where lies the defect. So this is the basic outline how the theory goes. Similarly, what are the cutoffs you should remember in clinical practice? A plasma aldosterone concentration of more than 15 with a ARR ratio of more than 20 would suffice as a screen positive, and this patient should be subjected for confirmatory tests. These are the only screening tests which need to be done, and after they are screen positive, we need to do a confirmatory test. So what confirmatory tests we usually use in clinical settings? There are 4 confirmatory tests, but IV saline loading test is what is commonly used. So if the patient is positive after IV saline loading test, that means the levels are not suppressed, then it is a confirmed case of primary aldosteronism. So this is the diagnostic algorithm how we proceed with. The thing is, you need not need a confirmatory test if your baseline primary aldo concentration is more than 20 ng per ml. So that means if the patient has spontaneous hypokalemia with a high level of PAC, you may not opt the patient for a confirmatory testing. Apart from that, all other patients should be offered confirmatory testing. Once you have confirmed the disease, then particularly adrenal detected CT should be done so that you can diagnose whether it is adenoma, bilateral hyperplasia, or any other disease. The problem lies if it is very, very difficult for endocrinologist also to diagnose and treat primary aldo because of the problem with the screening. There are a lot of interactions with possibly every antihypertensive drug except few alpha blockers which do not have interaction. So patient has to be put on them while we evaluate for ARR. So that is the difficulty. At least mineralocorticoid antagonists should be stopped for 6 weeks prior to testing the patient, and other drugs including ACE, ARB, beta blockers, they have to withhold for 2 weeks, which is sometimes impossible in a case of primary aldo because of the resistant hypertension. Once you have diagnosed primary aldo, then you move on with a dedicated adrenal CT, that is the imaging of choice. So once you have done a CT, it could be a adenoma which is localized. Then if it is young age, a large adenoma more than 1 centimeter, perhaps it is adrenal adenoma, we can straight away go for dedicated adrenalectomy with a laparoscopic approach. The problem when the age progresses beyond 40 years, there are a lot of incidentaloma which come into picture, or if there is no adenoma which is picked up by adrenal CT, there comes the role of adrenal venous sampling. That is a very sophisticated procedure, not available in majority of the centers. Only few selected academic centers do that. So if you can do AVS, you can actually lateralize the disease based on the ratios of more than 4:1. That suggests it is lateralized to a particular side. And if it is less than 3, that means the disease is bilateral. So bilateral disease, there is no cure. You have to treat with MRA for lifelong. It could be spironolactone or it could be eplerenone. Curative intent is guided for adrenal adenoma, which is well localized and treated. Now comes the great masquerader, because this disease can mimic multiple diseases including hypoglycemia, postmenopausal symptoms, and evade diagnosis up to decades. So pheochromocytoma, in which patients you are likely to encounter a positive test, is the patient who have symptoms of catecholamine excess, the classical triad which you are taught of from the undergraduate days. So patient with resistant hypertension, incidentally detected adrenal mass, they should always go a routine screening for assessment of pheochromocytoma. Syndromic features like von Hippel-Lindau, RET mutation, though these are the, or neurofibromatosis, these patients do have an pheochromocytoma, so I think more prudent screening should be opted for them. What are the clinical signs with which pheo presents? We are taught of the classical triad, headache, the hypertension, diaphoresis. That is only seen in 58%. The sensitivity is only 58%, but the positive likelihood is very high. If the patient has classical symptoms, more likely is to have this. But majority of the patients do not have the classical triad, so that is the crux of the presentation, that majority may have a monosynaptic presentation like abdominal pain, isolated hypertension, or just some catecholamine excess symptoms. So once you have a case which is diagnosed based on clinical findings, what should you do? Which test you should do? Routinely we see VHA being performed. It is outdated, so VHA assessment is not mandated as of now. Guidelines endorse using either 24-hour urinary metanephrines or plasma fractionated metanephrines. So these are the tests which have specificity and sensitivity of more than 95% to correctly diagnose pheochromocytoma. So this test should be ordered. But there are a lot of caveats, how the test should be done, venipuncture should be done, how they should be stored, which method should be used, like LC-MS-MS is the preferred method, that is also not available with us. Now, when you will tell that it is positive, once these metanephrines are more than 2 to 3-fold elevated from the baseline, that constitute a positive screen. If a patient has borderline, then you have to repeat or other tests may be performed. So once you have diagnosed biochemically, remember in every endocrine disorders, biochemical diagnosis should be followed by anatomic localization, not the other way around, otherwise you will fall in trap. So once you have that, adrenal dedicated CT is the modality of choice. MIBG is routinely not performed, not required. So adrenal CT is good enough. MRI is used in some scenarios. MIBG is only indicated when you have a large mass more than 10 centimeter. There is a negative imaging scan with CT, or there is evidence of paraganglioma. So very limited settings as of now. We have multiple PET scans which can be used, especially in metastatic PPGs. Once you have diagnosed, treatment is surgery. There is no other treatment. You have to prepare the patient by adequate alpha blockade, followed by beta blockade, followed by volume resuscitation. Then patient may be subjected to lap adrenectomy. One thing I would like to stress upon here is, in the last decade, we now know that this is a genetically driven event. So majority of the endocrine society guidelines endorse genetic testing because it offers you valuable tool for screening for unaffected family members. So PPG is a syndromic disorder and a genetically driven event, so genetic testing should be performed. Let's come to Cushing's. So this is also a very difficult disorder sometimes to localize and treat for us also. How do you enhance the diagnosis of Cushing's? Iatrogenic drug intake perhaps represents the most common cause of Cushing's, but endogenous Cushing's sometimes may be very difficult to identify. So we have some red flag signs which are high discriminatory index factors. When they are present, the chances of having endogenous Cushing's is quite high. So what are those factors? Presence of facial plethora, proximal myopathy, classical purple livid striae of Cushing's, and weight gain with deceleration of growth velocity in children. If these are present, there is a strong likelihood that patient may have an endogenous Cushing's. How these are the causes, ACTH dependent or independent. So how do you arrive at the diagnosis? Once you have a patient, what test has to be done? The patient should be at least identified by 2 screening tests, which could be 24-hour urinary free cortisol. That is not commonly done. Of course, it can be done. You can do a 11 p.m. cortisol to look for the rhymicity. You can do a ODS or the overnight dexamethasone suppression test, or LDDSD, low dose dexa suppression test. If the patient fails these 2 tests, the threshold is more than 1.8 microgram per deciliter. If the values are more than that, perhaps the patient is screened positive for Cushing's, then you proceed with for localization. So once you have done that, then you have to localize where is the possible source. So for that localization, you have to do serum ACTH. It can be done in 11 p.m. or 8 a.m. A 8 a.m. ACTH cutoff of less than 10 pg per ml suggests ACTH independent cause or adrenal causes. A ACTH of more than 20 pg per ml suggests it is ACTH dependent. ACTH dependent could be further classified into ectopic ACTH or eutopic ACTH. That means pituitary Cushing's or ectopic ACTH secreting tumors. So once you have diagnosed the case of ACTH dependent or independent, if it is independent, you go for CT adrenals to look for the adrenal adenoma, ACC, or other diseases. If it is ACTH dependent, you go for pituitary MRI. Sometimes it may be difficult because Cushing's imaging can remain negative despite having classical florid symptoms of Cushing's for years together. There you have to treat the patient medically and wait till adenoma is picked up. So these are the lesser known conditions in low aldosterone state, monogenic causes of hypertension, especially in children. 2 causes I will show. Congenital adrenal hyperplasia due to 2 factors, that is 11 beta hydroxylase deficiency, 17 alpha hydroxylase deficiency. These can cause resistant hypertension along with genital ambiguity or hormonal problems in children or young adults. That can cause hypertension. 11 beta hydroxylase deficiency, that can cause hypertension, and a state of apparent mineralocorticoid excess due to the defect in the enzyme of 11 beta HSD2. So I think I have summarized basically all. I will move through some case vignettes, actual life case scenarios what we commonly encounter in our clinical practice. So this young man presented, 35 years old male, presented with CVA, hemorrhagic CVA, admitted to the neuro ICU. There was the patient has refractory hypokalemia, so endo consultation was sought, and the patient had a bleed, and patient was intubated by the time we reached there. After metabolic evaluation was done, the patient had metabolic alkalosis. The PAC you can look, it is more than 26 ng per dl. So a CT was done, it localized adrenal adenoma, so diagnosis of primary adrenal adenoma, incidentally presenting with hemorrhagic CVA with resistant hypertension. This 60-year-old man presented with rapidly enlarging neck mass and hypertension of the last 2 years. On examination, the patient had a large goiter, you can see here. There is a large goiter here. So the patient had few
Dr.
chromosomes.
Mangaraj, please expedite your presentation.
Okay, it's finished, sir. So there is a large pheochromocytoma sitting here. The patient was diagnosed as MEN syndrome. This index child presented with virilization and hypertension. On evaluation, she was found to have a adenocortical carcinoma sitting at the right adrenal. So she underwent surgery, and then she had remission for around 2 years, but unfortunately died after that. We got another call from urology department where the patient was admitted with pain abdomen and palpitation, and on echo we had evidence of DCM with global hypokinesia. When we evaluated the patient, there was a patient of pheochromocytoma. There was a large mass sitting out here with classical catecholamine-induced cardiomyopathy, which is very rare, and the patient recovered when the patient underwent surgery. The last case would be a child who presented with precocious puberty at the age of 3 years with advancement of bone age, and workup for that revealed presence of 11 beta hydroxylase deficiency. So I think these are all the cases which perhaps tell you that it is indeed common to be seen in practice. Only thing is the vigil should be high. So this is endocrine hypertension, represents around 10% of the cases. It's a treatable cause. You identify and treat, and the results are excellent. So I'll acknowledge and sincerely thank all my teachers, colleagues, co-faculties, residents whom I worked over the years, and for their support and motivation. Thank you.
So thank you, Dr. Maharaj, for your valuable advice and case reports. Now only 2 questions are allowed. If anybody wants, any question can allow. So there is no question, so we close this session. Thank you, Dr. Maharaj.
Thank you, sir. Thank you very much. I request the chairperson and the speaker to please proceed for the presentation. Next, I would like to request chairpersons, Dr. Vijay Kumar Mishra, sir, Senior Consultant Medicine from Bhubaneswar, and Dr. S.R. Patnaik, Professor and Head, Department of Endocrinology, MKCG Medical College, Barampur, to please come on the stage.
Very good morning to all of you. Now we are coming to the second session. We'll be discussing about some aspects of mineral metabolism. We'll be discussing about hypercalcemia. What should be the approach to it? You know, hypercalcemia is not an uncommon problem, but it's quite a vexing problem. And many doctors feel distinctly uncomfortable while dealing with it. But we have to know one thing, that most of the cases are treatable, curable. Talking more about it will be Dr. Anantaraman, and Dr. Mishra will be my co-chair, will be introducing him.
Thank you. Today our speaker is Dr. Anantaraman, and he is a very experienced endocrinologist, and without wasting time, I will like him to proceed with his presentation.
Do I get the slides here on the podium? Yeah. So we are having a small technical glitch, so just waiting to get it started. Yeah. Huh? No, 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 not that one. I just gave it just now. So today I'm going to talk about hypercalcemia, so which is a fairly important topic for medical postgraduates and endocrinologists alike. So when it comes to hypercalcemia, we can talk a lot about hypercalcemia. So in my talk, I've tried to focus on broad approach rather than talk specifics about diagnosis of hyperparathyroidism. That's beyond the scope of the today's talk. So I'll be it's coming up just now. So I'll be talking about the definition. Let's look at what is hypercalcemia, and let's briefly look at calcium homeostasis. So then we'll approach to diagnose hypercalcemia. So how can we go about diagnosing this condition, and approach to treatment. Approach to diagnosis is more about differential diagnosis. So we want to recognize what is causing the hypercalcemia. Sometimes hypercalcemia by and of itself is dangerous to life, so we need to actually treat hypercalcemia as we diagnose it. So diagnosis and treatment are not distinct entities. So in emergent conditions, we need to diagnose and treat at the same time. So this is very important that hospitalists, those who are physicians, should know about hypercalcemia, how to approach. So because every hour is important in the management of such patients. So forgive the typos in this slide actually, I just recognized the last minute. So it's a corrected serum calcium value above the upper limit of normal range or an elevated serum calcium. So it's very interesting to note that 99% of the calcium in the body is actually in the bone. Only about 1% circulates in the extracellular fluid, ECF. Okay. So, and it's interesting to also note that the excretion of calcium is actually, extraction of calcium from the blood is more in the bone compartment. So there is, I think you must have all heard of hungry bone syndrome. So the flux between bone and the extracellular fluid is about 15 millimoles. The flux going into the urine, or urinary excretion, is only about 5 millimoles. And the loss in feces is also about 15 millimoles. So that's around 400 milligram per deciliter. So this is the calcium in the body fluid. This is how it is partitioned. You can see that ECF and ICF are separately given here. So you can see that it's a largely an extracellular fluid ion. So it is not present intracellularly. It is present only in nanomolar quantities. If calcium increases intracellularly, it causes cell death. So it's a sign of necrosis or apoptosis, necrosis happening actually. So in the extracellular fluid, you can divide it into, it equilibrates with the blood or blood compartment. In the blood compartment, calcium can be broken into ionized calcium, protein-bound calcium, and complexed calcium basically. So complexed calcium forms a very small component. Ionized calcium represents 50% of the calcium that is there. So usually ionized calcium value, it's easy to remember, it's around 1 millimole, 1 to 1.1 to 1.3 millimole, or 4 milligram per deciliter. Either if the ionized calcium is more, all the total calcium is more than the upper limit of normal, which is usually 10.5 milligram per deciliter, it's considered hypercalcemia. So we consider it mild if the level is between 10.5 to 12, 12 to 14 is considered moderate, and severe hypercalcemia is any level above 14 milligram per deciliter. This is how we calculate the corrected calcium. So whenever we measure the calcium, since calcium circulates complex to albumin, if the albumin level is low, you are likely to get a low calcium level. So you can see that if someone has an albumin of 3, say having chronic liver disease, they may have a calcium of 8, but you need to correct it for the level of serum albumin so that you get a correct picture of how much free calcium is there. So correcting the calcium gives us a clear indication of how much free or ionized calcium is there, and it's, it brings everybody on the same level comparison. So this is the sort of partitioning of calcium. So calcium in the ECF or extracellular fluid or in the blood comes from the intestine. So from the intestine, only one factor is responsible for absorption of calcium, that is vitamin D. So once vitamin D is activated, 125 hydroxy D, there is something called a TRPV6 channel which is responsible for absorbing the calcium from the intestine. So intestinal calcium absorption is entirely driven by 125 hydroxy D. So under the influence of both vitamin D and PTH, you can have calcium being extracted from the bone. Okay, so this happens every day, and PTH is a very important hormone which is responsible for calcium homeostasis in the body. So also calcium gets reabsorbed from the kidney, again under the influence of PTH and vitamin D. So you can think of PTH and vitamin D as both hormones which are actually driving to increase the serum calcium in the bloodstream. And eventually what happens to this calcium? Most of this calcium actually has to go to the bone. The purpose of extracellular fluid calcium is actually mineralization of bone. So, and the bone mineral is in continuous equilibrium with the extracellular fluid calcium. Let's look at what are the causes of hypercalcemia. This is a famous diagram from NEJM. So you can see that if there is a malignant tumor or immobilization or hyperthyroidism, you can have calcium being taken out of the bone. Okay, so then again, likewise, hyperparathyroidism, the number one cause or the most common cause for hypercalcemia is actually hyperparathyroidism. Hyperparathyroidism again causes resorption or entry of excess calcium from the bone into the extracellular fluid compartment. If you take too much of active vitamin D or if you take too much of vitamin D itself, vitamin D toxicity, I think because of the widespread use of vitamin D preparations, I think all of us would have seen 1 or 2 cases of vitamin D intoxication. That's again a reason for excess calcium in the blood. So these are some of the common causes. You can have a rare condition called familial hypercalciuric hypercalcemia. So in patients who have high calcium due to other reasons, say for example borderline hyperparathyroidism, if you give thiazide diuretics, the calcium level actually can shoot up. Okay, so if somebody has a hyperparathyroidism, has a calcium level of 11, you give thiazide diuretic, the calcium can go up to 13 or 14, precipitating a crisis. So these are some of the causes for hyperparathyroidism. But our approach is to, when we are presented with a patient, we don't know what the diagnosis is. Then what are the 2 questions we need to ask? We need to ask the one question, whether the patient is symptomatic or asymptomatic. So in this, you need to be very clear what are the symptoms of hypercalcemia. So if the patient has hemiparesis or peripheral neuropathy or something like that, unrelated, we cannot call it a symptom of hypercalcemia. And also we need to see, are the patient's symptoms due to hypercalcemia. So these are 2 important aspects that we need to see. So neurological symptom, so hypercalcemia, especially if it is above 14 milligram per deciliter, can cause stupor, coma, muscle weakness, depression. It can cause GI symptoms, nausea, vomiting, anorexia. It can cause cardiovascular signs, especially higher values of calcium, say 16, 15 milligram per deciliter, can cause a shortened QT interval and a bradycardia. So hopefully we do not see cardiovascular manifestation. If we start seeing cardiovascular manifestation, we need to run immediately. We need to act immediately. We cannot be studying the patient. We need to start treating the patient immediately. So what are the labs which are required for differential diagnosis of calcium? So it is these set of labs are required for all patients with hypercalcemia. Please note. So we need to have a serum calcium, a phosphorus, alkaline phosphatase and albumin. This is a standard set of investigation. So we also should know what is the renal function of the patient. We should get a blood count and a ESR, mainly to rule out conditions like multiple myeloma, which are easily recognized by anemia and high ESR values. We can also get an intact PTH and vitamin D. So these are the set of investigations we must have in every patient who has hypercalcemia. So I'll come to how intact PTH is so important in differential diagnosis. So this is the curve of relationship between PTH and calcium. So you can see that the calcium is regulated very narrowly. You can see the sloping portion. So that is a normal calcium, in which you can see the highlights. So that's the normal calcium. So within the normal calcium range itself, if the calcium goes from 1 to 1.5, you can see that the PTH value drops from 75% to 50% or below. So any increase in calcium automatically suppresses the PTH production. So hypercalcemia is a very, very strong stimulus for suppressing PTH. Okay. So we have something called a calcium sensing receptor on the parathyroid gland, which senses the amount of calcium. So parathyroid gland basically a calcium sensor. It senses calcium and shuts off the production of parathyroid gland. Likewise, when the calcium falls, there is a rapid increase in calcium. So this is something that's very, very important to understand in the why PTH is so important. Another important thing is the half-life of PTH. So you have to realize that PTH itself, you know, these are different versions of PTH. You can see PTH 1 to 84, recombinant human PTH, okay, and you have PTH given through infusion pump, etc. So unless you give PTH through infusion pump, it's very difficult to elevate the PTH level. Meaning by that, the half-life of PTH is about 5 minutes. The PTH once introduced IV, like for example, if you give an IV bolus of PTH, it disappears in a span of minutes basically. So the PTH that you measure in the blood is a direct index of how much PTH is being produced in the body. So PTH is an important measure. So if you have a situation where the calcium is high and the PTH is also high, the calcium is high because of the PTH, all right? So the calcium is high because of the PTH. So whenever you have hypercalcemia, you must have a low PTH. If you don't have a low PTH, if you have a normal or high PTH, it is because of hyperparathyroidism. So intact PTH levels are direct indicator of how much PTH is being produced. High PTH with high serum calcium always means parathyroid glands are abnormal. Typically a long-standing or large parathyroidadenoma plus a trigger can be a reason for this hypercalcemia. Suppressed PTH with high calcium, parathyroid glands are not the source of calcium excess. So you can have calcium excess very commonly in malignancy. Malignancy can produce two forms of hypercalcemia. One is humoral hypercalcemia of malignancy, and another one is lytic hypercalcemia. Both of these do not produce an increase in PTH. Okay, they actually suppress the PTH. So what is the importance of the other parameters? Like for example, when you have vitamin D toxicity, you will get an excess phosphate as well, which is not seen in hyperparathyroidism. So you don't need to even wait for the PTH. So you see calcium high phosphorus, you need to think in terms of phosphorus. Alkaline phosphatase is variable. In myeloma bone disease, typically alkaline phosphatase is not elevated, but in humoral hypercalcemia of malignancy, alkaline phosphatase can be elevated. So you will know the difference between whether it's a myeloma or a humoral hypercalcemia of malignancy. So these are some pointers to diagnosis. So, but the most important thing is basically intact PTH. So these are various causes. There are solid tumors and hematological malignancies both cause hypercalcemia of malignancy. Most of the causes are because of PTHRP. You can see that in squamous cell carcinoma, breast cancer, advanced renal carcinoma, all these conditions, you have something called a PTHRP. So PTHRP, parathormone related protein, basically it increases the calcium. It works on the PTH receptor just like the PTH basically, but it's produced only by malignant cells, and it's called the humoral hypercalcemia of malignancy, and it increases the calcium. So in multiple myeloma alone, you don't have PTHRP. You have direct lysis of the bone cells, because multiple myeloma, as the word denotes, the tumor is in the bone itself and it releases calcium. So patients with symptomatic or asymptomatic or mild hypercalcemia, leave them alone. Do not treat. You don't need. There is no urgency for treatment. They should not be admitted. And over-treated actually. We don't need to give, IV infusion, etc. until a calcium of 12 milligram per deciliter. You should avoid over-treatment. 12 to 14 milligram per deciliter, you should individualize based on whether they have any symptoms or not. Only those more than 14 milligram per deciliter with symptoms we need to take up for treatment. We need to expand their volume by giving 200 to 300 ml, aiming for a urine output of around 200 ml. We can give injectable salmon calcitonin, not actually the nasal calcitonin. Nasal calcitonin is not effective. The injectable calcitonin can be given subcutaneously 4 international units per kilogram. It is available in our country but not widely used. We commonly use zoledronic acid. So zoledronic acid, how does it work? It actually goes and binds to the bone, and when the osteoclasts resorb the bisphosphonate, it kind of makes the causes apoptosis of the osteoclast, so thereby reducing hypercalcemia. It takes about 24 hours to start working. As far as denosumab is concerned, there are no RCTs, but denosumab also can reduce calcium in the blood. So it is effective in reducing calcium in, but only case reports are there, but it is not really used extensively in our country. And it takes about 2 days for it to start working. In cases which are refractory to zoledronic acid, where the calcium is not coming down, we can think in terms of giving denosumab, or think of giving denosumab directly also. Denosumab for this indication of osteoporosis is given every 6 months once, but in such conditions you can probably repeat the denosumab. Say for example malignancy related hypercalcemia, you can probably repeat it after a month again, so it gives you a better result actually. So in summary, I would say calcium metabolism has to be understood well to approach hypercalcemia. Lab diagnosis of hypercalcemia, the levels of various parameters help in quick differential diagnosis. In hospital management, there is no RCT evidence for using denosumab, but then zoledronate has conventionally been used very successfully in the management. So with that I conclude. Thank you.
So we have to first ascertain whether there is real hypercalcemia or not. Once we have done that, we have to find out what is the cause, then the management. Thanks, Dr. Anantharaman, for a nice presentation. Now, since many of our physician friends, they feel distinctly uncomfortable while managing these cases, I know there will be some definitely points needs to be clarified. So any questions or points? Dr. Mahapatra, please.
Excellent talk, a very convincing talk, like a teaching talk. We are physicians. I am a physician, senior physician located at Bhubaneswar. So elderly persons, 55, 60, they come with lethargy, drowsiness, sometimes nocturnal leg cramps, sometimes restless legs. We do a series of investigations what are required. In that case, we see serum calcium little borderline high, say about 12, 13. We are not able to do a corrected calcium. In such a situation, could it relate anything to the symptoms he presents, or how we further address
Sir, if you
borderline hypercalcemia with these symptoms?
these patients whom you see in the outpatient with slightly elevated calcium will invariably tend to have primary hyperparathyroidism. They'll invariably tend to have primary hyperparathyroidism, because symptoms, like I said, for primary hyperparathyroidism or mild hypercalcemia are non-specific. They are like hypothyroidism symptoms. We cannot say the symptom is exactly because of the calcium. So it's very difficult to say. And like I said, corrected calcium is required, but if you find a calcium value of 12, so I mean, unless the patient has a albumin of 2, you are not likely to miss hypercalcemia. So correction is more for lower calcium values rather than higher calcium values. If you see higher calcium values, please redo the test once more. Get the full profile, calcium, phosphorus, alkaline phosphatase, albumin. It gives you a lot of information. Like I said, lot of overdose of vitamin D is happening in the community, because people, instead of taking the vitamin D weekly, they end up taking it daily. There are overdoses which happen with the patient does not mention. Some remote injections given by orthopedic surgeons, it's very common. They give it weekly once, the 6 lakh IM. So these are all causes for hypercalcemia which is happening more frequently. So ask for a history of vitamin D ingestion and ask for this thing. So if we do this much, that's more than sufficient. Unlikely that it will be malignancy actually in the outpatient setting.
Actually, we will have to find out whether really the patient is having hypercalcemia or not. Sir, please. Dr.
No, yeah, beyond hyperparathyroidism and malignancy, because these are the two conditions where we are really concerned in case of hypercalcemia. But as you have already told, I am just citing one real world case within a minute. Just 2 weeks back, one of my classmates' wife, she came with hypercalcemia, history of vertebral collapse, pain, back pain. She got admitted in one of the tertiary care centers in Bhubaneswar. And again concerned, very much concerned with malignancy, hyperparathyroidism, all investigation rounds, coming to PET scan, everything, but everything was normal. But the history, as you have already mentioned, the history, her vitamin D level, that is something like that, more than 200 nanogram or something like that. And she was given teriparatide by the orthopedicians. So these are the two history, because teriparatide itself can also lead to
Yes,
hypercalcemia.
It's a very important point,
Yeah.
so you
So
brought it
these
up.
are the two conditions what lastly we analyzed and found that these are two conditions that had led to hypercalcemia, and gradually that came to normal gradually. So these are the conditions. So because nowadays vitamin D administration is so rampant, people give left and right, whatever, whichever doses they like. That's why that has led to this hypercalcemia.
Thank you, Dr. Aman. We
The
close
last,
this
one
session.
last question, sir.
Last,
Last question, yeah. Very nice presentation. I have a query. The hypercalcemic crisis, suppose it's really established, as Professor Patnaik has already pointed out, has to be repeated, really established, and the vitamin D3 and the calcium both all ruled out. Is it correctable by hemoperfusion or hemodialysis?
Hemodialysis is usually resorted to if the calcium levels are above 16 or 17, sir.
Yeah.
So in my last 10 years experience, one patient underwent a hemodialysis. In fact, she was actually a hyperparathyroidism patient, was diagnosed 6 months earlier, was awaiting surgery. She came for a routine visit, and then suddenly her calcium was 16 or 17. So though she didn't have much symptoms, the value was alarmingly high. So then we had to admit the patient, and patient underwent one episode of dialysis, though this thing. So for this is called basically a hypercalcemic crisis which happens in a hyperparathyroidism. So over a period of 5-6 years, if you follow up a hyperparathyroid patient without treatment, so they can have sudden episodes of flare-up. So I was indicating to you the intricate metabolism of calcium. Sometimes if the calcium excretion is reduced, or calcium reabsorption is increased, or intestinal absorption increases, some small aberration happens, then, or even the tumor itself growing can cause a sudden increase in calcium. So in such patients, we'll have to do a dialysis.
Thank you.
Yeah.
Thank you, Dr. Anantharaman. We close this session.
Next, I would like to request our chairperson, Dr. Bharat Panigrai, Senior Consultant in Medicine and Rheumatology at CARE Hospital and LV Prasad Hospital, and Dr. M.K. Chotrai, Senior Consultant Medicine at Apollo Hospital, to please come on the stage.
Thank you, Endeavor, for giving me this opportunity. So friends, the next topic is androgen deficiency in adults. And as you know, we have been coming across with so many diseases, specifically obesity, diabetes, and of course the aging process. And we do get this testosterone deficiency in the adults very commonly, but I think Dr. Sambit will be describing how to approach and when to treat, and what are the benefits of treating people or not treating people. So that I think Dr. Sambit will describe. So now I request Dr. Chotrai to introduce Dr. Sambit.
Dr. Sambit doesn't require any introduction. He single-handedly manages this Endeavor, this program. So he's the senior consultant in endocrinology in Apollo Hospital and a professor HOD in High-Tech Medical College. Please, Sambit, without spending much time, you start your deliveries.
Thank you, sir, for that kind introduction. So, all the time we have actually heard about menopause. So, hardly ever we come across the terminology known as andropause. So, I'll be discussing something on androgen deficiency in aging male, that is andropause. This is a very practical scenario. very common garden variety of patient which comes to our clinic. So how we are going to manage in terms of the androgen deficiency in this patient. So coming to the definition of male hypogonadism, hypogonadism is a clinical and biochemical syndrome characterized by persistently low levels of testosterone. I think this is very important that it's a persistently low level of testosterone with signs and symptoms of hypogonadism. So any patient who comes with a 30-page report of thyrocare with one report of low testosterone should not be taken into account, and it has to be persistently low testosterone report. So the signs and symptoms of hypogonadism in adult male is absence of secondary sexual characteristics, infertility, muscle wasting, decreased libido, impaired erectile function, muscle weakness, increased adiposity, depression, and decreased viability, and most are very commonly present in elderly people, so difficult to ascertain whether that's due to androgen deficiency or not. But these four things were present in our patient also. So there is a proposal that there should be a biopsychosexual model of andropause. So what should be the symptoms of andropause? There should be a biophysical, there should be a psychocognitive, and there should be sexual implications to andropause. Biophysical, it is sarcopenia, osteopenia, osteoporosis, loss of height. Cardiometabolic, there is increased adiposity. Trichocutaneous, it might be hair loss, cartilage involvement and all. Psychocognitive, hot flushes can also happen. It's not like menopause will only produce hot flushes. Sometimes andropause can also produce hot flushes. Loss of concentration, change in mood are few of the features. And sexual dysfunction like loss of libido and erectile dysfunction can also be other signs and symptoms of andropause. What is the epidemiology of ADAM or androgen deficiency in elderly male? Androgen deficiency increases with age in healthy men, and the incidence in the middle age is between 2.1 to 12.8%. There is the late onset hypogonadism has been shown to be between 2 to 15%, and there is a very nice study known as the HIM study. They have found that almost 38% of men above 45 years can have low testosterone level, which is persistent. And Indian men by Dr. Prashna Kumar et al., they have done some survey which they found that almost 20 to 48% of prevalence in men above 40 years of age can have low testosterone. And the association of low testosterone is quite marked with obesity and also with diabetes. Like prevalence rate of hypogonadism has been found to be as high as 45 to 57%. And European male aging study, there are 73% of men with reduced testosterone were overweight or obese. Serum testosterone with BMI more than 30 kg per meter square have actually 144 nanograms per deciliter lower in compared to the same age-matched population who are not obese. So obesity, diabetes per se can reduce the testosterone level. What is the classification of hypogonadism? We have two types of hypogonadism. Either it's a primary hypogonadism or secondary hypogonadism. Primary hypogonadism occurs when the testis is at a fault, so that the hormones like testosterone will be low, but LH-FSH level will be high. So when you do a test with low testosterone, if LH-FSH is high, probably we are dealing with a primary testicular failure. But when the GnRH axis and the LH-FSH axis is impaired, that will lead to a secondary hypogonadism. That means the testosterone will be low, LH-FSH either will be normal or will be low. So that is the secondary hypogonadism. And for ADAM, we are discussing mostly on the secondary hypogonadism, because for primary hypogonadism, there are other discussions in the later part of this symposium. And what are the causes of hypogonadotropic hypogonadism or secondary hypogonadism? Any condition which affects the pituitary axis or the hypothalamus can lead to hypogonadism. Obesity, older age, and the terminology which we are proposing or which we have discussing today is andropause, are all secondary hypogonadism where the pituitary hypothalamic axis is at fault. Some of the drugs can also affect the HPA axis. Now this slide is quite important because it clearly tells that the BMI quartiles, like the green one is BMI less than 25, the blue one is 25 to 30, and BMI more than 30 is red. You can see that and x-axis is the age, And you can see that as the BMI increases, the testosterone level is coming down in the first graph, and as the age increases, the testosterone level also comes down. The free testosterone level comes down over there. Coming to the evaluation, there are many questionnaires. I think there are this ADAM terminology is quite common for Western population, and they have devised many questionnaire, and one of the questionnaire is androgen deficiency in aging male ADAM questionnaire, and it has got 97% sensitivity for hypogonadism. We can apply some sort of questionnaire in our clinical practice also, but the most important thing is that we must confirm hypogonadism is present or not. And as I have told, patient coming with 30 or 40 pages of reports where the testosterone has been done, which has come once low and the patient is concerned, one should not be concerned about that. It has to be repeated on a particular fashion. Like there should be signs and symptoms suggestive of hypogonadism should be there. Early morning 8 am sample of testosterone should be taken in empty stomach, and at least 2 levels should be less than 300 nanograms per deciliter. Unless and otherwise all the 3 criteria are fulfilled, we cannot tell it as male hypogonadism. The things to ensure: the patient should come fasting between 8 to 10 am is the sampling, and the patient is not acutely ill. And the testosterone measurement has also some confusion, like total testosterone or free testosterone. Remember that for Indians, or we must do only total testosterone, because free testosterone, the accurate assay is by equilibrium dialysis and the free testosterone index, which is very difficult to do, and equilibrium dialysis is in most lab it's not available. So wherever the lab comes with free testosterone, it's probably not correct. So we must do a total testosterone. But the problem with total testosterone is that there are sex hormone binding globulin abnormality can affect the total testosterone measurement. I have just put it in a highlight. I'm not going into details of that. But this is the diagnostic evaluation how we should propose a patient with ADAM, that is clinical signs and symptoms of hypogonadism. We do a total testosterone. If it is less than 200 nanograms per deciliter, it is definitely a case of hypogonadism. We must do an LH assay after that. If the LH is high, then probably testis is at fault. That means the clean filter symptom, cryptorchidism, toxicity to testis are some of the causes. And if the testosterone is low and the LH is either normal or low, then probably we are dealing with hypogonadotropic hypogonadism. That's quite common, like GnRS deficiency, cellular mass, or the ADAM, or any functional causes which I have discussed. If the testosterone is more than 350, then leave the patient as such. Don't evaluate anything. Between 200 to 350, you have to repeat another testosterone assay. Coming to management in brief, the symptomatic improvement is the first criteria. Alleviate the signs is our next target. Maintain normal testosterone level and ensure no untoward side effects are present. And whenever you are prescribing testosterone, be sure that you are not doing any harm to the patient, because testosterone has got some other adverse events also. So patient preference is very important. Patient should be taken into confidence. Safety and efficacy are very important, and third is availability and the cost of testosterone therapy. Now these are the 3 points how we should diagnose the testosterone deficiency in the protocol which I have told. Clinical and biochemically rule out any of the contraindication. I will tell what are the contraindication. Do a medical and urological evaluation if the person is more than 40 years of age, and assess the indications for treatment and stringently follow the patient. These are the clear-cut contraindication where testosterone should not be given, like any metastatic prostate cancer or breast cancer we should not be giving. Moderate to high risk of adverse events like unevaluated prostatic nodule or induration, if the PSA is more than 4 nanograms per ml, or if it is more than 3 nanograms per ml in high risk population where the family history of CA prostate is there, if hematocrit is more than 48%, or there are uncontrolled lower urinary tract symptoms, or congestive heart failure, or recent onset of AMI and all. So these are the contraindication where testosterone should not be giving. So just a basic approach of how to progress. So first you diagnose whether it's a clear-cut ADAM, then psychological and cognitive and medical and sexual evaluation has to be done. If the symptoms are very severe and the patient is in significant distress and he or she tells that after knowing all the pros and cons about testosterone therapy and whether he is willing to take injection or not. If he is willing to take injection, use a aqueous testosterone for 1 or 2 weeks. If not willing for injection, then you can give a high dose oral testosterone on Deconet, which are currently available. If mild symptoms or minimal distress, no immediate relief is needed, we can start with a oral low dose testosterone, also BID or TID doses. After 1 to 2 weeks, definitely call the patient back. If there is satisfactory improvement, you continue with the therapy and the patient is willing to take injection, better to switch over to a longer acting testosterone injection which are currently available. Not willing for injection, you can use a oral testosterone or a gel. If there is unsatisfactory improvement, then rule out other causes and stop the testosterone right there. Because if the patient is not improving within 2 to 3 weeks of testosterone therapy, then probably it's not going to do any good. You may stop the therapy. So with that I'll end, summarizing that hypogonadism is quite common amongst elderly males and even higher prevalence when associated with obesity, type 2 diabetes. Optimal management should focus on symptomatic improvement and the patient should be motivated and there should be a clear-cut discussion with the patient. Overall biopsychosexual health should be given importance. Individualization of the management is very, very important. So with that I'll end. Thank you for the patient hearing.
Thank you, Sambit, for at least for your precise description of hypogonadism in adults. So as per your epidemiological study, I think 30% of this audience must be having andropods. So should they get treatment?
No, sir. So routine treatment is absolutely not indicated. First you confirm that testosterone deficiency is really there, because all the symptoms can be very vague. It may not be a testosterone deficiency. At least 2 occasions, 2 to 3 months apart, you confirm that there is a significant low testosterone and there are symptoms are suggestive, and then you can go ahead.
One small, there are reports are coming, many reports that statins, because statins are being used frequently, widely. Statins also, especially atorvastatin, that has also
Thank you, Chairperson, for kind words. Thanks, EDU Endocrine Diabetes Update 2022. And thanks to Dr. Sambit Das for giving me an opportunity to talk on a very important topic, diabetes in the young. I have no financial disclosure for this particular talk. We know that diabetes in young adolescent is really a worrisome. As young people are increasing, it is really a big challenge, both for the patients as well as for the doctor. Thanks, EDU Endocrine Diabetes Update 2020.
Pertinent question: why there occurs testosterone deficiency in insulin resistance or in diabetes? The fact is that there occurs a condition known as leptin resistance, and leptin is very important for activating the kiss peptine and the GnRH axis. So whenever in diabetes or in insulin resistance or in obesity there occurs leptin resistance, that can lead to secondary hypogonadism. That means the GnRH, LH, FSH and testosterone axis are affected. And regarding the treatment, what you have told, not all patients need treatment. Only when there is a documented significant persistently low testosterone and the patient is symptomatic, then we'll give. One just important thing I just wanted to add is that low testosterone is not a cause of erectile dysfunction. So never give testosterone to treat a erectile dysfunction, because even if we give testosterone, the erectile dysfunction may not improve. So that's one point I just wanted to make. Yes.
My question is, up to what age one can give testosterone safely?
Yes, sir. So there are Western data which is given up to 65 and 70 years also safely for testosterone therapy. But after 65 and 70 years, it is shown to have more adverse event rather than betterment.
Nice presentation.
Thank you, sir.
I think you have saved some time and started late but completed in your scheduled time.
Thank you, sir.
I have a doubt. Most of the diabetics are having hypogonadism. So the treatment line is almost same, or we have to approach them differently. And how long replacement?
Yes, sir.
So in them, those who have secondary causes of hypogonadism.
Yes, sir. Secondary causes of hypogonadism are many a times reversible. If we are going for a good reduction of the insulin resistance and lowering of the body weight and proper glycemic control, then probably it might be reversible. But if it is persistent, then we can try. And as I have shown in my last slide, how we should try. We give it for 1 to 2 weeks. If the patient is not improving, we immediately stop that. But if the patient has significant improvement, we may change over to a longer acting testosterone.
Thank you.
We are running short of the time. We will not. We will close the session now.
Thank you, sir. Thank you.
Thank you, sir.
Thank you, Chairperson. Thanks, EDU Endocrine Diabetes Update 2020. Thank Dr. Sambit Das for giving me an opportunity to talk on a very important in the young. I have no financial disclosure for diabetes. We know that diabetes in young adolescent is really particular. Worrisome. Increasing, it is really a big challenge both for the young. Development of diabetes at young age as doctors. Thanks EDU 2022 and thanks to Dr. Sambit Das for another very important topic, diabetes in the young. For this particular talk, we know that diabetes is worrisome. As young people are young, it is really a big challenge both for the patients as well as for the doctors. It is really at young age has several repercussions on health because it translates to significant morbidity and mortality productivity. The diagnosis and management of several unique changes, and many of which may not be familiar. They are accustomed to deal only with middle-aged and who are. So a correct diagnosis, motivating patients of time, a very regular follow-up compliance, patients have a long period in field of diabetes when we are dealing with diabetes. Diabetes in young patient is actually scenario. Still, type 1 is the most common, but we are seeing now that particularly even type 2 diabetes too. Young type 1 or type 2, they could be monogenic diabetes. Some are the type diabetes which are more common from the east part of the country, where diabetes is MMDM, or we can call it diabetes mellitus or fibrocalculous pancreatic diabetes. In young adults, still the age of onset is very important. Diabetes below the age of 12, still the most commonest reason will be if it is 12 to 25 or 30, there is a possibility is between it could be MODY or it could be type 1, and then we need it for these patients. This is an algorithm which is published for diagnosis. Diabetes Journal in 2007, and they are talking that if long diabetes, just try to find out what is the family history. If there is a is positive, there is a possibility of either two, either it could be family or it could be monogenic diabetes. The monogenic good, and they will have a response to sulfonylurea. Type 2 diabetes will have other signs of aggregants. They are also obese children, so this is in that way. And if monogenic diabetes, you are genotyping for subtype for a genotyping effect. Those who have families, they could be ketonuria positive or ketonuria negative. See for the negative is absent, try to get the autoantibody. It could be autoantibody. See autoantibody positive type 1 diabetes, or it could be autoantibody negative. Positive, poor, but there is a X-ray which shows pancreatic calcium. Also pancreatitis. There is a possibility these patients may have. It could be endocrine diabetes too. So a patient, a clinician who is young and between below the age of 30, you can suspect, depending on the history of ketonuria, X-ray abdomen, the investigations are required to confirm the diagnosis of the body. Some investigations. So type 1 in children, there is a position statement by 2018, and they just classified and still they had put diabetes to again the type 1 diabetes, but they had put that not very uncommon, and there is one more type 2 diabetes and it is increasing. They had also talked more than African American too. When we were talking about the Indian type 2, I mean Indian, it was not typical diabetes, which is commonly seen in only US. The challenges are there is a low level of awareness. Control is very high, and patients struggle to remain fully because there are significant psychological impact. Being missed or not taken as it is prescribed, and patients being for hypoglycemia, because many of these patients are on insulin. They are put on sulfonylurea, so risk of hypoglycemia is very high. Or patients protocol for a type 2 diabetic patients, those who have very resistant sign, think of type 2 diabetes patients, insulin. Otherwise, if they are symptomatic, if they be population, other insulin resistant sign, think of either MODI or A1C, fasting plasma glucose level, all are the investigation. But still the validity of HbA1c in pediatric populations for analysis clinical practice we do use for confirming the diagnosis for the where we are suspecting type 1 or type 2 or type 2 diabetes who are completely asymptomatic and HbA1c diabetes most to diagnose for confirmation. This is typical of good patients. See, even in a young patient, this is one of our patients which is had put in a clinical diabetes endocrinology below the age of communication having severe acanthosis nigricans. The monogenic patients who can be diagnosed even as early as 6 months of life, strong family history, they have negative autoantibodies. Well, for 1 to 3% of all young onset diabetes, genetic diagnosis for these patients will accurate therapy for an underlying genetic cause, and that is very therapy for these patients is a early onset diabetes. They are autosomal dominant inheritance, gene defects, and obesity is not common. Obesity possibility of type 2 diabetes becomes more. The is glucokinase mutation or either transcription diabetes Two are commonly mutations are there. Glucokinase mutation is present, but they have a stable hyperglycemia. 75% of them have transcription factor mutation. One third of them overchain, and one third of them are on a tight glycemic control because complications are frequent. There are other genetic tests which are done. There are slide which we have taken from Dr. Vimon, which is talking about this is the now he is doing at his center. It is a different analysis, more than 18 Moody investigations patients from all across the country also. The neonatal diabetes, we are saying the diabetes, first 6 months of life, not typical of autoimmune, again transient or permanent also. The FCPD could be pancreatic calcification coming from a tropical country. They already have very, very lean and thin patient. This is very typical of MMC type of patients we will find with a very lean and diabetes, very, very high, because they have very high insulin resistance. Not type 1 because they are severe hyperglycemia. They are even the C-peptide value may be low, but not those patients. This is LADA because it's low for growing type 1 diabetes patient. It's a subgroup of the patients who actually type 2 diabetes. And first time it was described in UKPDS. I know the type UKPDS, they were not responding initially to the Paul Gimet in 1995. This term, a latent autoimmune diabetes of adults, positive to the GAD, and they were having relatively less antibody even at the time of diagnosis or maybe after 6 months to implications of different type of diabetes. As I told you, the chances of complication for these patients are very, very high. For a lot of time, chance of microvascular complication, but young type 2 diabetic patients for risk factor 2. So these are the patients who are very micro and macrovascular complication. So screening for micro is here for all those patients, and even for macrovascular complications. One study which is the best drug for intervening. Out of different study which I had shown, the type 2012, this they were talking the patient between the age of the group. Patients were divided into 3 groups: metformin plus lifestyle. Other studies are also done. Trial where 45 months follow-up period. These patients were that these are the patients who can be started and even the glitazone also with the patient at the end of the second phase of the follow-up study, which the mean age of these patients who are included in this 4 to 22.8 plus minus. So when they were now at this point, it was 13.3 plus minus 1.8 when the therapy started, and in the second phase in January 2020 it was 26.4. Why I'm showing you this result, that is also diabetes in young age, particularly type 2 diabetes. Hypertension, dyslipidemia when they become at the age. And the nerve disease and diabetes kidney disease was 6. At least one complication had occurred. The participant in 2 complications were occurred. So conclusion is among participants who had on the 24 risk of complication, including microvascular complication, and affected most participants by the. So the follow-up of these patients shows that these are the particularly type 2 diabetes in young population, over diabetes also for microvascular complication. So we should not the serious cardiovascular event is been seen in the These who develop type 2 diabetes in young age, next 10 to 15 years, even the myocardial infarction, failure, and even stroke also in young age. This is the paper or in heart. The serious cardiovascular events in patients in mid-20s. Them lightly because they are kids. No, they are having kids to be more aggressively be treated with these. More there because of many of these medications cannot be used. Diabetes, particularly in type 2 diabetes, but SGLT off levelly across the world, people are using it also. I already told you that many of these patients have dyslipidemia, hypertension. Nice and spared in their guideline, they have put very clearly treated for hypertension and dyslipidemia. Two, even and obstructive sleep apnea is found to be very type 2 diabetes in the young population. This is one diabetes from India, where they found in even in 2011, 48% of the patients below the age type 2 diabetes. So in India also, it is increasing. A lot of young diabetes, not type 1, even type very guide registry, where they also try to see type 2, and they found across the country it is almost 20 patients below the age of 30 are type 2 diabetes. Managing these diabetes of young insulin, fulminant diabetes, always on insulin, LADA, insulin plus oral tablets, FCPD, eventually they need to be the sulfonylurea for MODY 1 and 3, otherwise insulin, sulfonylurea, and type 2 diabetes in young, preferably the patients who adhere to modification better glycemic control. Positive and nurturing patient chances they have making is a key in well-adjusted adolescent with diabetes. Behavioral therapy, providing telemedicine, reviewing blood sugar, and have shown some progress. And having a structured transition and education important and a future success in controlling diabetes. To some extent, diabetes is now perhaps the most common endocrine disorder in children and adults. Unique challenges, differential diagnosis wide, clinical course. Adolescent patient is prone to develop disease complication like but also because of suboptimal. Type 1 diabetes is diagnosed immediately, but other unlikely diabetes is often delayed, and that may also lead to complications. Combined with regular follow-up, maintenance of optimal glycemic control, judicious use of available therapy will ensure that these young people control by complication-free life in spite of diabetes. Thank you, Dr. Sambit, for giving me an opportunity. This again diagnose the patient. What exactly the diagnosis of this? And it should that will give you the correct way of treating these diabetology to treat for these patients. Thank you.
Hello. Hello. I'm not listening anything. Yes. Yes. Now I.
So we are expecting you at Bhubaneswar this morning. But your talk was excellent.
I'm missing hospitality. I think I'm missing you too. Hello. Some problem, but I'm missing too much. I think
there is one simple question. I is the old boy, when he comes to a physician, 40 years when he comes with a high blood glucose, old man, when he comes to a physician, this dilemma is existing in your it only see forget about antibody testing. What is your clinical?
Dr. Alok, very, very important and very pertinent question which you have. So, a 14-year-old girl comes and 24-year-old asks, just write oral anti-diabetic agent considering a 14-year-old might be type 1, but that may not be the most important thing is a clinical history. I think the of getting C-peptide and autoantibody, but isn't there possibility history can be taken? So one very important part of the examination is not diagnosed with significant weight loss or is any insulin deficiency. Think of that's number one. So if suppose she had come a 14 type 1 diagnosed, see whether is obese or not, see strong family history of diabetes or not. So now very easily history of weight loss, history of some like polydipsia, polydipsia, in 300 and many of them are diagnosed with possibility of a monogenic diabetes. Years, get the peptide. Now, as far as genetics, then our advanced center of genetics, which is run by the government, one can send the investigation for genetics of monogenic diabetes can be diagnosed. We can send the type will come within 1 month. That's number one. If you are in the dialysis and patients on insulin is always safe. Now, a 24-year-old sitting the patients of lean autoimmune, latent autoimmune diabetes of old age, we have to take the history. How much was the weight loss in because was started, what is control, whether it started with 5 patients. Now it is not controlled. So see the history. History itself is agent. I don't think that availability of C-peptide or I don't only way by which we can diagnose. Proper history, examination, what is only clinical value of diagnosis, and we must apply it is the algorithm which has been put by the pediatric diabetes. Yes. 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 I know in 2016, and dedication and very nice facts we have got. They already raised by the type 2 is common in this part of the world. Modified in school, they are very
cancer, IBA, classical presentation. And they can be pancreatic, they can be also here past we are patients of neonatal diabetes and young children, the infants and young children. So we will show this connection. The type 2, the malnutrition modified other type.
So I could hear, but the understand. But one thing, Jen, first of all, thanks for your comment. Understand very important comment here also for type 2 diabetes. Even what I want type 2 diabetes, now there is a definite clustering is been found. From India also, where I am also part of that group. Published one paper in Lancet Diabetes and Endocrinology. Even also we were classifying them only one variety of type 2 diabetes. Type which India is the first country where we had described there is a lean type 2 diabetes. India is again clustered in a different way. They could be obese in diabetes, or they could be insulin resistant, or they could be also diabetes. Also, we have typical type 1 diabetes, which is insulin diabetes in a separate condition. But type 2 diabetes also have a different in them according to their phenotype, and classify them whether they are a patient with insulin deficiency or a developing diabetes. And they have uniquely find one more condition where combined insulin deficiency and insulin resistance. We have in a Sweden group where they also tried to classify the type there. So we have a unique variety of to diabetes which is available in our country who are insulin cluster type resistance also. So each and every patient is with clinical history, clinical examination, and right now moving from individualized medicine to precision medicine. Continuous glucose monitoring and to find out what exactly patient. That is what the precision diabetes without going to tight glycemic control. That is key of it. But I'm sorry if I could not give the answer. Not listen you properly. I'm sorry for that, Jan.
No, this is the thing. What will you say about neonatal diabetes? If you are wrong defective, who are born
you are so neonatal again with it's a one variety of monogenic diabetes. Diabetes are of a two variety. One are permanent. They develop. It goes away within the next 6 months. Those the age of 6 months. I mean, the infants below the age of below. Most of the time, it is neonatal diabetes. Between 6 months to 12, it could be autoimmune. It could be neonatal also, or it could be neonatal is one of the genetic. If you find some glycemia, think of neonatal diabetes. Patients is very important. They respond to oral antidiabetic. These sulfonylurea, we had used the glimepiride in a in the dropper, and they respond to it. I have also to give diagnosed with a clinically, and then we sent diagnosis. These patients were treated. Luckily, both these two patients of mine, the neonatal diabetes had gone away. But there is a also the patient remained lifelong as a monogenic with sulfonyl lifelong also.
Thank you. Clarification as well of the audience is very clear. Just I had a small, I everything wanted to know a person
a young person. I got you here. Now, tell what is there to a monogenic diabetic or diabetic.
Saying is if somebody is responding to sulfonylurea, so what are somebody is a monogenic diabetes? That's not true. As per the literature, the monogenic diagnosis of diabetes diagnosed only is stamped when you have a diabetes diagnosis. But clinically, yes, a sulfonylurea response. You can think of that these are the patients with monogenic diabetes. Patient.
We will definitely like to interact with you more and more.
I am also.
Better we see you next time with you. Just a last comment. The person is taking sulfonylurea can be
very true, sir. Very true.
They can be considered. Thank you, Vansi, for all the best. Thank you, everyone.
Good evening, everybody. Now we are having a topic, the topic which was scheduled that has been changed, and we are having a topic, evidence to experience, choosing the right DPP4 inhibition. So you know, the gliptins are the drugs which have already changed the diabetic treatment scenario, and they are very important drugs in the Indian context. And we are having out of the gliptins, we are having DP4 inhibitors as well as GLP-1 analogs. But in the Indian context, GLP-1 analogs are very costly, and we are using it very rarely. Most frequently, gliptin used in the Indian context is the DP4 inhibitors, and everybody has experience about this drug, and Dr. Abhay will be speaking on this drug.
Everybody knows Dr. Abhay Sahu. He is a very well-known endocrinologist of Odisha. He was organizing secretary of ESICON 2018, and he is a EC member, Endocrine Society of India. He is a reviewer of big international journals of endocrine metabolism. He has many publications, both international and national publications, and he is also awarded with Rajdhani Gaurav and Ekamra Shri Award. And it's Dr. Abhay Sahu, you can carry on.
Thank you, respected chairpersons, Gandharv sir and Dr. Chandan.
Shri Award. And it's Dr. Abhay Sahu.
Thank you, respected chairpersons. We are going to discuss DP4 inhibitor. Probably in this August gathering, everybody has used DP4 for last almost 1 to 1.5 decades. And everybody has quite a good experience with DP4 inhibitors. So now we'll discuss evidence to experience choosing the right DP4 inhibitors. So if you see the current scenario diabetes in India, then probably more than 50% diabetic are undetected or undiagnosed, and the diabetes control in India is quite in a poor state. That means almost average HbA1c is found to be in close to 9%, and more than 60% patients fails to meet HbA1c of less than 7%. Hence, the therapeutic strategies to reach the target HbA1c in each and every patient is much most important, and we have to think about what are the strategies that we have to plan out our management accordingly for the diabetic patients. And for long-term durable glycemic control is quite a difficult goal to achieve among the Indian patients. Why? Because despite of well-defined treatments, majority of people have actually poor control, almost close to 76% patients poor glycemic control, and majority of the guideline recommends HbA1c of less than 7% as a target for particularly optimal management of the diabetes patients. And we know that there is a progressive decline in the beta cell, and it is one of the key challenge for control of the blood glucose among the diabetic patients. And this is the underlying loss of beta cells early in the type 2 diabetes, which is a serious concern. We know that this is the beta cell mass, and when by the time diabetes starts, almost a decade has gone, and by the time when someone is detected diabetes, more than 50% of the beta cells has already gone. So whatever the thing, or with subsequently few years probably that beta cell is further exhausted, and ultimately patient needs insulin therapy or some sort of therapies which will actually work without beta cell. So this uncontrolled hyperglycemia leads to accelerated beta mass loss, and there occurs also a functional deterioration of the, and that is due to specifically due to glucotoxicity. Hence, we need certain things like beta cell preservation is utmost important in the early course of diabetes, and that leads to a successful treatment in the subsequently, and also that helps in the prevention of the complications. So the need of the hour is the therapy should show at least an intensive, long or durable glycemic control that also protects with the recovery of the beta cells. And the most promising strategies is the successful diabetic management. And first thing will come to the metformin is metformin monotherapy, because we know all guidelines tell that metformin monotherapy is the first thing should be started. Is it the choice in the newly detected? This is that the metformin monotherapy tends to fail early, because if you see the monotherapy versus combined therapies, you see within 78 weeks, that means close to 1.5 years, metformin monotherapy fails to work. But if you are starting from the beginning a combination therapy, probably it works up to 5 years. So hence, if you differentiate between metformin versus a combination therapy, probably giving a metformin alone is not sufficient, or is not have a durable action or durable therapies. So 50% patients fail to metformin within 1.5 years versus 4.75 years in the early combination therapies. And that is, this combination is totally from the Verify trial, because we know Verify in that they have taken or given started therapies of combination of metformin and vildagliptin on drug naive type 2 diabetic patients. What they found, up to even 5 years actually there is durable, or that patient did not require any change in the medication, and majority of the patients actually has HbA1c less than 7%. And among Indian population, the combination shows almost a 53% risk reduction in time to initial failure. If you see, that is that for the patients with the event or shows initial failure or incidence of failure, it is 43% with early combination, whereas if you are going for a monotherapy, it is 60%. So that means if you are starting a combination from the early part, probably the durability is quite high, or we can have a durable therapies. So based on this Cox regression model analysis, the combination group showed a significant lower risk reduction of particularly time to failure in comparison to a particularly with the single base therapies. Then second part is majority time we use sulfonylurea with metformin. This is the probably the most common combination what classically we go in the clinical practice. So the concern regarding the use of sulfonylurea is the secondary failure rate is significantly high. There is lack of durability. That actually the building up particularly specifically that ischemic myocardial ischemic preconditioning is blunted. The weight gain, hypoglycemia and mortality. All are there are certain things which is actually associated with particularly specifically with the sulfonylurea therapies. And if you will see the sulfonylurea metformin combination from the what we have learned from UKPDS, that sulfonylurea had no protective effect on the beta cells. If you are using sulfonylurea alone, probably it has no protective effect, but of course the blood glucose control is utmost important. If you are controlling the blood glucose, if you are controlling the HbA1c, probably that has good effect on the particularly future complications. That is there. But if you think those who are on the sulfonylurea group, they actually have a early beta cell exhaustion or there was a early failure, and the combination of metformin and sulfonylurea resulted with a progressive decline of beta cells, and this combination has little bit less or slower progression return of the beta cell failure in comparison to giving sulfonylurea alone. And by 3 years, up to 50% of the diabetic patients required additional pharmacological therapies which make the HbA1c less than 7%. So that is beta cell exhaustion will be there, and also it is lack of durability with this particularly with use of this drug. Again, beta cell exhaustion from the sulfonylurea, if you will see, this failure of beta cell to respond sulfonylurea leads to decrease in the number of beta cells. This secondary failure, increase in the blood glucose, and that probably causes long time overstimulation of the beta cells due to sulfonylurea. There is increased beta cell defect, increased insulin resistance, also glucotoxicity. All those plays a critical role for specifically for this beta cell exhaustion and also secondary OHA failure specifically with the sulfonylureas. Again, this is the lack of durability that is actually study with sulfonylurea versus metformin, which has clearly shown that again there is 74% increased risk of overall monotherapy failure over a period of 5 years with sulfonylurea. That means if you are using sulfonylurea, probably within 5 years the sulfonylurea resistance or failure to sulfonylurea will be there in almost close to 75% cases. Again, this decline in the beta cell function, because we know that whatever the drugs we give from the beginning, it's with lifestyle, then we start monotherapy, the subsequently we add another drug. There will be a particularly stepwise pattern of the HbA1c that shows that majority time the blood glucose remain uncontrolled, and this combination of sulfonylurea and metformin probably that is actually there, that remains, that result in the failure because the patients are allowed to remain in the hyperglycemic state for a quite long period, and this is the reason, and this glucose toxicity itself is one of the important factor which causes beta cell failure or decrease in the beta cell functions. And the effect of the glycemic parameters in the newly detected type 2 diabetic patients, you will see, then we take HbA1c, fasting, postprandial and beta cell, then that is the HbA1c, if you will see, again, this is the randomized control trial among the newly detected type 2 diabetic patients with Vilda metformin versus sulfonylurea combination, then probably the combination as actually both are almost equal. You see with Vilda metformin there is HbA1c reduction in 3 months is 3.23 versus 3.1. Again, p-value is found to be statistically significant, and again by 12 months, and that is also that p-value is found to be statistically significant. That means a Vilda metformin combination is far better than sulfonylurea and metformin combination even if at 3rd month, and that is maintained up to 12 weeks. Again, on the fasting plasma glucose, it is 51 versus 57, which is again found to be statistically significant. So Vilda metformin, again you can say it has Vilda metformin has little bit superior fasting control in comparison to this sulfonylurea and metformin group. And postprandial control, similarly, postprandial control is found to be superior compared to similar reduction of the as early as up to 3rd months, and that is numerically it is built with Vilda metformin, it is better in comparison to sulfonylurea and metformin group. But the most important crux is what is happening to the beta cells. You see that with Vilda metformin, there is actually HOMA beta is improved by 17, close to 18%. That means there is the beta cell function is being preserved, but here there is reduced by almost 2%. That indicates that we have almost similar fasting control, we have almost similar postprandial, we have almost similar HbA1c control, but at the cost of preservation of the beta cells. And that is the advantage of particularly, specifically with particular DP4 metformin combination in comparison to the sulfonylurea and metformin combinations. Hence, the DP4, a novel therapy addressing the particularly complexities of management of type 2 diabetic patients, and this therapies like DP4 ensures a good glycemic durability and good beta cell preservation, and this DP4 actually that prevents breakdown of the GLP-1 we know, and this inhibition of DP4 leads to reduction in the glycemia, the blood insulin level is maintained, glucagon level is also reduced, that preserves the beta cell mass, also decreases the beta cell apoptosis. So this is some of the basic pathophysiological mechanism how this DP4 acts. So the advantages of DP4 with international guidelines, it is efficacious, it has minimal risk of hypoglycemia, it is found to be weight neutral, it is very well tolerated. Probably that is one of the drug in the diabetic armamentarium which can be given with telephone. There is no need to see the patients. That is the beauty of specifically these DP4s. And other advantages is cardiovascular shape, it is durable, low glycemic variability, and again there is no significant drug interaction is there with particularly use of this DP4s. Then which DP4 to be right choice? Then again depends on some factors like what is the how much the percentage of DP4 activities inhibited, then what is the efficacy, then glycemic variability, and the safety regarding the two parts. One is hypoglycemia and weight gain part. If you will see the DP4 inhibition, probably this actually vildagliptin has highest, almost also both are almost similar all four, but vildagliptin has little bit highest in comparison to the other. And again the vildagliptin inhibits the DP4 activity even after dilution as opposed to sitagliptin, that is that with serial dilution, that again shows Vilda has little bit superior actually HbA1c, superior DP4 inhibition in comparison to the sitagliptin. And what is the ability to achieve the target goal HbA1c? It is almost similar. Though numerical there is some difference, but it is almost similar in all groups. There is no significant difference. Again, what is the ability to achieve a target less than 6.5 or even if take less than 7? Everywhere it is found to be similar. There is no difference in the group. And if you will see the fasting response, again, though numerically Vilda is little bit superior, then of course there is almost similar. There is no significant difference. But a fasting from the baseline with 14 days, there is numerically greater reduction, but again it is not found to be statistically significant. Then the glycemic variability with Vilda-Sipta, that is one of the study which has clearly shown that MAGE is most commonly used the metric of the particular evaluation of the glycemic variability. Here with vildagliptin, the glycemic variability is significantly less in comparison to the sitagliptin, and that is the advantage, and that this study has clearly shown Vilda is actually far superior than sitagliptin for glycemic variability point of view. Again, if you take the incidence of hypoglycemia, it is almost similar between no significant difference, but there is some numerical differences there, but it is almost similar. There is no difference in the groups. Again, body weight point of view, all are found to be neutral. There is no significant difference. So Vilda 100 daily shows highest probability of reducing the body weight comparing the gliptins, but theoretically there is no difference in the particularly with any of the drugs there. So compared to the gliptins, if you will see the vildagliptin, 97% DPP inhibition, better fasting and HbA1c reduction, low glycemic variability, low risk of real world studies, and also it is with Verify has clearly shown it is 5-year durable studies are there with particularly with the Verify trial. So vildagliptin is one of the preferred DPP4 inhibitors. Both it inhibits DP4 action, achieves target HbA1c, also reduces fasting, shows low glycemic variability. In compared to other gliptins, the risk of hypoglycemia, weight gain and CV events is found to be neutral, and that is the preferred drug which is actually for particularly specific for the DP4 inhibitors. So therapy which shows intensive low turn glycemic control and protects recovery of the beta cells could be most promising successful therapies, and DP4 ensures good glycemic durability with beta cell function, and vildagliptin demonstrates better efficacy and safety profile in compared to other gliptins. Thank you.
Thank you, Dr. Abhay Sahu, for the wonderful talk on comparison of DPP4 inhibitors and their effects. And the evidences are quite clear that from all the big studies that sulfonylurea is not going to protect the beta cell mass, but still the juggernaut of sulfonylurea is not stopping. It's still going on in India. We can have few questions from the audience. If
when all your audience are silent, then I can start the question. So 3 things are coming. One is, this is gliptins are giving beta cell protection. Whether it has been proved in human beings, that is number 1. Then second thing, we are using gliptins for the last 1 decade. Suppose a patient has come with a fasting blood sugar more than 200. So whether you will start with the vildagliptin and metformin in this group of patients, because I am telling about moderate to severe diabetes. And third thing is that if you are choosing gliptin, you are telling vildagliptin is in its efficacy is 97% in comparison, but other trials have shown that sitagliptin is better. Some are telling linagliptin is better. So about this controversy, you are talking everything in favor of vildagliptin. So how can you account for that? Other literatures are telling that TECOS trial, all these things, that has passed the CVOT trial, but vildagliptin has not passed the CVOT. And about this MACE, reduction of MACE, I don't think none of the gliptin is protecting MACE. They are non-inferior, but they are not having reduction of MACE is not there with any of the gliptins.
Yeah. Thank you, sir. The first part of the question is that whether it is this beta cell preservation is actually in the human being or not. That with human being, human studies with beta any DP4, there is no human studies to show whether really the beta cell mass is being preserved or not. But these are all indirect evidences which has actually HOMA beta, they have calculated HOMA beta where actually they have shown that probably it is actually preserving the beta cell function. But animal studies has clearly shown that all DP4s are actually reduces the apoptosis of the beta cells. These are the animal studies which is not classical in the human being, it's not there. But these are the indirect evidence which has clearly shown that DP4s are actually associated with less beta cell apoptosis, first part. Second part is efficacy point of view. Efficacy point of view, all gliptins are same. There is no difference between any gliptins. So I am not, since this is a vildagliptin topic, so why I have shown what are the advantages of vildagliptin. I am not advocating that you should try vildagliptin alone. So all are same, first. Second part, third part is regarding the cardiovascular safety point of view. TECOS is there, which has clearly shown it is neutral. It is not advantageous. Vildagliptin, there is a VIVID trial, which is very small trial, with less than almost close to 200 to 250 patients. That is also shown neutral, but again, there is no, a landmark CVOT trial is not there with vildagliptin. And third part is regarding the saxagliptin, again, initial results of Severtimi came that probably the saxagliptin has increases the heart failure. But subsequently what they have shown that those group of patients, those who are having baseline BNP was significantly high, probably they have developed heart failure, not the whole cohort have developed. But subsequent meta-analysis has clearly shown that whether you use any sort of gliptins, whether it is Vilda, Saxa, Sita, any gliptins, there is a small tendency towards heart failure with each gliptin. So it's not like that any gliptin, so there is a small tendency, small leaks towards heart failure. So from the as a heart failure point of view, probably that is as a group there is there with particularly with every drug. But for the efficacy point of view, there are studies with Sita, there are studies with Vilda, almost similar. But from the MACE point of view, glycemic excursion point of view, there is a good study which has clearly shown that vildagliptin is having less, with glycemic excursion is less, or variability is less in comparison to sitagliptin, but Sita has now actually shown similar studies with specifically taking vildagliptin point of view. So that is one thing with Vilda, but otherwise from the efficacy point of view, from the DP4 inhibition point of view, from the cardiovascular point of view, what I have discussed probably.
Thank you, Abhay, for your neutral comment. Thank you.
Sir.
Sitagliptin came with a bang. Have we given it up? Sitagliptin.
Teneligliptin?
It came with a bang. All of us used it. Now where do you place it now?
So actually, this is also same thing what from the efficacy point of view, I can tell that all gliptins are similar. So even if with teneligliptin, that is the efficacy point of view similar. And again, from the trial point of view, there is no dedicated trial with teneligliptin to tell what is the cardiovascular point of view. And but efficacy point of view, it is almost similar. And with teneligliptin, there is a Indian trial, also there is a Korean trial to see the glycemic variability. And they have shown it is also teneligliptin is at par with sitagliptin. So there is a thing what actually with teneligliptin, but otherwise there is no dedicated CVOT trial with teneligliptin, and efficacy point of view almost similar with other gliptins.
Before winding up, I just want to ask you one question. You know, in Indian diabetics, we are coming to your clinic where I mean, they are young, newly detected type 2 diabetes without having any history of cardiovascular disease or any family history or any risk factors towards cardiovascular disease. And they are visibly not very obese. They are like BMI in little higher side, but they look, I mean, the visceral fat must be high, but they look lean. What is your take? I mean, you will start with metformin, you will start a gliptin or a SGLT2 inhibitors. They don't have any cardiovascular comorbidity.
So actually, that is the thing that what I have discussed probably, that in this COVID era, when you are not directly seeing the patient, just you have actually have some data of the patient, blood glucose, fasting BP, HbA1c, and body weight like that. Probably this is one of the medicine which can be self-prescribed in telephone. That is gliptin. But vis-a-vis to tell that if you will see the last 1, 2, 3 years guideline, probably everybody has advocated SGLT2 or GLP-1 receptor agonist before even if gliptins. So looking at that, if someone is having no family history of coronary disease, no risk factors, still if someone is obese, probably a SGLT2 inhibitor is a good choice. But if someone is a normal weight, in that case, whether it is SGLT2, whether it is a DP4 with combination of metformin, both can be well prescribed. That is, should be the individualized choice or individualized thing for the physician himself.
Dr. Chandan, you ruled out totally sulfonylurea in this case. You never mentioned that such patients can also be given glimepiride or anything. Dr. Sahu, your opinion, please.
Yeah, actually, people see again, sulfonylurea is the bread and butter of each and every physician who are treating diabetes, specifically in our country. And even if you go to the WHO guidelines, they have placed sulfonylurea. Those who are having poor, those who cannot afford, they have kept sulfonylurea as an option. And looking at that part, probably even if we can use, whether it is DP4, whether it is SGLT2, whether it is sulfonylurea, all can be used in a newly detected. But of course, as the guidelines, all guidelines telling probably SGLT2 first, then DP4, then sulfonylurea. If you tell me probably this is the sequence where will be the preference of particularly starting the medication in particularly newly detected type 2 diabetic patient.
Thank you, Dr. Abhay. I think we have cafeteria choice for our physicians. We have so many drugs, but it has to be individualized. Thank you, Dr. Abhay, for the wonderful deliberation. I think we'll wind up the discussion here. Thank you.
Thank you, sir. Thank you, chairpersons. I request you to please proceed to the presentation area. Sir. Next, I would like to request our chairpersons, Dr. Sisir Kumar Mahapatra, Senior Consultant of Medicine. He is the Chairman RSSD Odisha State Branch, and Dr. Manoranjan Tripathi. He is a Consultant Endocrinologist at Kalinga Hospital, Bhubaneswar.
So, dear delegates, after a very long and useful discussion with the DPP4 inhibitors, I assure you this will be still more interesting, because the oldest and the longest treatment option for diabetes is insulin. And this pre-mixed insulin is very widely prescribed in our country by almost all the physicians. Do you know why? Because our patients are typical Asian Indian phenotypes. They do have a great cardio-metabolic risk for different cardiac diseases. We are all carbohydrate eaters. Our PPHG, those patients we are treating, they have high postprandial hyperglycemia. In that context, today, and most widely we are prescribing pre-mixed insulin are a co-formulation insulins. And we have none other than today Dr. Partha Pratim Chakravarti, He will be introduced by my co-chairman, Dr. Tripathi.
Thank you, sir. I welcome Dr. Parthapratim Chakravarti to deliver his topic on today's topic. He is working as assistant professor in Department of Endocrinology in Medical College, Kolkata. He has multiple publications in national and international journals, and he is the author of many book chapters. So I hand over the session to Dr. Parthapratim Chakravarti.
Thank you, chairpersons. Very good afternoon to all of you. My job has been made much easier by my chairperson because he has already summarized my talk. So before I proceed, let me thank my good friend Sambit for having me here this morning. Before I proceed, let me tell you that I am here not to propose that premixed insulins are the best amongst what we have on board. I would rather discuss the reasons why premixed insulins should have its own position in clinical care. Now, I don't use premixed insulins in these scenarios for two reasons. Number one, they are not appropriate for individuals having absolute endogenous insulin deficiency. And number two, they do not offer you that flexibility you require in patients with fluctuating and unpredictable calorie intake and ever-changing metabolic demands. Now, basal bolus insulin is supposed to closely mimic endogenous insulin secretion, right? And this is the typical time action profile of any premixed insulin with its inherent disadvantages like early postprandial hyperglycemia, interprandial hypoglycemia, nocturnal hypoglycemia, and fasting hyperglycemia. Having said that, no insulin closely mimics insulin physiology because endogenous insulin is secreted in the portal circulation and the portal venous east to peripheral circulatory insulin concentration is around 2:1. Exogenous insulin is administered systematically, so the concentration is absolutely reverse. And if you want to achieve the adequate concentration of insulin in the portal vein, you have to achieve systemic hyperinsulinemia. In addition to that, it's virtually impossible to mimic insulin physiology. For an example, you cannot mimic the ultradian rhythm in basal insulin secretion. You cannot mimic the two phases of postprandial insulin kinetics. Coming back to basal bolus, this is a patient of mine, a long-standing diabetes on basal bolus. Look at the changes in fasting glucose, the changes in the post-breakfast glucose, changes in the pre-dinner glucose, and the changes in the post-dinner glucose. And this is the AGP, what it looked like. So basically, even basal bolus insulin therapy is a kind of compromised science. Now, it's not that premixed insulin does not offer you any flexibility whatsoever. You can achieve earlier and more pronounced peak in postprandial insulin concentration with premixed insulin analog compared to biphasic insulins, or you can choose a mid-mix or a low mix depending on the dietary pattern of your patients. Now, why is that important? Despite all our claims, despite so much hue and cry, look at the percentage of patients of India with type 2 diabetes achieving a glycemic target of less than 7. In 2011, it was 19.7. We are doing a bit good. In the latest publication in 2022, the ICMR India 13, 36.3% of our patients with type 2 diabetes achieve a target glycemic control of less than 7. What does it mean? It means that if we really want to win the war against diabetes, science probably is not enough. We have to use science with a little bit of arts and a bit of commerce. And how do we initiate insulin? The 4-tree trial suggested that if you initiate with premixed insulin twice a day, you achieve better post-meal glycemic control, you achieve better A1C, albeit at a risk of hypoglycemia and weight gain. However, it needs to be remembered that the dose escalation was pretty quick because of the study design, and many of the patients were on concomitant sulfonylurea that might have led to increased risk of hypoglycemia. A significant greater number of patients on Lispro mix in the durable trial maintained target A1C for a longer duration of time compared to basal glargine. And the findings remain unchanged, unaltered across studies. You achieve better A1C with premixed analog compared to basal. However, there is a chance of hypoglycemia with premixed insulin now. Switching from individual studies to meta-analysis, premixed insulin analog are as efficacious as human premixed insulin. However, scores much better than basal insulin as far as reduction of post-meal glycemia is concerned, reduction of A1C is concerned. Once again, there is a risk of hypoglycemia. And this is another meta-analysis published in Diabetes Care. Those with biphasic aspart achieved, more patients achieved a target of less than 7 with a little bit of hypoglycemia. Interestingly, if you look at the physician's perspective, this was taken from the ACHIEVE study. Physicians participated in the ACHIEVE trial. They thought somewhat different. They thought that their patients who were on premixed insulin analog had less risk of hypoglycemia and had less weight gain. So how do you choose insulin before initiating therapy? Now there are different difficult calculations, those have been put forward. What I would suggest, you take a difference between fasting plasma glucose and the post-meal plasma glucose. Now the authors in this particular study suggested a cutoff of 45, personally I take a cutoff of 100. If the difference is less than 100, you target fasting with the basal insulin, you are likely to get a control over the post-meal plasma glucose. If the difference is more than 100, I try to find out whether the patient takes single meal or a twice meal. If there is a history of single large meal, we start it once a day, and if the particular patient takes 2 large meals twice a day, I give premixed insulin on a twice daily basis. All the consensus guidelines, the National Insulin Consensus Guidelines, it recommend both human premix and analog premixed insulin as a first-line insulin for initiation. In fact, the ICMR also recommends premixed insulin to start with, and there are other guidelines, there are other consensus guidelines, experts' opinion, which also suggest that premixed insulin, either human or analogs, should be used in India as a first-line therapy. You start with 10 unit, depending on whether the pre-dinner blood sugar is high or the fasting blood glucose sugar is high, you gradually up titrate, and if the insulin dose requirement is more than 20 units per day, you divide the dose into twice daily basis. It's even easier to up titrate depending on simple algorithm. You can up titrate depending on the blood glucose value. Now once you initiate, how you intensify. Now according to the 4T study, you can intensify with a single shot of prandial insulin before lunch. However, you can also initiate with the same premixed insulin on a thrice daily basis. A thrice daily premixed insulin is superior to twice daily premixed insulin, particularly in individuals with a A1C level of more than 9%. This is as good as a basal bolus insulin if you look at the efficacy and if you look at the safety as well. So you achieve similar A1C control without causing significant hypoglycemia with somewhat fewer pricks. And this particular fact was evaluated in a randomized controlled trial, the so-called 1-2-3 study, in which they uptitrated a premixed insulin from once daily to twice daily to thrice daily basis. Once again, a very important finding in this particular study was that thrice daily Lispro was compared to basal bolus insulin therapy. The glycemic control was similar. What is even more important is that if you look at the 8-point SMBG, there was no difference between the two arms. And that came with a similar risk of hypoglycemia, be it nocturnal, be it severe, be it overall. Now we have moved forward from glycemic triads, that is fasting plasma glucose, post-meal plasma glucose and A1C. We have moved forward to tetrads, pentads, and hexads, and glycemic variability remains a concern nowadays. Premixed insulin, when combined with alpha glucosidase inhibitor or with a DPP4 inhibitor, it reduces MAGE. In the last session, we are having discussion on MAGE. How does a gliptin reduce MAGE? This is simply because of elevated GIP. Unlike GLP-1, GIP is a bidirectional hormone. During hypoglycemia, it stimulates glucagon, protect against hypoglycemia. During hyperglycemia, it inhibits glucagon. Meaning thereby, if you add a gliptin along with a premixed insulin or even with sulfonylurea, an individual is like to mount an hyperglucagonic response during hypoglycemia. So you get some amount of protection against hypoglycemia and you reduce the MAGE. So it's no wonder that bodies like RSSDI or the ESI have recommended premixed insulin both for initiation and maintenance for individuals with type 2 diabetes. So how do you intensify with thrice daily premix? You start with a 10% of total daily dose before lunch. For an example, if the total daily dose is around say 60 unit, you start 6 unit before lunch, then you might have to reduce the pre-morning dose by 2 to 4 units, and then you adjust the dose according to the SMBG level. And this is the recent publication published in last month. Majority of our colleagues treating diabetes, as already said by learned chairperson, they prefer a insulin which takes care of both fasting and the plasma glucose, which is possible with premixed insulin analog. You cannot achieve a significant post-meal plasma control over post-meal plasma glucose with basal insulin only if the difference between fasting plasma glucose and the post-meal plasma glucose is pretty high. So putting premixed insulin in clinical care, and to conclude my talk, this is simple to initiate. You can start with OD or BD dose depending on the blood glucose level. You can give the sulfonylureas in the morning and the insulin in the night, the so-called BIDS protocol, or you can also use a gliptin in the morning and the premixed insulin in the night. It's convenient to uptitrate. There are numerous algorithms by which you can uptitrate insulin. Because of a single injection, there is less chance of dosing error. There are probabilities of vial needle mismatch. You need not mix insulin. You need not take different insulins. It gives you excellent fasting and the post-meal coverage. There is effective and durable HbA1c control as seen in the durable trial. Depending on the meal pattern of your patients, if he takes a blanch, you can use a mid-mix, that is 50-50 in the morning, or it takes the usual breakfast and a heavy lunch in the afternoon. You can use a low mix 30-70 in the morning. There is suggestions of reduction in glycemic variability when combined with alpha glucosidase inhibitors or a DPP4 inhibitors. And once again, if you are not comfortable with a thrice daily premix, you can add a single bolus of post-meal insulin before lunch. And our colleagues in India treating individuals with type 2 diabetes, they prefer premixed insulin because it takes care of both fasting plasma glucose and post-meal plasma glucose. And they think that this is associated with somewhat less risk of hypoglycemia and less weight gain. Thank you for your patience.
Thank you, Dr. Chakravarti, for your very comprehensive talk. You also highlighted about human insulin and human premix analogs, and also aiding OADs, the advantages with insulin that also you have highlighted. So this must be very useful to your physicians. But after one or two very doubts, we'd be asking questions from the audience. In pregnancy, which one you prefer, a human premix or analog premix? And
Sir,
why?
Sir, both. You have safety data both for human insulins and aspart and lispo. However, if you look at the kinetics or the glucose kinetics of pregnancy, the post-breakfast blood glucose are likely to be higher. So you can achieve, as I have said, a faster and a pronounced insulin peak with insulin analogs. So you can use a premix 50-50 analog to take care of that glycemic excursion during pregnancy, which happens immediately after breakfast.
Now tell me, what are the situations you just inject premix insulin before dinner and sometimes before bedtime? Is there any difference in our Indian setup?
Sir, I don't use premixed insulin before bedtime. I always use premixed insulin before meal, either before breakfast or
any dose schedule of pre-formulations, co-formulations, like we are giving this premix insulin 0.2 or 0.3 per kg body weight. Is there anything like that when you prescribe co-formulations, any schedule of
Sir, as I have said, if the difference between fasting plasma glucose and the post-meal plasma glucose is less than 100, I continue daytime sulfonylurea, give either a pre-mixed insulin or a basal insulin at bedtime, usually around 0.2 unit per kg per day. It comes around 10 to 12 units per day in most of my patients. Now, if I start with a premix twice daily, particularly for type 2 diabetes, the starting dose would be around 0.5 unit per kg per day. For an example, in someone who is weighing about 60 kgs, I start with 30 units, 2/3 around morning and 1/3 in the evening. I don't continue sulfonylurea if the patient is being put on twice daily premixed.
No, I meant co-formulation, like I take as.
Okay, okay. So that's a different issue altogether. These are co-formulation. The kinetics are not that different. They can be, interchanged.
So it is left to the audience. Anybody, any questions?
Will you use premix insulin once a day in
Yeah,
any situation?
yeah. Like
Then
for
when you will use it and what is the time? Whether it should be before breakfast or before dinner? Anything?
It all depends whether the fasting plasma glucose is high or the pre-dinner plasma glucose is high. For an example, if the fasting plasma glucose is high, I continue sulfonylurea in the morning and start premixed insulin before dinner, right? If the pre-dinner blood glucose is high, I start premixed insulin before breakfast.
No, actually, if the fasting plasma glucose is high, it is better to start with a basal insulin rather than giving a premix.
Yeah, that's fine, sir. The point
then,
is.
If both are high, either the the fasting plasma glucose and the postprandial, then premix is better.
Now,
but if the only fasting is high, it is always better to start a basal insulin.
Yeah, as you have rightly pointed out, if the fasting glucose is high, even if you use a premixed insulin before dinner, for an example, if you give 10 units of premixed insulin before dinner, you get 7 units of basal insulin in the form of NPH. It's not that you are not getting basal insulin. In addition, you get a post-meal coverage after dinner with the soluble insulin it has. So you get a post-meal coverage after dinner, and you get a fasting coverage if you use a premixed insulin before dinner. And if you use only basal insulin before dinner, you get a coverage against fasting only. That's the point. You can choose between fasting plasma glucose and basal insulin and premixed insulin depending on the blood pressure.
Just a comment to make to your question. I think the preferred insulin in GDM is analog insulin. There's no doubt about it. If somebody is not able to afford, then you go for even. My question to you, if somebody is taking insulin, 20 unit premix insulin in the morning and 30 unit before dinner, and you find the fasting blood sugar is 240 and postprandial is 260, and patient is also on metformin 1 gram, and you have ruled out Samoghi effect, what do you do?
So I look, I look at the phenotype of the patient. Is the patient obese or not? Whether the patient is adhering to the lifestyles or not. Lifestyle modification can take care of the fasting glucose output. So if those are not there, then I have no options other than switching to basal bolus, or with the SGLT2 I have, or a GLP-1 receptor agonist I have, I can use one of those agents to help reducing body weight if the patient is overweight or obese.
If SGLT is not going to control the blood sugar of 240 in the morning, now the patient is doing everything. What is the problem of giving, instead of giving a basal bolus, breakfast, lunch and dinner, patient doesn't want to take insulin during lunch time. And what is the problem giving a premix insulin and a basal insulin in the night to control the fasting blood sugar, rest continuing metformin?
Yeah, that can be continued. For an example, we have used in selected individuals the split mix regime, right? We combine a different combination of soluble insulin and NPH insulin in the breakfast. So there are different permutations and combinations you can use. There is no harm if you use, for an example, a premixed, I don't know whether giving a protaminated aspart or a protaminated lispro and adding an analog separately does not probably make sense. So I would go for a basal bolus than combining a premixed insulin and a basal insulin at bedtime.
Okay, thank you very much. See, this is such a situation, the questions will never end. We will have more and more doubts.
I do understand.
Because you are day in and day out, we are having our doubts in using insulins. So thank you very much for a very clear-cut deliberation on the subject.
Thank you,
and now with this, we close this topic.
Thank you, sir. I request the chairpersons and the speaker to please proceed towards the presentation area. Now it's time for the inauguration session. I request Professor Dr. Sambit Das, Organizing Secretary, to please come up on the dais.
So a very good afternoon again to everyone, and we'll start our inauguration, and we'll keep it very short and brief. And I'll first invite our chief guest today, Professor S.R. Patnaik, who is currently the President, Endocrine Society of Odisha. So I'll invite Dr. Alok Srivastav, who is our Director Medical Services of Apollo Hospitals, Bhubaneswar, who is our guest of honor. I'll invite Dr. Sisir Mahapatra sir, who is the chairman of RSSDA currently. So he's serving the chairperson of RSSDA currently over the dais. I'll request my senior colleague, Dr. Pitambar Prushti sir, to kindly come over the dais. So just to mention that we are now at the fourth annual meeting of Endocrine and Diabetes Update, and we have started in 2017 endeavor in collaboration with Apollo Sugar, and now it has reached the fourth year, though it was not a consecutive year, and we all know that why it's not consecutive, because last 2 years have been, we are rolling with COVID, and probably this is the first biggest meeting in Bhubaneswar after COVID. So I could miss very important figures in the first row itself from 2017 to 2019, and many have lost their lives. We have lost Professor R.J. Das sir, who is our mentor all the time, and he sits in the first row from the day 1 to the end of day 2. Many other colleagues we have missed. So I'll request everyone to stand for their solidarity for 1 minute. Thank you. hope their soul rest in peace. And tomorrow we have a Professor R.J. Das memorial lecture also. So for the last 4 years, I think 3 things we have tried to maintain in EDU. And one is pure academics, and you can see the agenda that it is highly packed with all the scientific events. Probably there would be good discussion points. This time we had made a hybrid format also, and all the speakers are coming except Dr. Bansi Sabu could not come at the last moment, and Dr. Bhansali is not coming. Otherwise, all the outstation faculties are coming this time, and this time there are almost 18 national faculties, and there are very eminent state faculties who are of national repute also. So pure academics, we do not do much of the entertainment program, and we do not have in fact entertainment program. So that is another point we stick to EDU. And third is definitely we stick to the time, but somehow this time we are 20 minutes late. We will try to adjust that in the inauguration. So without wasting much time, I'll request the dignitaries on the dais to kindly lamp the light. I'll request our advisors, Dr. Abhay Sahu, and Dr. Jayant Panda sir, Sunil Kota and Ritesh, and Mahesh also to join the lighting of the lamp. Dr. Kanwar and Dr. Kishore, please.
ॐ श्री गणेशाय नमः। ॐ भद्रं कर्णेभिः शृणुयाम देवाः। भद्रं पश्येमाक्षभिर्यजत्राः। स्थिरैरङ्गैस्तुष्टुवांसस्तनूभिर्व्यशेम देवहितं यदायुः। ॐ स्वस्ति न इन्द्रो वृद्धश्रवाः। स्वस्ति नः पूषा विश्ववेदाः। स्वस्ति नस्तार्क्ष्यो अरिष्टनेमिः। स्वस्ति नो बृहस्पतिर्दधातु। ॐ शान्तिः शान्तिः शान्तिः। ॐ नमस्ते गणपतये। त्वमेव प्रत्यक्षं तत्त्वमसि। त्वमेव केवलं कर्तासि। त्वमेव केवलं धर्तासि। त्वमेव केवलं हर्तासि। त्वमेव सर्वं खल्विदं ब्रह्मासि। त्वं साक्षादात्मासि नित्यम्। ऋतं वच्मि सत्यं वच्मि अवत्वं माम् अववक्तारम् अवश्रोतारम् अवदातारम्।
Thank you, dear Sambit. Now, actually, we are at the crossroads. Crossroads because we are seeing a dramatic spot in the incidence of endocrine diseases. Just look at our country. A simple estimate says around more than 100 million people in our country are suffering from diabetes. And this is a gross underestimation. What about other diseases? Same thing regarding thyroid diseases. Today morning we were discussing about endocrine hypertension. Many of our such patients are going underdiagnosed. Now what is the reason? Is it the lifestyle? Is it because of endocrine disruptors in the environment? Microplastics are also now discovered in the blood of the human beings. So what should you do? Somebody was mentioning about Professor R.J. Das. We have lost our teacher. He used to tell us during our rounds and seminars and everything that the first thing here is education. We need education. And for that, in that endeavor, this sort of conference goes a long way in helping us in appreciating the magnitude and the reason behind the problem, how to face it. For that reason, my thanks, best wishes and appreciation to Sambit and his team for holding such conference. Thank you all.
Thank you, sir. I now request Dr. Alok to say a few words.
Distinguished dignitaries on the dais and distinguished clinicians of the dais. A very good morning to all of you. Updates have become not just a routine or essential part of any medical community, but it's most important in day-to-day life that as a clinician we must be aware what is happening around the world and what kind of treatment we are providing to the patients must be known to us through the updates. So I would like to first thank Dr. Sambit Das and Dr. Pushti for creating such and organizing a forum which is today standing 4th year of organizing this forum, which is going on in hybrid mode. Now through this forum I would like to put 2-3 things, because as a Chief Operating Operating Officer of the Hospital and Director of Medical Services, what I have noticed over the years is diseases have grown. And if you look at any incidence of disease today, be it diabetes, be it thyroid disorders, be it anything, everything is growing and is coming to the hospital in the form that we are realizing that the beds are inadequate to provide care. Now, we have grown in expertise to offer control to all the diseases, and to an extent it has a limitation that we are unable to control if patients come to the hospital a bit late. What is very important today and becoming of concern when incidence of any disease is growing is to focus on prevention. And on this forum I would want to request all the eminent clinicians who are participating today that if you, through your presence, a society can focus much more on prevention, the incidence can only be reduced in that way, because the way we see today, the incidence of diabetes or morbid obesity, everything is alarming. And the way it is turning out into an outcomes of whether it giving a diabetic nephropathy or mortality, it's coming out on a larger scale. So if a focus is also drawn into the system of community to focus more proactively into prevention, I think it will go a long way. Lastly, I would like to thank each one of you for giving us this honor of coming out over here and joining this session. And I would also like to thank Dr. Sambit Das for putting up this nice forum. Thank you.
I'll request Chairman RSSDI, Dr. Sisir Mahapatra sir, to say a few words.
Jai Jagannath. Good luck to everyone. Warm greetings on behalf of RSSDI Odisha and on my own behalf. Esteemed Chief Guest, President ESI Odisha Chapter, Professor S.R. Patnaik, respected Dr. Alok, Director and Chief of the Medical Services Apollo Group of Hospitals, respected our advisor Dr. Pitambar Prusti, and most lovable Dr. Sambit Das, the organizing secretary. National faculty, delegates, ladies and gentlemen, invited guests. I express my limitless thanks to Endeavour and Apollo Sugar, particularly to Dr. Sambit Das for inviting me as a guest of honor of EDU. At the very outset, on behalf of the RSDI Odisha chapter, I welcome each one of you to this august event. The main purpose of this EDU is to update the delegates in the field of diabetes and related endocrine issues. It is so required because the treatment of yesterday changes today with the latest options, and I am sure this EDU is unique in its educational and organizational aspect. Thank you, Dr. Sambit. It is needless to emphasize that worldwide, the prevalence and incidence of diabetes originates from a complex interaction between lifestyle, obesity, and innate susceptibility driven by both genetics and nutrition. Diabetes today is a major concern of the society as well as the health sector. According to IDF 2021, the 10th Diabetes Atlas, it speaks that today the world population is 790 crores and the adult population that includes 20 to 79 years is 501 crores. The prevalence of diabetes in the world is 10.5%, in India it is around 9%. Number of people with diabetes in the world, 53 crores, and in India it is around 7 crores. Number of deaths in the world, in 2021 it was 67 lakhs, whereas in India it was 6 lakhs, that was excluding the death due to COVID-19. Now India is faced with a galloping diabetic epidemic which is at a faster speed, and there is a shift from diabetes prevalence from urban to the rural areas, the affluent to the less privileged, and from the older to the younger people, and there is a high prevalence of pre-diabetes as per the ICMR INDEP data. This is going to substantially increase in our country as per the WHO data. Now recent epidemiology study says that women and diabetes are numerically almost the same as men, 10.7 is to 10, 9.7 is to 10.1. The monograph of diabetes and women, the untold story, it is rightly said that diabetes in women is difficult, dismissed, different, and deadly. It is noted here that women suffering from diabetes are not often cared for, dismissed as a mild touch of sugar, and there is a great gender bias and inequality in respect of care. So if we want to conquer diabetes and break the transgenerational transmission of diabetes, we have to focus on the women pre-gestational period, gestational diabetes in them. A nice slogan which has to evolve in our country, particularly Odisha, focus on the fetus for the future. As a chairman RSDI Odisha, we have a vision. The vision is how to defeat diabetes by observing 3 pillars. That is track, test and treatment. We had in 29th September 2021 the famous World Heart Day. At 2,000 sites we conducted the blood sugar test by RSDI members, and at 4,000 sites by Rotary Club. This is the biggest ever diabetes awareness done in the history of RSDI. In the book, Controversies and Consensus mentioned that advances in diabetes are relentless against a relentless disease. That the mission, one we have a vision, one we have a mission. The mission is one nation, one day, 1 million blood sugar tests. 100 million tests in 100 days. We did it. And this was the greatest successful event placed on record in the Limca record of books and in the Asian Book of Records. Now, how to achieve this? How to beat diabetes? How to achieve this mission? By observing 90-90-90 program that we are observing as a part of RSDI in our country. What is that 90-90-90? First 90 stands for 90% awareness and detection. Second 90 stands for 90% treatment. And the third 90 stands for 90% control. Achieving 90% of people with diabetes in control, we can achieve our goal of making India a diabetes care capital of the world. Thank you very much. Thank you, Dr. Sambit, for inviting me, and thank you for a patient hearing. Thank you.
Thank you, sir. That was quite insightful. I now request Dr. Pitambar Prushti, sir, who is the advisor and also organizing co-chair, so he will address.
Thank you, Dr. Sambit, for organizing a very grand update in subjects of endocrinology and diabetes in this part of our country. My pleasure job is just to give a vote of thanks. We are definitely, as organizers, very enlightened to see such type of august audience in front of us. We never expected actually. We are scared of the storm coming up, the corona raising its head. So, but such a physical meeting is really encouraging for us. First and foremost, I thank Professor S.R. Patnaik, Professor of Endocrinology Department, MKCG Medical College, Berhampur. He has spared all his time to accept and honor our invitation as a chief guest. I am really thankful to you, sir, for your from your busy schedule you could spare your time and are present with us. It is a matter of a great pride for us. Thank you, sir. Dr. Alok Srivastav, our DMS and COO, Apollo Hospital of Bhubaneswar. I must say he is an energetic person. Academically also he has got a great interest, always pleading before the consultants that how academics will improve, and to his credit he has trying to ensure that DNB and the super specialization courses open up in almost all the departments. So that is a great achievement which he has done. He is streamlining it, and very it always stands as a backbone for any conference of such magnitude, and he supports from his heart of hearts. Sir, many thanks to you for sparing your time and being with us as the guest of honor. So for this update. And to say something about Professor Shishir Mahapatra, I mean, without whom a meeting is really makes us feel that we are missing something in every meeting. So he is such a, has got a personal really feeling before us, and he spoke about RSSDI, and he is the chairman of RSSDI Odisha chapter. He will definitely do lot of things and bring about the changes which he has perceived and put before us, that how far diabetes will be treated effectively and must reach every door and a corner of Odisha. Thank you, sir, for sparing some time for us and being with us and really encouraging, giving an encouraging speech that I think everybody liked. Thank you, sir. And nothing to say much about Dr. Sambit. Single-handedly, he has conceived this update and really made it a reality. So that is about great to him. Just 1 week ago, he came to me that told that we will be having this update. I was surprised that how could within a short time he will be able to really give it a shape, and that he has done it. Many congratulations to him. So I thank also all these the august audience, our teachers, our faculty who have assembled us and have gave meaning to this update. Their comments and expertise opinions are very valuable for us when we go out of this hall, that we must carry something that as far as endocrinology and diabetes is concerned. Without the esteemed audience presence, the conference has no meaning. So I thank them all, each of us, whoever is present in the hall, and so that this update becomes successful. Behind the screen, many things, many people do help us, be it the audiovisual people, the IT people, our Apollo staff, our members from Apollo Hospital. So I am really thankful to all of them who have contributed and supported us in making this update successful. And lastly, I thank the organizing members for bringing about this update and making it a success. Thank you.
Thank you, sir. So just a small and important announcement that our teacher of teachers, Professor R.K. Dalai sir, has actually written a wonderful book, and we take this privilege on this auspicious occasion to inaugurate that book. May I request the chairman API, Professor Dr. Jayant Panda sir, to kindly come and invite Dr. R.K. Dalai to inaugurate his book. So Dalai sir, please, and Jayant sir.
Thank you, Sambit. We are running half an hour late, so I'll be very brief. Just 1 minute regarding Professor R.K. Dalai. From the undergraduate days, he's a brilliant student. He's the best graduate of his batch, best postgraduate of his batch. I am a proud undergraduate student at VSS Medical College under Professor Dalai, and he has served SCB as one of the finest faculties and shaped thousands of careers who are serving worldwide, and now he is the Dean and Principal at High Tech Medical College Hospital, Bhubaneswar. And I am proud that he is present on the occasion, and he has composed a book, complete textbook of medicine, comprising from the very basic infectious disease to metabolic diseases to cardiovascular to respiratory, all systems. I was amazed to go through the book where everything in the Indian context, which we don't get many times. We have very few books which is written in context to Indian standards, Indian problems. And I, as Chairman API, as Head of Medicine SCB, recommend this book to every undergraduate, every postgraduate, even those who are practicing medicine, to update their knowledge. So with this background, I invite Professor Dalai on stage, and I request the organizers to bring the book. I request our guests to release the book on the occasion. It's a proud moment for us to release such a prestigious book.
So, thank you, sir. That was amazing. So, I'll request now the guests on the dais to kindly take the seat. So, we'll start the scientific program. We have two very brief sessions followed by lunch. So, may I request Mohesh to kindly take the session.
Thank you, sir. Coming back to the scientific sessions, I would like to request our chairperson, Dr. Satish Pradhan, Senior Consultant Physician, Railway Hospital, Bhubaneswar, and Dr. Sandeep Devasis Mishra, Consultant Diabetologist and Podiatrist, Cuttack, to please come up on the dais.
So, good afternoon, everybody. Now the topic is practical tips and addressing the clinical inertia with SGLT2 inhibitors. Nowadays, many of the SGLT2 inhibitors are off patent and few are going to be off patent. So, I think from the price point of view, the inertia is over, and now it is up to the clinical inertia, which is to be addressed, and the speaker will focus on the clinical inertia and practical tips on that. Now I'll request Dr. Satish Pradhan to introduce the speaker.
Good afternoon, everybody. Actually, I think Dr. Sunil Kota does not require any introduction here. He has 77 peer-reviewed publications and 18 book chapters. So you will able to know now after he speaks how able speaker he is. I request Sunil to start the talk.
Thank you so much, sir, for those very kind words, and big rounds of applause to my dear friend Sambit, because the kind of mammoth event he has organized in a short span of time with an everlasting smile on face. So kudos to him. So this is nothing new which I am going to talk about, but again it is a rejoinder to what we all know. But then there is a gap between what we know and what we have been practicing, and that's across the globe. That's what I'm trying to address. And oh, bit of glitches. I'm not able to change the slide. Okay. So clinical inertia is something which we all are aware of, and there are points to hinder both on the side of the treating physician and also on the side of the doctor. But then we are going to talk about what exactly is holding us back. So this is again something which is telling us clearly a number of data. You can see some of the data are up to 2,22,000 patients, some are up to 1,30,000 patients, and all of them have been categorically stating that yes, the gliflozins and the glutides, the GLP-1 receptor agonists, are wonderful as far as the cardiorenal protection is concerned. And one of these studies clearly telling us that then still there is a gap as to when do we prescribe these molecules and where exactly do we. So this again is a study which was published in 2019. It states that it again, the combination we all have been talking about just now, Dr. Chandan Das was alluding to, we do not have a patient having no established cardiovascular disease, but then we do not have that much weaponry which can tell us whether the patient is having subclinical cardiovascular disease or not. But despite knowing that, the proportion of patients who are prescribed the combination of metformin plus gliflozin is only a paltry 4.3%. And this again is a study of 1,23,261 patients, and the message that needs to go across from this wonderful slide is that around 44% of patients with type 2 diabetes have a CVD, heart failure or CKD, and therefore are eligible for treatment with the gliflozin. But if you have a look at the previous slide, that clearly tells us only less than 5% of patients with type 2 diabetes are using gliflozins, and if you talk about CKD, it comes back to a very sorry figure of less than 1%. And the gliflozins are also less likely to be prescribed in older non-white population. Then why exactly is gliflozin? This again, this slide looks very busy, but we all understand the glomerular hyperfiltration is very much there in patients of type 2 diabetes, and it is the main driver of glomerular hypertension. And how the gliflozins help us here? They inhibit the proximal glucose and sodium reabsorption. They give rise to natriuresis and increase sodium delivery to the macula densa. And the TGF constricts the tubuloglomerular feedback, constricts the afferent arteriole, resulting in decreased glomerular hyperfiltration. And if you try to summarize the efficacy data of all the gliflozins put together, rather the dapagliflozin over here, HbA1c reduction of 0.89%, weight of 3 kg, systolic blood pressure reduction of 5.1 millimeter, and apart from that, there is a reduction, improvement in UACR, and also the eGFR remains stable for up to 4 years. This again is a very dirty nexus which we can say, either you have a kidney ailment or a heart ailment, it is going to give rise to the other one. And this again is something which is telling us about the data of what all comorbidities can be there when a patient is having type 2 diabetes. It is telling us about NFLD, obesity, the increase in risk of heart failure, cardiovascular death and all-cause mortality, and CKD, which affects around 50% of patients with type 2 diabetes, and diabetes happens to be the most common reason for progression to ESKD. And there is also heart failure. Sometimes it is not easily picked up clinically, but then 17 to 21% of patients have heart failure as well. And this again is a study from, look at the number of the nations who were included. Heart failure or CKD happens to be the first manifestation of cardiorenal disease, which, did I do something wrong? Can someone come here? So the slide was basically trying to tell us the proportion of patients having cardiorenal manifestation at the outset itself, and it crosses the figure of around 60%. And again, the left ventricular dysfunction is an early complication of type 2 diabetes. We have two varieties, where there is one end where we have cardiomyocyte hypertrophy, fibrosis giving rise to HFpEF, and HFrEF can be due to cardiomyocyte apoptosis and cardiomyocyte necrosis. And look at the number, 63% of Indian patients had evidence of left ventricular dysfunction in more than 1 year after type 2 diabetes. And if you look at this study in NEJM 2018, it clearly tells us there is a 45% increase in risk of heart failure whenever there is type 2 diabetes in a patient. And there are some additional risk factors: elevated A1C, systolic or diastolic blood pressure, LDL cholesterol, albuminuria, and tobacco use. And we all have been listening to it time and again. All the gliflozins across the spectrum give us significant reduction of heart failure, hospitalization, and CV death, may it be DECLARE, EMPA-REG, or the CANVAS. And if you look at the kidney composite endpoints also, the EMPA-REG giving us a reduction of 46%, CANVAS 40, DECLARE TIMI 47%, even the VERTIS CV also gave us 34% reduction in the composite kidney endpoint. And the beauty is that across the baseline eGFR, this is the slide which is telling us about its positive impact, in patients having EGFR across the spectrum and also having UACR across the spectrum, less than 30 to more than 300. So some, yes, are giving definite protective benefits, but then most of these are at least neutral. So who to treat with gliflozin? A number of lines. The evidence supporting first line, if metformin intolerant or in combination with metformin, second line to metformin, third line combination with basal insulin or multiple daily injections of insulin, combination with the glutides, established cardiovascular disease, history of heart failure, no history of limb amputation, no history of PAD, ACR of more than 3, EGFR of more than equal to 45, and if you have heart failure and CKD more than equal to 30. In fact, the DAPA CKD takes it to 25 and the EMPA takes it to 20. Overweight or obese, vulnerable to the effects of hypoglycemia and prior stroke. But these are some of the conditions which ask us to prescribe gliflozin with a note of caution. History of PAD, osteoporosis or history of fracture, frail or elderly, volume depletion, history of foot ulceration, previous low limb amputation, existing foot ulceration, ketogenic diet, very high A1C levels because you don't want it to go into a state of ketosis. Systemic steroid therapy, cognitive impairment, BMI less than 25, receiving loop diuretics, recurrent UTIs, men with BPH, and limited experience with ertugliflozin in those more than 75 years. But these are the red flag signs where you should not be using it at all. DKA or previous episode of DKA, eating disorder, rapid progression to insulin within 1 year, and latent autoimmune diabetes, excessive alcohol intake, diabetes due to pancreatic disease, type 1 disease, genetic diabetes, acute illness, pregnancy, recent major surgery, history of necrotizing fasciitis, of perineum fornius gangrene, EMPA not recommended in those more than equal to 85 years, and severe hepatic impairment. In fact, there is some data which suggests that DAPA 5 milligram can be initiated. So how to use it safely, because we all have been coming across these particular points. Genital and urinary tract infections, thrust type of infections are common, and it is common more so early in treatment. So providing hygiene information may improve treatment continuation. Treat with topical or oral treatments. So most people would end up continuing SGLT2 inhibitors, but if it is a recurrent one or if it is a severe one, then you need to discontinue it. What about people having low limb amputations? EMA has advised caution in using gliflozins in those at high risk of low limb amputation, as a class of it cannot be ruled out. Absolute risk is low but appears higher in those with previous amputation. Risk does not appear to be dose dependent, and all people treated with gliflozin should receive advice regarding preventive foot care, including inspect feet regularly and to report wounds, discoloration or pain and to stay well hydrated. Ideally, avoid gliflozins in those with active foot ulceration or previous amputation. What about DKA? It says that there is a small risk of decay which may be euglycemic. Discuss this prior to and during gliflozin therapy, and risk is higher if the patient is relatively insulin deficient, when insulin doses are reduced suddenly, and whenever there is an increased need of insulin, if the patient is dehydrated, and also if the patient is under a restricted food intake regimen. Symptoms we all are aware of, so it has to be kept in mind, and it can be euglycemic DKA. And stop gliflozins during acute illness and prior to surgical procedures, so we have to follow the sick day rules. What about bone fracture? It was the predominant finding from the CREDENCE and the CANVAS which was done for the molecule canagliflozin, but not identified in EMPA or dapagliflozin studies. Fractures occurred mainly early in treatment and may have been linked to increased falls due to volume depletion and hypotension. Sick day rules I'm not going to talk about, but then the SADMANs, which says the gliflozins, the ACE inhibitors, diuretics, metformin, ARB, NSAIDs and sulfonyl. There's a number of drugs in the list which have to be stopped temporarily during these sick days, and if the patient is unable to eat or drink or persistent vomiting or diarrhea, we have to stop all these drugs. So if you are unsure of how to manage it, probably you have to refer it to a center where it can be taken, where it can be given the adequate care. Stay hydrated. If not able to eat normally, replace meals with high carbohydrate snacks or drinks. Keep taking insulin and all other diabetic medicines even if not eating. And how to advise on sick day rules, we have number of guidelines in place. What about renal function? Monitor annually the electrolytes and the EGFR unless EGFR of less than 60, when EGFR should be checked once in 3 to 6 months. But then there were concerns as far as hyponatremia due to these particular molecules, but then there was a recent publication, I can say in 2021 in American Journal of Nephrology, which says that it probably gives rise to aquaresis instead of natriuresis. Therefore, it is sometimes used in euvolemic hyponatremia as a treatment option also. So it is not very frequently associated with hyponatremia. Modest reduction on EGFR, which may occur when starting gliflozins, but extra monitoring is not required unless unwell or starting another drug likely to impact renal function. DAPA, EMPA and A2 may be initiated with EGFR of more than 60. EMPA 10 and DAPA can be continued if EGFR of 45 to 60. This drug should be stopped if the EGFR is persistently less than 45. DAPA can be used to treat heart failure if EGFR is more than 30, but then we have this DAPA CKD trial which tells us that it can be given up to EGFR of 25 as well. So what do the guidelines say? Again, we have been talking about it number of times, we have been listening to our teachers about it, but then as far as the glycemic control is concerned, entry A1C between 7.5 to 9, dual or triple therapy, and the looking at the wealth of evidence that these molecules have in their favor, glutides and gliflozins do have a significant role to play. And this again, I'm not going to read out, but then if patient is having ASCVD, heart failure, CKD, we know which are the drugs to be given. But the concern, which again Chandan Das Bhai was alluding to earlier, we do not know what kind of patient is having subclinical CVD, which is very difficult to rule out. And the gliflozin is recommended independent of glycemic control in patients with CKD, heart failure and high CV risk apart from established ASCVD. So this again, we have primary heart failure outcome data, primary renal outcome data, reduction in heart failure and CKD progression, CVOTs. Dapagliflozin is a molecule which has data across the spectrum, but then we have studies coming up in other molecules as well. Again, the pump, pipes and filters, I'm not going to enumerate them. I think it is a wonderful molecule which should be initiated, and supposedly if you have a patient of A1C more than 1% above the target what you want the patient to get to, we do not know whether the patient is having baseline CVD or not. So therefore you are not wrong if you are initiating with a combination of gliflozin and metformin in those group of patients. Thank you all for the patient listening.
Thank you, Dr. Sunil, for an excellent presentation. Now it is open for discussion. Yeah, Dr. Jahan.
Rightly you have told that there is inertia in initiating SGLT2 inhibitors. When initially we work out a patient as a atherosclerotic cardiovascular disease or high risk of DKD or heart failure, so we can start right way with SGLT2 inhibitors or combination. And all the issues which raise a question on the use, starting from the genitourinary infection to the amputation and the EGFR you have touched upon. So what we require that to utilize this drug more for our patients who will benefit from its use for at least protection of their heart failure, atherosclerotic cardiovascular disease, or the early or late renal impairment. And if it is so, then our effort will be successful. The message should go loud and clear. And another important point which you have already touched upon is the safety part as well as the clinical inertia. And I'll like to put upon here that it has become more affordable than earlier, because we have few drugs, as you have told, gradually it is becoming off patent and we are getting more and more drugs affordable. We should have a consensus, our age-old consensus of lifestyle modification, metformin, then one drug, two drug, three drug, bypassing that. People who will definitely benefit from this, we should have a mindset to initiate and give the benefit to the patients. That's my comment. Thank you.
Thanks, Sunil. Nice presentation. How do you place SGLT2 inhibitor in elderly person? If somebody is 70 or 75, stubble, obese, you will find many people. It's not that 75 all are.
Yes, actually, exactly. I cannot quote the article here, but I have seen there are few articles which have cited usage of dapagliflozin and empagliflozin in people up to 80 years also. I have used that, but I have seen that. But then more than 75, if you have a safer option, I would definitely like to treat with other drugs. But having said that, I would also like to say that there are good number of patients of mine who are on gliflozin after 75. Basically, after this article in American Journal of Nephrology, which states that the traditional thought that it would be giving rise to hyponatremia is no more there. And practically, I don't know, I want to also understand from the people over here, how many of you really see hyponatremia when it is used in elderly?
It's not that common, but the problem in elderly SGLT2 inhibitor, because of the weight loss, because of sarcopenia, ongoing sarcopenia, those things, and prostate, genital tract infection, for these reasons, and that if they lose further weight, they would feel very uncomfortable in doing their daily activities. For these reasons, you normally avoid in 75, but somebody obese, 90 kg, and stable, maybe slightly increased creatinine or microalbuminuria should be used.
Yes.
No, I think at this age it has to be individualized, because these are the patients who are more prone for heart failure and kidney function are deteriorating in these sort of patients. But if they fit into your typical year, you should start it. Now we are running short of time, so we will close this session here.
Thank you,
Dr. Sunil.
Thank you, sir. I request our speaker, Dr. Sunil Kota, sir, to please go to the presentation area. Coming to the next session, I would like to request our chairpersons, Dr. Siba Prasad Dalai, sir, Associate Professor of Medicine, IMS and Sam Hospital, Bhubaneswar. Chairperson Asjan. And Dr. Phyllis Rautrai, Chief Consultant Diabetologist, Dr. Mohan's Diabetes Center, Bhubaneswar, to please come up on the stage.
Good afternoon, everyone. So, this topic will be about addressing meta-obesity with SGLT2 inhibitors. Dr. Sunil Kota has nicely elaborated about the SGLT2 inhibitors, the advantages and disadvantages. And regarding meta-obesity, the term actually was coined in 2013 by G. Alexander Fleming, and it encompasses various metabolic disorders that are deeply enrooted in a setting of diabetes, like obesity, cardiovascular diseases, rapid aging, and all such things. So, I would like to
So, on the topic of meta-obesity, I would like to invite Dr. Neeraj Mishra, sir, who is a senior consultant in medicine and diabetes at Kerr Clinic and Hospital, Bhubaneswar, who has 50 publications, including 3 international presentations and 4 publications related to cardiovascular disease. Over to you, sir.
Okay, good afternoon. I think there's some problem in the slide. In fact, what we just heard, this terminology came in 2013. We are used to the diabetes, that is the twin epidemic of obesity and diabetes. But what is coming nowadays is meta-obesity. So I think the slide some problem. Okay, so basically what I will be discussing is what is meta-obesity, the clinical implication of meta-obesity, and the evolving role of SGLT2 inhibitors in addressing meta-obesity. So what is meta-obesity? The spectrum of metabolic disorders with common metabolic and inflammatory origins, including diabetes, obesity, metabolic syndrome, cardiovascular diseases, and neurodegenerative diseases and accelerated aging, they all come under meta-obesity. You can add cancer to that also. And if meta-obesity is the tree, so these are the branches of meta-obesity. So continuing with that meta-obesity, it encompasses various conditions where etiology lies within complex relationship between genes in an obesogenic environment. What is that obesogenic environment? Where you consume lot of excess calories and a sedentary lifestyle. So that is the obesogenic environment with a genetic background, then you go on to develop meta-obesity. The progression of meta-obesity involves inflammatory and oxidative damages due to insensitivity to regulators such as insulin or leptin, which results in cell death due to compromise in the natural regeneration capacity of the tissues. When you look at the interlinked etiology behind meta-obesity, one of the important factors that accounts is visceral adiposity, and that is related to all I have told because of the unhealthy eating habits and sedentary lifestyle leading to visceral adiposity, and this is quite common in meta-obesity. And that leads to different dysfunction, like there is increased cytokines, there is dysfunctional subcutaneous tissues, increased free fatty acids and increased leptins, increased free radicals, RAS activation and fluid retention, all leads to increased inflammation. In fact, there is a chronic inflammation, ongoing chronic inflammation with meta-obesity. There is insulin resistance, that is also an important component of meta-obesity, and prothrombotic state, all leads to metabolic syndrome. So basically they are all interlinked. So the evolving, how to understand what is this meta-obesity, it all starts with visceral adiposity, insulin resistance leading to metabolic syndrome, and then you have the development of diabetes leading to diabetes, and then you have the cardiovascular disease, neurodegenerative disorders, then accelerated aging, and even cancer, and that all encompasses in the terminology of meta-obesity. So we'll come to what are the clinical implications of meta-obesity. Why should we worry about meta-obesity? And this is from the longevity and data from US special care team that was in 2019. And what it says that over 50% of deaths are from obesity related chronic diseases like diabetes, stroke, heart disease and cancer. So more than 50% of death are due to obesity related chronic diseases. Just see the staggering number of deaths that causes by meta-obesity. It has also cardiovascular implications. Obesity is a significant independent risk factor for cardiovascular disease such as hypertension, heart failure, myocardial infarction, stroke, and sudden cardiac death. There is derangements in metabolic parameters such as dyslipidemia, hyperglycemia, and systemic inflammation which promote the development and progression of cardiovascular disease. In the Framingham study, 23% of CSD in men and 15% of CSD in women was attributed to excess adiposity. In a long-term follow-up of the Framingham cohort, all-cause mortality increased with increased duration of obesity. In fact, the CVD mortality increases by 7% with every 2 years in succession with obesity. Means the more you remain obese, the more likely that you die from cardiovascular disease. Then it also has some metabolic implication, and the most important part is non-alcoholic fatty liver disease that we know is now the most common cause of chronic liver disease. The rising prevalence of non-alcoholic fatty liver disease mirrors the rising rates of obesity and closely associated with complications of metabolic syndrome and type 2 diabetes. Global prevalence is around 25%. In a diabetic, NAFLD is around 55%, and NAS, incidence of NAS, which is much more dangerous than NAFLD, is 37%. And type 2 diabetes is also an independent predictor of progression of NAFLD and NAS, and liver fibrosis also. And NAFLD is also is associated with high risk of incident type 2 diabetes and diabetes related complications like CKD and retinopathy. And the cost is staggering. It is projected that the prevalence of NAFLD and the cost treating will be hoping $103 billion in the US. And then it leads to cancer. So there are data now say that obesity and metabolic syndrome associated with high risk of onset and progression of cancer. There are different underlying factors like visceral adiposity, insulin and IGF-1, lipid levels, growth factors, sex hormones, and inflammatory mediators. Chronic low-grade inflammation in obesity is an important mechanism linking it to increase and progression of cancer. Obesity is also a risk factor for several cancers, including the prostate and breast cancer. We know they are the leading causes of death in men and women, respectively. A diabetic who gains weight and then the problem also accentuates. And from the ACCORD study, weight gain is associated 22% increase in overall mortality. Birmingham Heart study says that 2.25 kg weight gain associated 20% increased risk of severe risk factors in men and 37 increased risk in women. And Intra-Heart study says that abdominal obesity, which is quite common in our part of the world, is associated with increased risk of MI to the tune of 2.4 per, that the odds ratio. That brings us to the role of SGLT2 inhibitors in addressing meta-obesity. I'll just concentrate on that part, meta-obesity part. And this is a very good paper that was just published, and that was on effect of canagliflozin of insulin-resistant visceral adipose tissue, because these are the two important mechanisms that starts the process of meta-obesity. And this was on patients with newly diagnosed type 2 diabetes. Oh, no, sorry, yes. This was an open label parallel or control study. 142 participants were divided into canagliflozin 100 mg once daily or metformin 1000 mg twice daily. So it is a 12-week study. So they are measured insulin resistant HOMA-IR, subcutaneous and visceral adiposity are measured by imaging technology. Fasting blood glucose, HbA1c, CRP and nitric oxide evaluated and compared. What they found that I'll just come to the canagliflozin reduces visceral adipose tissue, improves blood glucose, insulin resistance and systemic inflammation. There is reduction in CRP. Also there is improvement in increased blood level of nitric oxide, and these are people with newly diagnosed type 2 diabetes. So maybe if you give it early, probably you have some beneficial effects so far as meta-obesity is concerned. And this was a meta-analysis published last year, and this was sodium glucose co-transporter 2 inhibitors for non-alcoholic fatty liver disease, because that I consider to be one of the important mechanisms by which meta-obesity can cause damage to the body. And this is in the Asian patients. And what this meta-analysis, this are basically 10 studies, and involving 555 patients. There are 7 randomized trials and 3 cohort studies. What it says that SGLT2 treatment reduces body weight, waist circumference and this subcutaneous fat and visceral adipose tissue, that is well known. The reduction in visceral adipose tissue is statistically significant after SGLT2 treatment and was greater with compared to control, insulin-based therapies and metformin. So, and the reduction in the subcutaneous adipose tissue reached statistical significance when compared to TGDs. We know that TGD is so far was the drug which causes some reduction in visceral fat. So again, in comparison to that also, there is some reduction, more reduction in subcutaneous fat. And when they compared the ALT level, there was significantly lower ALT level with the use of SGLT2 inhibitors. In that meta-analysis, AST level was also significantly reduced. And when they looked at the fibrosis marker, there is a numerical reduction in fibrosis markers such as FIB4 index, liver stiffness measurement by transient elastography. There is no significant changes in NFLD fibrosis score, but significantly reduced NAFIC score, which is a score that you predict NAS. And serum ferritin level was also significantly reduced. And compared to TGDs, that is the standard therapy so far we know about a patient having this non-alcoholic fatty liver disease, there is treatment resulted in significant lower FIB4 index values. So the study, that meta-analysis concluded that SGLT2 treatment improves hepatic steatosis, body composition and adiponectin levels, and to some extent liver fibrosis. And it could be considered as a potential treatment strategy among type 2 diabetic patients with NFLD after further discussion with physicians if there are no contraindications. More studies are needed to understand the direct and indirect effect of SGLT2 on the progression and mortality from NFLD. And then that brings us to that we know about the cardiovascular benefits and renal benefits of SGLT2. So this is the meta-analysis published in JAMA 2021. We know that there is a 3-point reduction. When you take the meta-analysis also, there is a 10% statistical significant 3-point MACE reduction with SGLT2 inhibitors. Also, they do have a beneficial effect, significant beneficial effect in heart failure and kidney-related outcome. But there is something interesting. We know that accelerated aging is one part of meta-obesity. So whether SGLT2 inhibitor has some role in accelerated aging. So this was the article published last year, April, and the title was SGLT2 inhibitors as calorie restriction mimetics insight on longevity pathways and age-related diseases. I'll not go into details, but what the abstract I'll be reading. By promoting a nutrition deprivation state, SGLT2 inhibitor upregulates the energy deprivation sensors, inhibits the nutrient sensors, and modulates closely linked hypoxia inducible factor pathways. Downregulation of insulin and IGF-1 pathway promotes cellular repair mechanisms. SGLT2 appears to be the most promising agent. You know that metformin is being tried, rapamycin and some other experimental drugs are also on the trial for anti-aging drug. But SGLT2 appears to be the most promising in the treatment of aging-related disease due to the regulation on multiple longevity pathways. Evidence is compelling for the role of SGLT2 inhibitor as a choice restriction, calorie restriction mimetic in anti-aging therapies. So maybe in the future we'll be seeing some studies, and probably maybe this will be used as an anti-aging therapy. And another interesting part, because neurodegenerative disease is one part of metabolicity. So whether they do have a neuroprotective effect. There's still a lot of experimental data, but I'll be reading, just summarize what the article says. This was published last year in 2021 publication. It says that flogenes may bring positive effects in type 2 diabetes, atherosclerosis, and cognitive impairment through several mechanisms, including anti-inflammatory and anti-atherosclerotic properties. SGLT1 inhibition leads to improvement in ischemic reperfusion injury, and acetylcholinesterase inhibition, that also has a beneficial effect. Reduction in oxidative stress, amelioration of cerebrovascular remodeling, and restoring a balance between catabolism and anabolism. However, long-term clinical trials are needed. A pilot trial is undergoing, and that will be published, I think that will finish in October this year. That was dapagliflozin in patients with Alzheimer's. And 48 patients enrolled, and I think by end of this year or beginning of the next year we'll have the data. And this from the Brunwald kernel, Eugene Brunwald wrote this in European Heart Journal 2022. SGLT2 inhibitors the statin of the 21st century, emphasizing the importance of use in heart failure with all type of ejection fraction. In fact, the DELIVER trial, the results were announced, top line results. So that is dapagliflozin heart failure preserved ejection fraction. And that also saw a significant reduction in heart failure hospitalization and cardiovascular death. That came last night only. So again, showing that SGLT2 inhibitors are the drug to stay for heart failure. And then to summarize, metabicity is the constellation of interconnected diseases with metabolic roots. It encompasses most of the major chronic diseases such as diabetes, cancer, and neurodegenerative disease. There is a build-up of excess visceral fat, which has been found to cause chronic inflammation and increased risk of age-related diseases. SGLT2 inhibitors have different pleiotropic effects and exhibits protective effects on heart and kidney, and possibly have beneficial effect on metabolic derangements associated with metabicity. The role, its role as a calorie restriction mimetic in anti-aging therapeutics is an exciting concept that needs further exploration. And SGLT2 inhibitors possibly have neuroprotective effect that we have to wait till the end of this year or beginning of the next year to know from the pilot study that is ongoing. I think that's all. Thank you.
Thank you, sir, for that nice deliberation. I would like questions from the audience. Yes.
What is the mechanism of action of SGLT2 in reduction of visceral fat and fat in the liver?
Sir, there are multiple mechanisms, but the question is that there is some reduction in, when studies have shown that there is some reduction. Not only that, they past came in the empagliflozin trial. Well, they found that
trials are different. Trials have shown that there is reduction of fat, and so many trials you have very nicely depicted and showed there is reduction of fat. But how? What is the mechanism of reduction of fat?
Exact mechanism probably, sir, I do not know. Exact mechanism probably is not known, but there is definite reduction in fat.
So just I am gone through the literature. The SGLT2 inhibitors are decreasing the carbohydrate or the glucose. There is energy dearth, as a result of which what is happening, there is shift of metabolism from glucose to fat, and there is fatty acid oxidation, fatty acid utilization, more and more free fatty acid utilization, and a decrease of lipolysis, also decreasing fatty acids, as a result of which there is decrease of fat in the visceral tissue as well as in the liver. It is also protecting the liver by NFLD and all these things that you have already told. This is a very nice topic and this is a very good concept.
I think one thing, sir, you can add, it causes some ketogenesis. So that is used as an alternate fuel, and that is a much better fuel, particularly for the cardiomyocytes.
Yes.
So it's a much better fuel.
Another point is, sir, conversion of white adipose tissue to brown
adipose tissue, yes.
And modification of the macrophages, the inflammation part is also taken care by
this. This is the mechanism, same
yes,
mechanism almost.
Sir, my question, are there any other drugs that can address this diabetes, metabolic
yes,
obesity?
I think GLP-1.
Yes.
GLP-1 receptor agonists are the other class of drug that can address this meta-obesity. In fact, there is only one group that has come with some sort of recommendation. It is from the Pakistan. So they have formed a group on meta-obesity, and they came with some recommendation. The two drugs are recommended for diabetes as part of meta-obesity are the SGLT2 inhibitors and GLP-1 receptor agonists. That you can consider as some sort of a recommendation from a authenticated group.
Yes. So if there are no more questions, we can conclude the session now. Thank you.
Thank you, sir. I request you to please proceed towards the presentation area for Momento. Now we have the lunch break. We'll assemble again after half an hour around 2:10 to 15 p.m. I request everyone to please proceed for the lunch and to be here sharp at 2:10 p.m. Thank you. come back to the session. We'll start the scientific session now. I request our chairpersons, Dr. J. Kishore, Senior Consultant, Medicine and Diabetologist, Ashok Diagnostic Center, Bhubaneswar, and Dr. B.N. Panda, sir, Retired Professor of Medicine and Pulmonology, Bhubaneswar, to please kindly come up on the stage.
Hello. Welcome to the post-lunch session. To tackle and handle the postprandial hyperglycemia with prospective anti-diabetic protocols, and to address a complicated issue like timely intervention in type 2 diabetes mellitus. Everybody knows it can be intervened, but what is the practical aspect of it? When you can plan to achieve early and sustained glycemic control. To address the issue, I request call upon Professor J.B. Kanwar from IMS and some hospital postgraduate department of endocrinology to address the issue.
Hello. It gives me immense pleasure to introduce Dr. Jai Bhanu Kanwar. As all of you know, he has been introduced, and his credentials are that he has published many articles in peer-reviewed national and international journals. He is a reviewer of many journals, including IJEM. He is a past secretary of Odisha Endocrine Society, and he has organized many national and state conferences, and many more. He has many other feathers in his cap. Now he will be talking about the topic which has been already told. On to you, Kanwar.
Thank you, Chairman Sir. Very good afternoon to all of you. It's a very difficult session to start post-lunch. So I would start with the Indigo dialogue. समय पे रहना अनिवार्य है. समय पे डायबिटीज ट्रीटमेंट करना भी अनिवार्य है. This is my topic. I would primarily focus on fixed drug combination of SGLT2 inhibitor and DP4 inhibitor. So today I will be speaking on timely intervention of type 2 diabetes, some practical consideration of achieving early and sustained glycemic control. All of us know that once the metformin fails, then we will start with the second oral antidiabetic agent. When do we start second oral antidiabetic agent? What is the HbA1c level? To see that, actually, Kamlesh Khunti, they had a prospective global observational study. At what time people are actually changing from metformin to second oral antidiabetic agent. So this is a Discover study program. This is a prospective study over 38 countries, and you can see there are 12,000 odd diabetic subjects, and you will see that hardly 17% of the people are achieving HbA1c of less than 7%. And globally, when the second drug being added, only 27% of the people achieve the target. 27 people are HbA1c of more than 9%. And this is about 36% in Indian population. That means 36% of the subjects, they are changing from one monotherapy to second drug after the second drug, maybe after long time. So I'll speak about that, how long. And as you all of us know that with the duration of the diabetes progresses, then the effectiveness of the drug decreases. So that's we can see in the graph, the diagram on the left-hand panel, that the metformin, the percentage of the people achieving the HbA1c of less than 7% with metformin is about 44%. So by the time 9 years with metformin, the people achieving target is substantially low, is 13%. So now we know that while we're starting with the second oral antidiabetic agent, so lots of time being spent, and many of them are having HbA1c of more than 9%. And this is a data from the Ramchandran group from Chennai. When the people are newly diagnosed with type 2 diabetes, we all see newly diagnosed diabetes with HbA1c of more than 8%, 9%, but this is the data from Ramchandran group, who actually looked into two groups. One group was clinically diagnosed to have diabetes in clinic, urban clinic, and other group who were detected diabetic on population screening. But you can see the HbA1c is newly diagnosed diabetes is about 9.1% to 8.3%. So what should you do now? Now we know that many of the people who are diagnosed with diabetes with HbA1c of 9%, and those who are diagnosed for going from one antidiabetic agent to the second oral antidiabetic agent, the HbA1c is very high. Mostly it is more than 9%. Then we go to the second oral antidiabetic agent. So stepwise approach, physician and patient, they don't feel of any urgency of controlling the blood sugar, then gradually increasing the one diabetic agent with another antidiabetic agent. But if you start with the early combination, you are more likely to achieve the target level. And obviously, there will be a feature, long-term outcome would be better if you start with a combination therapy. So this is another study by Khunti, Kamlesh Khunti. They looked into the UK United Kingdom research data link data. That is the world highest computerized database about the diabetic patient. From that, they looked into what time somebody on one oral antidiabetic agent, what time the second oral antidiabetic is added, how the treatment is being intensified. And it clearly shows that if somebody is on only on one oral antidiabetic agent, it takes about 1.6 to 1.9 years to add this second oral antidiabetic agent. And to further intensify adding the another oral antidiabetic agent takes further 7 years. And to reach the intensifying with insulin takes further 7 years and further 3 years for the addition of the GLP-1 receptor agonist. So that is the data from the UK. And forget about the data what would be happening in India. So that clearly says the intensification process takes some time, maybe 7 years, 8 years, or 10 years to achieve the blood sugar level. So what are the advantages of the combination therapy? If you start with a combination therapy, you would achieve the glycemic target early, and you have the opportunity to combine multiple medication with complementary actions and to address the legacy effect. I will speak about the legacy effect. And also, if you keep on increasing the dose of a single oral antidiabetic agent, that would be having adverse effect. So if you are giving combination therapy, obviously the doses used are very less, so likely to have less adverse effect. And also that would improve the patient adherence. So what is adverse effect? Legacy effect. Legacy effect, you can see the x-axis, there is a 1 year period. What is happening with the HbA1c level? The upper dotted line that denotes who were not treated intensively, and HbA1c continues to remain high, more than 7%. And the lower dotted line that denotes these people were intensively treated and the HbA1c remain less than 7% during the first year of treatment in diabetes. What happens? After 5 years, you can see those who continue to have higher HbA1c because they were not treated intensively, they have higher cardiovascular risk. The myocardial infarction, stroke, and cardiovascular events are much higher. About 50 to 60% are higher cardiovascular risk. How to address that? We all know that DP4 inhibitor are very good as compared to the SGLT2 inhibitor. You must have heard the morning discussion about the effectiveness of DP4 inhibitor. That when the HbA1c is between 8 to 8.5%, the DP4 are very effective in reducing HbA1c as compared to the SGLT2 inhibitor. Similarly, if you look at the HbA1c, baseline HbA1c is more than 8.5, then SGLT2 inhibitor are better than DP4 inhibitor as far as the HbA1c reduction is concerned. So if you combine both DP4 inhibitor and SGLT2 inhibitor, you are going to address the problem of achieving the target HbA1c level. How effective the both EMPA-LINA combination? If you combine these two medications initially in your treatment, and you can see those in the left-hand panel, those patients with baseline HbA1c of less than 8.5%, and right-hand panel showing the HbA1c baseline HbA1c of more than 8.5%. So EMPA-LINA, you can just focus on the blue bars and the sky blue bars, the EMPA-LINA combination reducing HbA1c by 1.191%, and when it is the baseline HbA1c is higher, more than 8.5%, even it is reducing HbA1c by 1.8%. And this is at the background therapy of metformin. And there are also data to suggest if you start a EMPA-LINA combination in a treatment-naive patient, it may reduce HbA1c up to 2%. So it's very effective as far as HbA1c reduction is concerned. Now, once we know that drug is very effective in reducing HbA1c level, how early it is achieving the target HbA1c, and how long it is the durability is persisting. So this is the study by DiFronzo. They clearly shows that the lower two lines you can see, these are EMPA 25 and LINA 5 and EMPA 10 and LINA 5. So you can see the lower graphs, lower curves, that denotes EMPA and LINA combination. So there is significant reduction of HbA1c of less than 7% very early, and the durability over the 52 weeks time is also persisting. So this combination is not only reducing HbA1c, it is reducing HbA1c very early, and the durability is persisting for more than 1 year. And we do know that they do have some pleiotropic effect by reducing body weight, blood pressure reduction, and serum uric acid reduction, and many of these pleiotropic benefit has been translated to the cardiovascular and renal benefit primarily because they are reducing the body weight higher as compared to the individual drugs. So the body weight reduction with the EMPA-LINA combination is much higher as compared to the individual EMPA-LINA or EMPA, both doses of EMPA. And once we know that it is effective in reducing HbA1c, then we always think of hypoglycemia. Like sulfonylureas, these are very good anti-diabetic agents. They reduce HbA1c by 2%, but there is risk of hypoglycemia. So as I mentioned, the combination reduced HbA1c by 2%, then what is the risk of hypoglycemia? So this is a study by the DiFronzo. This is pooled data from the 2 randomized control study, which showed that the EMPA-LINA combination, both 25-5 and 10-5, having similar kind of hypoglycemia like the individual drug of 25-10 and linagliptin 5 mg. As you all know that linagliptin is a very good DP4 inhibitor. The risk of hypoglycemia is much lower because the linagliptin has their insulin independent action. So depending on the glucose level, the insulin level would increase with the DP4 inhibitor. So there is risk of hypoglycemia much lower with the DP4 inhibitor. And similar thing is happening with these, with empagliflozin, they are insulin independent drugs. So risk of hypoglycemia is much lower. So this diagram you must have seen many of the times. The addressing all the octet or pathophysiological pathway of diabetes. If you combine DP4 inhibitor with the SGLT2 inhibitor, you are going to not only achieve the HbA1c, reducing the body weight, and all the pleiotropic benefit, as well as addressing the pathophysiology of the hyperglycemia in patient with type 2 diabetes. Almost 6 pathways have been addressed. What do you want from an anti-diabetic agent? It should be effective. Their risk of hypoglycemia must be low, and this should reduce body weight. Maybe if you have some systolic blood reduction, that is added advantage, and should be cardiovascular and renal protective. Normally you are using metformin and sulfonylureas, very good drug as far as the HbA1c reduction is concerned. When you add to that with the DP4 inhibitor, then the risk of hypoglycemia is lower, and they are also effective in reducing HbA1c. But on the background of metformin, if you use the combination of SGLT2 inhibitor and DP4 inhibitor, then that addresses all your target. That addresses effectiveness, reduce risk of hypoglycemia, body weight reduction, systolic blood pressure reduction, as well as cardiovascular and renal benefit. And this slide you must have seen many of the times that empagliflozin reduces 3-point MACE, reduces all-cause mortality by 32%, reduces cardiovascular death by 38%, and also renal protective, reducing nephropathy and the renal composite outcome by 46%. So what do you want from a medication which would reduce the cardiovascular mortality, all-cause mortality, and also reduce and gives renal protection? Now coming to the linagliptin, they are also having effect on the microalbuminuria. We have seen from the Carmelina study, there is 14% reduction with the microalbuminuria with the linagliptin. And as all know that in the Carmelina study, the background the patients were also on ACE inhibitor, ARB, and 55% on the metformin. So combining the two drugs, so linagliptin, which is cardiac safe, which is renal safe, and very easy to use, once daily, any time of the day, any day, irrespective of the food intake, you can give. So very easy to use. And other hand, empagliflozin is having very good data about the renal protection, cardiovascular protection. So if you combine, there will be faster achievement of the target HbA1c. There is also lesser risk of genital tract infection. As you know, empagliflozin increases risk of genital tract infection. So if you give a combination of empagliflozin and linagliptin, that would reduce the risk of genital tract infection. If somebody on DP4 inhibitor, then you sequentially add SGLT2 inhibitor, their reduction in genital tract infection is not much. But if you give a combination of both DP4 inhibitor and SGLT2 inhibitor, then the risk of genital tract infection is almost 4 times decreased as compared to the only giving empagliflozin. And the risk of hypoglycemia, I told, very minimum risk of hypoglycemia, complementary mode of action, and the most important thing is once daily, irrespective of the food intake, both combination can be given, and consistently would be reducing HbA1c and target, and would achieve all sort of thing you want to have in a diabetic patient. So both 10 milligram and 5 milligram and 5 milligram combination are available. And the only problem with the Empalina is the cost. Obviously, people would ask that this is a very good drug, however, it's costly. But if you look at the cost of a diabetic patient, the percentage of money they are spending for management of diabetes, you can see for maybe 28% for diabetes related treatment, and some 22% for the complication hospitalization, and for screening on complications about 36%, and other costs involved. So there are lots of costs involved. Even if you don't give these costly medications, there are lots of costs involved as far as hospitalization, cardiovascular disease, renal morbidity, and as well as the other complications. So if you give a combination of Empa-Lina fixed dose combination, however it may be costlier, but if you give separately it will be very costly, but if you combine a drug, then it will be reducing about 30 rupees, 40 rupees per tablet. So that's not an issue. The main problem is that it is addressing hospitalization for heart failure, CV death, is giving microalbuminuria, protecting kidney, and with robust data about the HbA1c reduction, minimal risk of hypoglycemia, and other pleiotropic benefit. So if you, over long term, if you see, if you have started a combination of drug, that would be cost effective as compared to the regular treatment of diabetes. So if in a day, if you think this tablet cost about 80 rupees or 70 rupees, but in the long term, it would be cost effective to prescribe Empalina combination. So just the last slide. So just to summarize the benefit of the Empalina combination, metabolic effectiveness is by reducing HbA1c in 1.8%, significant pleiotropic benefit of weight loss and BP reduction, and cardiovascular perspective like CV reduction, risk reduction, 3-point MACE, CV mortality reduction, all-cause mortality, and of course, hospitalization for heart failure. And as far as renal perspective, there is 39% relative risk reduction of microalbuminuria with empagliflozin, and as mentioned in Carmelina study, there is 14% reduction in the progression of microalbuminuria. So overall, very good drug with reduced HbA1c level and cardiovascular and renal protective drug. Thank you.
Thank you, Dr. Kanwar, for your very lucid presentation. I think the points must be well taken by the audience. Now they must be knowing that cost is not just a factor, but we need to see a lot of other benefits. So it's now open for any question from the audience.
Before audience makes up the mind, now think of us. Our robust friend, strong friend has been the metformin and the sulfonylurea combination, which has stood with us last more than half a century. Over that, we added glutathione schemes, went away. Some of the alpha glucoside inhibitors came, they have not gone away. Now, another robust thing has come, DPP4 inhibitors. Now, the SGLT2 inhibitors. Now, can we combine sulfonylurea, metformin with DPP4 inhibitors? Because there is no comparison earlier, not much of comparison in renal protective. It has got a renal protective effect. But the studies have shown that deaths in diabetes in India are more due to infection. Of course, cardiovascular mortality is there. 30% get. So, can't we use this previous combination sparing this SGLT2 inhibitors? I am going slightly off track.
Correct. I would agree with you. But if you use sulfonylureas metformin combination,
DPP4 and
okay. Now, you first question, you want to spare with the newer SGLT2 and DP4 inhibitor. Yeah, if you are giving those two combination, you are not going to achieve the target HbA1c level first, and second is you are not going to get the cardiovascular and renal benefits. So these are the two actually prime disadvantages with high risk of hypoglycemia in sulfonylureas. But in clinical scenario, I would agree with you that if somebody on glimepiride or sulfonylureas or metformin combination and the sugars are still not controlled, then that is, and many of the times we are using this combination of empagliflozin, linagliptin or other combinations, then the sugars are better controlled. See, our primary job is to achieve the HbA1c level in the target level, which if you are not able to do its sulfonylureas metformin combination, obviously you have to add. And the scenario where you feel that the patient can afford for good medication, then obviously if you think that would be a better medicine, then you start with the EMPA and DP4 combination. Yes?
There have not been head-to-head trial between
obviously there has not been head-to-head.
Any other questions from the audience?
You see, they had initially meta-analysis of 5 studies by Rosenstock, Matthews, DiFronzo, where they looked into the combination of SGLT2 inhibitor with DP4 inhibitor. They found the relative risk of having genital tract infection is 0.51%, almost 50% reduction with the genital tract infection. And in another meta-analysis, they found if you are giving as a combination of both drug, that would more beneficial as far as the genital tract infection, rather than sequentially using one after another. And the mechanism they suggest probably of better glycemic control. You know that when the sugars are uncontrolled, all the patients have increased risk of genital tract infection, even the urinary tract infection. You see, even a patient on not on these drugs, but they have genital tract, urinary tract infection because of poor glycemic control. So if you are using anti-diabetic, which is good in reducing blood sugar, so that would protect against the genital tract and urinary tract infection because of the good glycemic control first. And second, there has been some hypothesis that the DP4 enzyme is also expressed by the fungi and bacteria which are commonly causing genital tract infection in diabetes. So if you are using DP4 inhibitor, so whatever the risk of genital tract infection is there, because it's inhibiting the DP4 enzyme of those bacteria and fungi, the risk of genital tract infections are lower. Isn't it, Kishore? Or would you like to add something else?
No, I think this is right. This what you have told is right, absolutely.
There are many hotels available, but Sambit choose to organize this in Mayfair. That's the answer.
It's a good answer. Thank you, thank you.
Thank you, chairpersons. Thank you, our speaker. Please proceed to the presentation area. For our next session, I would like to request our chairpersons, Professor Dr. Samir Sahu, Professor and Head, PG Department of Medicine, IMS and Sam Hospital, Bhubaneswar, and Dr. Nishit Mohanty, Senior Consultant Nephrologist, Apollo Hospital, Bhubaneswar, to please kindly come on the stage.
So, so for the next topic, the speaker is Dr. Arindam Ray. He is MD, DM Endocrinology. He is Assistant Professor, Department of General Medicine, College of Medicine and Sagor Datta Hospital, Kolkata. He is a visiting consultant of endocrinology, Zenith Super Speciality Hospital, Kolkata. Many publications till date in peer-reviewed indexed national and international journals. He is a co-author of chapters of endocrinology in several textbooks, and he will be speaking on diabetic kidney disease, which is I think is a leading cause of chronic kidney disease and end-stage renal disease in India, and for that matter worldwide, leading to a lot of disability, decrease in quality of life, and increase in premature deaths. So these things will be addressed by the next speaker, and I welcome him to grace the dais.
So, good afternoon, Bhubaneswar. It's my pleasure to be a part of it, and thanks Chairperson sir for kind introduction, and thanks Dr. Shambit Das for inviting me here as a speaker. There I think a bit technical glitch is there, so I'm just starting my topic without delay. So what the diabetic kidney disease that we feel as the endocrinologist or diabetologist, the patient of diabetes when visit to you for the first time maybe. So we see the patient may have a prior diagnosis of kidney disease, or the patient may have the diagnosis of kidney disease at the same time of diagnosis of type 2 diabetes, or the patient will later develop the diabetic kidney disease. So the issue with the kidney disease that is always related to the diabetes, and we see that even in the pre-diabetes stage, the patient may have some kidney insult, so that will lead to a difference between the presentations of this diabetic kidney disease. Now the thing is, the diabetic kidney disease is a very important aspect of in any diabetic patient. So there are different data are there, not only from the India, but also from different part of the world, that says if you see the causes of kidney disease, the diabetic kidney disease is the leading cause of chronic kidney issues in different spectrum. So this is the data from Canada that actually shows the diabetic kidney disease is the leading cause of chronic kidney disease, keeping apart the glomerulonephritis, the pyelonephritis, the vascular disease. But the diabetic kidney disease is definitely the leading cause of this CKD. Again, if you consider the diabetic patients, then this, keeping in mind all the complications of diabetic patients, the cardiovascular complication, the ischemic heart disease, myocardial infarction, heart failure, cerebrovascular accidents, or the lower limb amputation, very significant position is there of this chronic kidney disease or the end-stage renal disease in this chronic, the diabetic patients to get admitted in the hospital. So this is the different stages of chronic kidney disease. We can see that when a patient starts the symptoms of having the chronic kidney disease, the patient actually have more than 70% of the kidney involvement, whereas the patient start to rise the serum creatinine level when the more than 50% of the kidney function is lost. But the gap is there in the diagnosis of the chronic kidney disease, and we see that primary care physicians screen only 20% of the patients or diabetic patients for the kidney disease before this prescribing medicines. And with the due course of time, there is worsening of hypoglycemia in the renal impairment that happens when the patients are actually face a lot of issues. So this is the prevalence of the chronic kidney disease in the risk in the Indian patients with type 2 diabetes, and this is a study from Dr. A.K. Dash and Dr. Sanjay Kalra that we can see in different stages of chronic kidney disease, where starting from the eGFR of less than 60 with the albuminuria, we can say there are different stages the patients actually presents with the prevalence. And here we can see the normal that is the patient have there is no albuminuria and the patient have EGFR of less than 60, there is almost 1.06% of the diabetic patients, whereas the patient who have the severe albuminuria or the patient have the normal EGFR, that's almost 6.3% of the patients. So these are the patients in the extremes of this diabetic kidney disease pattern with a massive or macroalbuminuria, with normal EGFR, or with a reduced EGFR of less than 60 to normal albuminuria level in the different Indian diabetic population. So this is a very important slide that we have to remember what are the risk factors for the diabetic kidney disease. So most of us is well known to it. The generic factors are there: male sex, increasing age, long duration of diabetes, definitely the family history of diabetic kidney disease is a very important issue. So when we see a patient of diabetes, definitely we have to ask whether there is any history of diabetic this kidney disease in the family. So these are the issues that we have to take care. Definitely the modifiable factors like the glycemic control, hypertension management, lipid management, at the same time smoking cessation, the weight reduction, and also the salt intake, that is the lifestyle modification, is very important to prevent this diabetic kidney disease. Now this is the classification. We have uttered about the two terms, the diabetic nephropathy and diabetic mellitus with chronic kidney disease. So what is diabetic nephropathy? There is a damage to the glomerular capillaries in people with diabetes mellitus resulting in albuminuria in the absence of other causes of albuminuria. Definitely we have to rule out other causes like glomerulonephritis. Whereas the diabetes mellitus with chronic kidney disease is a term for the presence of more than 3 months of structural and renal abnormalities with reduced glomerular filtration in people with diabetes mellitus. So the more recent studies are there to show that a more complex and non-linear relationship for the possibility of microalbuminuria regressing and a progressive decline in the EGFR. That I want to highlight, that people with normal EGFR with a microalbuminuria, macroalbuminuria, or patients with a macroalbuminuria or the normalbuminuria with a reduced EGFR. So this is the different categories of the diabetic kidney disease. So when we establish a patient to have the diabetic kidney disease, when there is actually a part of 3 months, the patient have either reduced EGFR of less than 60 or the albuminuria of more than 30 milligram per gram of creatinine. And we can stage it accordingly, that stage 3A, 3B, 4 and 5, where it's very clear that EGFR 9 to 45, that is stage 3A, whereas 30 to 44, 3B, 15 to 29, that is stage 4, and less than 15, that is the stage 5 or the end stage renal disease. Now this is the pathophysiology, where we can see that that is not only the proteinuric pathway, but there is another non-proteinuric pathway is there. So the non-proteinuric pathway is mainly the vasculopathy, whereas the proteinuric pathway is mainly the glomerular disease. That is a nutshell from this slide. So these are the different stages. I have already mentioned that we can divide it in according to the EGFR, that is from G1 to G5, whereas the albuminuria from A1 to A3, and the risk factor stratification according to this Kidney International published in 2020 in the KDIGO. These are the glycemic targets in type 2 diabetic kidney disease patient. So for the early diabetic kidney disease patient, we have to make a strict glycemic control. There is no doubt about that. So the patient with the EGFR of less than 60, less than 30, so there should be some difference in this glycemic control. So as the patient will move to end stage renal disease, the chance of hypoglycemia is more. So in that case, the glycemic target should be a bit less. In that case, we have to achieve a glycemic target close to 7.5 or 8, whereas the patient with a EGFR of close to 60, we can have a glycemic target of less than 7 or 6.5 close to make the patient prevention of the further renal disease. The glycemic monitoring is another very important issue here, because the HbA1c that we commonly do with the fasting and PP, we give you not a very clear-cut value, because here the HbA1c can be falsely high or it can be falsely low. So falsely low values can be there with a very reduced hemoglobin. That is a very common association of diabetic kidney disease or a chronic kidney disease, whereas the falsely high value will be there when there is the presence of metabolic acidosis, that is the advanced kidney disease, or through the advanced glycosylated end products formulation in the advanced stage of diabetic kidney disease. So here what it suggests, and also the guidelines suggest, that the GMI, that is the glucose management, that is an indicator that is evaluated from this CGM data, there's a continuous glucose monitoring data. So that gives you a better status of the diabetes or the glycemic status in the patient of diabetic kidney disease. Now what this GMI is, it is actually derived from the CGM to provide an average glucose value expressed as a percentage to correlate with the A1C measurement. Now coming to the blood pressure control, is a very important part of diabetic kidney disease management. So here what the ADA target blood pressure, they suggest that the patient with diabetes and hypertension have a lower risk of cardiovascular disease. They have calculated a 10-year atherosclerotic cardiovascular disease index, which is less than 15%. The target blood pressure should be less than 140 by 90 millimeter mercury. Whereas the patient of a higher cardiovascular risk, then the target will be lesser, that is less than 130 by 80 millimeter of mercury if it is achieved without hypotension. And here the cutoff blood pressure, usually we don't make it low, like less than 100 by 60 millimeter of mercury, because that will hamper the diastolic filling and the cardiovascular, the vascular fillings. So here the choice of antihypertensive is definitely ACE inhibitor, ARBs, and dihydropyridine CCBs, thiazide-like diuretics definitely, but ACE inhibitors, ARBs are preferred when there is associated with microalbuminuria or the macroalbuminuria. But it's very clear cut that diabetic kidney disease or chronic kidney disease is mostly a the resistant hypertension is there, so multiple agents should be used to make the patient normotensive. Now coming to the lipid management, definitely it's a cardiovascular disease is a very important association or the morbidity for a patient of diabetic kidney disease. So this antilipidemic agent should be used in almost every patient of this chronic kidney disease unless otherwise. So here the lipid lowering agents, the statins, we have to use judiciously because many of the statins are metabolized in the kidney, so dose reduction is necessary. But atorvastatin, for atorvastatin the dose reduction usually not is there. So in that case atorvastatin we can use as per the strategy of cardiovascular dose reduction. So dietary modification, definitely here a bit protein restricted diet, but for sure that many of us we see that the usually physicians said there is no protein. It's absolutely wrong. The patient has to take protein but in a reduced way. Usually the protein recommendation is 0.8 gram per kg per day in a diabetic kidney disease patient. The salt intake should be at least less than 2.3 gram per day, and here definitely the patients with a hypertension, then DASH diet with a whole grain carbohydrate, the fibers, the fresh fruit, vegetables, and omega-3, omega-9 fatty acids that are essential in the management of diabetic with the food or diet consultation. So coming to the primary prevention of the kidney disease in type 2 diabetes patients. So these are not all the diabetic kidney disease patients are identical progression. As I've already said, the early detection of the high risk of the diabetic kidney disease is very important, and this mineralocorticoid antagonist is a dynamic marker of the early stage of the diabetic kidney disease, and the progression of diabetic kidney disease is not necessarily associated with proteinuria, and thus proteinuria is also not a sensitive marker for diabetic kidney disease progression. So some anti-diabetic classes drugs like SGLT2 inhibitors, GLP-1 RAs have shown reduction in the eGFR decline, chances of end-stage kidney disease, and reduced progression for the dialysis. Now one new molecule is there, that is finerenone, that is also an effective intervention to improve the kidney and the CV outcomes in the type 2 diabetes and diabetic kidney disease. Coming to the management of diabetic kidney disease, the holistic approach, as I've already told you, the lifestyle modification starting from weight reduction, smoking cessation, alcohol cessation, at the same time the regular exercise and proper diet. Then comes the the management from oral antidiabetics and the hypertensive lipid management. So this is a part of this comprehensive strategy for the risk reduction of the kidney disease and progression, and also at the same time the cardiovascular disease burden reduction. So this is in a in a pictorial way what I have suggested. There's the holistic approach should be there. Now coming to the glycemic point, the KDIGO gives you the clear cut the medication, that what medication we can use particularly in diabetic kidney disease patient. So first of all the physical activity, then the nutrition, weight loss. Coming to the first line therapy, the metformin and SGLT2 inhibitor are there. So metformin above eGFR of 45 we can use the full dose, but when it's come to less than 45 eGFR, then we have to reduce the dose to half. We do not want to initiate the metformin therapy. For SGLT2 inhibitor, even few days back the eGFR cutoff was 30, but nowadays the KDIGO suggests up to eGFR of 20 we can use the SGLT2 inhibitors, and then if these two fails, then next line therapy includes the GLP-1 receptor agonist, the different DPP-4 inhibitors, and insulin, sulfonylureas, a lot of molecules are there accordingly. So this is the KDIGO therapeutic will. Is widely available in the internet, so we can just go through it. It's what's the different strategies for the choosing the oral anti-diabetic agents. It's very clear coming from the hypoglycemia point of view, cost-effective point of view, at the same time the weight gain and the other issues are there. So coming to metformin, as I've already told you, metformin is a very safe drug, because many of the patients in the chamber that call that say, please avoid metformin, metformin is nephrotoxic. It's absolutely wrong. Metformin is not nephrotoxic. Metformin saves the kidney by good glycemic control. So what's the issue is there? When we have to calculate the eGFR, we have to do the creatinine, and we have to reduce the dose when the eGFR is less than 45. It's not because of the nephrotoxicity, it's because of the lactic acidosis and other issues are there with the metformin. So when the eGFR drops to less than 30, then definitely we have to stop the metformin. Coming to the SGLT2 inhibitor, as I've already mentioned, there are the different studies are there. I will show you later. That is the DAPA-CKD study, EMPA-CKD study. So up to eGFR of 20, KDIGO suggests the use of this SGLT2 inhibitor, which just few months back even the eGFR cutoff was 30 for SGLT2 inhibitor in different studies. So what the SGLT2 inhibitor actually do? They have a holistic, the mechanism that's by constriction of the afferent arteriole by the that is a natriuresis. That's the sodium is actually restricted reabsorption in the proximal tubule, so sodium load high in the distal tubule, and that gives the sodium signal in the macula densa, and that causes the afferent arteriolar constriction, reduction of the interglomerular pressure, and that gives the advantage of this molecule for the nephroprotection. Coming to the other molecules like GLP-1 receptor agonist, so they have also in different studies suggest that they are nephroprotective, but when you use this GLP-1 receptor agonist, we have to have a eGFR cutoff. Like the dulaglutide, we can use a full dose without modification up to eGFR of 15. For exenatide and exenatide extended release up to eGFR of 30 is there. But for liraglutide, lixisenatide, semaglutide, this oral semaglutide is now widely available in the market of Indian market. But there is no, the data is there for the severe CKD, but usually in the upper eGFRs, there is no dose adjustment required. So coming to the DPP-4 inhibitor, Converser has already elaborated the beautiful Carmelina study where the linagliptin actually shows a reduction in the albuminuria, but whereas in the other DPP-4 inhibitors do not have been dedicated, there is the kidney disease studies are there, but sitagliptin, saxagliptin, alogliptin can be used with the reduced doses. So last few slides are there, agents with that actually mitigate the renal risk. The RAS inhibitors, that is we all use the different ACE inhibitors and ARBs with the reduction of the in patient of diabetes, hypertension, albuminuria, and RAS inhibition has been considered a standard of therapy in several decades before the SGLT2 inhibitor comes to the market. Coming to the SGLT2 inhibitor, as I've already mentioned, by reducing the glomerular hyperfiltration, it actually gives you the advantage. These are the different doses as I've already mentioned. So this is the different studies are there. There is a DAPA-CKD study and EMPA's kidney studies there. Whereas the preliminary studies, that is the CANVAS, the empiric outcome and the DECLARE-TIMI, where the kidney protection is the secondary benefits are there, not the primary, the details are there. But recent these DAPA-CKD and EMPA's kidney study are dedicated kidney studies of these SGLT2 inhibitors. So here we can see in the summary that the Credence and DAPA-CKD shows the advantage, but EMPA kidney study is yet to publish their data. So there is actually a 39% reduction in the Credence study with the canagliflozin relative risk reduction. There is a DAPA-CKD study with the dapagliflozin that shows actually almost 39%, the relative risk reduction published in 2020. Now coming to this GLP-1 RA, I have already mentioned, and the last slide, these are the non-steroidal mineralocorticoid receptor antagonist. There is a finerenone, as already mentioned, that the two studies are there, Fideldo-DKD and the Figaro-DKD study, that shows a reduction, with the microalbuminuria. At the same time, the kidney issues are improved and cardiovascular safety is there, and risk reduction is there with this molecule, finerenone, that is a non-steroidal mineralocorticoid receptor antagonist. So the take-home message from my presentation today, the diabetic kidney disease is definitely an important complication in patients with diabetes, and the therapeutic options to prevent and slow the progression of DKD have historically been limited with the RAS inhibitors primarily. The recent evidence support the benefit of novel therapies with the SGLT2 inhibitor that prevent the options to improve the kidney and outcomes in the high-risk population. Definitely we have the dapagliflozin that is in a very cheaper rate, the price in the market. So definitely we as a primary care physician, diabetologist, endocrinologist, we have to use it to prevent the diabetic kidney disease. And as I have already mentioned, the practitioners can play an important role in helping optimize the use of the important therapies, recommending the use in appropriate patients, educating patients and caregivers for the appropriate use. So this is to prevent the dialysis stage. When a patient comes to you for the first time with the diabetes, definitely the patient may not have the established this kidney disease. So as a primary prevention, it's your job to protect the kidneys. And my last slide for the acknowledgements to my hospital junior faculties who helped me to make the slides, and Lupin Pharmaceutical for providing information and logistics. Thank you.
Thank you, Dr. Roy, for your excellent talk. Here as a nephrologist, actually, I want to emphasize that 40% of diabetic patients will have diabetic nephropathy. The most important thing is that any patient, for the diabetic and non-diabetic patient, they can have non-diabetic kidney disease. As a physician, actually, you have to differentiate whether your particular patient you are seeing, whether he is having diabetic kidney disease or he is having non-diabetic kidney disease. So there are few indicators for that. If the patient is massive proteinuria, if massive proteinuria is not an indicator of diabetic nephropathy. If patient is present with accelerated hypertension, then it is not diabetic, most probably it is not diabetic nephropathy. If patient is presenting with active urinary sediment means if your urine contains RBC cast like this, and rapid deterioration. Today it is your GFR is 80, tomorrow it is 40. So if diabetic nephropathy does not behave like this. So as a physician, if people have to differentiate whether your particular patient is having diabetic nephropathy or it is non-diabetic nephropathy. And this topic regarding actually this SE inhibitors and SE inhibitors ARB, definitely actually maybe last 25 years, 20 years actually we are using it. But of late, there is lot of articles are now published. Recently there is a big article from Canada, it is published. It is a case control study of more than 5,000 patients. They have seen that SE inhibitor ARB, definitely it prevents your diabetic nephropathy initial 3 years. If your use is more than 3 years, then they have done this study because now we are seeing that diabetic nephropathy patients are developing, lot of them are developing end-stage kidney failure very, very early, very rapidly. So whether this SE inhibitor ARB are the culprit for this or not, so that was the topic of study. So they found that any people, this is a case control study with more than 5,000 patients, and they found that if you are using SE inhibitor ARB more than 3 years, then your development of CKD is increased by 4 times. Your hazard ratio is more than 3. So that is why, because you are using left and right, thinking that our patient is getting benefit from SE inhibitor, so you have to be very, very careful. So what are the indication? Indication that suppose your patient, you have started ARB for the first time, then check the creatinine after 2 weeks. If there is hyperkalemia or there is your rise in creatinine, it was earlier instruction or your earlier study that if there is rapid rise more than 30%, that means there is some problem and you have to stop it. Now, after using of so many years, so now it is if your patient developing, there are 3 indicators as a nephrologist, what I have observed is that if patient is having there was a stable problem, then there is decrease in creatinine, patient developing your anemia, because one of the complications of ARB S inhibitor is anemia. It is very, very significant. Anemia, one of the cause of anemia in diabetic nephropathy patient is ARB and S inhibitor and hyperkalemia. So probably if somebody diabetic nephropathy or diabetic patient getting S inhibitor, his kidney function is deteriorating rapidly, or if he has already received more than 3 years, then review your treatment, and possible then you have to reduce the dose. After that also there is no decrease in your creatinine, there is no improvement in renal function, then probably you have to discontinue. For that you can use CCBs or other antihypertensive. So this is my message for today, because we are using in tons this ARB-S inhibitors. Probably now it is not one paper, it is another paper published from UK, recently was published. There also they have seen the patients who are on long-term S inhibitor and ARB with stage 4 and stage 5 kidney disease, then if they are stopping S inhibitor and ARB, then their kidney function are improving, and initiation of dialysis is delayed. This topic is open for discussion. Any question from the audience?
Not only by the physician, primary physician, quacks, rheumatologist, orthopedics, everybody uses analgesics. I think you have to give a comment, sir, on role of analgesics. Both of
Sir, I think you are the best person to say it.
Definitely, not only in diabetics, but definitely all the NSAID, except the NSAIDs, they are prostaglandin inhibitors. And these diabetic nephropathy patients, their blood flow is maintained by your prostaglandin, vasodilatory prostaglandin. The moment you give your NSAID, there is a decrease in the intervallar pressure, and that is acute renal failure. So definitely, first it will cause acute renal failure, and repeated use it can cause CKD. So definitely it is no NSAID for diabetic patient. Strictly no.
Or some non-diabetic causes. Maybe because of hypertension or accelerated hypertension. How do the management differentiate? If you diagnose this because of diabetes, and if you diagnose this is non-diabetic kidney disease in a diabetes, how does the management differentiate?
Definitely. Suppose diabetic patient may have memorization nephropathy. Diabetes patient have RP, any autoimmune disease. Diabetic patient have you told that chronic NSAID abuse. So diabetic patient may develop any autoimmune disease or of glomerular disease other than the. So that you have to, because the treatment is different. Membranous nephropathy treatment is different, and diabetic nephropathy treatment is different. So you have to differentiate.
So immunosuppressive therapy will be better work there. So steroid, cyclosporin, tacrolimus. So that's a different category of kidney disease are there. So
we frequently getting it. Yeah. The combination frequently we are getting.
And amyloidosis and renal vein thrombosis are very common complication of diabetes. So we have to differentiate when a massive proteinuria is there. Tramadol is also safe. So tramadol, yeah, paracetamol, tramadol also this.
Low dose paracetamol you can try. Low dose paracetamol, 500 mg, not 650 or 1 gram.
One question. Out of the 3 glycogens, which one is the best for renal shutdown?
So it's a nice question, but the issue is that there is no head-to-head trial among all these glyphosins are there. But the different studies are showing different results. But as a class molecule, this works. So we have the dapagliflozin in our hand, which is a very cheaper rate. So definitely we can use it in particular patients. And also dapagliflozin shows improvement from cardiovascular point, the hospitalization for heart failure reduction also there, which is a very common association of the chronic kidney disease patients. So I think the dapagliflozin is a very good for the Indian market, but in next few months also empagliflozin will come, and that's also give a good result, particularly from mass reduction point of view. So canagliflozin, dapagliflozin, empagliflozin, all good, but you have to choose accordingly, keeping in mind what the patient have in background.
Okay, I think this is the end of this topic.
Thank you, sir. Thank you for your comment.
Thank you, sir. I request you to please proceed towards the presentation area. Next, I would like to request our chairperson, Professor Dr. K.N. Padhiyari, Senior Consultant of Medicine, Cuttack, and Professor Dr. Sanjay Kumar Janged, Professor of Medicine, High Tech Medical College, Bhubaneswar, to please come up on the stage.
So the topic is very interesting in the sense that it is errors in the management of thyroid toxicosis. Now it is different from other topic, conventional topic. We have already extensively discussed about diabetes. It is away from it. But the most important is the errors. It is very difficult to compile errors because these errors are committed by all of us. But how often we report it? How often it is published? How will you compile all the errors together? And you will be telling it before others. So most of the time errors remain confined to individual. I have seen some errors, it remains with me. You have seen some errors, it remains with you. So it is very difficult to compile errors of everybody and present it before an audience like this. And I know because I have written a book about common mistakes in clinical medicine, and the whole book is on errors, starting from history taking, from general examination, from intervention, from everything on errors. And basing on my own experience, whatever my students have committed and whatever my colleagues have committed. That much I can say. Many more might be there. Many people might have done much more mistakes. It is difficult to compile mistakes. So let us see how Dr. is going to discuss about the mistakes in treatment of thyroid toxicity.
So we have Dr. Colonel Vimal Upreti to speak on the topic. He is consultant endocrinology, Magna Centers for Obesity, Diabetes and Endocrinology, Greater Noida, and he is also associate director, JIP Hospital, Noida. And he has been former senior advisor, Indian Armed Forces, professor medicine endocrinology, and also examiner in National Board of Examinations. Over to you, sir.
Thank you so much, sir. Thanks a lot for the kind introduction. As sir has really pointed out that there can be so many mistakes, and I have tried to just compile a few of them. Coming from very common topic of diabetes, now we go to second most common endocrine condition, that is thyroid. But among thyroid disorders, thyrotoxicosis is rather uncommon. So errors making is commoner in thyrotoxicosis. So coming to the first differentiation, before I go on to the errors, what is hyperthyroidism and what is thyrotoxicosis? These are the two terms that we use interchangeably. So hyperthyroidism is a state of thyroid hormone excess in the blood when the thyroid hormone is functioning more. So the disease primarily lies in the thyroid gland itself. Whereas thyrotoxicosis is a broader term which encompasses not only hyperthyroidism but excess thyroid hormone from external sources like stroma ovarii or exogenous ingestion of thyroid hormone, etc. So thyrotoxicosis is a broader term than hyperthyroidism to use. Now I'll run you through few cases, and then we'll discuss what the errors are. So my first case is a 36-year-old male. He presented with complaint of weight loss of about 7 kgs, feverishness, tremorousness, and malaise of 6 weeks duration. His thyroid profile was done, which is showing thyrotoxicosis. He was diagnosed as a case of Graves' disease and was referred for treatment with antithyroid drugs. ATD stands for antithyroid drugs. So when he came to us, the patient was reviewed. He gave history of neck pain initially at the onset, and there was a mild tenderness over the thyroid area while palpating the patient. Pulse was 108 per minute. There were features of mild thyrotoxicosis was there. So what should be the next line of management for this patient? So we investigated a few more investigations other than thyroid profile, and we found that ESR was high. ESR was 80 millimeters at the end of first hour. C-reactive protein was positive. We did the T3 to T4 ratio, which was low in this patient. Less than 16 suggests thyroiditis, whereas more than 20 is seen in Graves' disease patient. Then we went ahead and did a thyroid pertechnetate scan in this patient, and this is the uptake of the salivary glands, and this is where the thyroid gland lies. So in Graves' disease, it should be like this only. So dark black it should be here. I am not sure whether this point is seen. So here we see it's not, the uptake is low. So what are the causes of thyrotoxicosis with low uptake? Any prior iodinated contrast media in prior 4 weeks, present of thyroiditis like subacute thyroiditis or drug-induced thyroiditis or silent or acute thyroiditis, any ectopic thyroid tissue, thyroiditis factitia where the patient is ingesting thyroid from outside sources, or extensive functioning metastasis from functional thyroid carcinoma. So this patient had subacute thyroiditis, and it was described first by Fritz de Quervain in 1904, and also known as de Quervain's thyroiditis. It is the most common cause of painful thyroid gland. So, and it almost accounts for about 5% of patients having clinical thyroid cases or thyroiditis. And this is how the hormones behave in this typical patient of thyroiditis. Here the red line is the serum T4 line. It rises initially, then it falls to below normal range in the hypothyroid range, and sorry, I think the pointer stopped working. It falls to hypothyroid range, and then it comes back to normal within about 6 to 9 months time. TSH behaves in the opposite manner to T4. So when the T4 is high, the TSH is low, and then it rises and then comes back to normal. And so is the iodine 121 uptake, 123 uptake. So in this first case, the diagnosis was subacute thyroiditis. The error was that sufficient cognizance was not given to the patient's symptoms and thyroidal tenderness that the patient was having. And so we made a diagnosis of thyroiditis in this patient, assured the patient, given NSAIDs and propranolol. There is no role of antithyroid drug in this patient because this is because of a destructive sort of thyroiditis where the preformed or pre-stored hormone from the gland is released in the circulation, and thyroid function test was serially monitored in this case. Now coming to the second case, she is a 38 years old female, was rated to have Graves' disease 3 months back with history with clinical features and biochemical features of thyrotoxicosis. As you can see in the first table, the thyroid hormones T3 and T4 are raised and TSH is low. So she was started on tablet carbimazole 10 milligram thrice a day, and she was called after 6 weeks for a follow-up. At the end of 6 weeks, the TSH is still low. So her dose of carbimazole was hiked to 15 milligram thrice daily, from 10 milligram thrice daily to 15 milligram thrice daily. So does the house agree with this treatment, or there is some error you can see in this patient? Okay. So yes. Okay, great, thank you. So as sir has correctly pointed out, here we should be targeting the T4 level rather than the TSH level, what I will come to later on. So coming from treatment modality between methimazole, carbimazole and propylthiouracil, carbimazole is the prodrug of methimazole. So both are more or less equivalent drugs. The 10 milligrams of carbimazole is equivalent to 6 milligrams of methimazole. And methimazole or carbimazole is preferred over PTU because it has got a lesser toxicity profile as compared to propylthiouracil. Though some people, they prefer to use propylthiouracil because of its peripheral effects, but the toxicity profile is much better with carbimazole or methimazole as compared to propylthiouracil. And dose is to start with initially 10 to 30 milligrams per day of methimazole and about 150 to 450 milligrams of propylthiouracil if we choose to, and then it is maintained at the given dosage. And monitoring should be done with T4 and T3 levels and not with TSH, because TSH may remain suppressed for several months even after starting the treatment. And this is because of a defective intrapituitary signal. As we know, T4 and TSH, they have a feedback loop going on. So when the T4 levels start coming down, the TSH should increase. But it does not, the feedback is not direct. It happens through a small cell in the pituitary which is called pituocytes, and then they give signal to the thyrotropes. So this signal is effective. So here we target the T4 levels initially, and then and then T3 levels. So error here was monitoring with TSH. The patient was reviewed. She claimed improvement in symptoms and weight gain. She was reassured. Carbimazole dose, as correctly pointed out, was reduced, and again it was she was reviewed with serial TFTs. Now coming to the third case, a 23-year-old lady, married woman, presented with Graves' disease. She was started with neomercazole 30 milligrams per day. She developed severe neck pain and TLC was low. CECT of the neck was done, which showed a pharyngeal abscess. So it was a case of drug-induced agranulocytosis. She was asked to go for radioiodine ablation, and she was referred to our center for this. So error in this patient was that immediately after CECT of the neck, she was asked to undergo radioablation. So radioiodine will not work because the thyroid now is suppressed because of giving radioiodine contrast medium. So we titrated over initially with antibiotics, beta blockers and steroids, and then after 2 months when she was stabilized, she was referred to iodine 131 treatment. And this being a special precaution because newly married lady, she was advised to use contraceptive to at least 6 months post receiving of radioiodine. So I'll just enumerate a few more pitfalls in the management of Graves' disease, that is agranulocytosis and LFT abnormalities in Graves' disease. What should be the starting dose of antithyroid drugs in these patients? What should be the duration of therapy in a patient with Graves' disease? And how should we treat a relapse of Graves' disease? So agranulocytosis and LFT abnormalities are common in patients with Graves' disease. Almost 10 to 14 or 11 to 14% of patients with Graves' disease can have low TLC levels even at the onset. And similarly, about 25% of patients can have abnormalities in the SGOT, SGPT levels, which can be up to 1.5 times of the upper limit of normal. So always we should get a baseline LFT and complete blood picture done in this patient before the treatment starts. Now what should be the starting dose of antithyroid drugs? This chart here shows European study which shows if we start at a lower dose versus higher dose, that is 10 versus 40 milligrams, the control rate at the end of 6 weeks is much better with higher dose. And a comparison of 20 to 40 milligrams of carbimazole per day for the initial treatment of hyperthyroidism showed 20 milligram per day was too low if the patient were severely hypothyroid. However, if it is a less severely hypothyroid, it was an adequate dose. So based on these studies, there is the suggested table for approximate starting dose of antithyroid drugs based on initial free T4 levels. If the T4 levels are elevated mildly, that is 1 to 1.5 times above levels of normal, then we should be giving about 10 to 15 milligrams of carbimazole per day. 1.5 to 2 times upper limit of normal, it should be 20 to 30 milligrams. And if it is more than 2 times or 3 times, then we can go for a higher dosage of carbimazole. And how long should I treat a patient with Graves' disease? So relapse rate among the patient having 4 prospective trials, and this shows there is a clear-cut statistically significant difference between if the patient was treated for 6 weeks as compared to 18 weeks. The patient treated for 18 weeks did much better. And then they also tried between 12 and 24 weeks, 6 and 24 weeks, and 18 and 42 weeks. They found no difference. So the recommendation is optimal treatment duration for antithyroid drugs therapy is about 12 to 18 months, with a high recurrence rate only after, if the treatment is stopped only after 6 months, and no apparent additional benefit is accrued if we extend the treatment duration to more than 18 months. So now we'll come to treatment of relapse. This is a 34-year-old lady. She presented to physician with relapse of Graves' disease. She had earlier used antithyroid drugs for 18 months. Now again she has become toxic for 6 months after drug-free interval. And the thyroid function test you can see is suggestive of thyrotoxicosis with elevated T3, T4 and suppressed TSH. On examination, she had a grade 2 goiter with retrosternal extension was there. She had Graves' orbitopathy which was severe and had an activity score of 4/7 which was an active disease. So she was advised radiotherapy because she had failed, she had relapsed after first course of medical therapy, and she was referred to us. So coming to relapse on GD, on Graves' disease patients on ATDs, the remission rate is just about 20 to 30% in various European, in US studies, and about 50 to 60% of European and Japanese population. So relapse rates in Graves' disease are very high, and best best remission is achieved, if we have already discussed, if we treat for 18 months. And relapse is common in men, in smokers, in a patient having large goiter, persistently elevated levels of thyroid receptor antibodies, increased vascularity on thyroid Doppler, and those who stop treatment before 1 year of duration. And the treatment for them is radioablation or surgery. And in our patient, what were the errors? First, it was radiotherapy related errors. Radiotherapy will work only, radioiodine, should I have written radioiodine here? Radioiodine will work better only if the degree of thyrotoxicosis is mild. So our patient was grossly toxic, it will not work. Secondly, very large goiters seldom respond well to radioiodine. They don't respond. If it is goiter is more than 80 grams, it does not respond. And if the Graves' orbitopathy is active, then there is a chances of precipitating a severe disease, and even visual loss can be precipitated. So we have to avoid. Our patient had active disease having activity score of 4/7. Any score more than 2 is active. So here the better treatment would be to go for making the patient euthyroid before, and surgery would be a better option, because not only active disease, patient also had retrosternal extension, and once we give radioiodine to this patient, there can be stridor can be precipitated. So we have to be very careful. And second best choice again would be once we control the Graves' disease also, and control the eye disease, and then under steroid cover we can give radioiodine to this patient. Now coming to next patient is a 40-year-old male. He had history of head injury 1 year back due to road traffic accident. He complained of lassitude, malaise, weight loss and anorexia for past about 3 to 4 months. Investigation showed low hemoglobin. His sodium was low at 132 and TSH was also low at 0.2. Patient was referred as a case of anemia and thyrotoxicosis. So there are conditions where measurement of TSH alone may be misleading. And what are these patients? A patient who has undergone treatment for thyrotoxicosis recently, as we have just seen that we should be seeing T4 levels. Then central hypothyroidism. Because of any pituitary or hypothalamic disorder, their TSH may be low and the patient may be hypothyroid actually. And again, other causes being thyrotropinoma, resistance to thyroid hormone, where the TSH would be elevated, and disorders of thyroid hormone transport or metabolism. So we did the complete panel of thyroid profile in this patient, and we found that T3 and T4 were low, and so was TSH. So this was the case of secondary hypothyroidism post-traumatic brain injury. His serum cortisol level was also low. At basal level was 2.1, and even after synaptic stimulation it was 8.4. It should have crossed 12.5 here. Serum testosterone was low, sorry, and LHFSH was also low in this patient. MRI of the sella was done, which was found to be normal. So diagnosed as case of pan-hypopituitarism or multiple pituitary hormone deficiency post-traumatic brain injury with secondary hypothyroidism, hypocortisolism and hypogonadotropic hypogonadism. He was treated with hydrocortisone, thyroxine and testosterone replacement. Now coming to last case, she is a 25-year-old lady, 13 weeks of pregnancy. There was no past or family history of autoimmune thyroid disease. Thyroid profile was done, which is suggestive of thyrotoxicosis. T3 is normal, T4 is elevated and TSH is low. So how should we treat? What agent should we use for treatment? Anybody from the house can take this question? Anyone? Sorry, sir? 13 weeks of pregnancy.
Is out now, in all likelihood. So we can start with the antithyroid drug, carmimazole preferable in second trimester.
Okay.
It has been already 13 weeks. That's what I am telling. So probably it is not due to gestational thyrotoxicosis.
Okay.
Because peak of SCG effect is up to 10 to 12 weeks.
Correct. So what happens is we have to see the T4 levels here now. So preconceptional steady state and during pregnancy, as you rightly pointed out, because of the estrogen effect, the thyroid binding hormone increases. I think the display has gone. Yeah. So due to effect of the estrogen during pregnancy, the steady state of preconception steady state and during pregnancy the steady state increases, the binding globulin increases, that is why the total hormone level increases. An extrathyroidal pool of T4 also increases, as is shown in this slide. At various months, how much T4 increases during pregnancy. So first month it is about 30%, second month it is about 45%, and then it's about 50% increase. And this is what happens to the thyroid hormones, TSH and free T4. The as Sir clearly pointed out, that HCG levels start coming down around this time, and the TSH levels start rising. But still TSH levels are suppressed during pregnancy, and even free T4 levels, total T4 rises, even free T4 levels also rise during pregnancy. So pregnancy actually is a state of mild thyrotoxicosis. We can do it later, sir. And there are various trimester specific TSH levels. So during first trimester, the TSH range is between 0.03 to 2.3, with median being about 0.8. During second trimester, it is 0.03 to 3.1, median being 1.1. And during third trimester of pregnancy, it is 0.13 to 3.5, median being 1.3. So what we do is, we take the total T4 level and we multiply it by 1.5. That is the range during pregnancy the person should be having for normal levels. So whatever say the range is between 4 to 12, so we multiply it by 1.5, it becomes between 6 to 18. That is the normal range during the pregnancy for that lady. So it is not abnormal to find somebody having total T4 of 16 during pregnancy. So diagnosis was just normal pregnancy in this patient. She was failed to the error here was failure to recognize TFT alteration during normal pregnancy. We just reassured the patient there were no drugs and patient was serially monitored. So to conclude, management of thyrotoxicosis is prone to multiple errors. Due diligence must be paid to clinical features and not just lab reports. Physiological alteration like pregnancy and non-thyroidal illness should be kept in mind. Concurrent medication, if any, can have effect on thyroid problems, and then we should also think of assay artifacts. During monitoring of Graves' disease, we should be monitoring with T4 and not TSH levels, and optimal dose and optimum duration of therapy should be paid heed to. With this, I complete my presentation. Thank you.
So thank you, doctor, for the discussion. As I told at the beginning, that mistakes are individualized. So he only enumerated 6, but there might be many. All of you might be having some experience about the misdiagnosis or mismanagement or mistreatment. All of you must be having some. I have got some. For example, I will tell the thyrotoxic patient continuing beta blocker throughout the course of treatment, starting from day 1 to 3 years. He is taking beta blocker. So whether it is justified or it is not justified. Number 2, the patients are not, I do not know where is the mistake. In the last week I saw 2 patients. Now both the patients are taking antithyroid drugs for 5 years, and they never turned up for the follow-up. One patient was treated by me, he never turned up for follow-up. The other patient was treated by some other doctor, and he also did not turn up for follow-up. So probably there is some mistake on our side that we are not able to motivate the patient. So that things happen, so that they continued for 5 years. The patient what I treated, the patient went to Saudi, for which he told that I could not come for follow-up. So such mistakes are also happening. And sometimes the patient who do not have a thyroid swelling, but tachycardia, weight loss, these things are there. Often we miss to detect thyrotoxicosis. These are the mistakes what I have encountered in my practice, and all of you must have some experience. If any of you have got experience, you can add and you can ask clarification from doctor.
Sir, regarding your first case,
yes,
you diagnosed subacute thyroiditis. Now that case, as you showed, you have shown ESR and CRP are high, so that is an immuno-inflammatory state. You have only given propranolol and Comiflam. Maybe your case might have got relief, but many cases there will be no relief. So in such a situation, we have to add some little steroids.
Steroids has to be given, correct.
Secondly, when a thyroid is sick, sick thyroid. Even in subacute thyroid also the thyroid is sick. In such a situation, thyroid hormone evaluation should not be done, in my opinion. You will clarify me. Second, in the second case, that thyrotoxicosis case, free T4 should have been done. And in my opinion also, one autoimmune testing like anti-TPO or something should have been done to confirm the diagnosis. Third, after taking 18 months of treatment in a case of thyrotoxicosis, in my experience, you may not agree or some others may agree, the suddenly anti-thyroid drugs should be withdrawn. It should be tapered, lest there will be recurrence.
The recurrence rate, I'll come to the third one first because that's what I remember. So the recurrence rate, as I have shown in the slides, in the various studies from the United States, it is just about 20 to 30%. Majority 70% would relapse. So there the treatment of choice actually is radioiodine. Even during first visit, when the patient comes, they make them almost euthyroid and then they ablate and make the patient hypothyroid. That is the prevailing approach in United States. Whereas in European countries and in Japan, it is about 50% and they prefer like us to give anti-thyroid drugs.
Yeah.
And he had asked 3 questions, sir. The second one was regarding subacute thyroiditis. Yes, subacute thyroiditis, if the patient is not responding to your NSAIDs alone, then you have to give steroids for some short duration. Yeah, persistent fever, persistent tenderness is there, patient is having low grade malaise and all those things, then you may have to give a short course about 10 days duration of steroids and then taper off accordingly. And free T4 again, sir, it is dependent on various laboratories. You have to have very study. It's not that free T4 is the end of the all, it's the panacea, it achieves everything. Even free T4, Dr. Samit will also agree with me, it is prone to multiple fallacies. If the labs are not robust, it is better to do a total T4 than at a free T4 level.
Yeah, I don't think you need to do free T4 level. T3, T4 is enough. And my question in your second case, when the T3, T4 has normalized with 30 milligram of carbimazole, it is mid-normal actually, 8 microgram T4. Don't you think it's the time also to continue the same dose rather than reducing doses? TSS is still suppressed. Not saying the increasing the dose. Once you find the TSS is a level of 0.2 and still T3, 4 going down, then you reduce the dose gradually.
Practice is once the T4 comes to within normal range, we reduce it by half. So suppose the patient is getting 40 milligrams of carbimazole, make it 20 milligrams and then again assess after 6 weeks. Or otherwise the chances of going to hypothyroidism are also there. As sir has told that the patient was lost to follow for 5 years. So I think that patient probably requires lifelong immunomodulation by giving these drugs. Otherwise he would have become hypothyroid by the time he came to you after 5 years. Yes, cases of, they are multiple, sir. They are multiple. See, in cases of thyrotoxicosis having high weight. Yeah. In children, basically, they have increased raised appetite is there, so they tend to put on weight. And even among the elderlies, where they don't have those much of adrenergic symptoms of thyroiditis because of the associated autonomic neuropathy, so they tend to put on more weight as compared to weight loss. And hypothyroidism having weight loss, mainly in secondary hypothyroidism, it is more likely seen.
So we can wind up the session here only for this presentation and keeping it case based. Thank you.
Thank you so much.
Thank you, sir. Thank you, chairpersons. Please proceed to the presentation area. Now I would like to request our chairpersons for the next session, Dr. Kishore Kumar Behera, Associate Professor, Department of Endocrinology, AIMS, Bhubaneswar, and Dr. Anup Kumar Budhia, Assistant Professor of Medicine, High Tech Medical College and Hospital, Bhubaneswar. Sir, please.
So this is a very interesting and little bit very sometimes very difficult to have a how to approach a thyroid nodule, and also when to go for a surgery, which nodules need to be subjected for the genetic studies. So I hope this will be well illustrated by our esteemed speakers. So I will hand over to my co-chair.
So today's topic, approach to a case of thyroid nodule, the next topic, by Dr. Ravi Shankar E. He is senior endocrinologist at Apollo Jubilee Hills, Hyderabad. Previously, he was senior registrar diabetes and endocrine at Northern Deanery, United Kingdom, and consultant endocrinologist at Sunderland Royal Hospital, UK. He has numerous publications, including book on PLAB1 UK. He has been featured in the book Lifesavers from Diary of a Medical Journalist in 2012. So requesting him to start the topic. Thank you, sir.
Thank you, chairpersons. Good afternoon, everyone. Please may I start at the outset with a question as to how many of you do see thyroid nodules incidentally in your patients in your OPs. Hands up, please. It looks like everybody almost on this side, but almost none on this side. It can't be that way. I didn't ask people to sit, the ones who see on that side and the ones who don't see on this side. I'm sure, you guys also see, and the fairer sex as well. Okay. So let me start the presentation that I'm going to present a case, the way people present to our OPDs, and of course, the evaluation process as well, which I am supposed to deal with. I know that we are running short of time, so I'll try to keep it as crisp as possible. So my title of the talk is Evaluation of a Thyroid Nodule in 15 Minutes for General Practitioners and Physicians. This is about a 36-year-old woman, a noted lump in the neck while taking shower, while she was, washing her neck. Seen ENT specialist, ultrasound, multinodular goiter, dominant nodule 3 centimeters, and they did FNA, no cancer cells. The patient has been advised surgery, and the patient came to me for second opinion. Unfortunately, it appears as if what used to be uterus for many gynecologists is thyroid for endocrinologists. We save many these days. So how do patients present with thyroid nodules? Either they are pointed by their friends or relatives, or they themselves notice while looking into the mirror or washing their body. It could be a clinician who can possibly pick up during a physical examination as well, or during a radiological procedure. I'm sure most of you might have seen incidental findings of thyroid nodules commented whilst PET CT scans are done or chest CTs are done for lung-related problems, or carotid Dopplers are done. So this is the example of a papillary thyroid cancer which has been found as an incidentaloma whilst whole body PET CT scan has been done for other reasons. So if you look at the causes of thyroid nodules, just like how everybody on this side raised their hands and nobody from this side, all on that side are benign and all on this side are malignant. If you look at the benign ones, you do have multinodular goiter, Hashimoto's thyroiditis, you do have cysts, follicular adenomas, Hurthle cell adenomas, and on the malignant side, you do have papillary thyroid cancer, which is the most common thyroid cancer, followed by follicular cancers, medullary cancer, anaplastic cancer, and of course, not to forget lymphoma and metastasis as well, from breast, renal cell cancer, etc. So why bother about thyroid nodules? Forget about the cosmetic reason. We are concerned mostly about cancers. If I randomly choose to palpate the nodules of people here, I'm sure I will find out at least 5% thyroid nodules. So roughly if there are about 50 audience here, I'm bound to find 2 or 3 thyroid nodules, but all of them are not cancerous. About 5 of them usually are cancerous. And even if they were to be cancerous, most of them really do not die due to it, but they may die with it, if you know the difference between the two. Some of them might suffer from pressure symptoms, especially if they are large and if they are pressing the trachea, the windpipe, or the esophagus. Some might have the recurrent laryngeal nerve giving away as well. So what do you do when somebody comes? You take a good going history, you measure a TSH and ultrasound. If you can't take anything out of this, just remember these 3. Take a good physical and general examination, including history, measure TSH and do an ultrasound scan. So what do you ask in history and physical examination? Ask when did they find it? Has it been growing rapidly of late? Did they have any cancers in the past? Is there any weight loss? Ask if there is any family history of cancers as well. Ask if they have had any radiotherapy in the past. You must have heard about the infamous Chernobyl tragedy, isn't it? So these are things that might help you understand if there could be a possibility of cancer in the nodule. Then do a TSH, very simple test, isn't it? I will try to explain as to why TSH is very important later on during my presentation. Do an ultrasound scan. A very simple test, very much cost effective as well. What are the various ultrasonological features that suggest if it could be thyroid cancer? We do have ultrasonological features suggesting increased risk of thyroid cancer up above here, not right and left on this occasion. Hypoechogenicity of the nodule points towards possibility of thyroid cancer. Punctate echogenic foci, we call it microcalcifications. Then you do have infiltrative and irregular margins. Taller than wide. If somebody is tall, we all feel proud, but not quite the case when it comes to thyroid nodules on ultrasound. Associated suspicious lymphadenopathy features. So these are all features that suggest that it might be cancerous. Then what are the ultrasonological features that are associated with the lower risk of thyroid cancer? Isoechoic or hyperechoic, spongiform appearance, simple cysts, and uninterrupted eggshell calcification. Unfortunately, I can't show you all this, but leave it to your radiologist. It's a very busy slide, but what I'm trying to say here is that we do have features here which raise the suspicion of cancer, which means that FNA ought to be done if the size is more than or equal to 1 centimeter. The first two, high suspicion, intermediate suspicion. Then you do have the low suspicion features. So if somebody were to have a thyroid nodule of 2 centimeters, and if you have even the low suspicion features, you need to do FNA. But if at all they were to have somewhere around 1.2 centimeters, and if they were to have any of the high suspicion features, just go for the FNA. So that's how the thyroid nodule size matters when it comes to doing an FNA. Very low suspicion, yeah, fair enough. Unless it is more than 2 centimeters, you don't really do FNA. Somebody were to have purely cystic simple cysts with no solid component, just leave it alone. You don't need to do FNA. This is a radiological classification of thyroid nodules. We call it Tirard's classification. And again, this is based on the increased risk of malignancy. Higher the Tirard score, Tirard's 3, 4, and 5, then you need to do FNA because the chance of malignancy is higher. They gave some points for each feature. For example, spongiform, as I previously mentioned, is not cancerous, so 0 score for that. But on the contrary, if there is extra thyroidal extension or punctate echogenic foci, then they gave a score of 3. So they would add up all this, and higher the Tirard score, higher the chance of malignancy, hence the higher the need to do FNA as well. I won't bore you with too much of this. So FNA, very simple test. I'm sure some of you might have done in your OPs as well. I'm not speaking about endocrinologists, ENT doctors do, pathologists do as well. So this is a fairly simple test, but with practice it becomes better. So this is the Bethesda system of classification of the FNA reports. Very simple. If you haven't got adequate cells and just blood, then you call it Bethesda 1. Bethesda 2 is benign, non-cancerous. Bethesda 3 and 4 are sitting on the fence. You really don't know what exactly to do. Even endocrinologists many times really don't know what exactly to do. I'll show over the next couple of slides as to what we do. 5 is suspicious for malignancy, and 6 is malignant. So if you have Bethesda 1, the chance of having cancer, because you haven't got adequate cells to really say which it is, you have to repeat it in another 6 weeks or 8 weeks. Okay? And the chance of Bethesda 1 nodules being malignant is 5 to 10%. Even Bethesda 2s, as I earlier mentioned, have a chance of being malignant by about 0 to 3%. But usually most of these people don't die because of it. They die with it. 3 and 4, about 10 to 40% chance of it being malignant. 5 is 50 to 75%, and when it comes to 6, almost 99%. So Bethesda 1, what do? You repeat the FNA in about 4 to 6 weeks. If a repeat FNA is again Bethesda 1, which happens sometimes, usually not if the person doing it is efficient and if it is ultrasound guided, but unfortunately sometimes we still get Bethesda 1s, in which case we go for core biopsy. Bethesda 2 is benign. Most of the cases don't need anything except ultrasound follow-up after an year or 2, depending on any increment in size. Different guidelines advocate in different fashion. UK guidelines usually say repeat FNA after 6 months to say, look, I'm going to be happy thinking it's going to be benign, but other guidelines say just monitor with ultrasound scan, and if it is increasing in size or if any sonological features suggestive of malignancy, then only do an FNA. So coming to Bethesda 3 and 4, they're indeterminate, they're a really big challenge actually, and you may have to rely on molecular studies if you have the benefit of having those, such as BRAF, TERT, RET, and RAS, but unfortunately most centers do not have this luxury. In which case you may have to rely on TSH to a certain extent. If at all the TSH were to be less, you end up doing a technetium scan, and if it is a hot nodule, it is very unlikely to be malignant, although I was caught once. One hot nodule ended up being malignant eventually. But usually hot nodules are not malignant. Cold nodules, you might remember from your MBBS days, that used to be a popular MCQ question as well in our postgraduate entrance exams. So cold nodules have a higher chance of being malignant. So if you haven't got molecular studies, the only way you can progress further is to go ahead doing a TSH. If the TSH is suppressed, then do a technetium scan. If it is hot, leave it alone. If it is cold, then you may have to go further by doing at least hemithyroidectomy or lobectomy. So this is the example of thyroid scintigraphy my good friend showed earlier. If it is hot, as I told you, you may have to just leave it alone. So Bethesda 5, suspicious for malignancy, you have to refer for surgery, and usually at least hemithyroidectomy is done. In some cases, even total thyroidectomy is advocated. Bethesda 6, malignant, total thyroidectomy is the way forward. So ladies and gentlemen, to summarize, that is what you are supposed to do whenever you get a thyroid nodule in your case. You do a TSH ultrasound scan, do an FNA wherever the ultrasonological features do suggest and the history suggests, and refer to the right person who is an endocrinologist. Thank you very much. I think we kept your time, didn't we?
Excellent presentation, and you have stick to the time. So any question from the audience?
Yeah, endocrinologist asking an endocrinologist, fair enough. Okay, see, the higher the size is one of the criteria, as you very well know. It's not the criteria, but certainly if the size is big enough, say 3 centimeters, even if the radiological features are giving a low Terard score, then you end up doing FNA. But on the contrary, if at all the radiological features, other radiological features as in tall, the punctate calcifications, even if they were to be giving a less score, if at all the size is big, you end up doing FNA, and you may have to weigh on the side of thinking as if it is malignant. But on the contrary, if the size is say 0.5 centimeters, and even if the Terard score otherwise is say 3, then the chance of it being malignant is less. So it is one of the factors, it's not the only factor. Well, right, let me answer in my way. I have seen an ultrasound report yesterday. With all due respect to my good radiology friends who give excellent reports, this was an exception yesterday. I could clearly palpate a left 3 centimeter thyroid nodule. I've sent for an ultrasound, and they commented that there is a 3 centimeter thyroid nodule, blah, 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 and the final conclusion is it possibly thyroiditis / goiter. What am I supposed to say about it? So I think there are good doctors everywhere. There are not so good doctors everywhere, including here everywhere. So let's not actually pick up on those odd ones. In general, yes, they give wonderful reports. Sometimes I pick up the phone and speak with them. The other way to work around is send to you somebody who you believe in. All the difficult cases, I send to only one endocrinologist, one radiologist in our hospital who gives us wonderful reports.
Thank you. So, because of time constraint, we'll end here. And
hello.
Okay, sir.
What is the role of color Doppler study in ultrasound?
What is the role of?
Color Doppler study.
Color Doppler.
And also elastography.
Yeah, these two are the next level tests. They do definitely add value, okay, if done by people who are well capable of doing it. I won't say that these are the only factors I rely on. In our center, we don't routinely don't do these, because I have a very good radiologist who really gives me excellent reports, but definitely they are of good value whenever you're struck. Okay, they definitely add value, but I don't rely on them. I don't use them. Oh, yeah, of course. Yeah. Yeah. See, personally, I don't use it because my center routinely doesn't do Apollo Jubilee Hills. But if you got the luxury of somebody doing it, and why not?
Thank you. So we end this session here. So whoever have any doubts, so he will be there, so you can clarify your doubt in the backstage. Thank you.
Thank you.
Thank you, sir. Thank you, chairpersons. Please proceed to the presentation area. Now, for the next session, I would like to invite our chairpersons, Professor Dr. Dayanidhi Meher, Professor, Department of Endocrinology, KIMS, Bhubaneswar, and Dr. Ankita Tiwari, Senior Consultant Endocrinologist, AMRI Hospitals, Bhubaneswar.
Good afternoon, everybody. Now we do have a very excellent topic, in fact, that is gender identity disorder. This gender dysphoria, that is which is a better terminology for this gender identity disorder, is not uncommon, and in our clinical practice, at least we face not so uncommonly. And this is a very complex and sensitive issue because it has got many personal, cultural, as well as social implications. Though the exact etiology is not known, probably there are factors responsible like cultural factors, biological factors, genetic factors. And to address this, to enlighten us in next few minutes, we do have one eminent speaker, Dr. Deepmalya Sanyal.
Gender identity disorder by Dr. Deepmalya Sanyal, who is a professor in Department of Endocrinology, KPC Medical College, Kolkata. Previously, he was conjoint professor at University of Newcastle, Australia. He is also a visiting senior consultant endocrinologist at various hospitals. He has published multiple multiple papers in national and international journals, and is also a secretary of RSSDI West Bengal, executive committee member of Endocrine Society of Bengal, and ex-secretary of Diabetic Association of India. All to you.
Thank you. Thank you for the introduction, and I would like to thank the organizers for their kind invitation. So increasingly we are seeing this group of patients, and probably this is something going to be seen more commonly in our day-to-day practice, that is gender identity disorders. So what are the main types of gender? Especially gender identity is basically one sense, whether it is male or female or even both. Cisgender is gender identity which matches the gender which is assigned at birth, and transgender is basically an umbrella term which encompasses all gender identity disorders as well. So that includes the LGBT community. though there is now an increasing prevalence because more people are coming out with these complaints, though historically we have had this for a long time. The average prevalence is 0.5 to 0.7%, but definitely that's low. We have you know, a grossly underreported prevalence of about 5 lakh patients, but that is definitely a gross underrepresentation. So there are other forms like gender queer or bigender. So this is what is men and women, and in between we definitely have this transgender. So the sex assigned by birth is dependent on the chromosomal sex as well as on the reproductive organs, but gender identity is basically the internal experience of that person with regards to gender. It can be binary, that is male or female. When it is male, then it is what we know as a trans male, and when it is female, then what is known as the trans female. When it is non-binary, then it can be between, it can be agender, that is there is no preference for any gender. It can be gender fluid, when there can be a you know, moving from one gender to the other, or gender queer when there is clarity, lack of clarity regarding gender. So if we remember that gender, the phenotypic sex, what we see, which is male gender, main genitalia, testis and the chromosomal sex, they are actually in concordance in gender identity disorders. But the gender identity is different. Whether it is a transgender male or transgender female, there is no problem with regards to chromosomal sex, the gonadal sex and the phenotypic sex. It's basically a problem with regards to gender identity. Now that is actually, there are a lot of biological determinants, and one of them is actually the neuronal impact when there is differentiation of brain between the second and the third trimester. And you know, we actually have the gonadal differentiation much later. So the neuronal pathways can be dimorphic. That has been revealed in the imaging studies as well. And the genetic studies have shown that there can be about 30% concordance between monozygotic twins. So there is also a pathophysiological basis of gender identity disorders as well. And previously it was known as gender identity when the psychiatric diagnosis, this was basically a psychiatric diagnosis when there was a persistent cross-gender identification which led to a dysphoria and discomfort. So next the term came to be known as gender dysphoria. But now there is a new terminology, what is known as gender incongruence. So they have actually done away with all those terms. Trans words have been deleted. Similarly, they have been deleted with regards to mental health disorders. So this gender incongruence, which is the new terminology, refers to a person whose sex assigned by birth does not match with their gender identity. And not all of them have gender dysphoria, some of them have gender dysphoria. So that's why they have done away with the term of gender dysphoria. And very important, the diagnosis is primarily made by the mental health physician. So it's a multidisciplinary approach, endocrinologists, but the primary diagnosis are mental health physicians. Then we have surgeons as well as for voice therapists as well. And it is multi-step, including from the final diagnosis to social transition, then hormone therapy, then surgery, and followed by lifelong follow-up. So if we are to treat a patient, whom to treat, we need to first clarify from the mental health physician, psychiatrist, confirm that there is a persistent dysphoria which is well documented. Very important, the patient should be able to give consent and should have achieved the age of majority. And what are the major goals of therapy? One is to reduce the endogenous sex hormones which are concordant with the secondary sexual characteristics of the designated gender that has been designated by the physician at birth. And we need to actually replace as well the endogenous sex hormones with the hormones which actually is in concordance with the identity of the patient as well. And very importantly, the success rate is about 87 to 97%. Now, we had published one of the early studies showed that all of these patients have normal testosterone, normal estradiol, normal karyotype in concordance with their biological sex. but very important, only 10% had family support. Now this is increasing because of more social acceptance. And as you can see, though the onset of the disease occurs around puberty, around 9 years, but actually the patients present at around 25 years. And again, there is a more prevalence in males. So male to female is more prevalent, 65 to 70% versus 30 to 40%, but the literature suggests it's equally distributed. It is only because males are more privileged in our society, so they can come out easily. And secondly, because of this, there are unplanned surgeries, about 16 to 20% in both male to females as well as female to males as well. So why do we need to treat? Because of the stigma and the sickness. You can see there is depression, anxiety, which is prevalent almost in 50% of patients, and suicidal ideation in about 20 to 40%. HIV and substance abuse is very common. We had another publication which showed that the suicidal thought and attempt was there in about 25% of patients. So this is not a disease to be ignored. So very, very important. We need to think about it carefully as well, and we need to raise our level of awareness as well. So there are several guidelines, including the Endocrine Society of US guidelines. This is one of the Australian guidelines. So after there is assessment by the mental health physicians, we need to have the endocrinology consult whether the patient is appropriate with regards to baseline investigations. Then we need to treat, and that has to be individualized as well. With regards to hormonal regimens, for transgender females, we need to give the female hormones, that is estradiol, the oral estrogens. Specifically, previously we used to give the synthetic, the conjugated estrogens. Nowadays we are not going for that because that is associated with higher risk. We are going for the oral estradiol, especially the estradiol valerate between 2 to 6 milligram. We can also go for transdermal estrogen, but that is very difficult in our population because of the humidity. We also can give injectable estradiol, but that the availability of that is not very good. Problem is, in females, just giving estrogens cannot suppress the male hormones. So we need to give either anti-androgens, which are less effective, or we can give GnRH, which can suppress the androgen level from the pituitary source as well. With regards to transgender male, testosterone therapy is given, generally injectable testosterone, which can be given intramuscularly, but now it is also recommended to be given subcutaneously as well, which can be given by the patient as well. Secondly, there is also the transdermal testosterone gels are also there, which are suitable especially in patients who have erythrocytosis as well. These are the patients where it is more suitable, but they are more costly. We also have the 3-monthly preparations of injection as well, but they are more painful because of an oily base. So in our experience with regards to male to female subjects which we had published, 70% of them actually preferred only estrogen because of the cost, but about 30% would go for GnRH, where there was more satisfaction, and the estrogen level was also, the estrogen requirement was less. That led to a decreased risk of complications as well. About 25% could go for surgery in our population of patients. Now coming to men, again, who were from transgender male, most of them preferred the testosterone injections, which is given every 2 to 4 weeks, which are testosterone esters, which are commonly found. 70% of them. 20% chose the 3-monthly injection, and only one patient who had erythrocytosis, there we actually chose to give the transdermal testosterone, which was found to be quite suitable, and the patient could be managed with that. Surgery again was done in about 50% of these patients. So what are the risks associated with sex hormone therapy? This is quite the similar risk which is there when we use either exogenous testosterone or either exogenous estradiol, similar to hormone replacement therapy after menopause as well. So in transgender female with estrogen, there is a high risk of thromboembolic disease, especially if progesterone is also given. Also, there is some increased risk of rise in prolactin, increase in breast cancer and cardiovascular disease. But now a long-term study has shown that the cardiovascular risk is not significantly increased. There is a risk of cholelithiasis. Second, in male, as I was talking about, there is a high risk of erythrocytosis, that the hematocrit or PCV is more than 50. That is something we need to monitor. And there is a risk of dyslipidemia and hypertension as well. Very commonly, these group of patients go for very high doses, self-prescribed high doses. So we need to explain to them they need to avoid these supraphysiological levels of hormones. So initial assessment, the red flag signs where treatment should be started early if there is suicidal intent or there is isolation. Also there is a lot of abuse, smoking and addiction is very common, that has to be evaluated. Hypertension, dyslipidemia has to be evaluated. The basic risk of venous thromboembolism has to be evaluated as well. So at baseline, we need to correct conditions which can be worsened by hormone therapy in patients who have a prior history of thrombosis, polycythemia, liver disease and cardiovascular failure, cardiac failure. These are relative contraindications, not absolute contraindications. Now CBC is very important at baseline because testosterone can increase the hematocrit. LFT, not because of testosterone but more because of estrogen, they are poorly metabolized in hepatic impairment. Lipids, testosterone, we are all aware, decreases HDL and increases triglycerides and LDL cholesterol, whereas estradiol increases the triglycerides. So we need to monitor the lipids level. Glucose, the estradiol is known to cause insulin resistance, so there can be increased incidence of diabetes. Not much data with regards to testosterone. Now BMD generally is only needed if the patients are non-compliant, because either way if you are giving one hormone, then the bone mineral density and osteoporosis risk is much less. Obviously electrolytes, especially potassium, needs to be monitored if anti-androgens like spironolactone is used. Very important, lot of these patients have sexually transmitted diseases like HIV and even hepatitis. We need to monitor as well as examine as well. So very important, we need to explain to the patient that the early effects in terms of libido, in terms of fertility, in terms of skin texture comes in about 3 months. But actually the total effects require about 2 to 3 years. Just like a normal puberty, it takes about 2 to 3 years. That has to be explained properly, especially with regards to facial hairs, voice change, breast size, testicular size. That takes time, 2 to 3 years. A very important concern with regards to transgender men, that is those who are female wanting to be male. So there the cycles or periods are a big botheration, but that also takes about 3 to 6 months to stop. That is also very important to explain. We need to do a lot of explaining as well. So monitoring, there is long-term data is inadequate. With aging, we need to lower the dose. We need to go for alternative therapy like transdermal estrogen in elderly women, and also have to address the cardiovascular risks. Very important, first year 3 monthly monitoring, next yearly monitoring if the patient is okay. Potassium, venous thromboembolism, cardiovascular disease, dyslipidemia and weight for females, and polycythemia, dyslipidemia and obstructive sleep apnea in men. Very important, the liver dysfunction with testosterone has been removed from the Endocrine Society guidelines. That is very important to remember. So monitoring, obviously the clinical parameters, the testosterone and estradiol 3 monthly we need to have in patients transgender female. The testosterone, the estradiol levels have to be between 100 to 200 picograms. Very important, we cannot monitor if the patient is on synthetic estrogen or a conjugated estrogen. We can only monitor if they are on estradiol. That is very important to remember. The testosterone needs to be less than 50. BMD, bone mineral density by DEXA scan, need to be done for osteoporosis if the patient is non-compliant with therapy. Who are at high risk for thromboembolic disease? So that is something we need to explain to them. Those who are obese, those who are more than 40 years, and smokers. Very importantly, before you start estrogen therapy, just like in hormone replacement therapy, you must explain to these patients, because a lot of them are smokers. So that is something we need to explain as well. And if there is a past history of thrombosis, go for transdermal estrogen or parenteral preparation and concurrently stop smoking. With regards to men, again clinical parameters, first year 3 monthly, then 6 to 12 monthly. The serum testosterone has to be monitored every 3 monthly. The target is in the normal main range between 400 to 700 nanograms per dl. Very, very important to monitor a PCV and a hematocrit. If the PCB is more than 0.5, we need to reduce the dose or increase the dosing interval. We need to screen for osteoporosis if there are risk factors for bone loss. The testosterone therapy is similar with regards to what we do in hypogonadal men. That is, those who have hypogonadism, the similar regimen is preferred, and GnRH is only required when there is continuous period in spite of testosterone therapy. Anti-androgens, a few words, basically in patients because estrogen cannot suppress the testosterone level, so anti-androgens decrease the testosterone level or decrease their action. Very important, they take time as well. With regards to spironolactone, a word of caution is don't forget to monitor potassium, and also look out for hypotension as well, because they also can cause lowering of blood pressure. We can also use the 5-alpha reductase inhibitors. Now, a lot of these patients use progestogenes preparations for breast development, but there is no conclusive evidence regarding progestogenes preparations in breast development in transgender. With regards to prolactin monitoring, especially in transgender female, we all are aware that both estrogen as well as cyproterone acetate, which is an anti-androgen, can raise the prolactin levels and sometimes can cause pituitary lactotrop hyperplasia, leading to a mass-like features in the pituitary. So prolactin monitoring should be done initially at least every 3 months and then yearly as a follow-up. More importantly, a lot of these patients take antipsychotic medications which can also raise the prolactin levels as well. So hormone therapy and cancer through the routine cancer monitoring, just like in non-transgender individuals. Very important, cervical in patients, transgender male who are actually females, cervical tissue has to be monitored for cervical cancer. Also breast cancer monitoring is important, and very important in transgender females, not only breast cancer monitoring but also prostatic cancer monitoring after the age of 50 years is essential. So these are the things we should not forget about the cancers as well. And in both sexes there is a risk of breast cancer that is very important to realize. So with regards to surgery, lot of these patients go for sex reassignment surgery, need to stop the medication, especially if there is limitation in mobility, especially if it is a genital surgery, that has to be, the medications have to be stopped at least 3 weeks prior to surgery and 2 weeks after surgery. But it is not necessary in terms of non-genital surgery. Now in children's and adolescents, lot of children and adolescents are coming to us with gender dysphoria and gender incongruence. So we do not go for hormone therapy because a lot of these patients actually do not persist in the long term after they achieve adulthood. So in these group of patients, we only suppress their puberty by using GnRH therapy, and that's how we manage. And once they become adults, when they can give consent, then only we go for a re-evaluation and start the gender affirmative hormone therapy. Now fertility, in lot of these patients, fertility counseling is also very important, because very importantly we need to preserve sperm or oocyte or embryos. Testosterone, very importantly, even if we give testosterone, they do not prevent ovulation. So proper contraception has to be also discussed. And if the patient desires pregnancy, we can always stop the testosterone, then the oocyte will actually develop back. Sperm cryopreservation also has to be discussed, especially before estrogen therapy, because estrogen can cause changes in spermatogenesis. Now, very important, judgment had come out on June 8, 2021 from Madras High Court, where we must be very, very careful, because lot of patients, at least their fathers, their mothers, their brothers, last week only a brother brought his sister, that, you know, try to counsel my sister out of this transgender. Very important to remember, there is a ban on health professionals from attempting to medically cure or change the sexual orientation of people, especially with gender identity disorder, to cisgender. So very, very important. We are legally liable to be sued if we try to change the opinion. We are nobody to change the opinion. It is their personal opinion. So we need to be very careful as well. So we should not, you know, try to please their parents and try to explain and try to bring them out of this situation. So we shouldn't be doing that. So in summary, gender identity is something which is going to come out increasingly. This has been there historically. If you go to Konarak temple, this is one of the glorious examples of a thriving transgender in our history. So it's not something new. Only now people are expressing more, and this is going to be more expressed in the future as well. So we need to know, we need to coordinate. There has to be a stepwise protocol, and it requires multidisciplinary teamwork. It is not only hormone therapy. We need, before we go for hormone therapy, we need to check eligibility criteria, the consent. We need to monitor, because it's a long-term therapy till the age of menopause, that is 50 years in female, and in men you have to continue almost for long term till the age of 60 to 70 years. But gender affirmative hormone therapy is safe, it is effective, and if we can keep the hormone within the normal ranges. Very important, they improve quality of life, improve functioning. Very, very important, it decreases depression and suicide. If we do not treat, the patient can die by committing suicide. The dysphoria is so intense, because there is some changes in the brain because probably of genetic imprinting. We are still not aware of the cause, as has been illustrated. So before going for gender affirmative therapy, also we need to explain to the patients the adverse effects, and they need to reduce weight, they need to stop smoking and stop abusing any drugs if they are taking. And also they must be explained the expected time of effects. Lot of these patients take excessive doses, that has to be explained as well. And before they go for surgical treatment, they have to be explained that these are irreversible. Hormone therapy also can impair fertility. So fertility counseling has to be done as well. And for us endocrinologists or treating physicians, where the patient is going for surgery, they have to wait at least 1 year of hormone therapy, then only they can go for surgery. They must discontinue at least the estrogen and testosterone at least 4 weeks prior to surgery, and restart at least after 2 to 3 weeks. Very important, after genital surgery, most of these patients will not require GnRH or anti-androgen therapy. Very important for us, we need to use also, remember, we need to explain, we need to, very important, be sensitive. We need to use the correct name and pronoun, because a lot of them become offended if we use inappropriate pronoun as well. And we need to look at the lifespan and the healthcare needs, because the cardiovascular disease will come up, the bone issues will come up as well from endocrine perspective. So the only valid route of understanding a person's gender identity is to listen to them. Whatever be our scientific understanding, the needs of transgender people should be met on the basis of universally recognized human rights. Thank you. Thanks a lot for a patient hearing.
Thank you, Dr. Devalya, for your wonderful presentation. Now it's open for. Sorry, we are getting late. So
thank you.
Very much.
Thank you, Speaker. Thank you, Chairperson. Next, we have a panel discussion. I would like to invite a Chairperson, Dr. Narayan Prasad Modi, sir, and moderator, Dr. Lipsa Das.
Good afternoon, everyone. Thank you, Endeavor, Dr. Sambit Das, and Dr. Lipsa. So it's a huge privilege to be part of this update and to be chairing 3 stalwarts for a panel discussion. So may I request first, going by the tradition of our state, Atithi Devo Bhava, Dr. Anurag Vajpayee sir. Sir, please. Then Divinity Dr. Jayashree Swai, Associate Professor, IMS and SAM Hospital. Please grace ma'am. My dearest friend, Dr. Amit Satpathy, Assistant Professor, AIMS Bhubaneswar.
Whenever parents enter our OPD with a short child and ask us this question, is my boy or girl really short? Then each one of us starts scratching our heads and asking this question, how short is actually short stature? A warm good afternoon to all of you. Today I, Dr. Lipsa Das, will try to breeze you through 6 interesting cases to widen your vision on short stature. And I am extremely privileged to have with me today Dr. Narayan Prasad Modi sir, one of my mentors, and as panelists Amit Kumar Satpathy sir, Jayashree Swai ma'am, and Anurag Vajpayee sir. So now, without much ado, let me take you all to case number 1. Case 1 is a 9-year-old girl Sheetal with chief complaints of poor gain in height. Weight is 27 kg, falling on 50th centile when plotted on the combined WHO-IP growth chart. Height is 107 centimeters, which is less than 3rd centile when plotted on the combined WHO-IP growth chart. Coming to parental height, father's height is 152 centimeters, mother's height is 146 centimeters, and there is a family history of short stature and no signs of any systemic illness on physical examination. So my case number 1 goes to Jayashree ma'am. Madam, how will you approach and manage this case?
Thank you, Dr. Lipsa. Please go to this case. It's a case of a 9-year-old female child, and height is 107 centimeter, less than 3rd centile. That means short stature with no systemic signs of systemic illness, without any systemic illness, with family history of a short stature. From this brief history, I can imagine it's a case of the familial short statures. But for that things, I need some growth some other evidence, like of this bone age, growth chart, and growth velocity, and other things. Kindly go for that. So, if kindly go to the growth chart. So, if you look to the bone age, it is approximately 9 years. This is at far of the chronological age. But if you look to the height of these patients, that is 3rd percentiles. And one important thing is here, while dealing with the short stretchers, there is some lacunae in this presentation. That means SMR, sexual maturation rate, you have not commented that things. And another thing is upper segment and lower segment ratio, whether it is disproportionate short stature or proportionate short stature. That is important thing is coming to the mind of the endocrinologist. And if you look to the height chart, growth, if you look to the growth chart, and before putting this height, we should have some knowledge regarding the mid-parental height, what is the target height, and what is this range. And here, this mid-parental height is this genetic. By doing this mid-parental height, we can assess the genetic. We can assess the genetic potential of that individual. It is the father height plus mother height divided by the 2 plus 6.5 centimeter in case of this male and minus 6.5 centimeter in case of this female. But if you look to the target height, it is somehow little bit different from the mid-parental height, and that target height is mid-parental height plus 20% of the difference between the mean adult height of the population minus the mid-parental height. So 95% of our populations, they will fall within this 10 centimeter above, within the 10 centimeter of the target height. So target height in this case is, that is around 142 centimeter, and if you project this present height to that of the target height, it is coming within the target range, and the target height range is approximately 135 centimeter to that of the 150 centimeter. So looking to this bone age and plotting the height in that of the target range, so we can comment it is a case of the familial short stretchers. And coming to these investigations of this case, it is usually after the diagnosis of this familial short stretcher, it is usually not required to go for this any investigations further, and as we have excluded the systemic illness previously. And coming to the management portion, it is only assurance of this patient and assurance of the parent, and some provision of the growth hormone. If I will discuss the thing, there are few studies, and there is only marginal benefit are seen in this study with the growth hormone therapy. So growth hormone therapy is the cost of the, we should, while going to this growth hormone therapy, we should have idea about the cost of the therapy, and also the adverse effect of the growth hormone therapy in the familial short stretcher groups. Because of this requirement of the growth hormone is very high in the different study. It is approximately in the range of the 0.37 microgram per kg of the body weight per week. So only parenteral counseling will be sufficient for this familial short stretchers.
Thank you, ma'am. You are absolutely true. It's a case of familial short stature. It's short stature, so height is definitely less than 3rd centile. Growth rate velocity is normal at a rate of 5 to 6 centimeters per year. Low target height because both the parents are short. Height age is less than bone age is equal to chronological age. Puberty occurs normally, and there is a strong positive family history of short stature. Next, coming to case number 2. Case number 2 is an 11-year-old boy Shiv with chief complaints of not growing as per his peers. Weight is 35 kg, falling on 15th centile when plotted on the combined WHO-IP growth chart. Height is 120 centimeters, which is less than 3rd centile when plotted on the combined WHO-IP growth chart. Coming to parental height, father's height is 170 centimeters, mother's height is 158 centimeters. There is a family history of delayed puberty and no signs of any systemic illnesses, and not yet attained puberty on physical examination. So this case goes to Amit sir. Sir, how will you approach and manage this case?
So as this is a case, 11-year child with height of almost 120 centimeter. So whenever a child, as a pediatrician, whenever a child comes to you with a parental anxiety or complaint of short stature, first thing you need to do is measure the height correctly, because this is the entry point. Right? Once you correctly measure the height, plot it on a growth chart, IEP growth chart. If comes out to be less than 3rd centile, then probably you are dealing with a case of short stature. As in this case, you can see in the graph, it is well below the 3rd centile. Once it is well below the 3rd centile, what you next to do is calculate the mid-parental. As madam has already told, so mid-parental height is, it is basically the genetic potential of the child, as the child will grow according to the parental heights, right? So it is maternal height plus paternal height divided by 2, plus for a boy it is plus 6.5, if the girl it is minus 6.5. And the target height will be plus or minus 8.5 or 9 centimeter. It has to be within that range. Here you can see when you calculate the mid-parental height, this black line which is there in the extreme right. So if you plot it and go to the adulthood, you can see that the mid-parental height, the child's height, predicted height is well below the mid-parental height. So he is lagging, right? So there is a problem. So then you come back to the history again. So here child probably require evaluation. He has short stature. You have plotted the mid-parental height. It is falling below. So then you need to take a good history whether child has some systemic manifestation or not. If there is a systemic manifestation, systemic disease which can explain the short stature, you need to find it out from the history itself. If it is not there,
like this child, what he got the history is, there is a history of delayed puberty. For a girl child, you can ask the maternal history of age of menarche. For boy child, when the father has developed the secondary sexual character, all these things you can take the history. Here there is a classical history is, so the key point here is, there is a history of delayed puberty in the father or mother, right? So in this case, probably when the height is less than 3rd centile and below the midparental head, probably you are dealing with a short stature, and it could be secondary to constitutional delay of growth and puberty. So what investigation we want to do? Usually I don't want to do any investigation other than a X-ray bone age. If X-ray bone age is, if suggests that it is delayed, so when we are seeing the X-ray, when you tell is delay, if the X-ray is less than 2 years below the what is its chronological age, right? So usually we used to use, for bedside, we used to use that Pillay-Guthrie chart, and now many centers using this Tanner-White chart also. So I am comfortable with that, because this is a routine pediatric practice. We used to do that in all patients, right? So you check the bone age. If it is delayed, then probably you are dealing with a case of constitutional delay. Tell the parents, because there is no other issue in your child, and there is a history of delayed puberty, probably you are dealing with a case of CDGP. So what treatment you want to give? I'll say, you just, because this is 10-year, 11-year child, I'll always tell that I'll monitor the growth velocity of the child over a period of less 1 to 2 years, how the child is growing, because many of the children, what will happen, once they will enter into the puberty, they will pick up the growth and attain the adult height. So I just monitor the growth velocity. If it is not up to the mark, he started at monitoring at 11 years and he has reached 12, 13 years, he is not responding, then think of giving growth hormone therapy. And many a times there is always a debate to give early growth hormone therapy, because those who are giving, they are giving credit to growth hormone. But when I was not giving, I always give the credit to sex hormones, right? Because once you go into the puberty, probably the growth hormone plus sex hormone giving the height rather than only the growth hormone. So that is always a debatable issue. But for me, it is just monitoring the growth velocity and decide and see how the growth velocity is. Then you can decide on the therapy, right? Thank you.
I would say definitely no to growth hormone therapy, and don't do a growth hormone stimulation without priming. Otherwise you will find low level and people will start growth hormone. So this will be the key method, that this is, if this is CDGP, which is likely, follow up and they will improve 13, 14 years, maybe give testosterone at 14, but no role of growth hormone.
Thank you so much, sir. In constitutional delay in growth and puberty, height is less than 3rd centile because it's short stature, but the growth rate velocity is normal at a rate of 5 to 6 centimeters per year. The target height is normal because both parents have normal height. The bone age is delayed. Height age is equal to bone age is less than chronological age, and there is definitely delayed puberty in the child and a strong positive family history of delayed puberty. Now coming to case number 3. My case number 3 is a 13-year-old girl, Radha, with chief complaints of inadequate height gain. Coming to anthropometry, weight is 66 kgs, which is falling on 97th centile when plotted on the combined WHO-IP growth chart, and height is 125 centimeters, which is less than 3rd centile when plotted on the WHO-IP combined growth chart. Coming to parental height, father's height is 172 centimeters, mother's height is 165 centimeters. There is mild delay in attaining motor milestones, on and off constipation, lethargy, excessively sleepy, not doing too well in studies. Coming to physical examination, the child has a coarse faces, bushy eyebrows, mouth sometimes open with large protruding tongue, dull faces, protuberant abdomen, dry scaly skin, and not attained menarche yet. So Anurag sir, would you like to approach and manage this case?
Yeah, I think you've given all the clues for the diagnosis very clearly there. Can you put the chart, please? So basically there are 3 questions that you have to answer in a short child. Is the child short? That is very clear from the height that we are seeing. Is the child short for the family? Which is also very clear from that perspective. And third is it nutritional or an endocrine pattern growth failure? The most important thing to look at in a child with short stature is actually the weight and not the height. If you have weight which is compromised, it means nutritional cause, maybe celiac, malabsorption, tuberculosis, RTA. If it is predominantly weight is increased, like in this case, a short and a plump child, it is an endocrine cause. 4 differentials are growth hormone deficiency, hypothyroidism, pseudo-hypoparathyroidism, and Turner syndrome. Now this girl, you have given all the features of hypothyroidism, so I think this is a walking diagnosis that is going to be there. But one caveat is, Girls with Turner syndrome may also have hypothyroidism. So whenever you are making a diagnosis of obvious hypothyroidism, always think of Turner's in the background. I've seen patients who were diagnosed as hypothyroid, but they also had Turner's in that regards. So initial investigation, I would say, would be the routine screening investigation, CBC, SGPT, creatinine, and along with that we'll do a thyroid profile, which will pretty much give you a picture in that perspective. And I would say do both FT4 and TSH in this setting. T3, I'm not a big fan of it. It is not a good test to do. So FT4 TSH will give you the diagnosis. Antibodies, you may or may not do. It may not help you in terms of treatment, because I expect TSH to be more than 100. The big message is, when you have acquired hypothyroidism, give a slow replacement. Do not start at a high dose. We are accustomed to congenital hypothyroidism. You start at 15 microgram per kg per day. Here you start at 25% of the recommended dose. Build it up gradually. She has been living with hypothyroidism for so many years, and if you give a high dose, she will develop benign intracranial hypertension, slip capital femoral epiphysis, and school performance will worsen. So I think the two key messages probably here is that if you have a short and plump child, think of an endocrine cause. Thyroid is important, but also think of Turner's. At least clinical manifestations are very, very important. Follow puberty closely. And third, start at 25% dose, maybe around 20, 25, 37.5, gradually build up over 2 months. That will be way. And fourth, very important, as soon as you give them thyroid, they will have a sudden jump. Their puberty will start, and you have to be very cautious, otherwise they will develop menarche and height may be compromised. We have done in our study in which we think that GnRH analogs may be required. It will depend. So you have to look at how the puberty progresses from there.
Thank you so much, sir. In hypothyroidism, the crunch is that
something here.
Yes,
Cushing syndrome, you will add Cushing syndromes in this scenario. In endocrine perspectives, growth hormone deficiency, Cushing syndrome, hypothyroidism and hypoparathyroidism. Apart from this,
But she is given all the features of hypothyroidism. But yes, Cushing will be number 2 in that.
Thank you, sir and ma'am. In hypothyroidism, the crux is that the girl is short and obese. That is, height is less than 3rd centile, but weight is more than 97th centile. The growth rate velocity is normal. The target height is of course normal, because both parents have normal height. The bone age is delayed. Bone age is less than height age, is less than chronological age, and there are stigmata signs of hypothyroidism, which I already described. Delayed puberty, and if it is a case of peripheral hypothyroidism, TSH will be high with low free T4, and in central hypothyroidism, low TSH and low free T4. Coming to case number 4, it's a 12 years old girl, Gayatri, with chief complaints of poor gain in height. Weight is 46 kgs, falling on 75th centile when plotted on the WHO-IP combined growth chart. Height is 125 centimeters, which is falling below 3rd centile when plotted on the WHO-IP combined growth chart. Father's height is 172 centimeters, mother's height is 166 centimeters. Clinically, there is webbing of neck, low posterior hairline, shield separate chest, widely spaced apart nipples, puffy hands and feet, wide carrying angle, and no pubertal signs yet. So, Jayashree ma'am, would you like to approach and manage this case?
You have already described the physical characteristics which is specific of the Turners. So a 12-year girl with the delayed puberty, short stature, delayed puberty with all these physical characteristics of typical physical characteristics. So Turner is definite my diagnosis, and it is not difficult to go for to diagnose this case. But the important thing is after that investigation and follow management is the most important. And while going for this, go to the chart. I think we don't need any growth chart for this evaluation of this Turner syndrome. But for diagnosis, we need FSH value and also karyotype. And FSH is also sometimes it may be this normal in the age group of this 5 to 12 years because of the immaturity of this hypothalamic pituitary axis. So in that in this case, we will go for the gonadotrophin, particularly FSH and karyotype, and which will by that things we can confirm our diagnosis of the Turner syndrome. It is not much important, but the investigation for the associated systemic involvement is most important. That means for the investigations regarding the cardiovascular, Turners may have the cardiovascular manifestations like coarctation of the aorta, bifid of the aortic valve, and PAPVR. So routine echocardiography and cardiological evaluations at the beginning of the diagnosis is important. Apart from that, ultrasound is also important to rule out the renal abnormality like horseshoe-shaped kidney defect and also collective abnormalities. And apart from that, hearing defect, they may have the sensory motor hearing defect, so audiometry is necessary at this beginning, at the time of the diagnosis. And thyroid function test, as Dr. Ajna Bajpayee nicely pointed it out, thyroid function test in a Turner is most important at the diagnosis and thereafter according to the protocols. So these are the investigation which we require in case of the Turners. And most difficult part is the management at the age of the 12 years. If it is before, then growth hormone is the first management approach is to approach for the growth of the child and for the sexual developments. And before for the growth of the child, sex hormone and some oxandrolone is also important. But the 12 when to start the growth hormone? As early as possible. Again, in which dose? That means in growth Turner patients, they require higher dose of the growth hormone as compared to the growth hormone deficient children. Approximately double dose of the growth hormone. That means 0.375 microgram per kg per week, or if you calculate in other way, that is 53 micrograms per kg for the day. They require the growth hormone. Then every day subcutaneous dose of the growth hormones they require. And then continue up to which periods? It is approximately till the height, there is growth potential. That means if the growth velocity is less than 2 centimeters for the year, or there is bone age is up to 14 years, in that case you may stop the growth hormone, which is most important. And the studies shows that addition of the oxandrolone with that of the growth hormone may have some potential benefit regarding the height gain. This is regarding the growth hormones, and you should know how to monitor at which frequency, frequent interval you should monitor the growth hormone while the patient is on growth hormone. And adverse event like that of the intracranial hypertension, so that glucose intolerance, and that of otitis media and scoliosis, we should have vision regarding these things. And next, coming to the estrogen supplementations, potentiation of the pivotal effect. So at this age of 12 years, I think so while if I give growth hormones, I should delay the steroid estrogen supplementations by the 2 years. Otherwise, if I will give early growth hormone, then at 12 years, it is ideal for go for the estrogen supplementation. Then at which dose I will supplement? That means 10 to 20% of the adult dose. I will initiate the growth hormone. Then at which estrogen I will give. And I think it is discussed previously. And estrogens, estradiol valerate or conjugated equine estrogen or ethinyl estradiols in the reduced dose. That means 10 to 20% of the adult dose you can start, and you can up titrate every 6 months to reach adult dose within the 2 years. Then after that, this question arises when to supplement the progesterones, when there is breakthrough bleeding, or 2 years after the supplementation of the estrogens, we may go for the progesterone. Then what progesterones? Is it madrasi progesterone acetate 10 milligrams once daily for 20 to 30 days, or micronized progesterone 200 micrograms once daily for 20 to 30 days. This may be the ideal, and supplement these things up to the maximum dose up to the 30 years. After that, you may reduce the dose. You know the potential side effect of the estrogen, you may reduce the dose.
Thank you so much, ma'am. It's a case of Turner syndrome. Height is less than 3rd centile, growth rate velocity is low, target height is normal because parents are normal. However, the final attained or achieved adult height of this child is around 20 centimeters below the target height. Bone age is delayed. Bone age is less than height age is less than chronological age. There are certain stigmata signs of Turner syndrome which nobody can miss. There is delayed puberty, increased LH and FSH on hormonal assay, and on karyotyping if it's a classical Turner 45XO, or if it's a mosaic pattern 45XO 46XX variety. Next, coming to case 5, it's a 10 years old boy Lakshman with chief complaints of being short. Weight is 36 kgs, falling on 75th centile. Height is 105 centimeters, falling below 3rd centile. father's height is 170 centimeters, mother's height is 158 centimeters. Coming to perinatal history, he had a traumatic breech delivery with neonatal hypoglycemia and prolonged jaundice. Clinically, the child has a puppet-like facies with mid-facial hypoplasia, micrognathia, abdominal obesity, and micropenis, and there is a family history of similar features in 2 younger siblings. So, Amit sir, how will you approach and diagnose this case?
So, almost everything is given in the clue, right? So, this is a patient which is 105 centimeter only at 10 years of age. So, as a pediatrician, you know 105 centimeter will be reached by the age of 5 to 6 years. So, he is a high, if you see the growth chart, whenever you see it, when you plot the height in a growth chart and the present height is almost 4th or 5th standard deviation, -5 deviation in the growth chart, then you always think of probably you are dealing with a case of growth hormone deficiency. That is a basic clue. Along with that, you take the facial features, that is mid-facial hypoplasia, puppet-like face, the neonatal hypoglycemia, prolonged jaundice. All these are the clues of a deficiency, growth hormone deficiency in the early infancy. And when there is a history of family history, you are thinking probably some genetic disease which is dealing with running in the family. So this is a clear-cut case of a growth hormone deficiency. So what investigation you do, along with what routine investigation you are doing, here you need to go for a growth hormone stimulation test. So more than it depends on how you want to do the growth hormone stimulation test. Most of the times we used to do with clonidine. Probably sir is going to tell about everything about growth hormone in the subsequent talk. But I would used to in our institute we used to do with the clonidine, where we will give 150 microgram per meter square, and we take the blood sample every 30 minutes for next 2 hours and take the GH levels, GH hormone levels. So don't do a 1 point GH level, which may not have some meaning. Many times we used to see this type of report, so that should be avoided. Then once you reach to and you can go for IGF-1, IGF-BP3 also, but once you reach a diagnosis of growth hormone deficiency, it is better to start therapy early. The major problem with the growth hormone therapy is your cost, right? And you can go for a imaging also, where you can look for the hypopituitarism. So along with growth hormone, many times you will have necessary other hormones also deficient. So for that you need to look for the LH, FSH, TSH levels, all these things you can check for. And if your cortisols are deficient, better to go for ACTH stimulation. So you need to basically say whether it is a panhypopit or it is isolated growth hormone deficiency. Because your treatment along with growth hormone deficiency, you need to treat if there is other hormone deficiency, you need to go for treatment about it, right? So once you start treatment, for growth hormone treatment, how will you monitor, we will discuss in the subsequent case, right?
Thank you, sir. It's a case of growth hormone deficiency.
So before going to the growth hormone dynamic test, we should have our normalizations of the thyroid function test, and the cortisol report should be normal. And it may be this case is empty cell, so multiple pituitary hormone deficiency is most likely rather than the isolated growth hormone deficiency here in this case.
Thank you so much, ma'am. It's a case of GH deficiency, and GH deficiency is characterized by severe short stature. That is, height is less than -2 standard deviation. Growth rate velocity is very low, less than -2 standard deviation over a period of 1 year. Target height is normal. Bone age is delayed. Bone age is less than height age, is less than chronological age. Puppet-like faces with midline facial defects like cleft lip, cleft palate, midline hypoplasia. There is delayed puberty, low IGF-1 and IGF-BP3, and a positive GH stimulation test, whether a screening test done with oral clonidine or a confirmatory test done with IV insulin. And on neuroimaging, you may get an empty cella syndrome, a redundant pituitary stalk, or an ectopic pituitary. Now coming to case number 6, my case number 6 is a 14 years old boy Keshav with chief complaints of not growing appropriately. Weight is 57 kg, falling on 75th centile. Height is 110 centimeters, which is falling on -2 standard deviation when plotted on the specific growth charts. Father's height is 174 centimeters, mother's height is 162 centimeters. There is abnormalities of size and shape of limbs, skull and spine, and upper segment is to lower segment ratio is 1:3, as expected 1 in a case of 14 years old. Now Anurag sir, can you just highlight us how to approach and manage this case?
I think this is a very, very important group of disorders, clearly with a primary cause of growth failure. So when you know this child is short, and this is a pathological cause, not familial or constitutional, the first question is it primary or secondary? And for that you have to look at birth weight, because HGA may also have a primary cause, syndromic features and body proportion. So this child is hugely short, 110 centimeters at 14 years is like, there is no problem, you will easily identify them. and even with the specific skeletal dysplasia chart, he is very, very below. So this is a classical case of skeletal dysplasia, most likely achondroplasia, and the severity of growth failure is such the condition is very, very clinically evident. So you can look at the X-rays which are showing the typical abnormalities which are there in the form of bullet-shaped fingers, tapering fingers. If you look at the spine, you will be able to identify it very easily. You will look at the AP spine with regards to pelvis, you will get the diagnosis quickly. So this is a classical case of skeletal dysplasia. The problem is regarding treatment in that regards, what treatment to give. Unfortunately, there is no evidence that growth hormone therapy will be beneficial. The only treatment which has been found to be effective now in an experimental basis is CNP receptor analogs. So these are the C-type natriuretic factor analogs, vosoritide, which have been used, which have been found to be effective in international studies. So this is going to be a promising therapy now. But at the moment, there is not much treatment as far as achondroplasia is concerned, and we do not recommend growth hormone therapy definitely in this setting.
Thank you so much, sir. It is a case of skeletal dysplasia, probably achondroplasia. Skeletal dysplasia is characteristically have disproportionate short stature. That is, height is less than 3rd centile and altered upper segment lower segment ratio. I would like to add that in a newborn and in infancy, upper segment lower segment ratio is 1.7, slightly older children 1.3, and in adolescent it is 1, just like adults. Here the growth rate velocity is low, target height is normal, bone age is delayed, bone age is less than height age is less than chronological age. There are intrinsic abnormalities of the cartilage and bone, and there is a genetic transmission via FGFR3 gene, abnormalities of the size and shape of limbs, skull and spine, and normal growth hormone dynamics on hormonal assay. So let me summarize how to evaluate a case of short child. Step 1 is careful documentation of serial heights. Please note it is serial heights. It is not one-time height assessment. And careful documentation of serial height velocities, calculating chronological age, bone age, target height range, and growth rate velocity. Step 2 is screening investigations, bone age by doing the X-ray left hand and plotting on the Grulla-Pillay charts, thyroid panel, IGF-1, IGF-BP3 levels, and exclusion of other organic causes, and if GH deficiency or insufficiency is suspected, step 3 is GH stimulation test using oral clonidine or IV insulin. Step 4 is neuroimaging or evaluation of pituitary by CT or MRI, MRI being preferable, where you can get ectopic pituitary, redundant pituitary stalk, etc. This is a flow chart approach to short stature in children in brief. First, take a detailed history, detailed clinical evaluation and screening investigations. If there are clues or pointers to specific etiology, proceed and confirm the diagnosis. If there are no pointers but history and oxiology, that is anthropometry, is pointing towards growth hormone deficiency, then please do a IGF-1 and IGF-BP3 level, followed by a GH stimulation test with oral clonidine, followed by IV insulin, followed by neuroimaging, that is MRI brain, to look at pituitary. Now with this we come to the end of our panel discussion, but few brief take home points. Growth is a cumulative phenomenon, not a one-time assessment. With a proper background knowledge, careful detailed history, meticulous physical examination and targeted investigations, an exact diagnosis of a short child can be arrived at. Growth hormone therapy is a boon for short children. However, therapy is rewarding only for approved indications. So my dear friends, with this I end my panel discussion here. I thank all my panelists and chairperson, and I feel that next time when you encounter a case of small child entering your OPD, please do not panic, please do not scratch your heads, but please encounter them with great confidence and valor. Thank you so much.
For putting up wonderful and most common clinical situations in pediatric OPD. In an excitement to start the sessions, it didn't allow me to introduce my esteemed panelists. So I request the August House to give a huge round of applause to all the stalwarts, especially Anurag Bajpai Bhai, one of the finest ambassador of pediatric endocrinology in our country. So a huge round of applause should come from the audience. Now the house is open for discussion. If we can take up a couple of questions from the house. Sir.
regarding the second case you presented for the consistent delay of growth and puberty. But the age of the patient is 11 years. But how can you say now the patient is in consistent delay in growth and puberty? And there is no pivotal findings. Clinically, we have not examined the puberty, testicular volume and all this thing has not been seen. And to diagnose this patient, if you wait and watch, you have to wait for 14 years till to say the delayed puberty. Okay? But again, how will differentiate from the hypogonadotrophic hypogonadism with this consistent delay of growth and puberty?
That is why, sir, it is we need to monitor the child and monitor the growth velocity. And you can have a SMA staging over a period of time that, and you take a good history that will take that will tell. Once child will go into the puberty, you can see there is a progressively increase in the growth velocity, rapid pick of the growth velocity. That will tell that probably you are dealing with a CDGP. So the main issue is you need to monitor the child very frequent, which is not possible in ours. Many times patient will run away, they will not come for the follow-up. Otherwise,
but how long you are going to wait?
how
14,
long?
14 years.
At least you need to tell till 13 to 14 years, right?
Suppose
14
for
years.
14 years nothing happens, what you will do?
So then you can think of doing all the tests, right? That's what I'm telling you. If 14 years you are not getting, then you can go for investigation, right?
Sir, so I think just to add a couple of points, sir. So definitely at 11 years we are considering CDGP, but we cannot say it is CDGP because puberty, of course, is not delayed at the moment. So wait at least till 14 years. But even at 14 years, if you have a very short child whose bone age is commensurate with the height, so our studies show that if your height SDS for bone age is within -2, it's mostly CDGP. HH, if you talk about congenital hypogonadotrophic hypogonadism, typically they will not have that much short stature. They will have pubic hair growth by 14 years of age. They will have very, very small testicular volume, less than 1 ml in most cases. Here, if you talk about CDGP, usually TV will be around 2 to 3 ml by this time. There will be no pubarchy, there will be short stature which is there. And then, generally speaking, at 14, we are able to distinguish that. And if you want, we can do a LHFSH level. What we find is that inhibin B is a very good marker beyond 14 years of age. And if your TV is less and inhibin is less than 35, this is permanent HS usually. If your TV is more than 1 ml and inhibin is more than 100, it is usually CDGP. Otherwise, follow up. But I would say weight watch will be a much better strategy, definitely in this case.
Yes. So you have to take the help of EDB and also.
Yeah.
Sir, I would like to add one more point. I counsel my parents who come with familial short stature that banana plants will bear short banana saplings and palm plants will bear tall palm saplings. So please wait with patience, nothing needs to be done. Similarly in CDGP, I counsel my parents, you have blossomed late, so your child will also blossom late. But you have blossomed fruitfully. So please have patience, your child will also blossom one day and it will be fruitful. Thank you, sir.
More questions? So very ironically, today's Times of India has brought out this National Family Health Survey 5, a beautiful piece of information on obesity and short stature today only. So it has said obesity is increasing and short stature is shortening, it's decreasing. Sir, I went through this article. It said the 3 most common reasons for short stature in pediatric age group is, one is nutrition, another is repeated chronic illnesses, and the third one is psychosocial stimulation. So actually, sir, on the face of it, we think psychosocial stimulation has a lot to do with the growth, the weight, but to deal with this height, can you just explain how psychosocial stimulation helps in gaining height?
Sure. So psychosocial impact as far as growth failure is a common well-established entity, more in terms of children who are neglected, people who are orphaned and in a poor socioeconomic strata who are not giving value. The major impact is through the neuroendocrinology in the terms of the other hormones which are inhibiting growth hormone secretion, so their growth hormone pulses are less. The magnitude of growth hormone pulses is less, so it's like behaving quote unquote like a neurosecretory dysfunction of growth hormone. So it is once you improve their state, they are not deficient, their Secretion is less because when you are in a bad shape, body doesn't want you to grow. If you can't eat, if you are in a very stressed situation, why would you grow? You want to be small in your shell. So this is what the body does, shuts down the GHRH, increases somatostatin, so growth hormone goes down. So this is the basis of that.
For long, actually, we used to think there is only nutritional aspect to the psychosocial stimulation, but I have gathered from you that there is a neuroendo axis also, which plays into gaining height. Another thing it carries, the short stature in rural belt is 37%, and in urban area it is 30%. Sir, your take on it, your explanation.
I would be a bit careful about using the term short stature as 37%, because when we talk about short stature, we are talking about percentiles. We are saying percentile below third centile. So how can it be 3? It should be 3% theoretically. So we can say that you can have 15, 20, 37% figure is a huge figure. So I need to really validate on that. Our study in a school survey of around 10,000 children showed a figure of around 5%. So 30% is not physiologically possible. Now what criteria they are using? 37% is not acceptable, I would say, because it is a statistical definition in that regard.
Thank you so much. And
one aspect you are leaving. Another aspect is idiopathic short stature and familial short stature. I will differentiate between two, idiopathic short stature and familial short stature.
Actually, in idiopathic short stretchers, familial short stature and constitutional delay in the growth, they are coming sometimes under the heading of the idiopathic short stature. Some genetic defect is there in idiopathic short stature, what is not there in the familial short stature. Familial short stature, they are short because of their parents. But in idiopathic short stature, there is some receptor defect maybe they are locating nowadays, and now they researchers are incorporate these familial short stretchers and CDGP under the heading of the idiopathic short stretchers. So there is no question to differentiate between these
Sir,
three.
currently idiopathic short stature is an umbrella term which incorporates familial short stature, constitutional delay in growth and puberty, and subtle abnormalities of IGF-BP3 axis which cannot be detected on GH hormonal assay.
It is in idiopathic short stature, it is not necessary that the MPH will be less. The parents may have very good height.
Parents may have the normal growth, normal target height.
But in idiopathic short stature, they will have low profile growth profile, and usually the growth rate is less than 4 centimeter, and also the growth hormone response is very poor in them also. We will not achieve much growth in idiopathic short stature.
Thank you, sir.
The maximum height gain is around 4.6 centimeter per annum.
So with this, we should end the panel. Thank you my panelists and the moderator, Dr. Lipsa Das. Thank you so much.
Thank you, sir.
Thank you, ma'am. Thank you, sir. Coming to the next session, I would like to invite the chairpersons, Professor Dr. A.K. Baliyar Sinha, Professor Endocrine Department, SC Medical College, Cuttack, and Dr. Arakita Swine, sir, Professor, Department of Pediatrics, IMS and Sam Hospital, Bhubaneswar.
Good afternoon, and coming to an excellent session that is growth hormone therapy and beyond. Our speaker is Dr. Anurag Bajpayee. Needless to introduce him, as already has been introduced, and he has many publications to his credit, more than 40 index publications, and over 300 presentations in the state, national and international. So already he has been introduced, and we are going to listen from him the growth hormone therapy and beyond. You know, the growth hormone therapy is mainly initially used for the short stature, but till now there are many facets of use of growth hormone. I think we'd like to listen from Dr. Bajpayee.
Thanks a lot, sir, for kind words of introduction. So I'll start off, often we discuss that growth hormone therapy is simple. You are just replacing a deficiency, so how much complicated it would be? Why do we need to talk even for 15 minutes? I'll show two cases why it becomes important. This was a 10-year-old girl whose height was 120, weight was 15 kgs, and the family was not short in that regard. The basic workup was normal, and the investigations which were done showed that there was a low level of basal growth hormone and IGF-1 was low. Now, based on that, she was diagnosed as growth hormone deficiency and advised a growth hormone therapy. Now, she did not move an inch. There was hardly any improvement in height. And when she came to me, this was the growth chart. And we already discussed that when you look at the growth chart, the most important thing is to look at whether the weight is more affected or the height is more affected. And what you see here is that clearly this was a case in which there was a major effect of weight, which indicates a nutritional rather than an endocrine cause. And this was not growth hormone deficiency, and if we analyze the data, it actually was suggestive of more of a nutritional cause, and this turned out to be a celiac disease with IgA deficiency. So this highlights that if you don't diagnose the case properly and you start treatment, you will have no response. You have to be very, very careful in this scenario in that regards. The second case, very typical case of what Dr. Lipsa presented, a typical girl with the features of Turner syndrome. All the features was there. She was started on growth hormone and there was no response at all. Why was that? Because the dose which was given was extremely low, 25 microgram per kg. So we have seen in these two cases as to how simple issues in terms of evaluation and management can cause so much confusion, and there is a lot to discuss about growth hormone in that perspective. So growth hormone therapy has evolved over the last 60 years or so, starting from the pituitary therapy to the recombinant therapy, starting only for growth hormone deficient children to Turner syndrome to chronic kidney disease, and subsequently the process has gone forward and now we have got much wider indications and management in that regards. What's very important is that we should choose our patients in a proper fashion, because it's a therapy which is very effective, very safe, but should be used in where it is only required. Cost is an issue and adverse effects are also an issue. All of you can go and have a look at our website learning.growthsociety.in, which has got a lot of presentations, including this presentation in a video form. You can have a look on that, and our application which helps on that regards. So growth hormone therapy is most clearly indicated in growth hormone deficiency. It's also indicated in Turner's, SGA, chronic kidney disease, Prader-Willi syndrome, and the ISS. Now, other than GHD, all other situations, it is a pharmacological therapy. It's not a physiological therapy. So you do not need to do a growth hormone stimulation test in other 5 indications. That's a big message. I'll be focusing largely about these things, mainly about GHD. Also approved for Shock's deletion and Noonan syndrome in that regards. Now, what about growth hormone deficiency? The most important thing is to diagnose appropriately and correctly about growth hormone deficiency. And Dr. Lipsa gave a very wonderful talk that the most important thing is a height. So your height should be less. So the growth hormone guidelines say that the height below -3 standard deviation score, which is somewhere around 0.1st percentile with a low growth velocity, then only you do a growth hormone stimulation test. If you have a borderline case like the second case which was presented, it is most likely CDGP, you do not need to do a growth hormone stimulation, because growth hormone stimulation has fallacies and you may miss that in that perspective. Now, very importantly, 2 key messages: basal growth hormone is a useless test. Don't do a basal growth hormone becomes like that, so do a stimulation test. IGF-1 is only a screening test. A low IGF-1 doesn't mean anything. It may be low in the setting of malnutrition, in the setting of liver disease. It's low below 2 years of age, unreliable below 5 years of age. So I don't routinely rely too much on IGF-1. Better to go ahead with a growth hormone stimulation test. There is a debate whether you go for clonidine, whether you go for insulin, whether you go for glucagon. Generally, clonidine is the safest, easiest to do. Insulin requires a lot of safety, so we have to be careful. Now we are moving more towards oxology. So if height is very less and clonidine is strongly suggestive of GHD, that's good enough. You don't need to do an insulin. People have died because of insulin test also, so you have to be very, very careful on that regards. Earlier guidelines showed a peak level less than 5 for partial, complete, and less than 10 for partial. The recent guidelines talks about 7. Now these are figures which keep on changing. Earlier people used to say 3 nanogram per ml, which is still the adult cutoff, which is actually the true cutoff. Because a lot of children who actually are retested in adulthood do not have GHD. Because we are trying to give treatment to more people, we are increasing the cutoff of growth hormone. That's something we need to understand in that regards. Now IGF-1, as I said, is not a alone marker of GHD, but if somebody had a brain tumor, had a radiation, had a hypoplastic pituitary, if your IGF-1 is low, you don't need to do a growth hormone stimulation test. This also is important in that perspective. Now what dose to use? This will depend upon why you are giving growth hormone. What you can see that growth hormone has a pulsatile way, not only in a diurnal basis, but also with age. So we have got lower level, immediately after birth the level goes down, childhood levels are low, puberty it goes up again, and then it goes down with age because then you have a somatopause which is happening. So there are different indications. One is for growth, second is for bone health, and then you have talked about the quality of life, adiposity, and finally as an anti-aging agent. Now in prepubertal age group, usually 25 microgram per kg per day is the usual production rate, which increases to around 45 microgram per kg per day in the first after the pubertal age group. So your doses will depend upon what you are treating. If you have somebody who has a very severe growth hormone deficiency, start at a lower dose. As I said, for hypothyroidism severe, don't start with a high dose. Start with 15 to 20 and then gradually build up from there. For mild GHD, you go up to 35. For puberty, people talk about using a higher dose of 35 to 45, which is debatable in that regards. And then after that, till 25 years of age, if you want to treat after the completion of growth for bone, you need a dose of around 25 microgram per kg per day. And subsequently, in adulthood, the dose is much lower, 200 micrograms for men and 100 micrograms, 300 micrograms for women in that regards. So you have to be careful about the doses, which depend upon the ages. Also look at the growth hormone level, also look at the growth velocity, and then decide on the dose. But rough dose is 25 microgram per kg per day is what I would say in that perspective. Now what do you expect in terms of response? You expect in GHD, the first year the height increases by around 10 to 15 centimeters. The second year it increases by around 8 to 10 centimeters. Overall, a benefit of approximately 20 centimeters in therapy. Now many people find it difficult to continue treatment till final height. So ideally you need to treat till final height, but people say, okay, I can't treat that much, how much should we treat? We did a study 20 years ago at AIIMS which showed that 2-year treatment is the minimum to get a good cost-effective ratio. So if you want to treat minimum for 2 years, you will get a gain of approximately 20 centimeters by then, and that will have a lasting impact. 3 months, 6 months is a waste of money. You should say, no, there is no point of treatment here, and at least 2-year treatment is what is recommended. Ideal is till final height. Now that is an issue in terms of cost, which is there in that regards. Monitor for bone age and look for IGF-1. Now why are we looking at IGF-1 levels? Some people talk about adjusting the dosage, like you adjust your thyroid doses according to TSH levels. Do you adjust growth hormone doses for IGF-1? Recommendations are against. But you do not want to keep IGF-1 above 2 standard deviation score because that could be a malignancy risk. So you have to be careful in terms of the growth hormone dosage in that regards, and you monitor them in that perspective. What are the side effects? Summary is that it is very safe in growth hormone deficiency, extremely safe. You can have some protein retention and edema. Benign intracranial hypertension is rare, but if somebody talks about headache, visual complaints, get a fundus done. Very important in that regards. You may unmask central hypothyroidism to monitor FT4 levels very, very carefully in that perspective. You can also have slipped capital femoral epiphysis rarely. So if a child complains of a limp, pain in hip, pain in knee, always get an X-ray done for a slipped capital femoral epiphysis. This is the effect of rapid growth rather than an effect of growth hormone per se. You do not develop glucose intolerance or diabetes. It's extremely rare in that perspective, and I'll talk a bit about tumorigenesis in that perspective. A lot of people are worried that growth hormone is a mitogenic compound, and it will cause a tumor risk in that perspective. For tumor to develop, what you need to have is a high free IGF-1. But if you give growth hormone, you are increasing both IGF-1 and IGF bonding protein. So theoretically, your free IGF-1 is not increasing. So in that sense, growth hormone does not increase free IGF-1 or tumorigenesis. If you summarize everything, no evidence about primary cancer, no evidence about recurrence. The only thing we know about is that second tumors may happen a bit earlier. There was a big concern from European study which suggested that the risk of meningioma increases in growth hormone therapy. But again, people looked on other factors and they summarized that probably this risk was more related to the radiation exposure rather than growth hormone therapy. So to summarize, growth hormone therapy does not have a risk of new tumor or in the sense of recurrence. If somebody has an underlying neoplasm, wait for 1 year. So if there is a craniopharyngioma, wait for a year before you start growth hormone. That's what the recommendations are. Now, what will affect your response? If your levels of growth hormone are lower, you will have a good response. If parents are taller, you will have a good response. If you use a higher doses, there will be a good response. Earlier treatment is better. So only thing you can modify it is earlier treatment. So always go for an early treatment, do not wait. If you have diagnosed GSD, start treatment then. Don't say come back after 3 years, 2 years, because by the time weight will increase, the cost will increase. So always better to treat earlier rather than later in that perspective. Very important, if you have given growth hormone, the child is not responding, look at alternate diagnosis. Whether you miss celiac like the first case, whether there is a skeletal dysplasia, whether the nutrition is the issue, hypothyroidism has developed, whether there is an issue of adherence, technique, and very importantly, in very rare causes of GSD1, if you have never had any growth hormone, they will develop antibodies. So all these factors have to be looked into when you're looking at lack of responsiveness to growth hormone therapy in that perspective. So this was the first case who was falsely diagnosed as growth hormone deficiency while the child was celiac. So do not make a wrong diagnosis and then growth hormone is not going to work again in that perspective. Second case, 10-year-old boy with short stature, very, very short, 100 centimeters, no growth hormone level. You gave the treatment, there was a good response, but on follow-up, there is a very poor response. Adherence is good, thyroid is normal, there is no celiac. So what are you thinking about? Very severe short stature, zero growth hormone level, good response, then lack of response. This is what I talked about, development of growth hormone antibodies, which happens with growth hormone deficiency type 1, which you need to bother about in that perspective. Now, what about puberty? Often children come to us quite late and they have limited time to grow. 12-year-old boy on GH, good response, but now he has entered puberty. What do you do? Now this is because your time is limited, people talk about increasing a higher dose, or you increase the duration of puberty using a GnRH analog or aromatase inhibitors. Now, if the child is short at onset of puberty, you can increase the dose. But definitely aromatase inhibitors are not recommended because they have a high risk of causing effects on bone, effects on prostate, effects on testes. So in boys, aromatase inhibitors are not recommended. GnRH analog, again, in a normal puberty is not going to help. So diagnosis should be early, and that's the basic key rather than doing these parameters in that perspective. So what about newer developments? We have got now developments with regards to the weekly growth hormone therapy, which is found to be effective in that perspective, and now it's coming up in that regard. So I'll take a couple of minutes to finish off the other indications. It won't take much time. So in that perspective, you should continue growth hormone therapy till around 14 to 16 years of age, and after that the treatment may be continued if you have specific issues for bone for 25 years. Adipocyte, more for adult GSD, you need to retest because many of them will become normal in that perspective subsequently, and anti-aging in that regards. Now in India, most children with GSD do not get treatment because they are not diagnosed properly. So what is the problem there is in terms of we are missing them and we are diagnosing them late. We need to have more awareness about, and what we have developed is a new algorithm which helps immediate diagnosis, evaluation and management of these conditions. So I'll just take a couple of minutes about other indications. I'll talk about Turner syndrome. Now Turner syndrome was the second indication where it was approved. These girls are 20 centimeters short as compared to their normal adult potential. So anybody who is growing less or the height is below the normal chart, you can give growth hormone therapy. You do not need to do a growth hormone stimulation test. Very importantly, the dose is double the dose as compared to the normal dose, 50 microgram per kg per day, and it should be ideally given 4 years before puberty. You should not wait for a long time, so pick them up at the right time. Do not do a growth hormone testing. You gain 1 centimeter per treatment year. So this is important. Don't tell them that you will gain 120 centimeters. It's 1 centimeter extra adult height per treatment year. So it's a moderate one as compared to GHD, and do not keep IGF-1 at the higher level. Very importantly, if there is a delayed diagnosis, as we were discussing, you can delay the pubertal induction or theoretically use oxandrolone. Most of us will be delaying the pubertal induction in that perspective. Very importantly, because you are using a higher dose, there will be a higher risk of slip capital femoral epiphysis, benign intracranial hypertension, and a theoretical risk of scoliosis in that perspective. What about SGA, which is the next important indication? 90% of children who are SGA will catch up by 2 years. If somebody is not catching by 2 years, you would definitely be short till final height and you will consider growth hormone. So what the recommendations are, that if you have a child who is not catching by 2 to 4 years of age and all other causes have been excluded, growth hormone therapy is recommended in SGA. It's a very effective therapy, more effective than Turner's. 1.5 to 2 centimeters per year gain would be there. So if you treat for 5 years, you expect an additional height gain of around 7 to 10 centimeters in that perspective. So no catch up. By around 4 years, you would be considering this treatment in that perspective. And you, very importantly, you will have other benefits in terms of bone, in terms of body composition and weight in that regards. What about CKD? One quick message, that unless you are thinking of transplant, don't go for growth hormone therapy. And second, correct anemia, correct acidosis, and correct hyperparathyroidism before giving growth hormone. Otherwise, it's a safe one, but only if somebody is going for a renal transplant should you be giving a treatment for chronic kidney disease. Very importantly, they have other improvement and you can plan a good height in that perspective. Last two indications about Prader-Willi. Now Prader-Willi syndrome is a syndromic cause of obesity and short stature. If you have somebody with hyperphagia, obesity, think of Prader-Willi syndrome. Giving growth hormone to them will improve their body composition and their height. So anybody with Prader-Willi syndrome is approved for treatment, but remember that they have a sleep apnea, and if you do not correct that, they may die also. So growth hormone therapy in Prader-Willi is something which is careful, but they will have a good response, they will lose weight, their fat will come down in that perspective and they will improve. So very importantly, if they have sleep apnea, diabetes or severe obesity, do not use that treatment. Final issue about idiopathic short stature, which sir was discussing. Now idiopathic short stature is nothing but a combination of partial GHD and partial growth hormone insensitivity. Either the growth hormone is not there or it's not working. It can be genetic, it can be environmental, so many factors. So what we are trying to know is that it is not a single diagnosis. So what we do in this scenario is give a trial of growth hormone. See for 3 to 6 months whether the child improves or not. If there is no improvement, in that perspective start around 35. If there is no improvement, that is your growth velocity should increase at least 50%. If there is no increase, then stop treatment. So this is that you not everybody will benefit with that. No improvement in 3 to 6 months, stop treatment. That is the key indication in that perspective. So what I'm trying to say that GHD is an absolute indication, very good benefit. Turner syndrome, good indication, but it's a costly treatment. High dose, less response. SGA, a good indication. Low dose will give you a good response. CKD, ISS, Prader-Willi, more specialist input. You require much more issues in that perspective and you give a trial in that perspective. Skeletal dysplasia, no. Steroid toxicity, theoretical indications. Hypophosphatemic rickets and Russell Silver. Russell Silver is more like SGA, they will respond to that. So I think this was an exhaustive topic. We tried to cover a lot of topics in one go, but the key message is growth hormone therapy is absolutely safe if used properly in the right dose, in the right condition, good response. You do not expect a lot of adverse effects. Thanks for patient hearing. Again, you can go through these presentations which are already available in the website. Thank you, sir.
Good afternoon, one and all. Before I thank the speaker for his wonderful talk, I must thank the organizers, both the Das, Sambit and Lipsa and their team, to give us both the Anuj sir and me, Arkhit, a chance to chair a session where Dr. A.B. is involved. Okay, so he has very wonderfully finished his talk, and he has given the indications, particularly in short chaser and all other indications. And because there is a time constraint, I should invite at least 1 to 2 questions on the floor. Then I request my Anuj sir to wind up the things.
Growth hormone therapy develops adenoid hypertrophy. So would you recommend to continue this, or would you want to, he is not having any stridor or sleep apnea, but he has developed definitely this thing. What is your take on that?
We are talking about Prader-Willi syndrome. That is the only indication where I would be a bit careful. But routine growth hormone deficiency, lymphoid hyperplasia, adenoid hyperplasia are very, very common. So I would not, we will continue the therapy. If it is causing sleep apnea, then maybe go ahead with the surgery. It's a mild one. It doesn't cause a lot of problem. Usually in the initial phase, then it comes down over time.
Because one of our kid who is on therapy, after 1.5 years, he developed this adenoid hypertrophy, which is almost grade 3, grade 4 symptomatic. So I just withhold the therapy. So I just want to know, if call the patient day after tomorrow.
So generally we would not stop the therapy. We will maybe use alternate therapies and if required surgery, because it is part of it and it improves over time as well. So we don't expect much problem from that.
If no other questions, I would like to wind up. Growth hormone is very much used, and we have listened the use of growth hormone, but there are abuse of growth hormone also. Like in the sports panel or in the adult growth hormone therapy and the growth hormone therapy in the old age, though not recommended, has been used, but these are the abuse of growth hormones. And I think, and there are also long-acting growth hormone you have already told. Growth hormone has been trialed and has been passed phase 3 trial at China and Australia, but has not been marketed till yet for the long-acting growth hormones because of the definite complications of growth hormone therapy, like glucose intolerance or the lipid problem or the carpal tunnel syndromes. I think he has already, Dr. Bajpai has already told the indications of growth hormone therapy. We think I wind up, and I thank you, Dr. Bajpai, coming and
thank you, sir.
Thank you, sir. Thank you to the speakers and chairpersons. Now I would request the panelists of the previous session to please come to the presentation area for the presentation ceremony. Dr. Lipsa Das ma'am, Dr. Modi sir, Anurag sir, Amit sir, and Jayashree ma'am. Please proceed to the presentation area. Thank you. Coming to the next session, I would like to invite the chairpersons, Dr. Jabarchan Jena, Consultant Endocrinologist, Department of Endocrinology, SCU Medical College, Cuttack, and Dr. Rasmiranjan Das, Additional Professor of Pediatrics, AIMS, Bhubaneswar. There has been a slight change in the topic. So, Dr. P. Ravi Kumar will speak first, followed by Dr. Santosh Ramakrishnan.
Good afternoon. Thank you, Endeavor. Our next topic is delayed puberty. As you all know that puberty is an important stage in the life of a child with change in emotion and physical changes also. So when it doesn't occur in time, so there is more stress to the family and to the child. So to talk about this topic, we have Associate Professor Dr. Ravi Kumar. He is the most sought after endocrinologist of Barampur, and he has contributed widely in terms of 30 publications that are featured in reputed national and international journals. Apart from academic activity, Dr. Ravi Kumar practice in RK Diabetes and Endocrine Center. Sir, please start your call.
Thank you, Dr. Devatsan, Chairpersons, Dr. Sambit, and entire the team. I must congratulate for such a wonderful organization of this event. And I have been asked to speak on delayed puberty. So what I will be doing is I will be talking today on some basics about delayed puberty. Many times I think there was some discussion regarding CDGP and somebody coming at 11 years, how to proceed, whether to call it as a delayed puberty or not. So we shall be doing that in a short period of time. So puberty, as you say that, puberty is a very complex process of transition from the childhood to adulthood. It is characterized by three important events. One is development of secondary sex characteristics, second is the gonadal maturation, and the third is attainment of reproductive capacity. So these are the three main events that are taking place at the time of puberty. So before proceeding to delayed puberty, just some information about puberty is very important. Now pubertally, there is a natural progression of pubertal events during the puberty. And in case of boys, if you can see that it starts with gonadarchy, followed by pubarchy, followed by the initiation of the height spurt, then there occurs penile enlargement, followed by the peak height velocity. Compared to that, in case of girls, you find that it is the first is the initiation of the height spurt. So whenever it was asked to some of our students, what is the first event to take place in the onset of puberty in girls, they would immediately say thelarchy, but actually it is the height spurt is the first indicator of puberty in case of girls, which is followed subsequently by thelarchy, pubarchy, then it reaches the peak height velocity followed by the menarche. So what is the time period usually that happens with the onset of puberty? In case of girls, it is around 10.5 years. That is the mean time period for a onset of the puberty in case of girls is around 10.5 years, and in case of boys, it is almost 11.5 years, which is followed by the subsequently by other events. Now, during puberty, during the childhood period, you can see that there are two events. One is there is a juvenile pause. The juvenile pause starts from the age group of 4 years and it lasts till the onset of puberty. There is a central inhibition of GnRH neurons, during which time there occurs no puberty. But with the onset of puberty, this central inhibition is got disinhibited and there occurs onset of puberty. It's a very complex process. So before going nowadays, there is a lot of talk about various genes that are involved in the GnRH development and puberty. So one important thing is the development of GnRH neurons. The second is the migration of GnRH neurons, then pituitary gonadotropes, all are involved in a coordinated manner to cause the puberty. So puberty generally you require the gonadotrope cells which are mainly stimulated by the candy neurons which are present in the arcuate nucleus, and there are also AVPV in the AVPV we also got kiss peptide neurons. So these two neurons actually stimulate the GnRH neurons to cause the puberty. But one of the important thing is the onset of puberty is also one of the limiting factors is the leptin. Leptin is a permissive role. So you find that some of the very young girls, everything is normal, but still they will not be entering into puberty just because the leptin levels are very low. So an optimal leptin levels is also required for the onset of puberty. Now when do we say that somebody is having delayed puberty? So what is the general mean age of onset of puberty in case of girls is, as I told, it is 10.5 years, and in case of boys, it is 11.5 years. So we normally take 2.5 standard deviations to say that somebody is either it is delayed or it is precocious. So in this case, it is 13 years, it comes to around 13 years if you add 2.5 standard deviations in case of girls, and in case of boys, it is the 14 years. That is how the definition of delayed puberty has come. Now coming to the various causes. Causes can be the most common cause or the physiological causes, as has been discussed, it is the constitutional delay in growth and puberty, followed by the various other causes. There is no time to scope for each and every cause, but it is just sufficient to say the two most important causes is, one is constitutional delay in growth and puberty, the other one is hypogonadism. And there is also occurs when the testes in case of boys and ovary in case of girls, if it is involved, we call it as a hypergonadotropic hypogonadism. So there are various causes are there. It is not possible to go into all the causes. Just to highlight that various causes where enzyme defects, it can be hypogonadism, so and even any chronic illness causes functional hypogonadism. So, but to summarize this, in case of boys, the most common cause is the constitutional delay in growth and puberty, which accounts for almost 65% of all the cases. Whereas in case of girls, it is only 30% of cases is due to attributed to the CDGP. So CDGP is more common in case of boys compared to the girls, followed by the hypogonadism. The hypogonadism is almost 20% both in boys and girls, you will find that, and the functional hypogonadism is also very important in these conditions. So coming to the CDGP, CDGP is the most common to affect the delayed puberty, and usually what happens is that by the age of 2 to 3 years, there is a shortage of, height shortage will be there, but the growth velocity will be normal. If you see the growth velocity, it will be normal, and it is comparable to their bone age. Whereas, but it is of course it is low for their chronological age, and the bone age is usually delayed compared to the chronological age. And a family history of delayed puberty is seen in almost 50 to 80% of cases, and if you follow these cases, you will find that the final adult height is usually within the target height range, and fertility is usually normal. So what are the indicators? In clinically, we can say that we can suspect that there is a hypogonadotropic hypogonadism. There are certain features which will indicate that probably you are dealing with a case of hypogonadotropic hypogonadism. This includes if there is a presence of anosmia, presence of synkinesia, or any midline defects, or presence of micropenis, or cryptorchidism, or unicaudal proportion. These usually indicates there is a, probably you are dealing with a case of hypogonadism. Similarly, if you are dealing with a case with hypergonadotropic hypogonadism, especially in boys, you find gynecomastia with long leggedness and a small firm testis. Usually KFS is the common cause which causes these abnormalities. Now, recently, there are various genes which have been identified, and these genes, as you know, that there are genetic testing is now available. It is not that it is only in theory. The genetic testing is now available. As you can see that various genes of the GnRH or in the pituitary, they can affect the puberty, and especially the CAL1 gene, where the anosmia is the main defect will be there. Then CAL2 is the FGFR1 or FGF8. So many genes which have been now, we can identify these genes if you can do the genetic testing. Now there are certain clinical pointers to the diagnosis of delayed puberty. If there is a presence of anosmia, it usually indicates there is a Kallmann syndrome, and there are CAL1, CAL2, CAL3, CAL4. These are the 4 varieties of Kallmann syndrome. All can present with anosmia, and if you have the asymmetric testis, probably there is a testicular, there is some damage is there, or if somebody is receiving the chemotherapy, radiation treatment, probably you are dealing with a case of hypogonadism. And in the case of dysmorphic features, probably you are dealing with a case of Turner's in case of girls. And if there is a presence of short stature, of course, Turner's or CDGP or Kallmann syndrome, it can be there. And tall stature usually will be present in case of Klinefelter syndrome. Now, how to distinguish CDGP versus congenital hypogonadism? There is some discussion about this. So one important thing is that in CDGP usually the children are short, whereas in case of hypo, usually the children are either normal height or they are slightly above the normal height. Family history is present almost 50 to 80% of the patients. Usually either a parents or one of the siblings might be having delayed family history of delayed puberty. And if there is a presence of micropenis, cryptorchidism or midline defects, it usually indicates hypo. And if there is a bone age is significantly delayed, that usually indicates CDGP. But this is not, even after all these clinical findings, we will not be able to distinguish CDGP versus hypo in many cases. So what to do next? What to do is we have to go for the testing. The two important testing is, one is the gonadotropes, LH, FSH, and the testosterone or estradiol depending upon the boys or girls. And if you find that LH, FSH is normal or it is decreased, and if the gonadal hormones are decreased, it usually you are dealing with a case of CDGP or hypo. And if your LH and FSH gonadotropes are increased, and if the testosterone or estradiol are decreased, it usually indicates hypergonadotropic hypogonadism. So the question is then what to do next? In case of boys, we usually do a testosterone level. So if a basal testosterone level is more than 1.7 nanomoles per liter, that is roughly 50 nanograms per deciliter, then it usually indicates CDGP. It doesn't mean that in all cases you will have the CDGP. In some cases of CDGP, still they can have testosterone levels less than 50 nanogram per deciliter also. Suppose if the testosterone levels are less than 1.7 nanomoles per liter, then if you do a basal LH, and basal LH is less than more than 0.3, it usually indicates CDGP. But if it is less than 0.3, again it can be hypo or it can be CDGP. So then you have got two tests. One is the GNR stimulation test using the triptorelin, or you can use the HCG stimulation test to distinguish between these two. I will not go into much details about it, but it is not so easy to distinguish CDGP from hypo even in the experienced cases. Sometimes you might need to wait till 18 years of age to say somebody conclusively that you are dealing with a case of CDGP or hypo. The other important aspect of hypo is that some of the patients will actually reverse. They were receiving treatment, they will become actually normal after the treatment. After some time you might need to stop. So nowadays we are also doing the inhibin B levels. Now inhibin B has come in a very good way to distinguish between somebody who is dealing with CDGP or hypo or somebody entered into puberty or not. The initial study by the Cowtent, it was published in 2010, and it showed that a inhibin B level of less than 35 usually it indicates hypo. But later on in 2015, it was found that by Binder et al. That it can be, the inhibin B levels can be as high as 111 was the cutoff it was used. So there were also studies from India, from the PGI also. They have taken a different cutoffs because different people have used different cutoffs. Somebody has taken 94, somebody has taken 61 picograms per ml. But the most important thing is that inhibin B can be used as a marker for to say that somebody has entered into puberty or not. Now recently one of the studies where from PGI, they also used the FSH stimulated inhibin B. What used to be I will take just 5 minutes. So what used to be FSH stimulated basal inhibin B, in this case they have actually stimulated with FSH and found out what is the cutoff to better differentiate between CDGP from hypo. And it has been found that the inhibin B levels were 116.14 picogram per ml in males and nearly 116.5 picogram in females, almost 100% sensitivity and specificity for labeling them to enter into puberty. So this has also been found to be a very useful test. Of course, it requires FSH to do this test. Then one other test, experimental test that has been used is using kisspeptin to predict pubertal outcomes for youth with puberty, in which kisspeptin has been given intravenously, and they try to find out what is the LH with this, and they found that people with LH with less than 0.4 milli international per ml, he found that almost all of them were hypo. I think these are the future diagnostic modalities which we will be coming across. Now, just I will tell about two cases. This is a case of 18 years old boy who present with a short stature, micropenis, unicaudal proportions, and cryptorchidism. And when it was seen the X-rays, you find that there is a synkinase of 4th and 5th metacarpals are there, and you find that when the investigations were done, both LH, FSH were low and testosterone were also low, so it was a case of hypogonadism. And when the MRI of the abdomen was done, you find that right kidney was absent. So it is a case of right kidney was absent in this case. And you find when we did the MRI of the brain, in the coronal picture you find that there is absence of olfactory placodes with olfactory sulcus. So this is a case of Kalman syndrome type 2, where you find that the defect could be probably in FGF8 or FGFR receptor 1 mutation. So lastly, there is one more case. This is a 23-year-old female who presented with a severe short stature, she had no breast development. Breast development started only after giving the OCPs, and she was hypothyroid on levothyroxine treatment, and she had all the features, some of the features of short neck, high arched palate. There is a carrying angle was 30 degrees, and when we did the hormones, we find that LH-FSH was very much increased, with estradiol was very low, and you find also there is a rudimentary uterus with streak ovaries, and when the karyotype was done, it is a 46X with the deletion of X chromosome. So this is a case of variant of Turner syndrome. So there are so many cases which we can discuss, like PROP1, PIT1. So because the time doesn't permit us to do that, so I will stop here. Thank you very much for a wonderful session.
And because we have exceeded time, so we can take one or two questions from the audience.
Yes.
And one of my question to you, sir, before we take the audience questions, what is the most common symptom with which they present to you, delayed puberty?
Which one?
Suppose a child is coming to you, what is the most common symptom with which they present?
Actually, they in the age group of, say, suppose 10 to 14 years, short stature is the commonest presentation, whereas above the 14 years, up to 18 years, they come with a lack of secondary sex character. That is the commonest presentation.
From audience, we can take one or two questions. So I think there is no question. So thank you so much, sir. And
thank you so much
to Sambit Das, sir, and Lipsa for the invite. Thank you so much.
Thank you, sir. I request the speaker and chairperson to please proceed to the presentation area. Now for the next talk, I would like to request our chairperson, Dr. Pitambar Prishti sir, Senior Consultant Endocrinologist, Apollo Hospital, Bhubaneswar, and Professor Dr. Suryakanta Swain sir, Professor and HOD, Pediatrics, High Tech Medical College, Bhubaneswar.
So after a nice talk by Professor Ravi Kumar about delayed puberty, we are going to hear another lecture about early puberty. As you know, puberty should occur naturally and timely. If it occurs before certain defined age, either for girls or boys, then it is called early puberty or precocious puberty. Precocious puberty poses problems not only for the child, but also for the parents as well as in the society. So it is a really very difficult problem to tackle. It may carry very sinister diseases which will be brought out by investigations, cannot be taken lightly, although the treatment sometimes may seem to be easier by the general practitioner or endocrinologist. So with this, I think let us have the talk, and I will request my co-chairperson to introduce the speaker, please.
Good afternoon. Thank you, Sambit, Lipsa, and the Endeavor team to give me the opportunity to chair the session. And I have the privilege to introduce our next speaker, Dr. Santosh Ramakrishnan, who is the founder and director of Magna Clinics for Obesity, Diabetes, and Endocrinology at Hyderabad. He has lots of publications, and he has written also chapters in textbooks. He has addressed many scientific forums in international and national endocrinology conferences. He has interest in spreading and acquiring latest advances in the field of diabetes and endocrinology. He is the lead clinician in the Growth Clinic and Basal Insulin Initiative in the Magna Code. And over to you, sir.
Thank you, sir, for the kind words, and thank you, Sambit, for inviting me to the city of Bhubaneswar, which I really like to come here again and again. So I'll be talking today about the approach to precocious puberty, and for the first few slides, I'll be skipping them because Dr. Ravi Kumar has already presented, so that I can concentrate more on the topic that I would like to present, that is precocious puberty. So when do you say a person is having precocious puberty? Precocious puberty is when the physical pubertal change occurs in girls less than 8 years of age, and in boys when it occurs then less than 9 years of age. And when Dr. Ravi Kumar said, it was very clear. So in girls, if there is a pubertal growth spurt or appearance of thelarchy before 8 years, or if there is an enlargement of the gonads and there is a height spurt in boys less than 9 years, we are supposed to say it's precocious. There is a secular trend, however, nowadays many girls especially are developing earlier and earlier puberty. That needs to be kept in mind, but till we have normative data, we have to use this particular definition of less than 8 years and less than 9 years. What are the types of precocious puberty? I'm sure as many pediatricians are already there here, and even in our MBBS days we have learned it. So there is something called as central precocious puberty, and there is peripheral precocious puberty. So central precocious puberty is what premature activation of the HPG axis leading to a gonadotropin dependent precocious puberty, which follows a particular pattern. So there will be thelarchy, pubarchy, menarchy. It will go in one particular pattern only. So these are the type. Central precocious puberty is a gonadotropin dependent precocious puberty. Peripheral precocious puberty is not dependent on the HPG axis. It's occurring because of a peripheral problem. It's gonadotropin independent. It could be isosexual puberty or heterosexual puberty, and on most cases it will be incomplete. It won't be a complete thelarchy, pubarchy, menarchy type of picture. It will be incomplete. There are some variants of normal puberty that we need to know, that is premature thelarchy, pubarchy, and menarchy, which I will be touching on briefly. What is the etiology, the commonest etiology of central precocious puberty in girls and boys? The commonest cause is idiopathic or sporadic. In fact, 80% to 90% of the cases who come to us with early puberty are usually because of idiopathic or sporadic causes. What are the commonest organic causes for precocious puberty? The commonest ones that we see as endocrinologists is in fact hypothalamic hamartoma, CNS tumors, infections, CNS insults, malformations we do see. Miscellaneous causes like Russell syndrome, IUGR, and endocrine disruptors are more common nowadays. And also as endocrinologists, we see this particular thing. Peripheral precocious puberty, which is left untreated, can turn into central precocious puberty, especially in cases of congenital adrenal hyperplasia and McCune-Albright syndrome. These are also pretty common conditions that we see in our day-to-day practice. What are the causes of peripheral precocious puberty? To be very frank, peripheral precocious puberty we do see as endocrinologists, but not as many as central precocious puberty. Hypothyroidism seems to be the commonest cause. So Dr. Ravi Kumar has just told that hypothyroidism causes delayed puberty. But hypothyroidism is a condition which can present with pseudo-precocious puberty as well. Ovarian sources of estrogen like McCune-Albright syndrome, follicular cysts, or tumors can also present with peripheral precocious puberty in girls. Feminizing adrenal tumors, exogenous estrogens can present with peripheral precocious puberty in girls. In boys, one of the commonest causes is adrenal source. Congenital adrenal hyperplasia because of 21 alpha hydroxylase deficiency is one of the commonest causes of peripheral precocious puberty that we see in boys. Testicular tumors, adrenal rest tumors, testotoxicosis, HCG secreting tumors are all there, but they are quite rare. As endocrinologists, all of us would have seen 1-2 cases, not many more than that. Heterosexual precocity, that means there is increased virilization in girls. So virilization in girls occurs because of congenital adrenal hyperplasia or virilizing tumors of the ovaries and the adrenals. And aromatase mutations, they can all cause heterosexual puberty in girls. The opposite, that is feminization in boys, can occur because of estrogen secreting tumors from the adrenals or from the testes, or exogenous exocrine therapy, or feminizing aromatase excess syndrome. Heterosexual precocious puberty, I personally as an endocrinologist for the last 18 years, I would have probably seen only 3 or 4 cases. It's very rare, but it's very important to recognize. So history-wise, what do we take? We ask for the age of onset, and we see the progression of physical pubertal changes because it helps us to differentiate between central and peripheral. What is the growth velocity, any exposure to exogenous hormones, any possible CNS symptoms that can give us a clue to a CNS related disorder. Hypothyroidism history and family history are very important during our history taking sessions. Whereas in examination, we would like to mainly see obviously the height, weight and arm span. We do the staging of pubertal development. Unfortunately, we still have to rely on Tanner staging, which was done by Mr. Tanner in Britain in 1940s. We are still using that particular staging, but that is the only thing that's available for us. We are doing that. Careful assessment in obese girls to see whether we are dealing with increased breast or increased fat tissue in the chest area. Testicular volume in boys is very important. In central precocious puberty, the testicular volume will be enlarged. In testotoxicosis and HCG secreting tumors, they'll be enlarged, whereas other causes will all be reduced. There are some causes where there can be a unilateral testicular enlargement. For example, adrenal rest tumors or testicular tumors, we might see that. Thyroid palpation is also very important to see for features of hypothyroidism. In our examination, we have to do a neurological examination mainly to rule out if there are any visual field defects mainly. And evaluation of skin lesion. So in our DM exam, if we miss this McCune-Albright syndrome or neurofibromatosis, you can fail the exam also. So it has become our daily practice. Like anyone who comes with precocious puberty, we always look for skin signs. McCune-Albright syndrome and neurofibromatosis. Palpation of the abdomen is important because many patients can present with an adrenal mass. I've personally picked up at least 4 cases by only palpation of the abdomen, and psychological evaluation can be done. Bone age obviously will be advanced if the patient is undergoing precocious puberty. So bone age will help us to differentiate between true precocious puberty and the variants of precocious puberty like premature thelarche and other things. Baseline lab evaluation, what do we do? First we find out whether it's really precocious puberty or no. So as I said, it's important to differentiate between premature thelarche, pubarche, menarche from puberty. So is it puberty? If the testosterone is greater than 30 nanogram per deciliter or estradiol is greater than 20, then it is precocious puberty. Then whether it is central or peripheral, we have to do the LH test. So LH, if it's low, below 0.1, then it's either pre-pubertal or peripheral precocious puberty. Then in that cases, we undergo something called as, we make the patient undergo GnRH stimulation test, which I'll tell in the next slide. If the LH is high, that is greater than 0.8, we can directly label this person as gonadotropin dependent precocious puberty. FSH levels usually are not supposed to be done for the diagnosis of precocious puberty, but if we do it and find out that the FSH is very high, then it's most likely a peripheral precocious puberty and not central. GnRH stimulation test is what is done routinely to differentiate between prepubertal status and central precocious puberty. The standard GnRH stimulation test nobody is doing. Nowadays, we are doing something called as the GnRH agonist stimulation test, either with leuprolide at 10 to 20 microgram per kilogram or triptorelin 100 microgram per meter square. In our institution, we prefer the triptorelin test. That is 100 microgram per meter square. We do sampling at 0 hours LH, 60 minutes and 120 minutes LH to find out what is the bump. So after giving triptorelin, if you find out that the LH has gone above 6, then we say it's a true central precocious puberty, not a peripheral precocious puberty. So I'd like to go to some cases now just to highlight what I've been telling all this time. This is a 3-year-old boy. 3-year-old boy, okay, look at him. He's 102 centimeters in size. He's a testicular volume of 6 ml bilateral. and he has P3, G3 in tenor staging and his low-pitched voice. Actually, the first thing that was very striking to us when he came into the room was his voice. For a 3-year-old boy, it was almost like an adult voice. Bone age was 10 years for this boy. Testosterone is pubertal, LH was 0.8, and we did a GnRH stimulation test. It came to 16 international units per liter. FSH was low. Diagnosis, we did it central precocious puberty. This is the first case that I have seen in my private practice, so that's why I remember. First case of precocious puberty. Before that, everything was in PGI Chandigarh. This is a 18-month-old girl presented with bilateral thelarchy. A pediatrician has reassured that this is normal and asked the girl to follow up. Was the pediatrician wrong? No. Statistically, he was not wrong actually. Because premature thelarchy does occur at this particular age, between the first 2 to 4 years of age, because of increased sensitivity to the ovarian estrogens that are circulating. But however, the breast does not cross Tanner 3, and height and bone age are normal, and GnRH response is prepubertal. For this age, it's usually premature thelarchy only. So statistically, the pediatrician was not wrong there. Premature pubarchy is another thing which occurs usually at the age of 6 to 7 years. I just started 5 minutes back. 10 minutes back I would have started. The timer is coming here also. Okay. So the early maturation of the adrenal androgen production, the height and bone age is slightly advanced in premature pubarchy, and usually premature pubarchy will signal the presence of either PCOS or late onset CAH. So in that case too, the child's length was above the percentile defined by mid-parental target height. The bone age was advanced. It was 3 years, the bone age. So it was 18 months old girl with 3 years of bone age. Estradiol was high, basal LH was 0.4, and after stimulating with triptorelin, it was 9.2. So this girl was actually having central peripheral precocious puberty, gonadotropin dependent. So we have to do MRI in these particular cases. So when to do MRI? MRI is usually done in those patients who have central precocious puberty. In all boys we need to do, and in girls who are less than 6 years of age. Above 6 years of age, girls usually don't require MRI because it's usually idiopathic only in all of them. But if they have neurological findings on MRI, then we might have to do it. So in that girl who was 18 months old, she had a normal MRI and she was treated with GnRH receptor agonist, that's all. Whereas that boy which I showed, who was a 3-year-old boy, now you can see something that is coming out of the hypothalamus over here. I don't know whether you're able to see. But there is something that's coming out of the hypothalamus. This is in fact a hypothalamic hamartoma. When we do ultrasound, you can see a uterus length of greater than 3.5 centimeters in length, which is suggesting of a pubertal uterus, endometrium thickness, which is high, and ovary, multicystic ovaries or follicular size will also suggest that the patient is having actually precocious puberty and not premature variants of the thelarchy and menarche and pubarchy. How do we treat central precocious puberty? Why we should treat it in the first place? Sir, Dr. Pusti has already told, we should treat to avoid the discrepancy between the physical and psychological maturity. So imagine if a girl is having periods when she's 8 years old, it's very difficult to treat them. To arrest the progression of puberty, and most importantly, is because after menarche, the height usually increases only for 1.5 years. The girl will stop growing at the age of 9.5 years to enable to achieve a proper adult height. That's why we treat central precocious puberty. Central precocious puberty is treated mainly with GnRH receptor agonists. They are more potent, they have a longer action, no toxicity, and the benefit is less than 6 years onset, is more than between 6 to 8 years. And once you give GnRH receptor agonist, usually the sex steroids revert back to the prepubertal range. How do we follow up these patients? We call them once in 3 months. We check for their sexual maturity scoring, and we do a GnRH, followed GnRH treatment. There is one particular protocol to see whether it's actually working or not. We give the GnRH receptor agonist, which they are using for the routine treatment, and check the LH after 3 hours. The commonly used GnRH agonists are leuprolide and triptorelin, and the doses I have written here. Medroxyprogesterone acetate we do give for people who cannot afford GnRH receptor agonist, or those people who are having peripheral precocious puberty. So as I said, in response, in girls, the breast will usually regress, the vagina becomes non-estrogenized. In boys, there is cessation or regression of testicular growth and growth advancement. And there may be an initial flare-up with advancement of pubertal changes usually. So with GnRH receptor agonist, there can actually The increase in breast size and spotting may be seen in the first 2 months of use, after which it will regress. When do you continue GnRH receptor agonist? This is the commonest question that is asked by all the parents. We usually give for up to 10 to 11 years chronological age in girls and up to 12 years in boys, and which allows the puberty to go on in the correct time after that. So I'm going to skip through these cases very fast because of want of time. This is a 7-year-old girl. She came with precocious puberty with short stature. Precocious puberty with short stature, is it possible? Yes. So this girl was actually having primary hypothyroidism with pseudo-precocious puberty. This is a 2-year-old boy who presented with gynecomastia. That means heterosexual precocious puberty. And what we found out in this particular patient was, it was a gonadotropin independent precocious puberty due to a adrenocortical carcinoma secreting testosterone and estrogen. McCune-Albright syndrome, it's a GNS receptor mutation. We do see McCune-Albright syndrome not very often in our day-to-day practice. I personally would have seen only 3 to 4 cases in my entire life. But they do present with cafeolar macules and fiber optic dysplasia, and they present with peripheral precocious puberty. This is a case of testotoxicosis, gonadotropin, independent precocious puberty with a strong family history in the parents. So this was happening in every male in the house was having precocious puberty. Obviously, this is not the correct picture. This is just a cartoon I have put because patient refused to take a photo. So this is a gonadotropin independent precocious puberty in a young boy, which was occurring in their father, and father's father also had this. It was a case of testotoxicosis. This is a rather interesting case. There are sisters, okay? One is 8 years old, one is 6 years old. Both of them presented with thelarchy and growth spurt. Both of them had bone age advanced. That means it is precocious puberty. Both of them had estrogen about 20. But the elder sister is having gonadotropin dependent precocious puberty. Younger sister is having gonadotropin independent precocious puberty. What can it be now? That cannot be such a major coincidence that one person has a CNS problem, one person has a peripheral problem. Actually, what is happening was this patient was buying milk from one buffalo milk vendor, and for most reasons that we know that this buffalo was being injected with estrogens. So this patient was, both of them were actually having peripheral precocious puberty. And I told you in the initial few slides, peripheral precocious puberty, if it's left untreated for a very long time, it will activate the pituitary and lead to central precocious puberty. So just by changing the milk vendor, the younger girl, her precocious puberty disappeared, but the older one had to be treated with GnRH receptor agonist. Now that is one of the reasons why precocious puberty is increasing, because of so many environmental disruptors that are occurring, especially the insecticides, pesticides, and the estrogen that is being used in poultry, and also because of obesity. Nowadays people are saying that obesity is causing leptin resistance leading to early precocious puberty also. Obesity related precocious puberty is usually at around 8 years, 9 years of age. It won't be the very, very early type of precocious puberty. So I think I will skip all these slides because how to approach the precocious puberty I've already told. And I think I will stop over here for want of time. Thank you. Thanks a lot.
Thank you, Dr. Santosh, for a very lucid and script presentation. I think as the global trend indicates, you see there is a shifting of
investigate all those people who are having puberty before 8 years of age. Endocrine disruptors are one of the leading causes of developing early precocious puberty. As I told, the insecticides and pesticides are causing it. Second thing is the poultry which is and buffaloes which are getting injected with estrogen, they are causing early precocious puberty in many girls. Very difficult to identify what is exactly the root cause in all of them, but definitely endocrine disruptors are playing a role.
Thank you. Actually, we should be well aware of these things when we come across a case of precocious puberty. Now, the second important question for the clinician, you see, once you are giving a GnRH analog, especially what is available is leptoranil or triptorelin, how long you will continue? At what stage you should say, no, it is enough and we should stop?
Yeah. So, as in girls, we usually stop in the 11th birthday. In boys, we usually stop in the 12th birthday. So if you stop in the 11th birthday, the girl will usually develop menarche when she's in the end of 6th standard or early 7th standard. That's what most of the girls are now developing periods in the 6th standard end or early 7th standard. In boys, we would like to continue at least till 12 years because that will maximize their height potential and their puberty will start at the age of 13, 14 only.
Any questions from the audience? I think because of time constraint, we should wind up the session. Thank you, Dr. Ramakrishnan. Thank you.
Thank you, sir. Sir, I would request you to please proceed to the presentation area. For the next talk, I would like to request the chairpersons, Dr. M.K. Chotrai, sir, Senior Consultant of Medicine, Apollo Hospital, Bhubaneswar, and Dr. Paresh Jena, sir, Senior Consultant of Medicine, Apollo Hospital, Bhubaneswar.
So, today, this time we are going to listen from Dr. Abhay Sahu. He will be talking on empowering holistic patient-centric case in type 2 diabetes mellitus, risk factors reduction and organ protection with SGLT2 inhibitors. The SGLT2 inhibitors, they have taken a center stage nowadays. The cardiologist, the nephrologist, they are using it because of the protection they give to the heart failure and CKD cases. So I hope Dr. Sahu will be telling these things in detail. Well, my co-chairman will introduce him.
I think Professor Abhay Sahu needs no introduction to this audience. Actually, I have opportunity to work with him for almost 10 years in my previous hospital, Calling Hospital. Now he is working as a professor in endocrinology. He is a bright and brilliant endocrinologist of Bhubaneswar. He was organizing secretary of ESICON 2018 and EC member.
We have actually discussed this thing in the morning.
Society.
No need to introduce again. We have discussed this thing in the morning. So
morning you have delivered.
Respected chairpersons, my dear friends. So probably today we have another topic on SGLT2 inhibitors. So we are discussing some of the few things. Probably a lot of the time we have not discussed about SGLT2 inhibitors regarding the pathophysiology mechanism and how it gives some sort of protection to each and every organ. That part we will discuss in this topic. So first part is there occurs a dysfunctional adipose tissue and premature cardiovascular risk. So if you will see there occurs excessive adipose tissue gets accumulated in the body. In fat, this accumulates in the heart. Can lead to cardiac steatosis, which leads to mitochondrial dysfunction, impaired cardiac energy metabolism, and also conduction abnormalities. If you will see again in the abdomen, there occurs abdominal fat deposit, central obesity that leads to altered fat metabolism, also lipid abnormalities. And in liver, again it causes hepatic steatosis that leads to increased liver synthesis of the fat and also increased VLDL secretion. So these are the certain important things what classically occurs in a diabetic patient, and this altered metabolic profile leads to insulin resistance, altered glucose metabolism, altered adipocytokine release. There is low-grade systemic inflammation and endothelial dysfunction. Again, from the cardiac dysfunction point of view, this dyslipidemia, systemic hypertension, diabetes, obstructive sleep apnea, all has direct effect on the heart. And also there occurs certain changes in the hemodynamics, like increase in the blood volume, left ventricular wall stress, LV remodeling, hypertrophy. Again, there occurs RV enlargement. All those things also plays a critical role regarding the early diastolic dysfunction and subsequent cardiac abnormalities. And again, there are certain neuro abnormalities, because we know in diabetes there occurs autonomic dysfunction, along with there occurs RACS activation. Thus, RACS system activation also plays a critical role in particularly cardiovascular point of view. So we know this, if you see the diabetes, this actually slide everybody know, as the beta cell stress or beta cell work in gradual increases. Throughout the course, insulin resistance remains static, there is no further change, but insulin secretion gradually comes down, beta cell mass and beta cell function gradually comes down in due course of time. And so what is happening? We know that insulin resistance is remaining static throughout the course. So once this insulin resistance is remaining, so this insulin resistance acts on the fat cells to produce fatty acids and triglycerides, and they enters into the liver to start producing or lipogenesis, and ultimately there occurs accelerated release of the VLDL from the liver, and also this VLDL plays a critical role for particularly chylomicron production, and we know chylomicron is the basic factor which is responsible for particularly atherosclerosis in particularly type 2 diabetic patients, or in a normal patient also this chylomicron comes, but the process is much more accelerated due to this stress, due to insulin resistance, due to various oxidative stress. Probably this atherosclerosis process is getting accelerated, and that leads to early atherosclerosis in the type 2 diabetic patients. Again, insulin resistance leads to what happens to the myocardial metabolic dysfunction. So in the cardiomyocytes, if you will see a normal person, once the insulin, actual blood glucose acts on the particular insulin that occurs enter into the cell, and there plays a critical role. They increase glucose transport, there occurs glycogen synthesis, neoglucogenesis comes down, lipolysis comes down, protein synthesis increases, and also the proliferation, differentiated proliferation is happening. So that is in a normal cell. But once there is insulin resistance, what is happening? You see, all those actually specifically glucose, free fatty acid, they cannot enter. There occurs a over nutrient state outside the cell. Inside the cardiac myocytes, actually not majority cells or majority of the nutrients is not coming down, and again that leads to, again that is due to insulin resistance, there occurs hyperinsulinemia. So all these factors leads to actual activation, leads to increased activation of the RAS pathway, and this RAS itself leads to actually additional oxidative stress, and also there occurs this actually, as I have already discussed in my previous slide, there occurs increased production of the free fatty acids and also triglycerides, and triglycerides, both that can induce lipotoxicity, and this lipotoxicity is one of the factor which is responsible for mitochondrial dysfunction, and that leads to actually gradual dysfunction of the cell, and that ultimately leads to cell death or apoptosis, and in this metabolic instability also causes reduction in the ATP level, also that cardiac reduction in the cardiac contractility, and that ultimately leads to apoptosis of the cells. So in a normal cell, in the left side, there is the normal function or normal when there is normal. When there is excessive insulin resistance, hyperinsulinemia is there, how this actually leads to apoptosis and cell death. That is the basic mechanism how this cell this happens. Then in cardiac myocytes, this starts usually the earliest change is diastolic dysfunction. We know everybody there occurs initially diastolic dysfunction, and the major one of the important thing they have got there is increase in the triacylglycerol content in the myocytes. So this increase in triacylglycerol, when the content increases, probably the stiffness of the cell increases. So from initial diastolic dysfunctions, gradually there occurs both systolic and diastolic dysfunctions. Then there occurs gradual blockage of the arteries, then microvascular complications with coronary atherosclerosis, and ultimately you can have a clinical overt ischemia or directly myocardial infarction does happen. And basic pathophysiological mechanisms, there occurs deranged calcium homeostasis, there is abnormal fatty acid metabolism, there occurs hyperglycemia, myocardial fibrosis, there is presence of AS products, advanced glycated end products, there is reactive oxygen species, inflammation, microvascular dysfunctions, and also deranged protein hemostasis. All those things actually plays a critical role in the pathogenesis, how this particularly specifically dysfunction occurs in particularly specifically among those patients. So when we are discussing about the holistic care in the a person of type 2 diabetic patients, so we have to take care all those things. We have to take care the blood glucose control should be normal. There should be optimal body weight. GFR should be normal, or there should be, if there is albuminuria, we should take care of that part. We can make it the normal albuminuria, probably that is the best thing. And also, of course, we have to control additional risk factors like blood pressure, lipid profile, and if there is some additional severe risk factor also, we have to take care of that part. That includes a holistic approach in a type 2 diabetic patients. So once we are discussing about target organ protection, from the metabolic point of view, we have to take care hyperglycemia, hyperinsulinemia or insulin resistance, obesity, dyslipidemia, and NAFLD and NASH. From the cardiac point of view, we have to take care hypertension, hypercoagulation state, atherosclerosis, heart failure, and all acute coronary syndrome. And from the renal point of view, if there is a progressive decrease in GFR, we have to strategize so that the GFR should be stabilized or GFR should gradually improve. Along with there should be improvement in the albuminuria, there should not be electrolyte imbalance, and also if there is low hemoglobin, it should be also taken care of in the holistic approach of diabetes. So how this particularly Indian people are, how we are different from others, how it is we people are different, how we should strategize out specifically from our people. You will see the new onset type 2 diabetes in India and UK. If you compare in India, that young age of onset, they have a less generalized obesity, that is the limbs are lean and thin, but our truncal obesity is quite severe. There is high central obesity and also having more insulin resistance. And this is the study between India and UK white, that as age of diagnosis, we have actually 10 years earlier our diagnosis. We have actually BMI is almost 4 to 6 kg less, kg per meter square less, but still our truncal obesity is high. Mid-arm is 20% less, but our waist hip ratio is more than 5%. Our skin fold thickness in the subscapular and tricep skin fold thickness is 20% high. Our fat percent is 30% high. Our insulin resistance is almost 1.5 times higher than the general than the UK population or the UK white comparison. Then this then here comes the, for this holistic approach, how this glycemic efficacy of SGLT2 is stronger. Again, this is, if you will see SGLT2 and DP4, probably in the morning we are discussing, for the Asian population, genetically they are actually much more responsive to SGLT2 and DP4. It's not only SGLT2, DP4 also similarly. You see, this is actually the comparison between SGLT2 in Asian versus white. Here the SGLT2, Asian population, it can reduce HbA1c up to close to 1, whereas in white population it is only 0.6%. Similarly, like DP4 in Asian versus white, it is 0.6%, 0.45. So genetically, we particularly Asian, as a Asian subset, probably actually our response to SGLT2 and DP4 is better than white people. Then when we are using this SGLT2, what is happening or how this glycemic part is getting improved, people see, this is the placebo, the first one is placebo at baseline and day 1 and day 28. From actually the green part is what is the time in range. You say from the green part actually from 52%, it has increased to only 59%. But when we are using MPAT 10 milligram, you see green 52, which has increased to 77% by 28 days. And MPAT 25 full doses, it is from 55% to increase to 81%. That means that time in range is significantly improved with particularly use of empagliflozin. So that we can say from the glycemic point of view, probably it is giving significant benefit when time in range is significantly improved with this age. And this is another important study where actually they try to see what is happening to the hypothalamic insulin resistance with particularly this use of this particular empagliflozin. This is a study in which actually 40 impaired glucose tolerance people were taken. They are non-diabetic, they are all pre-diabetic, where actually they were given empagliflozin, and they try to see what is happening to the particularly blood flow. Actually, those who are having insulin resistance is high. They have actually MR spectroscopy blood flow. They have shown that blood flow is significantly high. But when actually after use of empagliflozin, they are seeing the blood flow is coming down. This is the second part, that the cerebral blood flow is coming down with particularly use of empagliflozin after 8 weeks. So that is the way how they actually from this MR imaging, how they have actually done when they have found out that insulin sensitivity is improved after use of particularly use this empagliflozin. Again, empagliflozin improves overall insulin. It's not in the brain. If you see the HOMA-IR overall, if you see that EMPA versus placebo, you see from 3 actually empagliflozin it has significantly reduced, where in the placebo group it is almost similar. Again, if you see the insulin level, again it has significantly reduced with empagliflozin, because once the glucose is coming out, the glucose load is reduced in the body, probably the endogenous insulin secretion significantly comes down. So that is one of the advantage, that amount of insulin secretion in the body is coming down, that gives some sort of beta cell rest, and also as we have discussed, insulin resistance is also coming down with use of empagliflozin. It's the mechanism is, we know that there is almost a weight loss of 3 to 4 kg, and that loss is due to loss of fat. That is very minimal, lean body mass is lost, and that is one of the important factor for particularly reduction in the things. So again, here how again from the thermogenesis point of view, what is the effect on the lipid point of view, we'll see. Then this actually use of empagliflozin actually causes glycosuria, and with glycosuria we are getting two important things. The glucose level is coming down, the insulin level is coming down, as I have already shown, but the FGF21 is increased, and this FGF21 from the liver actually, there is whatever the fat is there actually from the brown adipose tissue, there is accelerated thermogenesis, so energy expenditure is increases, and also there is a shifting of particularly fat towards the brown fats in comparison to the normal white adipose tissue. So this brown fat, we know that is actually one of the better in comparison to the white adipose tissue, and that way actually empagliflozin gives some sort of again advantage in the particularly lipid metabolism point of view, and also from the differentiated fat point of view. Again, how this insulin resistance and empagliflozin therapy, specifically associated disorders, what are the advantages? It reduces particularly inflammatory cytokines, T cell accumulation is reduced, adiponectin level increases, energy expenditure and fat browning of the fat increases, then non-steroid fatty acid increases. Then there are few pathways like NLRP3, mTOR pathway, and are actually getting reduced, and that leads to actually reduction in the oxidative stress. And so in this way, this how this actually inflammatory cytokine and how this inflammation is actually comes down, and the process of atherosclerosis come down particularly with this basic mechanisms. So again, for the particularly NAFLD point of view, what we have discussed, there are a lot of pathways that there occurs reduction in the PPAR gamma, the reduction in the various cytokines, cytokine 2E1, cytochrome 4A12, and NRF2, and also SCD1. These are the certain various actually things which actually enzyme activity is actually getting suppressed, and ultimately that actually causes decrease in the liver fat synthesis, also liver fat accumulation in those group of patients. So ultimately this is helps in particularly reduction in the particularly the NAFLD and also NASH point of view. So SGLT2 inhibition may improve NASH in the patients. Here if you see, whatever you take, the first one is SGLT2 and second one is the placebo group, you see the hepatic steatosis, lobular inflammation, ballooning degeneration, NASH resolution, fibrosis resolution, and also progression to cirrhosis. Everywhere empagliflozin has a significant benefit than comparison to the placebo groups. Again, from the inflammation point of view, we have discussed, from the NASH point of view, and from the pathogenesis, from the NASH point of view, also all parameters are significantly used with use of this empagliflozin. Hence, SGLT2 with intermediate effect on the heart failure, if you see, the preload part is increased, there is increase in the pre-water clearance, all additional things we have already discussed. There is some sort of effect in the myocardium where actually metabolic efficiency increases, myocardial oxygen supply balance improves, and so LV hypertrophy reduces, and also there occurs reduction in the LV remodeling and fibrosis. And again, there occurs after load reduction, that all those things actually helps in particularly specifically not only the myocardial function, also structural improvement is also there, so particularly specifically in the cardiac point of view. So, and we have actually empagliflozin, these are the certain trials which has not included EMPA-REG. Excluding EMPA-REG, there are 7 phase 3 trials which has clearly shown, if you see the CV death and hospitalization to the heart failure, everywhere actually in comparison to the placebo, EMPA is the green one is the EMPA, there is significant improvement is there with empagliflozin. And again, when we have discussed already EMPA-REG has clearly shown that in the overall study population, there is 38% relative reduction. And if we take the ASEAN subset, probably there is further reduction up to 56%. That is the advantage, and that is the benefit. Probably not only we respond better, or also the benefit from the empagliflozin is far better in Asian population in comparison to the Western population. Again, this is the empagliflozin from the SCBD point of view, measure CV events, myocardial infections and myocardial infection or coronary revascularization, all actually favoring empagliflozin in comparison to the placebo, and that again shows there is a 21% risk reduction of the myocardial events with empagliflozin in comparison to the placebo group. So, in addition to particularly blood glucose control, when we are using this empagliflozin in 100 patients for 3 years, probably we are reducing 9.8 CV events, we are 8.5 CKD events is prevented, 3.4 acute kidney injury cases are prevented, 12.9 people who requires insulin can be prevented, or insulination can be prevented in 2.9 patients, and that is 5.1 additional systolic BP goal is achieved. 5.5 patients with edema and new obstetric sleep apnea patients are prevented, and also 3.4 total additional life years are gained when this EMPA is used in 100 patients up to 3 years. So, empagliflozin demonstrates a meaningful heart failure benefits in patients across CV momentum, whether you take low to medium risk CV patients, ASCVD without prior CV events, ASCVD with prior CV events, with preserved ejection fraction, with reduced ejection fraction, everywhere empagliflozin has significant benefit in comparison to the placebo group. So, across the group, anywhere, whether it is normal or having reduced, everywhere actually empagliflozin has significant benefit from the placebo point of view. So, this is the ADA standard care. Actually, we have discussed a lot of time. There is no need to discuss that part. Probably after lifestyle, if any sort of specific comorbidities or any sort of cardiovascular risk factor is there, probably SGLT2 and GLP-1 receptors are the two drugs which has been actually advocated, and we know that part. There is no need to discuss that part. Again, if you will see SGLT2, then CV events all from the EMPA, CANA, ASCVD parts, from the heart failure point of view all, and from the progression of DKD point of view all, EMPA, DAPA, CANA, everything gives benefits from the particularly benefit point of view. So, if you will see the empowering the risk factor controls and target organ protection with SGLT2 in people of type 2 diabetes, if you will see the risk factor control, probably there is effective across any HbA1c we are starting, there is low risk of hypoglycemia, there is long-term durable HbA1c control, improves in TIR, reduces adiposity inflammation, improves blood pressure, and also improves insulin sensitivity. And from the target organ protection point of view, it improves cellular energy metabolism, reduces the risk of major CV events, reduces the risk of CV death, heart failure, reduces the risk of kidney disease, also the reduces hepatic fat and NAFLD outcome. Thank you.
Thanks, Professor Sahu, for nice deliberation. Now I invite one or two questions because already we are running late.
Morning that it protects the kidney. What about the liver? About dapagliflozin?
No, actually, from the liver point of view, there is also study from the dapagliflozin that also reduces NAFLD. Here, actually, I am not comparing EMPA, DAPA, CANA in this thing, so that's why we discussed about EMPA. But this is a out of thing, whether it is, there is actually with canagliflozin, actually, I am not recollecting whether any NAFLD data is there or not, but with dapagliflozin, there is a study where actually they have shown there is significant improvement with NAFLD with use of dapagliflozin. Also again, there is one study with dapagliflozin which has shown use of dapagliflozin has improved significantly the anemia in CKD patients. Anemia, there is significant improvement in anemia in CKD patients. They have not, even if they have not, in both the groups, the iron required intake is same. But despite of that, actually in the DAPA group, the number of people having actually requiring additional therapy, iron therapy or requiring particularly recombinant erythropoietin is significantly less in comparison to the other group. That is DAPA study with dapagliflozin.
You see, from this data, it appears they have done liver biopsy. They have done liver biopsy proof.
Yeah, they have taken in the EMPA study, they have DAPA study, they have a small group of patients, but they have taken liver biopsy.
Dapagliflozin also they have done
Liver biopsy. Yeah, absolutely.
ELIP study that is the first in the world in Indian patients that has reduced the liver fat, and no such trial has been done with any other HTT.
No, dapagliflozin has this trial, but with NAFLD, dapagliflozin has a clear-cut trial, dedicated trial with NAFLD to see NAFLD. But this is the, for NAFLD, first trial come from the empagliflozin. But dapagliflozin has a trial is there.
I have one question actually. Is there an incidence of urinary tract infection and ketoacidosis with
No,
SGLT?
ketosis, that is actually theoretical risk. Actually, we have not seen a case of ketoacidosis with use of particularly any sort of glyphosins, not only EMPA. But UTIs and vulvovaginitis or balanoposthitis is quite common. Everybody might have faced in the clinical practice. That is quite common in whatever you use, EMPA, CANA, DAPA, everything, that is quite common.
Help. For the elaborate discussion on SGLT inhibitor, so we'll wind up this session.
One question, Sri one question, please. You are telling that SGLT2 inhibitors, particularly DAPA or CANA or EMPA, they have effect on both major and minor vasculature. So, is there in study they are effect in male sexual dysfunction, particularly is there improvement in the endothelial nitroxy synthase or inducible nitroxy synthase, which is responsible for, which depression is responsible for male sexual dysfunction. Is there in study like that?
No, that's something. Whatever the pathophysiology has been discussed, it should improve. But actually, there is no studies which have a dedicated trial which has been done for specifically to see the sexual function in with particularly any sort of SGLT2 inhibitors. So again, it is very difficult to tell for that point of view.
Thank you.
Heart failure and the cardiovascular mortality risk reduction. Doesn't have any effect on the, not like GLP-1 receptor agonist. Empagliflozin is primarily function reducing the heart failure. Because the basic is mechanism like a diuretic, so it's a basic effect on the heart failure. Doesn't have any effect on the atherosclerotic process itself, vascular process itself.
It is indicated for atherosclerotic cardiovascular disease.
No,
to prevent primary and secondary both.
It's the outcome. You just
yes.
subanalyze the outcome is all cardiac benefit. It's primarily driven by the cardiovascular mortality because its hazard ratio is 0.62 and heart failure. So overall, it's shown that the 3-point MACE is improved. That has been with all the glyphosate.
Again, heart failure also microvascular, macrovascular.
That do you accept? This is going micro way. But overall on the atherosclerotic process, coronary vascular disease doesn't have any role.
Thank you.
So we will end this session. Okay. Thank you.
Thank you, sir. I request the chairpersons and the speaker to please proceed to the presentation area. Coming to the next talk, I'd like to request our chairpersons, Dr. Shubhranshu Patra, Professor, Department of Medicine, KIMS Bhubaneswar, Dr. R.N. Kaur, Senior Consultant Physician of Talcher and Bhubaneswar, and Dr. Vijay Ketan Das, Senior Consultant Physician, Bhubaneswar.
Welcome all of you to this session
As you all of you know that we have already discussed from the morning, diabetic is a polymetabolic disorder, and the ominous octet which has been talked decades back has already been extended to a lot of other factors. So multiple factors are now required. It is not only the glycemic-centric treatment, but beyond that much more is required for diabetic control, because of the organ protection is required and control of diabetics, sugar is required, and with the lipid control also is required. So we do not have a single molecule to target all the factors that creates problem in diabetics. So to talk about this particular aspect is Dr. Santosh Ramakrishnan will be talking on that. I will request my co-chair to introduce Dr. Santosh Ramakrishnan. Welcome Dr. Santosh Ramakrishnan. Please come to the dais. He has already been introduced in his previous talk, so no more introduction. Directly, please go to your topic.
So, good evening, and sorry to be back again so early on the stage. Please bear with my voice once again. So, I'll be speaking on the multifactorial approach to type 2 diabetes management, and I'm going to specifically be speaking about the once weekly GLP-1 receptor agonist that's available in India, that is dulaglutide. Now, just now the chairpersons have spoken about this. We need to go much beyond the HbA1c to manage the complications in type 2 diabetes mellitus. In type 2 diabetes mellitus, we know that the cardiovascular risk is high. The cardiovascular risk begins at the stage of pre-diabetes only. In fact, when the patient is getting converted from pre-diabetes to diabetes, already the cardiovascular risk is double of what it should be when the person is normal. And as the duration of diabetes progresses, the cardiovascular risk increases exponentially. And therefore, as an endocrinologist or a diabetologist, we should no longer be seen as sugar managers. Okay, we should be looking at number one, we should be able to control the blood glucose properly to prevent the microvascular complications, which are so nicely seen by the UKPDS trial. But we should do our best to prevent the cardiovascular mortality and morbidity that is also increased in this particular group of patients by addressing all the risk factors. Now, how do you address the risk factor, cardiovascular risk? So cardiovascular risk is mainly what we can do in our clinics is obviously we are going to talk about diet, we are going to ask them to stop smoking and exercise regularly, but there are 3 clinical parameters that we need to address very tightly. One is the blood pressure. So if you are able to bring down the systolic blood pressure by 4 millimeters Hg also, we are able to bring down the cardiovascular risk significantly. LDL cholesterol is something that we should be targeting, and if you are able to bring down the LDL cholesterol, we will be able to improve the cardiovascular risk. Obviously, triglyceride improvement and HDL improvement also play a very important role. A reduction of HbA1c will also improve the cardiovascular risk. So as I said, as an endocrinologist, diabetologist, we need to manage the sugar, BP and cholesterol very well to prevent the cardiovascular risk in the future. The STENO-2 trial, it is one of my favorite trials. So it has been done in such a small number of patients, okay? So they have done only 40 to 50 patients they have done. But these people, they have followed up these patients very nicely. So in this group of patients, they have, number one, asked them to follow a healthy lifestyle. They have given them a diet pattern. They have asked them to exercise regularly. They have asked them to stop smoking. They have asked them to get the HbA1c under control. I mean, the investigators have controlled the HbA1c. Blood pressure control was done nicely. Lipid control was done nicely. And all of them were put on antiplatelets. So in a very small cohort, but they followed them up for a long period of time and so showed that those people who were in this active phase, that means all the things were controlled very nicely, the cardiovascular risk came down significantly. So you have very few trials which will show such significant drop in the cardiovascular risk as it is the STENO-2 trial, and that is our logical thing that we need to do. We need to control all the risk factors at the same time. So as the respected chairperson was speaking, do we have any molecule that can actually address all of them? So we are going to talk about a certain group of molecules, that is the GLP-1 receptor agonists. Yes, so GLP-1 receptor agonist, it has not only effects on certain organs of the body that we know of since the last 14 to 15 years, we have come to know more and more about the pleiotropic benefits of GLP-1 receptor agonist. The GLP-1 receptor agonists primarily act on the pancreas, where they cause beta cell proliferation, they prevent the apoptosis and cause glucose-dependent insulin secretion from the beta cell. They obviously act on the alpha cell and shut down the glucagon production. This helps in controlling the hepatic glucose output, but the most importantly is they also go to the stomach and reduce the gastric emptying, leading to increased satiety, and also go to the brain to cause increased satiety from there as well. But many pleiotropic benefits have now come up with GLP-1 receptor agonist at the level of the gut, at the level of the endothelium, at the level of the adipose tissue, at the level of brain. Everywhere the GLP-1 receptor agonists have shown to improve the cardiovascular risk factors and atherosclerosis. As Dr. Jaya Banu was telling, GLP-1 receptor agonists, they are seeming to have much more effect on the pathophysiology of atherosclerotic vascular disease rather than the SGLT2 inhibitors. SGLT2 inhibitors do have effects on the atherosclerosis, but GLP-1 receptor agonists, they seem to have a much larger effect on the atherosclerotic pathophysiology as compared to the SGLT2 inhibitors. So much has been spoken about these two class of molecules is that the latest ADA 2022 guidelines, they very specifically say that if the patient is having atherosclerotic cardiovascular disease or the patient is having high risk factors for atherosclerotic cardiovascular disease, you must initiate either GLP-1 receptor agonist with proven cardiovascular benefit or SGLT2 inhibitor with cardiovascular benefit, irrespective of what the baseline HbA1c is. So for example, if the patient is taking metformin and his HbA1c is 6.9%, if the patient is having atherosclerotic cardiovascular disease or risk for cardiovascular disease, you can add a GLP-1 receptor agonist. Initially, as a group of endocrinologists, diabetologists, we used to take this as a pinch of salt. If the HbA1c is already 6.9, why we should add another agent? But nowadays, slowly, even in our routine clinical practice, we are now started to do that. Even if the HbA1c is normal, if the patient is having cardiovascular disease, we either add an SGLT2 inhibitor or GLP-1 receptor agonist, because in combination with metformin, GLP-1 agonist plus metformin will not cause hypoglycemia. So even if the HbA1c comes to 6.1, 6.2, the patient will not go into hypoglycemia because of the mechanism of actions. The ADA 2022 go one step ahead and they said that the first injectable possibly for all patients, you should try to give GLP-1 receptor agonist only. Obviously, if the patient is having catabolic symptoms, the patient is having a very high HbA1c, patients having polyuria, polydipsia, and so many other symptoms, you have to start insulin only. Insulin cannot be substituted in those group of patients. But at least if you are going to consider the other group of patients who don't have this particular status, probably GLP-1 receptor agonist can be initiated as the first injectable rather than insulin because of its cardiovascular benefits and pleiotropic effects. So if you cut down the chase and now we speak about the molecule in question, that is once weekly dulaglutide in the multifactorial approach to type 2 diabetes. Obviously, as again, the endos and diabetologists, what are we most worried about? Sugar control. So does this molecule control the blood sugar or no? Very well it controls. So dulaglutide helps in control of blood glucose very well. Even in the clinical trials, dulaglutide 1.5 milligram is shown to be equal to liraglutide 1.8 milligram. So liraglutide we use 1.2 milligram in most of our patients, but dulaglutide is shown to be equal to 1.8 milligram of liraglutide as well. If you compare only with insulin, glargine, we know that glargine obviously controls the fasting blood sugar and does not have so much effect on postprandial. Dulaglutide seems to be superior. But if you compare it with a basal bolus regimen, dulaglutide is almost equal to a basal bolus regimen in controlling the HbA1c. As with all GLP-1 receptor agonists, weight loss is something that is of important parameter that we see. With dulaglutide, people say people don't lose much weight. Well, it varies actually. So in our clinical practice also, we do see some patients who don't lose any weight with any GLP-1 receptor agonist. But there are some patients with dulaglutide also who end up losing 7 to 10 kgs of body weight. They are called super responders. So not everybody will be this side, not everybody will be that side. On an average with GLP-1 receptor agonist and especially dulaglutide, people do lose around 5 to 6 kilograms easily. If you compare it with insulin, obviously insulin will cause weight gain and GLP-1 receptors will cause weight loss. If you compare with liraglutide 1.8 mg, yes, it is dulaglutide is a little bit inferior. it causes around almost 700 grams to 1 kg lesser as compared to liraglutide 1.8. But liraglutide 1.8 is much more costlier than dulaglutide 1.5. Liraglutide 1.2 is something that is equivalent in cost to dulaglutide 1.5. Now, if you look at the different cardiovascular outcomes trials of GLP-1 receptor agonists, now it has been, we all know without doubt that GLP-1 receptor agonists are now cardiovascular superior, especially if they are used for a long period of time, because they reduce the atherosclerosis. Dr. Kanwar is back here. They reduce the atherosclerosis. So we don't see immediate change in the mortality like with SGLT2 inhibitors, because they affect the hemodynamics more, SGLT2. But if you are giving GLP-1 receptor agonists for a long time, you will see definite superior results with GLP-1 receptor agonists. So this, when I tell my patients also, I tell that only. Those people who are using this particular group of medicines are living longer because they are having fewer heart-related problems, fewer kidney-related problems. All the different trials have been designed in their own specific way, but I would like to talk mainly about the REWIND trial. REWIND trial is a very good trial because the patient population which they have selected in this group is almost same as what we see in our day-to-day practice. In our day-to-day practice, we see around 30% of patients who are having cardiovascular problems already, and around 70% are those who are yet to develop a cardiovascular problem. They have multiple risk factors. So other trials, if you see, they have done the opposite. They have checked for secondary prevention, whereas the GLP-1 REWIND has tried for primary prevention as well as secondary prevention in the ratio that we usually see in our clinical practice. They have more number of women in their trial. So diabetes, as we know, affects both women and men. The other trials have mainly been done on men only. And the mean follow-up has been very long. For 5.5 years, this particular CVOT trial was done. This helps us to know more about the agent because it's been tried for such a long time. If you see the different CVOTs of GLP-1 receptor agonist, in our country what is available, liraglutide is available, semaglutide oral is available, Sustain 6 is with injectable semaglutide. But it's good to know that semaglutide and liraglutide both help in reduction of cardiovascular disease. But what is important to notice that even dulaglutide is able to reduce the cardiovascular disease to the tune of 12%. So if you see 12%, it's very less as compared to what semaglutide is showing, is it not? 26% with semaglutide, it's only 12% with dulaglutide. Why? Because of what I told before. This particular study, there are a lot of patients who don't have cardiovascular disease. So this is almost like a primary prevention study. And therefore, to see a huge difference between one group and another group, it will take years actually. It will take 5 years, 6 years, 7 years, 8 years also. So therefore, the findings of the REWIND trial are very important because even in a primary care setting, we are able to see that, primary prevention setting, we are able to see that GLP-1 receptor agonists are helping in preventing atherosclerotic cardiovascular disease. It is the only GLP-1 receptor agonist to demonstrate both primary and secondary prevention of cardiovascular disease in type 2 diabetes patients as shown in this particular graph. And if you're following some people for 5 years on GLP-1 receptor agonist, it's very, very good because we can actually study their adverse events also for a very long time. There were no cases of malignancies that were reported, no hepatic events, no renal or urinary events that were significantly higher than placebo that were reported. This GI events obviously were much higher in those people who were using dulaglutide, but serious GI events were not higher than those who were not using dulaglutide. Hypoglycemia also was actually lesser than placebo. The secondary outcomes with dulaglutide, as I told, it helps, it has certain pleiotropic benefits. It helps in reducing the LDL cholesterol by 1.9 milligram per deciliter. Systolic BP also comes down, and heart rate is a little bit higher with dulaglutide as compared to not having dulaglutide. Microvascular composite outcome can also be studied. Now, for 5 years, you're giving one particular molecule. We can see its effect on the development of retinopathy and development of kidney problems. And dulaglutide showed very clearly that even microvascular complications were definitely impacted by the use of GLP-1 receptor agonist in a very positive manner as compared to those who are not using it. What about the ease of administration with dulaglutide? Obviously, if you take a once weekly injection and you compare it with a once daily injection, the patient will definitely prefer the once weekly injection only. Now the main comparison comes about the oral GLP-1 and the weekly once injection agonist. Well, in my clinical practice, we obviously tell the patients about the once weekly injection and the oral GLP-1 receptor agonist. And if they go to the pharmacy and they learn about the once weekly injection, we have I can't say that all the patients, but significantly large number of patients, they come and say, instead of taking the tablet orally every day, I might as well take that weekly once injection only because it's very easy. So compared to the oral GLP-1 analogs also, there are some subgroup of patients who are preferring the once weekly injection rather than having to take a tablet every day and wait for half an hour after that. But you have to counsel about the GI side effects, because the GI side effects are one of the major things why people stop the GLP-1 receptor agonist. So unless you warn them before, it's very difficult. So in my clinical practice, I start by telling them only the first 2 weeks are going to be very difficult for you. So there are some practical tips that you need to follow. You please eat small meals, eat frequent meals, eat low-fat meals. Now, because if you eat more of fat, cheese, you eat a lot of butter and all that, what will happen is a lot of nausea will be there. So at least for the first 2 weeks, you eat very small and very frequent meals rather than eating the heavy meal. So in our country, we are used to putting roti, then dal, then chawal, then sabji, and then we eat kulfi also in the end of it. That much obviously nobody can eat when you are taking GLP-1 receptor agonist. You start eating lesser and lesser, and you will, for the first time in your life, you will start feeling full by eating very less also. So the patients actually view it as a positive thing that they are developing side effects in the first 2 weeks, and after first 2 weeks it goes away. So beyond glucose centricity, dulaglutide we don't give only for glucose control. We help in, it helps in those patients where weight gain is of a clinical concern, cardiovascular risk is of clinical concern, and we can give it for those patients who are having a very erratic lifestyle because it has to be taken only once in a week. So I'd like to conclude my talk by saying that now we need to move beyond the glycemic control to manage type 2 diabetes complications, and we must now use agents that have been proven cardiovascular benefit as compared to those who are only helping in reducing the blood glucose levels. Because if you are able to treat them early with such agents, we are not only going to prevent the microvascular complications, but macrovascular complications are also going to be prevented, which are very important in diabetes. Dulaglutide weekly once has a very robust cardiovascular outcome trial right now. It has been studied both as a primary prevention drug and a secondary prevention drug, and it has been studied for a very long period of time, showing that not only it's preventing cardiovascular illness, but it's also a very safe molecule to use in our clinical practice. That's all. Thanks.
Thank you, Dr. Santosh Ramakrishnan, for a very nice talk. I am having only just one doubt, that multifactorial approach is needed for type 2. So whether this drug will take care of antiplatelets or what? Or antiplatelet, the persons who are receiving this drug, whether antiplatelet is needed or not?
So for primary prevention, antiplatelets are still not been approved. Till the year 2009, we used to use antiplatelet for primary prevention of cardiovascular disease. But after 2009, the large aspirin-related data that came with which increases the GI hemorrhage and the cerebrovascular hemorrhage, we are not using aspirin for primary prevention. For secondary prevention, we are using.
My question is a little bit different, because multifactorial approach in type 2 diabetes mellitus, we have to take in consideration all 5 factors.
Yes.
But whether it has some effect.
So this particular molecule will not have effect on platelet management. Yes.
Thank you for a nice talk. Now we'll invite only 1 or 2 questions from the audience side. Yeah.
Thank you for such a wonderful talk. Thanks. Because this rewind trial really a trial which has got many pleural effects. Beyond this, what you have also described, there are many exploratory analyses of rewind trial. So that has shown beyond that is one is cognitive dysfunction. So it improves cognitive dysfunction, one exploratory trial. There is one stroke. It is also improves and reduces and stroke. There is also the last one is the erectile dysfunction. So it has also shown to be improved erectile dysfunction. So these are the many exploratory analyses of rewind trial that has shown many pleiotropic actions. I will ask one question. What about the, you have shown here the 1.5 milligram, but the 3 milligram and 4.2 milligram has also been US FDA approved of dulaglutide, and that has also been more effective, and also reduction of weight is also more. So what is your comment on that, number one? Number two, do you feel, because we have been using this in GLP-1 receptor agonist, but all the patients, they do not behave equally. in some cases, the weight reduction is very fast. In some patients, there is very minimal weight reduction. Patients are not satisfied. So what is your comment on that also?
So whatever I'm saying is going to be off-label because in India, dulaglutide is only 1.5 mg is approved. We can't use higher doses. But there have been studies with 3 mg of dulaglutide which has been shown very good effects as far as weight loss is concerned. So we are able to document larger weight loss but not superior glycemic control with 3 mg dulaglutide, which is approved in other countries. In India, it's not approved. Second thing, as sir said very clearly, there are some patients who respond very well. There are some patients who just don't respond. Usually the patients who don't respond are those people who are used to eating very high calorie foods in small contents. Now, for example, if a patient starts eating high fiber diet, for example, if he starts eating his meal with a salad or with a fruit, with the salad itself, the satiety will build in. If he directly starts eating rice with curd, for example, rice with curd, small quantity also will have high calories. And because basically these are not appetite suppressants, they are only helping us to reduce the increase the satiety, fullness of the stomach. So I try to encourage the patients by eating salads before they eat the meal, because when they eat the salads, they will feel very full with the salad only, and therefore they will end up responding better than those people who directly start with the main course, that is with rice or roti or anything like that. But besides that, sir, I will be unable to answer your question. Why some people do not reduce weight, some people do reduce more weight.
Thank you, Santosh. I will have a few comments on that. First, diabetic is a pro-inflammatory and pro-coagulative disease. A lot of factor goes to the cardiovascular complications.
Correct.
We haven't yet proved actually GLP agonist does work for that way or not. The newer, most important and latest dual incretin agonist, tirzepatide, which is just in the market, which is once weekly. Well, they are working on this particular aspect. Well, this is much better than the earlier peptides, actually, semaglutide, and they have already proved it. But this particular aspect has not yet been proved by any of the trial. They are on trial on this thing. This is one point I would like to talk to. Second important thing I would like to recall, the toxicity of the GLP agonist, especially the GI. Now, you are already pointed out actually. Portion control is the only accepted norm globally now for that particular, and there is no other alternative available. Right. And third important thing I would like to tell you that while going to the GLP agonist and the other molecules, we should not forget the basic primary objective. We are having the approach to diabetic control. Structural nutritional management and physical activity should not be forgotten at any stage of management. That should be the first and continue, then the rest is over.
Correct.
Thank you.
We end this session.
Thank you, sir.
Thank you, sir. Please proceed to the presentation area. Now for the next topic, I would like to request our chairpersons, Dr. Bharat Panigrai sir, Senior Consultant in Medicine and Rheumatology, Care Hospital and L.V. Prasad Eye Institute, Bhubaneswar, and Dr. Manoranjan Behera, Professor, Department of Medicine, Bhimabhai Medical College, Bolangir.
Good evening, all. So, friends, you know that glycemic target or maintenance of glycemic target for all diabetic patients is a challenge for all physicians. There is always a debate regarding good glycemic control or tight glycemic control. Lot of papers are there regarding the adverse outcome out of hypoglycemic events. As per the CGMS norm, we know that the time in days should be around 70% of out of 24 hours, and only 5% or less than that is allotted for hypoglycemia. And you know that there are many symptoms, the neuroglycopenic symptoms, autonomic symptoms as regards to hypoglycemia, and that will be dealt by none other than Professor Jayant Kumar Panda. So you can start your topic, sir.
Thank
you.
you.
Professor and HOD, Department of Medicine, SC Medical College, Cuttack, and presently hold the position of Chairman, FA Odisha State Branch. Thank you, sir.
Thank you, Professor Manoranjan. Thank you, Professor Bharat Panigrahi. It's a pleasure this evening with you all. And the topic assigned to me is a very simple, at the same time, very complicated one. Because hypoglycemia is a topic which every diabetes patient, leave aside the consultants and practitioner, every diabetes patient need to understand. And what we are thinking that it's just a reeling of head, sweating and the palpitation which goes away with the glucose drinks is no more there. So many cardiovascular, hypoglycemia, unawareness and related complications have crept in, increasing the mortality, morbidity of the patient. This is the topic which, though simple, needs your active attention. I'll be very quick to shave some time because we are running late, and I'm sure we have an interesting session following. And in hypoglycemia, I'll be telling you in this order. First the definition, the burden, then the consequence and the pathophysiology, which is very interesting. You'll be love to know evidences from clinical trials, and finally the strategies to minimize. All of us know that severe hypoglycemia is a situation where you need somebody's assistance. Somebody need to give glucose, admit the patient, maybe administer glucagon, and when person himself cannot manage, it's severe. Documented hypoglycemia is when you have a report of less than 70 milligram per deciliter. Asymptomatic hypoglycemia is patient silently goes to hypoglycemia. I have already told about the unawareness. I'll tell more facts about that. Probable symptomatic hypoglycemia is another entity where the typical symptom of hypoglycemia are not accompanied by a plasma glucose determination. They maybe it shows high, but the situation is different. And pseudo hypoglycemia is there is symptom and the levels are more than 70, just the reverse. So I'll show you in a very compact diagram that when we reach 70, there is a alert value for the patients and the clinicians, and the autonomic symptoms usually not there. They are asymptomatic, requires rechecking and may require alteration in the insulin dose or the type. So this is the level 1. When it reaches 54, we tell it the severe hypoglycemia. It denotes impaired cognitive function, repeated episodes of reduced awareness and the predicted severe episodes, and the cardiac arrhythmias and the other things like clinically relevant and significant things happen. When it still comes down, when it's level 3, it's the clinical evaluation is mandatory, severe cognitive impairment, external assistance is required, and you need to intervene. Another data I want to put you before, nocturnal hypoglycemia. We have to be very serious regarding nocturnal hypoglycemia, because between 12 midnight to 6 AM in the morning, the patient is on rest, everybody is relaxing around, and this hypoglycemia can be fatal. And when you detect, all means should be done to prevent this hypoglycemia, which can be fatal for the patient. This is the EDU classification we have already discussed, less than 70, less than 54. And I am sure most of you will agree to me, in your clinical practice, the insulin-induced hypoglycemia is more than 50%. Every time you get a call, the doctor, I am having altered mentation, and patient becomes very sick, very serious about the episode. And doctor doesn't become serious because doctor knows blood sugar kam ho gaya hoga. But if you see the incidence, that also matches. In type 1, it's more than type 2, and it's almost 50% or little more. You can see the non-severe are 59.8% here in hypoglycemia 4 weeks after the baseline, and the data shows almost 50% or more people, they have presentation which is more than 50% patient have levels less than 70% or hypoglycemia. The relevance in this big study, the insulin with minimum risk of hypoglycemia will help reduce the hospital stay and mortality. So while choosing drugs, always put in your mind, when you are dealing with a frail patient, 80 years, and not taking food very regularly, maybe no caregivers, you have to be very conscious about preventing a hypoglycemia, then controlling the blood sugar very stringently. That is very important. And if you see the doctors, the patients, the diabetes consultant, the cardiologist, all they agree, had there been no fear of hypoglycemia, we would have treated the patient more freely. So after a attack, even patient doesn't listen you. You tell that take medicines regularly. They decrease the insulin dose themselves. They drop the medicines. Once they have a symptom or experience of hypoglycemia, they don't listen to you very carefully. And you know the direct cost and the indirect costs are very high, and what you see is just tip of the iceberg. And the pathophysiology is very interesting. Just I am touching upon the at the 4.6 millimole, it's just inhibition of endogenous insulin secretion. But when it comes down at 3.8, it's the counter-regulatory hormone glucagon and epinephrine. 3.2 to 2.8, it's autonomic and the neuroglycopenic symptoms. 3 to 2.4, it evoked responses, the neurophysiological dysfunction. At 3, it's widespread EEG changes. 2.8, it's cognitive dysfunction, inability to perform complex tasks, and less than 1.5, reduced conscious level, convulsion, coma, and death. And this is the nutshell, the sensor, the effector organ, the counter-regulatory hormone, and target organ. When there is hypoglycemia, the hypothalamus is affected, the brain is affected, and it leads to the increased glucagon and decreased insulin in pancreas, increased cortisol and increased epinephrine in adrenal gland. Finally, in the liver and muscle, there is increased glucose output and decreased glucose utilization. The vicious cycle, the repeated episode of hypoglycemia, this defective counter regulation, impaired awareness of hypoglycemia, and increased vulnerability to hypoglycemia. This I want to impress upon, that recurrent hypoglycemia can lead to hypoglycemia unawareness. So that is what known as HAF. You can see the pathway, the energy depletion and the metabolic stress leads to this sympathetic activation, and the hypoglycemia unawareness and the adenomedullary response. So this very clearly results in the subsequent hypoglycemia where the patient may not be able to detect he is hypoglycemic. So remember, hypoglycemia results when it's repeated hypoglycemia unawareness, and the unawareness results in a higher death, higher morbidity, and more severe hypoglycemia. You can see in this graph, and the rates are higher than the expected, and the prospective data suggest the higher than the previous observed rates of hypoglycemia both in type 1 type 2. You see this graph of type 1 retrospective, prospective, and type 2 retrospective and prospective, and type 1 prospective, it's almost 4.9. And this is what the consequences happen: cognitive dysfunction, impaired memory formation, seizure, coma, and fear of hypoglycemia, the myocardial infarction and cardiac arrhythmia, the falls, fractures, dislocations, and the driving accidents, the inflammation leading to the blood coagulation abnormality, hemodynamic changes, and endothelial dysfunction. What all we have seen in the COVID time occurs here. I'll show you in a picture. So what you see, it's just palpitation, sweating, and little dizziness of the head. It's not that. You see the problems like endothelial dysfunction, decreased vasodilatation, the increasing of the heart workload, increased contractility and output, it stays for 48 hours, but the neutrophil activation, platelet activation, and the factor 8 activation and the blood coagulation abnormality remains up to 7 days. So patient undergoes a hypercoagulable state after the episode of hypoglycemia. See the ECG changes. This is a normal ECG of healthy person. This is euglycemic hyperinsulinemia, and when there occurs hypoglycemia, the hypoglycemic hyperinsulinemia occurs. There occurs atrioventricular conduction defects, the ventricular and arterial repolarization, R wave amplification, T wave flattening, depression of the ST segment and prolongation of the QT interval leading to risk of cardiac arrhythmia. Many people die during this episode in nocturnal hypoglycemia, which is designated as dead in bed syndrome. So that's what the bradycardia, the arterial ectopic, the ventricular ectopic, and then you can see this dead in bed syndrome, that diabetics have parasympathetic autonomic neuropathy already existing, sympathetic autonomic neuropathy already existing, and the reduced awareness, it leads to QT dispersion, ventricular arrhythmias and sudden death. So it's a very common cause of dead in bed syndrome, and hypoglycemia is the event which triggers the death. So these all trials, I'm not going to the details in the interest of time, Accord, Advance, Examine, Origin, Leader, Devote, DECOS, VADT, all you know, all tells that severe hypoglycemia is an important cause of mortality, not only morbidity, mortality. And the total mortality, the cardiovascular mortality, the major cardiovascular events, all are high in patients who underweight repeated sessions of hypoglycemia. How to prevent? This all of you know. Just to put in your memory, the monitoring and the goal setting is important. Before you plan a prescription, talk about hypoglycemia to your patient. I practice that. First tell what can happen in the course of treatment. The self-monitoring of the blood glucose before meals, at bedtime, and during the suggestive symptoms. And 2 AM and 5 AM at least 3 times weekly initially you have to do to detect the nocturnal hypoglycemia, which many of us don't do. You have to individualize the glucose targets between 100 to 150 milligram per deciliter. As you know, very elderly patient, hypoglycemia prone patients, you have to fix separate targets. Patient education I had already talked. Dietary intervention is important. Adequate calorie intake is important. Before planning an exercise, the patient has to take adequate calorie, and the ready carbohydrates have to be ready. During the COVID time, I told all my patients, blood sugar may go beyond 200, not to worry. But if it's come down, please keep your calorie ready. Exercise counseling is very important because exercise is essential, but somebody should not go to hypoglycemia during exercise. And the medication adjustment should be guided to the patient or the paramedics. Every time patient cannot reach you because you are having so many barriers, but patient can decrease the insulin 2 units, 4 units. Your nurse can decrease the insulin and readjust the drug to avoid a episode of fatal hypoglycemia. This is the rule of 15 in nutshell. We treat with 15 to 20 gram of fast acting carbohydrate, wait for 15 minutes, see the level. If not corrected, we repeat again 15 grams after that. And if it's a severe, we can give glucagon subcutaneous, and we can call an ambulance and transfer the patient to the ward. Treatment we have already discussed. This is the summary of what I told: 15, 15, 15. 15 gram of the carbohydrate, wait for 15 minutes, and then repeat the 15 grams. And the subcutaneous glucagon, you never forget. Anybody who is not responding adequately, going to severe hypoglycemia, we have to administer this. All guidelines, the Endocrine Society 2009, the CDA 2013, the Canadian Diabetic Association, all the guidelines tell that. So the consequences of hypoglycemia are a considerable burden on both patients and society. Hypoglycemia events can have far-reaching consequences, as I have shown: the cardiovascular, the neurological, the cognitive, even the dead and bed syndrome. The pathophysiological mechanism of hypoglycemia may explain the association of cardiovascular involvement in the form of hypercoagulability, and the clinical evidence result showed severe hypoglycemia is associated with increased CV death and all-cause mortality. So this is the time we have to be very conscious in the patients who are more liable to develop hypoglycemia. So remember, every new patient you are talking, they should have a guidance how to manage themselves, and tell them about the problem before you talk them about the drugs. And it's not simple symptoms and few grams of glucose. It's a cardiovascular, it's a neurological, it's a morbidity, hypercoagulability, including resulting in the death. So hopefully in our practice we can incorporate, prevent most of the episode, and empower our patients and the paramedicals to just avoid such a incidents and give our patient a better health security for good treatment. Thanks again the team, especially my good friend Sambit, and hopefully Odisha will excel in the field of diabetes and metabolic medicine with so many such good educative programs in the future days. Thank you all.
Thank you, Professor Jant. So, achieving the target is definitely desirable, but side by side also we should be very much aware of the preventing hypoglycemia. So I think it is a awareness both the treating physician as well as the patient, both it is necessary. One thing I want to just ask you, it's okay in a country like India and also in the remote areas where a patient of severe hypoglycemia, where we don't have a glucagon not being used, and there is no facility of IV glucose, giving IV glucose. So in that situation, how can we save the patient? Because you see, brain cells need glucose very badly. So as you delay, there is more and more brain cell dysfunction. So you tell, what are the methods, what maneuver we can take in a remote area where nothing is available? How to improve this?
It's a very relevant question, sir. Actually, we know there are places where 25% dextrose, 50% dextrose or subcutaneous glucagon is a dream. But we can educate the patient that before patient goes to severe hypoglycemia, they can be very alert and give glucose supplement. In worst case, when I was working a remote periphery, I was putting a RALS tube and giving glucose through RALS tube to the patient who had cognitive impairment. And on a priority basis, I think there are many policy makers and the people who are working with the government can suggest that even a primary healthcare center should be equipped with the management of hypoglycemia, because like we keep different kits. The testing of the blood glucose can be done with a simple glucometer, and the glucagon kit or a 25% dextrose, it's not impossible to keep it available, and even a quack gives a IV injection at present. So this has to be there in our planning, in our mind to avoid, but we have to teach patient to detect it in time and try to avoid.
Manojan, you will comment.
In your slide, you have shown that hypoglycemia also promotes inflammation. We are discussing. We know that obesity or hyperglycemia is a chronic state. It causes inflammation. But hypoglycemia is acute episode, or recurrent hypoglycemia can also be acute episodes. How it causes inflammation? You know one of your slide. Both thrombotic state as well.
Yeah. Till that's what I impressed upon. Till recently, you had idea that the diabetes is a pro-inflammatory state and the obesity is a pro-inflammatory state. But after every episode of hypoglycemia, what I showed, for 48 hours, the problems are related to the cardiovascular risk, and for 7 days, all the pictures that we show increase the markers, and then the neutrophilic activation, different mediators are raised, and the endothelium is in a very high inflammable state. That has been published and proved beyond doubt, and that is the cause of the incidents, maybe a cardiovascular, maybe CNS, maybe hematological, following an episode of hypoglycemia. So we have to go beyond, not that only correction of the blood glucose, but prevention is more important than the treatment. That we have to keep in our mind.
Thank you, sir. Because of paucity of time, we are winding up this session. Thank you all.
Thank you.
Thank you, sir. For the next session, I would like to request our chairpersons, Dr. S.N. Swain, Associate Professor of Medicine, IMS and SAM Hospital, and Senior Consultant Physician, Amri Hospital, and Dr. J. Kishore, Senior Consultant Diabetologist, Ashok Diagnostic Center, Bhubaneswar. I think Dr. Kishore is not here, so Dr. Swain will only chair the session.
Thank you, Dr. Sambit, for his endeavor and the EDU 2022. Now, the topic, achieving treatment goals in type 2 diabetes mellitus, making the most innovation with insulin. Insulin, you know, is very important for insulin because for diabetes control, insulin is required, and early insulin in the armamentarium of the treatment of diabetes will prevent the beta cell destruction, preserve the beta cell mass, and they produce the glycemic memory, metabolic memory, and the legacy effect, and to reduce the forthcoming complications. So insulin is the best. As early as possible, you must institute. And for today's Dr. Devamalya Shanyal is invited to the dais. He is a professor, Department of Endocrinology, KPC Medical College, Jadavpur, Kolkata, and he is earlier speaker, so I am not delaying the matter because everybody is wanting to finish up early. So, Dr. Sanyal.
Thank you, sir. And I would again like to thank Shambit for the kind invitation and an excellent meeting. So we have heard excellent talk from Jayant sir with regards to hypoglycemia, and in all diabetes patients obviously we would like to avoid hypoglycemia, but at the same time we would like to achieve goals. So basically the modernization of insulin is with two targets, because all insulins have similar efficacy in terms of glucose lowering and HbA1c. But the impediment with regards to getting to target, as we have seen from the previous speaker, is hypoglycemia. And one episode of hypoglycemia can scare the patients, and especially at insulin initiation, this can have devastating effect. Patients will never up titrate their dose of insulin, and they will down titrate, and they will never reach the targets. So if we are already aware of the huge amount of patients worldwide and a significant increase, and especially in India, not only we have a huge burden of type 2 diabetes patients, nearly 74 million, out of which nearly 50% are undiagnosed, and which accounts for about 6 lakhs deaths. But we also, something which is never stressed, is the fact that we also have the highest number of type 1 diabetes subjects in the world. It's not a, it's percentage wise it may not be highest, but by sheer numbers the number of type 1 diabetes is also highest in the world. And probably we are seeing a increase in the number of type 1 diabetes over the last few years, as well as with regards to this COVID times, probably this may also have an additional etiology, we don't know really. So if you look at the control, the HbA1c achievement, the target achievement of less than 7%, hardly 20% achieve target, and nearly 80% is uncontrolled. And this is quite similar across the world. Even in US, they are not doing really well. It's about 30 to 35% in US. And if you see, with regards to insulin initiation, generally several studies have shown we require probably by 7 to 10 years we would require insulin. But if you see out here, most people are not on insulin even after 15 years. Even after 15 years, only 25% are on insulin. So we are delaying insulin by a mean of about 8 to 9 years. We are starting insulin when the HbA1c is around 9% or even higher, when it should be started when the glucose is not controlled
with any oral hypoglycemic agents, at least 3 optimum oral hypoglycemic agents. It has been seen that after 3 oral tablets, if you give a 4th additional tablets, there is hardly any improvement in HbA1c by 0.3 percentage or 0.4 percentage. So here is the time when you should appropriately start insulin, when your glucose is not controlled with 3 oral agents. With regards to efficacy, there is no denying the fact, even in the era of GLP-1 group of drugs, which has a very good efficacy, but still insulin has unlimited HbA1c lowering capacity. This is one agent where whatever be the glucose, whatever be the HbA1c, even if we see patients sometimes, at least couple of patients in a month who have HbA1c in 15 and 16 or 17 as well, and their HbA1c can be dropped down to 7 with insulin, less than 7. So it can lower HbA1c even by 10%. So we need to overcome the barriers of using insulin therapy. So this is one of my patients, which is very common, a corporate patients, executive, who generally lives early in the morning, erratic lifestyle with a heavy breakfast, and obviously he is obese, already on 3 medications, and his HbA1c is 9.9%. He is already having diabetes for about 8 years. His fasting glucose is around 248, and his post breakfast is 376. You can see the difference between fasting and postprandial is about 150. The post lunch is not significantly high. So there are few important takes out here from this patient. One is the early heavy breakfast he leaves, which is very common. Second is not only is having a fasting hyperglycemia in spite of 3 oral anti-diabetic agents, but the difference between fasting and postprandial is more than 50, and the highest peak is at breakfast. So these actually will lead us to selecting therapy. So in spite of 3 medications, if the HbA1c target is about 3% higher, so no medication can lower oral tablets, the 4th agent can never lower the HbA1c by more than 1%. Whether it is SGLT2 inhibitor, that also won't do that. So an oral tablet will not get us to target. Secondly, now you have an excellent article which was published a couple of years back in IJEM, Indian Journal of Endocrinology and Metabolism, which suggested that if the difference between fasting and postprandial glucose is more than 50 milligrams per DL, basal insulin will not get you to target. And unfortunately, across India, as I would be showing, our carbohydrate content is significantly higher. So most of the patients will have a significant postprandial spike. So in a lot of our patients, only a basal insulin will not be sufficient to getting us to target. Very importantly, if you see this patient, something we never do, whenever we look for PP, we tell our patients, do it after lunch. But mind you, this study showed that with the same amount of carbohydrate, the highest spike is after breakfast. The physiological explanation is simple. It is because of the counter-regulatory hormones, the cortisol and growth hormone which is raised in the morning, which is causing this spike after breakfast. And this is more so during pregnancy, where the spike is significantly higher. So post breakfast is something which we are again not monitoring, which has the highest glycemic excursion. So we have a high carbohydrate diet, high postprandial glucose, uncontrolled on multiple tablets. We go on for adding agent after agent, 4th agent and all, and we also require simplicity as well. So as you can see, the START study, which revealed that across India, the carbohydrate content in the diet is around 65 to 70%. And we also have a predominantly rice eating population, especially in the eastern part of the country, and we are more moving towards the refined rice, which also causes a significant amount of spike in the glucose as well. Very importantly, with the same identical food compared to Caucasians, the Asian Indians have a higher glycemic spike as well. So this is also very important. Our postprandial spike is also higher, and that is very important to remember. And this may be contributed. We have learned about higher insulin resistance in our population, but also there is an insulin secretory defect in our population, and that may be also responsible for the postprandial spike in glucose as well. Not only that, we are also aware of the Monius concept, where, you know, in the Western population, when the HbA1c is on the higher side, then it is primarily contributed by fasting glucose. When the HbA1c is below 8 or around 8 and below, then it's about 50% by postprandial glucose. But in our population, across the board, whether it is on the higher side or whether it is nearing our target, 50%, nearly 50% of our HbA1c is at least contributed by postprandial glucose. And we spent at least 60% of our time in postprandial state. That is also very important to remember. And if you look at it, that about 40% of our patients would achieve their target with a single basal insulin. 60% would not be controlled. And if we can get the postprandial glucose under control, nearly 90% would achieve their glycemic control. Even after initiating basal insulin, a significant proportion of them would have to be up titrated either by adding a bolus insulin or by shifting to premix or a co-formulation within a year's time to get to target. Something which we are lagging behind is titration and monitoring of insulin doses and glucose. That is very important, which we are again lagging behind. So if we look at the newer IDEG ASP formulation compared to the premixed insulin, the major physiological difference is that there is no shoulder effect with this IDEG ASP. So you have a separate basal peak, separate basal insulin throughout 24 hours, and you have the separate bolus peak as well, and there is no between meal hypoglycemia which is increased if you have the premixed insulin. So that is very important to remember with regards to physiological difference between these two groups of insulin. The shoulder effect is not there with this formulation. Again, if you look at the premixed insulin compared to this co-formulation with degludec as a long-acting insulin, it has a steady basal coverage with more than 24-hour duration of action. So there is persistent 24-hour coverage, and that helps in flexibility with regards to dosage as well. So as I was discussing with my patient profile, there is shifting because the meals are also shifted. They can have a heavy breakfast, or some days they may skip breakfast, take a lunch. So you can shift the insulin from morning to lunchtime, and that can also suffice. Because of the long-acting component, there is significant amount of flexibility as well. So if you look at comparison between IDEG ASP with the premixed bi-ASP, there is a lower risk of overall and nocturnal hypoglycemia and better fasting glucose control. Now, with this ultra long-acting profile of the background IDEG, that is degludec, the flexibility in dosing is also there. So if we have had several trials with this IDEG, so one of the studies compared which is better with regards to whether basal insulin glargine or a combination co-formulation IDEG ASP as an initiating therapy. As you can see, there was superior HbA1c reduction, better fasting, better postprandial glucose control, and similar fasting control with about 70% of basal component. And there was about 27% lower risk of hypoglycemia, which was though not statistically significant. So more number of patients would get to target with less amount of hypoglycemia. It doesn't mean we need to shift all our patients or start all our patients on IDEG ASP or this co-formulation. We need to select our patients. One of the guides could be that if you look at the fasting and the postprandial, if the difference is more than 50, then probably this co-formulation or a co-formulation where we have a basal and bolus component will be better efficacious in terms of getting us to target. So we have the recommendations from the RSSDI ESI, which also suggests that this can be one of the options when we are initiating insulin. And with regards to a real world study, it was seen a similar HbA1c control compared to global counterparts with similar significant reduction in fasting glucose, and especially those patients who were previously on basal insulin, once they were shifted, they were actually having a significant improvement in glycemic control, and the hypoglycemia episodes were significantly lower. So it can be, IDIC-ASP can be a simple solution with a start. If you choose your patients appropriately, you can start with a dose of 10 units, and based on your fasting glucose, you can actually get to target by titrating every 3 days or even once a week. This is specially suited for patients who, as I was suggesting in the case which I was discussing, patients who travel across time zones with significant differences in their timing of meal, shift workers, patients having hypoglycemic episodes, prior hypoglycemic episodes on premixed insulin, patients who are at a significant higher risk of hypoglycemia, like patients who have renal or hepatic dysfunction. And this is the way which, just like you titrate your basal insulin, you can titrate this based on your fasting glucose levels. And there was again, you can, with this same insulin, you can up titrate. This study compared the basal plus, that is glargine plus a bolus insulin, compared to this single daily combination of co-formulation, and there was a similar HbA1c control with similar insulin dose, somewhat less, about 10%, but with a significant lower risk of nocturnal hypoglycemia and with a single prick. It has been seen that number of pricks, increasing number of pricks, is associated with less adherence to therapy as well. So say 57% of insulin treated patients reported intentional insulin omission because of increasing number of pricks. So obviously, if the daily pricks increase, there is a significant non-adherence as well. So this is something we need to remember, because we are thinking that the patients are taking all the insulin shots, but a lot of them may be missing. We had one of the studies which we published a couple of years back, where in patients who presented with very high glucose at diagnosis of diabetes with an HbA1c of around more than 10 with osmotic symptoms, there we started insulin, and this was a real world study, and we found a significant improvement in their HbA1c within 3 months, and majority of the patients, almost 90% of the patients, were tapered off after 3 months with insulin, and the episodes of hypoglycemia were minimal. So there was only one single episode of hypoglycemia which was documented. So this insulin also is a valid option in recently detected uncontrolled diabetes patients who are symptomatic, having osmotic symptoms, having catabolic symptoms, with a very high HbA1c. Our mean HbA1c was around 12.9 in this study. Again, we had another abstract which was presented in IDF in 2019 with regards to insulin initiation, and we compared this with glargine U100 and glargine U300, and it was found, though we didn't find any difference in terms of hypoglycemia, but there was significantly better postprandial glucose control, better HbA1c reduction with similar fasting glucose control. So the efficacy was better, though there was no difference with regards to hypoglycemia per se, even compared to U300 as well. So if we have a brief recap, compared to as an initiating agent with regards to IDEC as compared to a basal insulin, superior HbA1c reduction, better postprandial control, lower, though not statistically significant, nocturnal and confirmed hypoglycemia. Compared to if we are switching from basal insulin to this molecule versus a basal plus therapy, that is 2 shots of insulin, there is similar HbA1c control, because all of these are treat to target trials. There is lower risk of hypoglycemia, about 45% lower risk of nocturnal hypoglycemia, and 12% lower dose as well. And again, if we are switching from a premixed insulin, that is premixed by ASP, to this molecule, there is better fasting control because you have degludec which controls the fasting better. There is lower risk of hypoglycemia and also nocturnal hypoglycemia with 10% lower dose, especially in patients who are having recurrent hypoglycemia, who are at a higher risk of hypoglycemia like elderly, CKD and CLD. This can be a valid option, especially in comparison to a premixed bias. And as I was saying, in special population like in elderly, in renal impairment and in hepatic impairment, this can be considered because there is no alteration in the pharmacokinetics in renal and hepatic impaired patients. So the key takeaway is that fact that we have, though we have a significant diversity in our country, there is still a unity in diversity with regards to high carbohydrate diet, high PPG level, uncontrolled on multiple OADs, and need for simplicity and convenience. So this co-formulation remains a significant option which addresses both fasting and postprandial, takes care of overall hyperglycemia with lower risk of hypoglycemia, and especially in patients who are high risk of hypoglycemia with CKD, CLD, as well as previous episodes of hypoglycemia, this can be a valid option which you can consider, and you can even consider at the start or diagnosis of diabetes in patients with significant symptomatic hyperglycemia. Thank you very much.
Thank you, Dr. Sanyal, for your excellent presentation. Now we are going late, therefore 1 to 2 questions I can, yes, Dr. Mahapatra.
Before breakfast and post breakfast, the plasma glucose should be more than 50 milligram. Then you can start this co-formula. Is it to take once or you have to take 3 times? Before breakfast, before lunch, after lunch, before dinner, after dinner, then you think of giving co-formulation or taking just one episode of blood sugar?
Well, there are 2 ways where you can select the studies. A lot of them have been done with the largest meal. Whichever is the largest meal. The other thing which you can do is the largest, you can check the postprandial spike. Whichever meal has the highest postprandial spike, you can choose that meal as well with regards to starting the therapy.
Any more questions?
So, lot of these patients who have had previous episodes of hypoglycemia especially, there we have shifted. So dose is almost similar with regards to that. The advantage is especially with regards to nocturnal hypoglycemia. This is one area where there can be a significant lower risk of nocturnal hypoglycemia, and that is an important advantage with regards to shifting. So in elderly patients, in patients who are a high risk, or especially those who have had previous hypoglycemia on premixed insulin, this remain a very valid option. No, we have a
prescribe Idegasp in newly diagnosed very high blood sugar level. Is there any contraindication, any adverse effect not using somebody newly detected with HbA1c of 12%?
So
what is the purpose of doing the study?
The reason is that one is we have some data with regards to basal insulin, because a lot of patients who present with symptomatic hyperglycemia, there we would like to, and there is recommendation as well, we generally it is recommended to start a basal insulin, especially to get the patient under control, and then most of these patients can be shifted back to oral tablets. There is a concept of giving the beta cell rest and regeneration, which can lead to temporary remission of diabetes as well. There is some data as well. Initially it was with regards to CSII, then there have been several studies with regards to Dr. Mohan's group, which has suggested a short term, even twice daily insulin use can lead to a significant amount of beta cell rest. So the basic intention was, because we have used basal insulin in these conditions, those patients who accept, especially who are symptomatic with very high glucose. But the problem is in a lot of patients there is a significant amount of postprandial hyperglycemia as well, and in this scenario most of the patients are not willing to take twice daily insulin, because the diagnosis very few people actually accept to take twice daily insulin. So with one shot, if you can address both the fasting and the postprandial glucose control, because we have a significant amount of postprandial hyperglycemia, we could get a lot of patients to under control. There were a few patients who required up titration to twice daily as well. But almost all of them could be weaned off insulin after 3 months, within 2 to 3 months.
That I do understand. The patient on multiple OADs and is shifting to insulin. I presume you did this study in newly detected diabetes.
Yes, in newly detected.
High uncontrolled blood sugar.
Yeah.
Normally you use premix insulin or any insulin or premix insulin. What is the reason of choosing particularly IDEGAS in these base population?
Because of the low risk of hypoglycemia. One of the major concerns with regards to insulin initiation is once they are initiated on any insulin, if there is a significant amount, if there is any episode of hypoglycemia, the patients are very reluctant to be on insulin. Most of them would discontinue insulin, and very few people would be agreeable to up titrate insulin to reach their target glycemic levels.
So if there is no questions, we are winding up the session with a big thanks to Dr. Sanyal.
Thank you.
Thank you, sir. At the end of this Novo Symposium, we will be giving all the mementos to the speakers and the chairpersons. So for the next session, may I invite the chairpersons, Dr. Chandan Das, Professor of Medicine, IMS and Sam Hospital, Bhubaneswar, and Dr. M.K. Chotrai, Senior Consultant Medicine, Apollo Hospital, Bhubaneswar.
A very good evening, everyone. After this wonderful talk by Dr. Sanyal on basal insulin and I think we will shift to another important topic, that is managing hyperglycemia when stakes are high, intricacies in IP hyperglycemia management. So basically we are going to discuss the various aspects of hospital management of diabetes, blood sugar management in hospitalized patients. You know, there are certain nuances in management of medical and surgical patients. In medical issues, surgical issues, I think they have different protocols. I mean, there are a lot of controversies, and what should be the goal in the issues, what should be the goal in the indoor patients and all. I think all these questions can have your answers in the upcoming talk. For that, I think Dr. Kalyan Kumar Gangopadhyay, sir, you introduce Dr. Gangopadhyay.
So it's a privilege to introduce Kalyan Kumar Gangopadhyay. He is a consultant endocrinologist in Birla Hospital and Peerless Hospital, Calcutta. He has worked in Birmingham, UK for 2 years, and he is principal investigator in several clinical trials. He has many prizes to his credit from UK, and he has got 20 international journal papers, publications in 20 international journals and 19 in national journals. Dr. Gangopadhyay, you can start your deliberations.
Thank you very much, Chairperson, sir. I'll just start the Thank you, Chairperson, sir. So, as has been alluded to, this is a very big area. So I can talk for 1 hour, 1.5 hours. So it will be whole day, whole night we'll spend here in patient management. So I'm going to just, in this 15-minute talk, I'm going to just talk on a few aspects. Now the topic is a bit misleading. So managing hyperglycemia when stakes are high, I think for inpatients stakes are always high. So there's nothing that stakes are high or stakes are low. Stakes are always high. So without delving much on the impact of blood sugar and mortality, length of stay, we all know that lower the blood sugar, closer to target, less is the length of stay, less is the mortality. Now, you have got data to suggest here, which you can see this was done in about 9 years ago, which suggested, you can see at the bottom here, there's no pointer, so I'm just going to use the cursor, so you might be able to see. Oh, no, you can't see. So, at the bottom you can see the standard deviation or the coefficient of variation. So, more the glycemic variability in inpatients I'm talking about, my talk will be focused entirely on inpatients. So, more the glycemic variability, more will be the length of stay, more chances of dying. So, we have to, our effort should be to reduce the glycemic variability, and very, very important for me at least is to reduce the hypoglycemia to the minimum. So, most of the problems occur with the hypoglycemia, and yes, of course, with some with hyperglycemia, the hypoglycemia I'm more scared of. So, less of variability. So, these are the roughly the targets. We all know about this. So, ICU, we roughly keep around 140 to 180. You have got some exceptions, which some are lower, some are higher. Fasting, we try and keep between 80 to 120, pre-meal less than 140, post-meal less than 180. Now, roughly for my patients, I keep it between 100 to 180, so roughly around that figure. So my talk is based on these two. So one is the Endocrine Society, which is a very exhaustive guidance on hyperglycemia management in patients, and I was one of the authors in the Indian version as well. So commonly used sliding scale insulin, I'll give an example for that as well. So that is a knee-jerk reaction. So prescribed mostly by the RMOs, the blood sugar is high, you give this much dose, blood sugar is normal, you don't give any dose. That leads to a roller coaster effect, so which we have to minimize. So we didn't have much data actually till about 10-15 years ago that basal bolus insulin in inpatients, we knew that this is going to work, but we didn't have any data to suggest that it will work. It's only in the last 10 to 15 years that data has come up. And you can see here, in here, I'm going to use my finger and you have to guess from here. The pointer starts working, please give me. So here, the dark colored ones are the ones where sliding scale is used, okay? Sorry, the dark colored ones is where the basal bolus is used. And the light colored circles are where the sliding scale is used. You can clearly see that with the sliding scale, the blood sugars are higher, and with the basal bolus is lower. On that side, in those patients in whom the blood sugars were really high on sliding scale, so you can see it's touching about 280. So there, it was changed straight away. It was changed straight away to basal bolus. So high sugars on sliding scale changed to basal bolus. Look, the nice decline in the blood sugar levels. So I'm just going to give you a simple hypothetical case. So 55-year-old type 2 diabetes, 5 years, creatinine 1.1, almost full dose of glimepiride, metformin, UTI, sepsis. However, the patient is eating. So we have to resist the temptation of giving IV insulin to everybody. That's not the right approach. If the patient is eating, is not septic, meaning not hemodynamically unstable, you can always give subcut insulin. Hemodynamically okay, blood sugar is 280, HbA1c not available yet, as typically occurs. So how are you going to manage? So first thing is decide on the total insulin dose the patient is going to need. That's the first thing, and this is where your experience comes into play. So first decide total insulin dose, then you go on to the basal and bolus component. So this is the typical example what happens in most of the hospitals. And mind you, this happens abroad as well. So the RMO writes this, the blood sugars between 100 to 140, no insulin, 2 units, 4 units, so on and so forth. So typically what happens, fasting sugar 110, so it's written here no insulin, so nothing is given. And before lunch is 301, so the phone calls start to come in, what to do? Then we give higher dose of insulin. And then it drops again, no insulin. So this roller coaster effect will continue. It is still happening in my hospital, still in spite of my best efforts. So you can see here, this roller coaster effect is there, and then you'll end up in hypoglycemia at some stage or the other. So, as I said, deciding on what dose to start on. So this would go to some extent in helping you. So roughly, you give about 0.4 to 0.5 units per kilogram per day. That's the total dose. So if it's underweight, older individuals, patients CKD, chronic liver disease, use a lower starting dose. Patients who are obese or on steroids use a much higher dose. But mind you, those who are already on insulin at home, you have got a platform already. So you can see how much of insulin they are getting at home, and then you can judge what is the total dose. Once you get the total dose, now the Western guidelines will tell you total dose, give 50% basal, 50% bolus. What do I use? I use 40% basal and 60% bolus. Why? Because for us, the postprandial increment is more as compared to the Western population. So 40% basal and 60% bolus. Of the 60%, you will see typically in inpatients, the after breakfast sugars tends to be higher. So I use more at breakfast, little less at lunch, and the lowest value for dinner. So frequency of monitoring. So I see varying prescriptions. Sometimes I see my juniors writing, check blood sugar fasting before breakfast, 2 hours after breakfast, 2 hours after lunch. So it is universally agreed that the sugar check should be fasting, before lunch, before dinner, and 11 p.m. or bedtime. Why not PP? Many times my patients ask me, so in the outpatients, you ask me about PP. Here, you are not checking the PP. PP never happens on time in hospitals. PP is start of your meal to 2 hours. The nurses don't know exactly when the patient is going to start the meal, so the PP reading is always erroneous. There's no point in doing the PP apart from selected few cases. So it's pre-meals only. If the patient is on RT feed or TPN, then you check it 4 to 6 hourly. So for this example which I gave you, I will make a rough guess and I will use say 0.5 units per kilogram. Why 0.5? Why not 0.45? Why not 0.55? I cannot answer that question. This is depending on your individual experience and a rough guidance. So use 0.5, so that amounts to 38 units. Of the 38, I'll use 16 as a long-acting insulin, and 8 breakfast, 8 lunch, or 6 dinner, and 6 dinner. So mind you, I use the higher doses before breakfast. Now, if on this regime the sugar level goes up, for that particular meal, you will use a correction dose. So this is not sliding scale, this is a correction dose. So this is the usual correction dose which I use. This is the usual, but I tend to use the insulin-sensitive correction dose. So suppose pre-meal, the blood sugar is 250, the pre-lunch sugar is 250, the lunch dose I will increase by 6 units, and I'll show you the example here. So for this patient, if I prescribe 12 units rapid before breakfast, 10 before lunch, 10 before dinner, and long-acting insulin 18, and the sugar level is 301 before lunch, so I will use, instead of 10, I will add, say, 8 units. So I will use 18 for this. The next day, I will increase the breakfast insulin dose to bring this under control. So for now, I will add 8 units to the dose. The next day, my prescription changes. This was 10 units, now this has become 18 units because the blood sugars were higher here, so instead of 12, I've used 18 units. Now, this is the data, and why I'm scared of the early morning hypoglycemia. This is data from UK, over lakhs of blood sugar, capillary blood sugar collection, not 100 or 1,000, lakhs. So what it showed here, so this one is blood sugar less than 70, and this is blood sugar less than 54, okay? So here, if you see, the maximum low sugar readings occur between midnight and 4 a.m. That's the worst time. Patients are sleeping, often that is misunderstood. Hypoglycemia, patient is going into coma, no, he is sleeping. The nurses are on duty, may have ill patients, so they will not concentrate on your patient if he appears to be inverted comma, sleeping. So my endeavor always is to prevent the hypoglycemia, particularly nocturnal hypoglycemia. If the hypoglycemia occurs during the daytime, there are lots of people around and you can treat it. At night time, I'm really scared. So my endeavor is always to reduce it. To that end, in patients, if I'm using a long-acting insulin like say Glargine, I will use it in the morning. I don't use it at bedtime. So in the morning, if I use, then there are studies to suggest that if you shift Glargine from bedtime to morning, you'll have less nocturnal hypoglycemia. So I use it in the morning. Maybe the fasting sugar might be a little bit high. I can deal with it. But I don't want early morning hypoglycemia. So I use it in the morning. If I use further better longer acting insulins, U300 or Degludec, I can use it anytime, but still I use it in the morning. So till now, there wasn't much data with Degludec as the basal insulin. Now this is coming up. So mind you, this is an observational data. This is not a randomized controlled trial. So patients who were put on a basal bolus insulin using Degludec, you can see at fourth day, the blood sugar has come down nicely and stays so at discharge. Average plasma glucose going down as well. So one of the criticisms of using Degludec is it takes about 3 days to reach its its plateau level. So the first day, you will get 70% of the glucose lowering, and third or fourth day, you'll get 100%. So I don't use it for every patient of my basal bolus. I use it for selected few patients. Who do I use? Those patients who are going to stay in a hospital for a longer period of 3 to 4 days. Suppose I'm starting somebody on IV insulin, and that patient is going to stay on IV insulin for at least 2 or 3 days. I start the Degludec then, so that by the end of third day, when I change to basal bolus, the maximum effect of Degludec is there. So I don't use for every day. Why use the Degludec at all then? Because of the low hypoglycemic potential. So here in this study also, the hypoglycemia incidence is very low. So better insulins, low hypoglycemia. Focus always on hypoglycemia. So in this study, you can see on admission, there was a wide range here outside the target, and after initiating basal bolus with Degludec, that tended to come down to tolerable levels. And you can see here the blood sugar levels less than 140, 140 to 180, and more than 180. So, however, I use the other rapid-acting insulin much, much more. So this, I had done this study in United Kingdom, wherein 2 groups of patients, I had divided the patients into 2 groups. One group, only the nursing staff will administer the insulin. Other group, patients will administer the insulin themselves. I wanted to see who gives the insulin on time. So I gave the patients time chart. I said, you write down what time you're starting your meal. And if the patient is injecting insulin himself, what time you have injected. And for the nursing, whenever they inject, they have to enter into the computer, so I get the time. So when I put them all together, I was surprised to find that when the hospital staff injected the insulin, it's a rapid-acting insulin, only 19% was delivered on time. This is second largest hospital in United Kingdom, University Hospital. And if the patient injected themselves, 80% was accurate. So this happens there, and I'm sure this happens here as well. So that is the problem. So if you use a soluble insulin, it should be injected 20 to 30 minutes before a meal. Almost always it never happens. It will happen just before, during, or after meal. So why not use an insulin? So that's an argument you can use. Why not use an insulin which you can use just before or during or just after an insulin? So with that in mind, keeping in mind that for us, our postprandial increments are much higher than the rest of the world, we need an insulin which works quickly. So to that effect, this is the usual insulin secretion from the normal pancreas. So this is the soluble insulin, used quite frequently. I still use it. This is the rapid acting insulin that we have, and this is the ultra fast insulin. So here you can see it is as close to the normal secretion as is possible. So this is very useful. So many of the patients have CKD, cannot eat on time, having sickness, vomiting. So I can safely say that give the insulin just after meal. If you say just after meal, I'm sure most of the time they will give it just after meal. Before meal doesn't happen all the time. So with the rapid acting, the FASP insulin here, fast acting insulin aspart, if you give it mealtime or post meal as opposed to insulin aspart, so the effect is roughly the same. So you can safely use it without incurring the PKPD suggests that it will not disrupt the pharmacokinetics and the pharmacodynamics. So here, particularly useful for elderly patients, those who are not eating well, renal failure patients, so I use in them quite frequently. So last couple of minutes, Chairperson, sir. So once the patient is on IV insulin, how to change it to subcut? So you start on IV insulin, then you want to change to subcut. First, the IV insulin, one or two nuances of the IV insulin. Many times I give IV insulin, the blood sugar doesn't come down. So this is just been published recently, just a month ago. So this is roughly the IV insulin guideline. There are multiple guidelines available all over the world, and there is really a dearth of evidence as to which one is better than the other. This we had come up to make it simple for the RMOs. So if you see here, bit less than 150, so towards 100, that's 1 unit. More than 150, that means towards 200, you use 2 units per hour. After 4 hours, sugar levels are not coming down, you add 1 unit to this. Not coming down, add 2 units to this. So that's keeping it simple. So this is one chart. This is the time of the day, and this is the amount of insulin given per hour. You can see here, the blood sugars are staying high all the time. Many times what happens is, you give the IV insulin, and sugars are high. If you inquire properly, they will find the patient had gone down for MRI, for endoscopy, for ultrasound, 4 hours, no insulin being given. Shift change, 3 hours, no insulin being given. All this happens all the time. So most of the time, I do end up giving a basal insulin when I'm starting IV insulin. So at least there will be some insulin on board. And this is ratified by the Joint British Society for inpatient diabetes, where they recommended that you give basal insulin in type 1 diabetes in DKA patients. So here, the next day, the blood sugars tended to get better when you start on the IV insulin. So transition to ward. So you calculate the total insulin given in 24 hours IV. So you calculate it, so 100 units in 24 hours. Now you give 80 units as subcut, not the 100 units. So 80 units, you divide it into 40% basal and 60% bolus. So suppose somebody is requiring 38 units 24 hours, you give either 19 units or say 16 units, and the rest you divide by 3. Commonly asked question, more often by the surgeons. 1 unit of insulin, how much of sugar will it reduce by? How do I know? Nobody on earth knows this. It is variable. For one person sitting here, it will be one amount, another person it will be another amount. So you cannot answer that. How much is 1 unit of insulin going to reduce the blood sugar? Still, so what my answer to the surgeons, if I tell like this, then they will say, you physicians always talk in riddles. So I say, you calculate yourself, 1700 divided by the total insulin requirement. If I say this, they will not say anything, go away. So this is for that, okay? So I think I'll have to end here because I'm running out of time. So inpatient, there are 1001 nuances, 1001 tips about inpatient diabetes, but as I said, it will require the whole of the afternoon or the evening. So inpatient diabetes is important but often neglected area. Basal bolus always preferred over sliding scale. Choosing the regime with the least hypoglycemic effect and least variability, that should be our aim. So with that, I end. Thank you.
Thank you, the honorable speaker. I think he has thrown a light on how to manage inpatient diabetic management in our hospitals. I think after RABBIT-2 trial, people have given up this sliding scale, and more and more people are now getting acquainted with the basal bolus therapy. What you've described in the entire talk is basically patients who are eating and we are conscious, but in many of our ICUs where patients are unconscious, we have stroke patients, and we give them feeding by Ryle's tube. So what should be the protocol in those kind of patients? What should be the duration of insulin therapy, and what should be the, are you going to divide it by major meal and minor meal, and accordingly you give insulins?
Okay, so I had the slides for them, but for lack of time I didn't go through it. So for patients who are on Ryle's tube feed, so divide into two, Ryle's tube and TPN, total parenteral nutrition. TPN is really difficult sometimes. You need really high sugar insulin levels. So for them, you give once a day once a day basal insulin, and you check the blood sugars every 4 to 6 hours. If it goes above your target, then you give correctional bolus doses. So for example, I give 20 units of basal insulin. I'm checking it every 6 hours. The third, 6th hour, it is 240. So I give, say, 6 units of bolus insulin. Next day, I will add that, and instead of 20, I'll use 26 units of basal insulin and check it 6 hourly. That's how I will proceed.
That's a very nice way. Any question from the audience?
Is it to be given same time just before meals, or aspart 15 minutes before meals and a Lispro just before meals?
So the product insert says you have to give it 5 minutes before meal. But both of them, both are similar. There's not much difference. You may give it just during meals as well, or just after. But if you look at the PKPD data, the best fit for this will be the fast-acting aspart, which I've just shown you the data.
Many of the times patient get admitted for surgery and taking some amount of insulin, and the outside report says it's reasonably okay. And after hospitalization, you find sugars are very high, maybe 400, 500 range. But the surgeon asks you to control the blood sugar in a day or 2 days time. Then how do you decide the dose?
Yes, as I said, there are so many aspects of inpatient, it will take me half a day to cover everything. So this is, as you have said, commonly asked. They think that we have a magic wand, we'll do like this, Yadu Mantar, and within 6 hours, everything will be under control. So if you have 2 days, 2 days is a luxury. So that's enough time, I think. So 2 days, what I do is, moment I see the patient, I give the basal insulin straight away. So if I see the patient at 10 a.m., I give it then and there. If I see at 2 p.m., I give it then and there. At least some insulin is there. And then I start the basal bolus insulin. So we would expect within 48, most patients, not all, within 48 to 72 hours, it should come down. The key is you give the insulin straight away, the basal insulin, when you see the patient. The best outcome is CABG patients, pre and immediate post. So there have been multiple studies, good quality studies, where they have seen deep sternal wound. That's one thing which the cardiothoracic surgeons dread, deep sternal wound infection or pus collection. Remarkable improvement in the occurrence of deep sternal wound if you keep good glycemic control. The best evidence is for them, is for that. And unfortunately, even for the CABG patients, I've seen they come in 20 hours before their operation just at evening, and their sugar is 300. So I say you must get them admitted at least a day, or at least get them seen by us to see that blood sugar control is very good, and then you go. Otherwise, within 12 hours, how can you control it? So more often than not, for all CABG patients for diabetes, I always start IV insulin at 6 o'clock in the morning. So if the surgery is at 9 a.m. or 10 a.m., I make it a point, you must start at 6 a.m. in the morning, IV insulin, because that's the best evidence you have got for IV insulin.
Thank you, Dr. Gangapadhyay, for that nice tips for using insulin. You tell that before insulin, before operation, you are starting insulin, irrespective of the blood sugar level.
No, so if somebody is having operation like the gentleman asked here, so about 2 days later, so irrespective of the blood sugar level, I will use, because the blood sugar level when the patients come to, say suppose somebody has come in with a blood sugar of 120,
yes,
and they are already on multiple oral drugs, I have to give it time to wash off the system. I cannot start it on them. So I may keep it till the night, and from the next morning I won't give any more. But if the blood sugar levels are high when they come in, I stop all the oral drugs and start the basal bolus insulin then straight away before the operation.
No, that's the
but
usually
but if
practice that.
somebody's blood sugar is okay just now, I'll have to wait till the oral tablet effect wears off. Otherwise, he'll land in hyperglycemia.
Before operation, we always withdraw oral hyperglycemia, then you start with insulin. But irrespective of the blood level, blood sugar level, are you starting insulin before operation?
So as I said, if they are on oral tablets, suppose a patient has come at 10 o'clock in the morning, they are given, they have had all their breakfast tablet. Then you will be in muddy waters if you start straight away on insulin then, if the blood sugars are normal. Because you have to give it the whole day for the oral effects to wear off.
Okay, thank you for that beautiful tips. Any other question? Or else we will wind up. Why are you winding up this session? Thank you.
Okay.
Thank you.
Thank you, sir. Thank you, chairpersons. Moving on to the next session, may I request the chairperson, Dr. Utkal Kishore Khadenga sir, to please come up on the dais. He is a senior consultant diabetologist at Care Hospital, Bhubaneswar.
Thank you, Mohez, for inviting me. And so the next topic is going to be lab to life, and it's all about the oral semaglutide. I think the first GLP-1 receptor agonist came in 2005 in the form of exenatide, that is Bita, and the next one to come was Victoza, that is liraglutide in 2010. And then afterwards, like dulaglutide, injectable semaglutide, and a year back we got oral semaglutide. And we have here Dr. Rajiv Kovil to talk about this oral semaglutide. And he is the medical director and consultant diabetologist of Dr. Kovil's Diabetes Care Center. And he has got many publications to his credit, and I think
Thank you, Chair.
my honor.
We'll start. We're already running late, and
over to you, sir.
Thank you so much. Thank you, Sambit, for having all of us here. And I'm going to talk about something which everyone around is calling it a game changer, and the journey of oral semaglutide. Before Dr. Sujoy Ghosh comes and bombards you with the data, I'm going to give you a background of this semaglutide, which took a lot of time for it to come in. So it's been almost 100 years of insulin, and we heard two excellent topics being spoken on insulin. And insulin converted a fatal disease like type 1 into something that we were able to control. The lifespan of type 1 diabetes has improved over the last 100 years. And GLP-1, I will not compare it to an insulin, but it's something very similar to insulin in type 2 diabetics. Insulin in type 1 is a lifesaver. This comes very, very close. And my agenda is this. We're going to look at what is an ideal anti-diabetic drug, how we have reached Mars, but we still could not put a peptide into a pill. And I'm going to summarize very, very fast. So what is an ideal anti-diabetic drug? Now, we all want that the patient should not call us the next day and talk about hypoglycemia. Hypoglycemia is a rate-limiting step in we targeting a good control. So I call this state where you have euglycemia without hypoglycemia, kind of metabolic nirvana. If we can have agents which can get you to an HbA1c of 5.7 and 6 without hypoglycemia, and the incretins and the twin cretins which are being developed and which are showing that kind of results, you're getting to an majority are getting to an HbA1c below 6% without hypoglycemia. So imagine if we had these agents maybe 1.5 decades back, and all those studies which were done to a glycemic strategy study that, get down to a HbA1c of less than 6%, our results would have been different, the Accord, VADT, and Advance. If we had these kind of molecules, our whole objective would have been different, and we would have different results. So our whole desire is to get good control, no weight gain, we should not have off-label targets, and we should also have good CV safety, and at the end, it's an anti-diabetic drug, so you should have excellent HbA1c reduction as well. So if you, now there have been lot of what do you call candidates for the pathophysiological defects in diabetes and type 2 diabetes, and paradoxical hyperglucagonemia is a very clean defect which we realized around 1.5 decades back, and that's why incretin-based therapy has become very popular. And if you look at GLP-1RA, it's got multiple benefits. It's got what we call as a glucose competence concept. So it works only when the glucose is high, and that's why it's insulinotropic. It reduces the glucagon, slows gastric emptying, and increases satiety. And again, lowers weight, and we all know that there is a good amount of CV benefit and CV safety with most of them as such. So when we look at this, that the GLP-1RAs comes much higher in terms of their multiple effects on the pathophysiology. Almost 6 out of the 8 pathophysiological defects are addressed with the GLP-1. And if you look at this, majority of them, whether it's on the liver, where liver, I call it as the kingpin in this metabolic blunder, and it can reduce the hepatic glucose production. Pancreas, I said, it's an insulinotropic action. GI, the ileal brake makes sure that your satiety is lesser, you eat lesser. Again, on the muscles, brain, heart, and vessels. So overall, there's a lot of benefit when we use a GLP-1RA. Now, GLP-1RA are different from their origins and also in the structure and size. We know we have the exendin-based therapies and the human GLP-1. Exendin was exenatide, the longer-acting one and the shorter-acting one, and lixisenatide. And another one also came in. Unfortunately, nobody took it for further trials, and Sanofi dumped it. The human GLP-1s are obviously albiglutide, dulaglutide, liraglutide, and again, semaglutide. So if you look at the multifactorial mechanisms and final effects of them, you have a whole range of benefits. So you can't be glucocentric and how we were 10 years back, that go down to an HbA1c of 6%, use whatever you want. And now we have changed. Then we changed that no hypoglycemia. In the last 5 years, we changed that we should add drugs based on comorbidities. Now we are changing that we need drugs which works like a polypill. It has multiple effects. And here you have a drug which reduces HbA1c, weight, blood pressure, reduces cardiovascular events, albumin, urea, and reduces the load on the liver. So it comes very close to being an ideal anti-diabetic drug. And the data which Dr. Sujoy Ghosh will present will actually endorse what I am saying today as such. So how did it change? How did a peptide come into a pill form? We all know that the ACE, ADA, ESD, IDF, RSSDI, all of us recommend that we should use a GLP-1RA in patients with atherosclerotic cardiovascular disease, but in reality it doesn't happen. We also say that we should use it to minimize weight gain or to promote weight loss. Again, that does not happen because the use probably is one, because the cost is higher. Two, again, because it's an injectable. And data also suggests that when physicians are surveyed, that most of us agree that injectable comes in the way, and that's probably the reason that when you have an injectable in an oral form, compliance is going to improve irrespective of whatever the other parameters may be, and especially cost. So what was the rationale for oral delivery of peptide? One was there was an unmet need for safe, non-invasive, convenient mode of therapy. It would improve patient compliance, address the barriers which are associated with subcutaneous administration. And it's been 100 years of insulin, we've still not been able to get an oral insulin, and we may never get it because insulin is all about fine titration. And GLP-1s are not about fine titration. There are some fixed dosages, and we get a limited exposure of them in the plasma. They are able to do the therapeutic benefit. So the quest was, what are the challenges we are facing? We have an acidic environment, there are proteolytic enzymes, there's limited permeability across the gastrointestinal epithelium, and also very low bioavailability. So when we give a peptide, the bioavailability is less than 0.1%. And that's been the problem that, that we face for insulins and with GLP-1s. So what is there in semaglutide? You know, I'm not a pharmacologist, I don't understand these things, but by tweaking certain amino acids, you are able to prevent degradation by the DPP-4, and also by adding a spacer and a fatty acid chain, you are able to make it a larger molecule and have a strong affinity to albumin. Thus, the half-life becomes longer, close to almost a week. And that's how semaglutide was the discovery which led to the innovation of what is called as an oral semaglutide. So what is oral semaglutide? Oral semaglutide is a co-formulation, and it is combined with something called a SNAC, which is an absorption enhancer. What SNAC does is that it increases the pH very locally. Where the drug erodes, very locally there's an increase in pH, and it enhances the semaglutide oral bioavailability, and you have the absorption of semaglutide across the gastric epithelium in a concentration dependent manner. So SNAC is where the difference between anything lies. So the hero in semaglutide is actually SNAC. It's a fatty acid derivative, undergoes hepatic glucuronidation. They studied SNAC very well. SNAC is also being used for PCSK9, and probably you will have very long-acting PCSK9 with SNAC. So SNAC is actually the hero when you have it, and the bioavailability increases to almost 1%. So what does SNAC do with oral semaglutide? You can give an oral route of administration for GLP-1RA. Because it's an absorption enhancer, your bioavailability from 0.01 goes up to 1%. You'll say it's very low, but that much is enough for the therapeutic benefit. There can be variability of absorption, but it's a longer half-life. You have a 1-week half-life. So thus, once daily dosing and 1-week half-life actually minimizes the absorption inadequacies that can occur, especially with our kind of conditions where patients may not actually fix up to that half an hour before and 120 ml of water that is required. So as I said, SNAC is an enhancer that facilitates absorption. The available data for semaglutide co-formulation with SNAC supports the absorption takes place in the stomach in a localized buffered environment, and it's time dependent, occurs via the transcellular route. So if you look at it, the absorption takes place in the stomach, and it's early systemic absorption and slow elimination of semaglutide in healthy human subjects. And what is the mechanism of oral semaglutide? As I explained earlier, the SNAC causes a local increase, leading to a higher solubility and protection from the proteolytic degradation as such. The effect of SNAC is strictly time and concentration dependent and fully reversible. So when you give SNAC, it doesn't mean that the others don't get absorbed all through the day. And approximately 1% of semaglutide is absorbed. The rest is degraded in the GI tract itself. And if you look at exposure, whether it's oral or subcute, it's almost similar. So it's able to mimic what happens when we give an injectable semaglutide weekly, or we give an oral semaglutide daily. It's able to mimic. If you look at the exposure relationship, it seems to be very, very similar. And hence, it becomes very convenient for patients. So whatever we do in diabetes, the mantra is do simple things right. And if you're able to do simple things, we will improve compliance as such. So again, no dose adjustment recommended regardless of hepatic and renal impairment. No dose adjustments in elderlies. Where if the pioneer group, Dr. Sujoy will present, again, hardly any risk of hypoglycemia. The challenge is this, that you need these patients to wake up, take their semaglutide straight as soon as they wake up with 120 ml of water. Some people who have a 60 ml every day will know how to calculate 120 ml. Otherwise, it's very, very difficult. It's half a cup. Wait for at least 30 minutes before eating, drinking, or taking any other medications. You need to start at 3 milligram for a month, then go up to 7. Majority of the benefit is seen with the experience we have for the last 2.5 months in the 7 mg itself. And as the dose goes up of semaglutide, whether it's injectable or oral, the HbA1c reduction may not be much, but the weight reduction keeps going up. That's what has been seen with the injectable per se. So I would summarize saying that peptides are challenging compounds and they require really engineering, which has been seen with oral semaglutides. Peptide analogs can be designed to improve stability and prolong the half-life. Absorption of oral sema takes place in the stomach, requires co-formulation with this fatty acid derivative called SNAC. Mechanism of absorption shown to be compound-specific, transcellular, without any effects on tight junctions. This is important. Development of this is one of the questions which was asked, that, you know, if it's continuously going to absorb, are the other molecules also going to happen? So that does not happen. Development of a peptide in a pill represents a very big advancement in the treatment possibilities for chronic diseases by transforming these peptides into tablets-based oral formulation. Thank you all for a patient hearing.
Lucid presentation and finishing before time.
Thank you.
So we can take 1-2 questions here.
So it's all
no
for
questions,
Sujoy
we
to
can,
answer.
yeah,
Thank you.
it's a very well explained, and we can finish talk and we can proceed to the next one. Thank you so much.
Thank you, sir. Thank you, Chairperson. Moving to the last talk of the evening, may I request our chairpersons, Dr. Bijay Kumar Mishra, sir, Senior Consulting Physician, Bhubaneswar, and Professor Dr. Shrikant Kumar Dhar, Professor of Medicine, IMS and Sama Ultimate Hospital.
So we are almost in the last session, and the speaker will be Dr. Sujoy Ghosh, who will be introduced by my co-chairman, because the Dr. Kovil has already set the platform of oral semaglutide, and now we will be seeing that the pioneering research translating into clinical outcomes. Dr. Ghosh will be giving evidences what are the best clinical outcomes of this sought after molecule, that is oral semaglutide. So with this, I request Dr. Dhar to introduce Dr.
Thank you, sir. Everybody knows that Dr. Sujoy Ghosh needs no introduction. He is a pioneer in the field of endocrinology in India and abroad too. There is so many recognition, but without much delay, because he is a pioneer in this study also. He will be delivering his talk, and everybody is waiting for that. Thank you. Dr. Ghosh, please.
Thank you, respected chairpersons. It's a very mixed feeling, you know. The first bit is feeling very good because after a long hiatus, we have managed to actually meet face to face, and I've managed to come back to one of my favorite cities, and a big thank you to Sombit for having given me this opportunity. The other bit is I'm not feeling great is because semaglutide is a drug that suppresses appetite, and I'm standing between you and your dinner. So I'm going to talk about oral semaglutide, pioneering research translating into clinical outcomes. And essentially, the talk is divided into 3 sections. First, about the clinical development program and the clinical trial data, and what we've managed to achieve with semaglutide as of now, and a little bit about where do you position semaglutide in regular clinical practice. So coming to the first bit, you know, seldom do you have a drug getting launched which already has 25 clinical pharmacological trials even before it gets launched. There's 1 phase 2 trial and there are 10 phase 3A trials. And I think ever since the SGLT2s, we've started having trials where you already have huge data even before a drug gets launched, and close to 6,000 patients had been on semaglutide, oral semaglutide, before the drug actually got marketed. And if I actually have to summarize the entire clinical trial development program, just remember a couple of things, that all of these studies start with the name Pioneer, and it's 1, 2, 3, 4, 5, 6, 7, 8, 9. Now you have the Pioneer Real, which is also going on. And remember, Pioneer 6 was a CV outcome trial. The rest are actually in specific circumstances. So if you look at Pioneer 1, it's a study of the drug as compared to a placebo, because that's usually the first kind of study that you would do with any drug. Pioneer 2 is a comparison with empagliflozin, an SGLT2 inhibitor. Pioneer 3 is a study of oral semaglutide as compared to sitagliptin. Pioneer 4 is a comparison with liraglutide. Pioneer 7 is the sitagliptin extension study. As you can see, Pioneer 8 is an insulin study, and this is one of the studies where you have some Indian patients, that's about 50 odd patients there. Pioneer 5 is a study of patients with renal impairment. Pioneer 6 I'll talk a little bit more in detail. 9 and 10 are patients exclusively in patients from Japan. The SOUL study is a study that's currently ongoing. Even our site is one of the sites of the SOUL study, IPGMER Kolkata. Now, you might wonder and say, you know, why do you have a 6 there and why do you have another SOUL study here? We'll talk about that as well. So if you look at the baseline characteristics of most of the Pioneer studies, one of the things that you will realize that most of the patients enrolled in the studies had a BMI around of 30-31. So that's probably slightly higher than our average type 2 diabetic individuals. Most of the Pioneer studies enrolled people who had an HbA1c of around 8. So you are trying to look at people around 8 and you're trying to see what proportion have come down to below 7. So you're trying to look at a 1+ HbA1c reduction, and each of the studies, if you look at, there was a huge variability in the duration of the diabetes. Some less than 5 years, some 5 to 10 years, and some of them more than 15 years. And the age group is more or less what you would see in the Western counterpart, 50s to 60s kind of age group, though in India we probably have diabetes at a much younger age. This is again some of the data, but more or less, like I've said, BMI above 30 or 32, somewhere around there. A1C is around 8 in all of the Pioneer data that we are talking about. And in most of the studies that you're talking about in the Pioneer studies, what are the primary endpoints and the secondary endpoints? You know, you're using this drug predominantly to reduce blood glucose. So it's a glucose lowering agent. So that's your primary target. And the secondary target would be that in addition to the HbA1c reduction, you want to reduce the weight in these individuals. So the secondary confirmatory secondary endpoint in most of the studies are weight. And like I said, the Pioneer 6 was a regulatory CV outcome trial where you tried, it was almost like a classical CVOT. You tried to look at the 3-point MACE and then the extended MACE requirement. The Pioneer 7 was a little bit different. You just not wanted to see the reduction A1C, but also see the proportion of people who achieved glycemic targets less than 7%. So more or less, keep in mind that there are two targets, the primary one being HbA1c reduction and the secondary one being the weight reduction. So if you look at HbA1c across the board, Dr. Rajiv quite mentioned that there are 3 doses of oral semaglutide, the 3 milligram, the 7 milligram and the 14 milligram. You can see that there is a dose dependent reduction of HbA1c, and irrespective of which Pioneer study you're talking about, at least at the highest dose that you're talking about, there was almost always a more than 1% reduction in HbA1c. So if you're looking at a placebo controlled trial, that's Pioneer 1 or Pioneer 2, you can see that there is consistent reduction of HbA1c anywhere between 0.8% to 1.3% to 1.4%. That's the usual kind of HbA1c reduction that you would anticipate that will happen with the Pioneer group of studies. The next bit is what proportion of our patients are actually achieving targets of less than 7%. So I told you that most of the studies here had a starting HbA1c of around 8 to 8.2, and if you see the proportion of people achieving HbA1cs less than 7%, because overall 1% reduction does not necessarily mean that everybody is having a 1% reduction. Some are having higher reduction, some are having a relatively lower reduction. But overall, close to 60 to 80% of patients in the pioneer group of studies will reach targets of less than 7% if you're using oral semaglutide. And the next bit that is to look at is, if you look at the highest dose, that is 14 milligram dose that we are talking about, and if you select people who had a starting HbA1c of more than 9%, so you are now doing a analysis, a post hoc analysis. You're looking at people who to start with had an A1C more than 9, and you are looking at people who got a dose of 14 milligram. You will see that they've got more than 2% reduction of HbA1c. So that's dramatic, you know, for an oral agent. Apart from sulfonylureas, what proportion of our patients actually achieve A1C reduction up to about 2%? I don't think so, unless and until it's someone who's newly diagnosed diabetes, where you will have dramatic reduction of A1C with whatever agents you use, because whether it's the DPP-4 inhibitors or the SGLT2 inhibitors, in most of the circumstances the HbA1c reduction is close to 0.7 to 1% at the most. So up to 2% with higher dose in individuals where the starting A1C was pretty high. Moving on to the next bit, that is the secondary endpoint in most of the studies, is the body weight reduction. So if you look at, again, there is a dose dependent incremental effect of lowering of body weight with oral semaglutide, and the weight reduction is anywhere between 1.5 kilograms to up to 4 kilograms of body weight. So again, huge weight reduction with an oral agent, with the background of loss of weight, which usually is not that ill sustained as that of a SGLT2 inhibitor, because when we use an SGLT2 inhibitor, the weight loss tends to plateau off usually in most of the cases after the 3rd to the 4th month. So if you look at what proportion of patients are achieving both, that means they have achieved a HbA1c reduction of more than 1%, as well as lost at least 5% of the body weight, because in that case you can say, you know, you've achieved a dual target of both weight loss as well as A1C loss. So again, there if you see, at least 1/3 of our patients who have been on oral semaglutide in the clinical trial setup would have at least had this dual target achievement of both A1C reduction as well as body weight reduction. So that again is dramatic. So if you then look at, you know, what proportion of your patients are more likely to achieve this dual target as compared to the comparators in the pioneer study. So for example, if someone was on placebo, as in pioneer 1, almost 10 times more patient would have achieved A1C reduction as well as weight reduction. And if you particularly look at liraglutide, because you know hardly any of our patients tolerated 1.8 milligrams of liraglutide, but even if you had used liraglutide and you compared that with oral semaglutide, at least 3 times more number of patients would actually achieve the dual target of 1% A1C reduction along with 5% weight reduction. So the odds of achieving a dual target in all of these pioneer studies is much greater with oral semaglutide compared to all of the other comparators that you're talking about, whether it's the GLP-1s, whether it's the SGLT2 inhibitors or the DPP-4 inhibitors. Coming to the next study, which is the Pioneer 6 study. Now, why did Novo go and do Pioneer 6 study? That might be a question that you might ask. Now, as you know, as part of the US FDA mandate that was required of showing that a drug is CV safe, they needed numbers in their kitty before they could get regulatory approval. So they went and did quickly a CV outcome study called Pioneer 6, where they essentially wanted to see that there was no excess of cardiovascular mortality, so that they could get license for the drug to get marketed. So that's the reason how Pioneer 6 was designed, because a lot of people will say, you know, injectable sema has got cardiovascular outcome benefits. So people will say, why has the hazards ratio crossed 1 and therefore probably oral sema is not a great drug when it comes to reducing cardiovascular outcome. So you will see that there is an overall 21% reduction, but that reduction is non-significant, and you will see that this was done predominantly to show that the drug was safe for marketing purpose. Now you have a dedicated big CV outcome trial which is going on, that's the SOUL study, which we are almost convinced, given the pathophysiological mechanism by which this drug works, that it will show that it reduces the 3-point MACE and cardiovascular benefits will be there. The better or the more exciting bit of the thing of the study here is that close to 99% of the population was actually retained in the study, which itself is great for any GLP-1. You and I have been using injectable GLP-1s, and you know the kind of dropout rates that we've had with injectable GLP-1 because of tolerability issue. Of course, financial issues are there as well, but this is reassuring that this might be relatively better tolerated than several of our previous injectable GLP-1s. Now, if you look at again here the Pioneer 6, we are talking about relative glycemic equipoise, which of course did not happen because it's such a dramatic drug in terms of reduction of weight as well as HbA1c. So moving on to the next bit, though I don't know how rational it is actually to pool the data of oral semaglutide and the injectable semaglutide CV outcome trials, if you put the data of Pioneer 6 and put the data of Sustain 6 together, but still, at least if you do that from a pathophysiological point of view, because one, you are taking a drug and that's achieving a bioavailability, and the other is a subcutaneous injection and you're achieving bioavailability. So logically you might say that, you know, it's the same drug. It's like giving either oral furosemide or injectable furosemide, and you're saying that the blood level of furosemide is same and the drug is doing the job, but ultimately you would depend on the SOUL study. But if you do club the data of the two together, you can see that there is dramatic improvement of the 3-point MACE and reduction of all the parameters of cardiovascular mortality and cardiovascular events. So moving on to the next bit of the presentation, we've talked about overall in terms of the Pioneer study. But what about certain special subgroups? Because we are all worried about managing diabetes in certain populations, right? So first of all, you might say, you know, this is an incretin based therapy, so it will work in people who are relatively early on in the disease of diabetes. Once they are further down in the course, beta cells are dead and gone, so whatever kind of incretin stimulation you give, nothing is going to happen in terms of the benefits of glucose lowering and weight reduction. So let us first look at the diabetes duration and how that influences if you actually go and look at the data. Now this is again the summary of all of those Pioneer studies, and if you split it up into people who had diabetes less than 5 years, diabetes between 5 to 10 years, and diabetes more than 10 years, you can see that there is hardly any difference in terms of the glucose lowering benefit of oral semaglutide, essentially telling us that in our clinical practice, when we are using a drug like this will probably work from the beginning to at least until 10 to 15 years after diagnosis of diabetes. And similarly, the weight bit was there. So the next bit you will say is, you know, does it work in younger individuals better? Does it work in older individuals better? Because as India is growing into a nation with a greater proportion of older population, would it work in them as well? So if you look at again the data in terms of the baseline age, and you split it up as less than 45, 45 to 65 and more than 65, again there is no impact of age, and in fact particularly this is the 14 milligram dose, you can see it consistently works across whatever age of patients that you are talking about. What about those people who are on different kinds of background medication? You might say, if you are on a sulfonylurea, does it work as good as it was? if you were on a DPP-4 inhibitor or a SGLT2 inhibitor or whatever else. So if you again reanalyze the data and you see whether you're looking at metformin or metformin sulfonylurea, SGLT2 and metformin, or on insulin therapy, on others, you can see in whatever background therapy of anti-diabetic agents you are using, the drug is working in terms of the HbA1c reduction. And again, in terms of the body weight as well, because you might say, if you are on an SGLT2 inhibitor, this will no longer reduce any more weight. So if you see here, even if you were on an SGLT2 inhibitor, there will be an incremental weight loss even if you were on an SGLT2 inhibitor. So finally, if you're coming to race, because you might say, oh, this is a drug that's worked well in the Westerners, it might not work that well in Indians. We already know from the DPP-4 studies that in Asia, particularly Southeast Asia, we seem to have higher DPP-4 levels due to whatever ethnic reasons, and not surprisingly, if you're looking at the effect of race, this group of drugs seem to be working even better in the Asian population as compared to either the white population or the Afro-Caribbean and black population worldwide. So if I actually have to summarize the data of Pioneer and put it into clinical practice into what you and I are using, because you want to know, is it better than SGLT2 inhibitor in terms of weight? Is it better than SGLT2 inhibitors in terms of HbA1c reduction? Is it better than a GLP-1 which is injectable in terms of weight and A1c? So this is a kind of summary slide of that. So let us look at HbA1c and oral semaglutide. It is superior to empagliflozin and sitagliptin in clinical trials. I've shown you that data. And I've shown you that the HbA1c reduction with oral semaglutide is similar and non-inferior to injectable liraglutide. What about weight? With use of oral semaglutide, the weight reduction is superior to sitagliptin, superior to liraglutide, superior to empagliflozin. In terms of the cardiovascular safety, we've already shown that the drug is safe with the Pioneer 6 study, and we are waiting for the SOUL study so that you have actually an RCT data to show that it is superior. In terms of the club data of SUSTAIN 6 and Pioneer 6, we showed that there was good results. And if you look at overall safety of oral semaglutide, it was well tolerated and the side effects are in line with the injectable GLP-1 analogs. So finally, a little bit about tips in routine management in clinical practice. So if you have to tell me, who do you think is going to be the ideal patient in whom you are going to start oral semaglutide? Let us look at certain parameters. Anyone on metformin and beyond, this would be a drug which you can use. So you can start using this drug as a second line after metformin failure. And the data that I showed you, you can add this on even as a third line, even as a fourth line, once the other drugs have not worked. In terms of who do you think is going to benefit and in terms of the weight loss, I've shown you the data that it is superior to the other oral agents and is equal to that of liraglutide, maybe slightly superior even with injectable liraglutide in terms of the weight loss. And it would be reasonable to consider this drug in anyone where you don't want weight gain and where you want weight loss to happen. In individuals where you're worried about hypoglycemia, we were talking about, there is very low risk of hypoglycemia with oral semaglutide and is similar to EMPA, SITA and GLP-1 receptor analogs. Patients who are already on an injectable GLP-1 analogs, some of them will come and say, I don't want injections anymore. You can always switch them over to oral semaglutide if they so wish so. And in individuals with established cardiovascular disease and high risk cardiovascular disease, we have definitive evidence from the Pioneer 6 that it's safe, it's not going to increase risk, and the meta-analysis of SUSTAIN 6 and Pioneer 6 suggests that there is going to be benefit. We'll wait for the SOUL study results for the final verdict. And like Rajiv already stated, that in individuals with renal and hepatic dysfunction, you don't need any dose adjustment for oral semaglutide. Older patients, I've shown you people whatever age, whether they're less than 45 or above 65, the drug is going to be safe and is going to be equally efficacious. So if you're going to talk about potential place of oral semaglutide, metformin plus minus any other OAD, if they have an A1C more than 7, if they are high risk, definitely start thinking of a GLP-1 based therapy, including oral semaglutide. This is the flow diagram, I think, which was shown in one of the studies, in one of the presentations a little earlier. And even in individuals who are not high risk, you can start or consider starting this for glucose lowering, for weight reduction and avoidance of hypoglycemia. And you can keep on adding or continuing the oral semaglutide at all phases of management of type 2 diabetes, even in individuals who are already on insulin or where you are considering using insulin. So to summarize, GLP-1 receptor analogs are among the most effective medications for type 2 diabetes. They have great robust reduction of A1C, body weight and a composite of both. Oral semaglutide is a truly game changer in terms of not only giving us hope about a peptide in a pill in terms of GLP-1, like Rajiv stated, in future we'll probably have a lot of other drugs which will also become oral drugs like the PCSK9 inhibitors, and we've shown that on an average 0.8 to at least 1.2 to 1.3% reduction of A1C and weight reduction on an average 1.5 to 4.5 kilograms happen. Oral semaglutide has been found to reduce A1Cs more than GLP, at least equal to GLP-1 and more than the DPP-4 inhibitor and the SGLT2 inhibitors. The Pioneer 6 has shown that the drug is CV safe. The larger SOUL study will actually tell us more. The drug is efficacious given early and given late, given in younger, given in older, and also when given in patients with comorbidities like renal and hepatic dysfunction. I shall stop there. Thank you very much.
Thank you, Dr. Ghosh, for the lucid and very comprehensive presentation. I think this is open for discussion. For one question from my side, where will you put in guideline ahead of SGLT2, at par or below?
I think we should not be making comparisons. Every drug has a place in clinical practice. So if somebody is able to afford, and if somebody has got atherosclerotic cardiovascular disease, probably I will choose any GLP-1 based therapies ahead of SGLT2 inhibitors. But if someone has got heart failure and renal disease, I'll probably choose an SGLT2 inhibitor ahead of a GLP-1 based therapy.
Dr. Ghosh, you know that semaglutide can worsen diabetic retinopathy. So before starting, why not examine the eye?
Right, that's a bit of a controversial statement. I think with all of the GLP-1s, we've had variable degrees of results trying to suggest that in some of the GLP-1 trials that there were worsening of retinopathy. The LIRA trial was there as well like that. But you know, it's like insulin trial as well. When the first of the intensive insulin trials came up, they showed that it worsens retinopathy. So do you and I actually go and check retinal examination for the sake of starting insulin therapy? We check the eyes anyway, whether you start insulin or otherwise, but I am not convinced about the data of worsening of retinopathy with any of the GLP-1s, and I think it's more of a chance finding.
Like less BMI or normal weight or underweight?
I think my pocket is the biggest contraindication.
What is the early data about SOUL? You are a pioneer also.
We don't know because the data is unblind, not yet been unblinded. You know, we don't know.
If there is no further question, we can wind up here.
Thank you very much.
Thank you.
Thank you, sir. Thank you very much. It was wonderful listening to you and your experience. Now it's time for the panel discussion. May I request the moderator, Dr. Pitambar Prusti, sir, Senior Consultant Endocrinologist, Apollo Hospital, Bhubaneswar, to please come on the dais.
So we are into the last session. I can see that the crowd is still waiting. I think there is a very less time before dinner. So I think I will not take much of time. Within maybe 10 to 15 minutes or so, we will wind up the session. Now for this panel discussion session on the various topics whatever discussed in the last 4 sessions, I will call upon my panelists, Dr. Rajiv Kovil, Dr. Sujay Ghosh, Dr. Gangopadhyay, and Dr. Devamalya Sanyal to the dais. So I think a day-long discussion on various aspects of diabetes and endocrine disorders, I think must have at least a partially saturated because the audience, because I think there is another day. But whatever we have learned in the last 4 sessions, whatever you talk of about the insulin, newer insulins, the insulin analogs, insulin innovations, the various categories of patients that we come across in patients and their management of hyperglycemia in that setting, and of course the new drug, the semaglutide, the oral form of GLP receptor analogs. I think there may not be many questions because our experts speakers have taken a lot of pains in explaining the science behind it, the literature on these subjects. So I don't think there will be many questions from the audience. But at the outset, if there is any question pertaining these 4 last topics, please raise your hands and ask the panelists. Now, as the audience is maybe taking time, I will ask my first question to Dr. Devamalya Sanyal. Sir, you discussed many of the innovations as far as newer insulin is concerned, especially the, I will ask about the insulin IDEG aspect. In which type of circumstances, you discussed many things of course. Now, if a patient is on IDEG or IZODEG, so usually is given twice daily for a better control. Now, if the control is not achieved, at what stage you will switch over? No, this is not effective. I will must go for basal bolus therapy.
Well, generally after, if we do not achieve an adequate glycemic control in spite of up titration of therapy, and we still have the HbA1c above our target range, then still we all recognize that basal bolus therapy remains the most effective, though it has its limitations in terms of more monitoring and more number of pricks. But at the end of the day, when there is inadequate control, even with a twice daily of co-formulation, obviously basal bolus insulin is one regime, if it is used successfully, will address the glycemic control, which we have seen even in the hospital setting, it addresses. So that remains the most effective regime in terms of getting us to target. So if the target is not achieved, we with twice daily, we can up titrate to a basal bolus therapy.
Because why this question arises is because 2 doses of Izodeg in some of the studies, of course many of them are company sponsored, have shown that may be better than basal bolus insulin therapy. So definitely there is scope for basal bolus because nothing can beat it. Even 2 doses, maximum doses of Izodeg may not beat the basal bolus, the convenience and effectiveness of a basal bolus therapy. So at times whenever we confront this situation not control, better to go for basal bolus insulin therapy.
Especially in patients who have a high postprandial glucose,
Yes.
because here it is a 30-70 composition. So 30% bolus. So in patients who have a high postprandial glucose, which we lot of times find,
Yes.
the postprandial control is not adequate, even having a good fasting control, and that's why their HbA1c is not on target. In such a scenario, you cannot titrate. The major advantage of a basal bolus therapy, you can titrate your fasting and you can titrate your postprandial separately, which is a limitation with any form of, whether it is a premixed or a co-formulation, that is a limitation.
Thank you. Yes, please add on to it. You can add on.
Yes,
please.
yes. So as Demolo was just saying that the postprandial becomes an issue on occasion. So you can play around with the PK/PD of Rhizodec. So suppose you're giving it before breakfast and before dinner, but the main meal is at lunchtime and your PP sugars are high. So before going on to basal bolus, you may give the Rhizodec before lunch and before dinner, not before breakfast
Yeah.
and before dinner.
Shift the
That might
timing.
that might
Shift the
just
timing of
address,
Rhizodec.
in a few patients.
The next question will be to you, sir, Dr. Gangpadhyay. Sir, I was listening to your talk very intently. Actually, we are trying to devise a method of managing inpatient hyperglycemia, which has been very difficult, I should say. So in your experience, whatever you brought out, and the lecture was so impressive, I think our many of our clinicians and students should learn from your talk. Sir, in your talk, you talked about the newer insulin analogs, various other insulins, but you did not touch upon the mixed insulin analogs or the mixed insulins as such, as far as the inpatient hyperglycemia management is concerned. So will you throw some light? At least there are many hospitals, and even our hospitals here also, they control the blood sugar with a mixed insulin, either analogs or mixed insulins. So what is your opinion on this?
There are very few studies, not randomized control trials, using premixed insulin in hospital setup. But if you have to initiate, basal bolus is the best. But play it by the ear. So if we have got a patient who is well controlled on premixed insulin twice a day, and he has come in for, say, blood transfusion for his myelodysplastic syndrome, he has come in not septic for some other reason, then you may just continue with the twice daily premix. There's no point in changing it. But for the vast majority basal bolus, you may decide on changing to premix at the point of discharge to twice a day, but not inpatient.
Yes, definitely. At the time of a discharge, in switching over which insulin patient should go to home, and for his convenience, there lies the role of premixed insulins. Yes,
if I may add, because we have had these in limited resource setting where cost is a limiting factor, as well as in our state we have one of the schemes, government sponsored schemes, where the government funds insulin. There the basal insulin is still not reimbursed. So the issue is, then we have to depend on regular and premix that is only available. So in a lot of scenarios, we do give 2 times regular insulin before breakfast and lunch, and nighttime premixed insulin. In some patients where it is even difficult, we may even sometimes do 2 times premixed insulin as he is taking in the morning, along with that add the lunch dose of regular insulin. So either way we may manage in some patients, but ideally basal insulin and basal bolus therapy is the ideal choice.
Thank you. Definitely I agree on that. I think this audience should go with the impression of a basal bolus therapy in inpatient management of hyperglycemia. The premixed insulins may have a role after discharge or for the convenience of the patient and the cost point of view. Now the last 2 lectures were on the revolutionary drug, that is the oral semaglutide, a peptide which can be given by mouth. So my first question is to Dr. Rajiv. He brought out many of the aspects of the pharmacokinetics of the oral semaglutide. The one doubt remains, actually, will you please explain to this audience why they have specified taking in the morning, fasting stomach, with half a glass of water. And the second thing, if that is so, then how the patient who is on multiple drugs and he has to take in the morning, how you reorganize the things, which drug after whom, and what is the time interval, like the thyroid hormone or other drugs he is on, because the patient will be definitely going to ask you all these questions.
So, very interesting question. Again, it requires the fasting state for absorption. So that's important, and that's the reason you are giving it in the fasting state. Two, they've tried it with various compositions of water, right, from 50 ml to 300 ml, and they saw that between 80 to 120 ml is where the erosion is the best. So more water causes lesser erosion, and lesser water causes more erosion. So they have tried it with that, and they've also tried it with various doses of snack as well, which works the best. So based on this is what it's like a dose finding study, like you do. But so this is an additional finding, that what is the amount of water you require for optimal absorption. And when you have to give other products, the problem is only when we have to give thyroid supplements, and the option is to give it if our patients are eating early dinners, to probably give it 3 to 4 hours after dinner, but majority of us don't. So then the problem remains whether you can give concomitantly, where the thyroid supplements, the thyroid exposure goes up, or we have to wait for half an hour after giving semaglutide for the thyroid. So the patient needs to be very, very regimented in that. So you would, I would love a study coming out where you give concomitantly and then give later, and whether there is any difference found. But yes, the thyroxine level goes up, so it's better to have that half an hour gap or bedtime.
Thank you. I think we'll finish up. If Dr. Sambit has some questions, he can ask. Otherwise, the last question to Dr. Sujay. You discussed all the things about the pioneer studies, which people must have come across, and especially the cardiovascular outcome study, which is a real trial, which is coming up, and the results may be out in a few months or in a year or so. Now, if we think of for diabetic type 2 diabetes, there are major groups, and the chairperson also did ask that question, that keeping the guidelines, which one should come first and which one will be later. Now, as far as oral semaglutide is concerned, which patient group, especially young, not having the cardiovascular risk is so much, you will definitely choose over metformin as the first line drug.
Semaglutide, I don't think is still reached a place where I can choose it as a first line drug. So metformin still remains the first line drug. There might be controversies of that about, but when you're talking about GLP-1s and we are talking about semaglutide, ideally, because of certain things like the difficulty of taking the drug, the cost and everything, my positioning of the drug will be in relatively higher risk group of patients to start with. It's just like with SGLT2 inhibitors. We started it as a third line drug or a fourth line drug, and we gradually learnt about the drug, and we gradually came up the ladder. So if I have someone who's obese, where I want the individual to lose weight, if someone has got high blood glucose levels, background atherosclerotic cardiovascular disease, high risk, those would be the situations where I would want to choose the drug. But I would not give it to everybody, at least at this point of time. And I think that same was with SGLT2 inhibitors when we first started. I don't think we gave SGLT2 inhibitor to everybody.
Yeah, definitely.
We learnt about the drug over a period of time. We gained confidence. More and more data got generated, and then only we gradually moved up to the ladder, and now almost everybody talks about SGLT2 as a panacea.
Definitely. So definitely metformin still remains the monotherapy of a choice for any diabetic coming to your clinic. Now the last question to Dr. Sujay again. In your, because you are very intently have reviewed the literature on oral semaglutide, in future, what do you think the side effects of a semaglutide can be or a new side effect, because there is a new drug you think of which may come up and pose a problem?
Right, that's very difficult to actually predict. I'm not an astrologer. You know, people had thought of certain side effects might be very common. For example, medullary thyroid cancers, they thought would be common because in animal model studies that was shown. That actually hasn't come up. On the other hand, we don't know about pancreatic malignancies yet. There, with the injectable GLP-1s, that's probably a done and dusted bit. But what will happen with the oral, I don't know. But these two were probably the concerns that most people have had. But going by history, you know, history springs up mysteries and unknown side effects all of a sudden. What will happen in the long run is anybody's guess.
Yes, I specifically wanted to bring out these things from Sujay's mouth. Anyway, it's very nice. I thank all the panelists for very nice answers and clearing the doubts of audience at large. And lastly, I request Sambit to come up on the dais and hand over the mementos to the panelists, please.
I'd request our other chairpersons, Dr. S.N. Swain sir, or Dr. Utkal Kharenga sir, Dr. Shrikant Dhar sir, to please come up on the dais. Thank you everyone. That was the end of today's session. We'll meet tomorrow at 9 a.m. and tomorrow 9 a.m. with breakfast.